So good morning, everyone, all my friends, members of Maharashtra Ophthalmic Society and everyone across the country. Good morning and welcome to the day 4 of the Maharashtra Ophthalmic Society virtual conference Vircon 2021. We have in this with us today for the retina session, the surgical retina session, a galaxy of stars and speakers. I would like to welcome my co-chairman for this session. It's none other than Dr. Lalit Verma, sir. Everybody across the country and beyond knows him. He's a vice president of the AIOS, and he's a mentor, guide, and a beacon of light for ophthalmologists across the world. Welcome, Dr. Verma, sir. I would like to invite Dr. Jagdish Loya, again, a very accomplished retinal surgeon from Aurangabad, and Dr. Dipti Kulkarni, again, a very prolific vitreoretinal surgeon from Sangli. With this, I would like to kick off the session. Our first speaker is Dr. Alok Sen. He's yet to join. So I am going to pass the baton straight to Dr. Saurabh Luthra. Dr. Saurabh Luthra, again, is a very, very senior and experienced vitreoretinal surgeon from Dehradun. Welcome, Dr. Saurabh. He is going to speak to us on unraveling the unseen embrace, the vitreomacular traction disorders. So Saurabh, over to you.
I thank MOS and I also thank Dr. Preetham and Dr. Swapnesh for this opportunity, and good morning, respected chairpersons and panelists. I will be speaking on VMT disorders. I'll be sharing my screen now.
This is for all our speakers and audience that there'll be a timer there, and 2 minutes before the end, there'll be a bell, and at the end, there will be an alarm.
So, can you see my screen as yet or not as yet?
Yeah, it's coming up. Yes, okay. We can see your screen.
So we know that the vitreous attachments are stronger at the vitreous base, at the V-guts ligament, at the peripheral margin of the optic nerve head and posterior pole, at the margin of the fovea and along the retinal veins. The vitreoretinal interface is an adhesive sheet which facilitates connection of posterior vitreous cortex to ILM. It consists of posterior vitreous cortex, ILM, and intervening extracellular matrix. So we have various vitreoretinal interface disorders which are epiretinal membrane, vitreomacular traction, macular hole, lamellar hole, and LHEP. Epiretinal membrane is a pathologic fibrocellular membrane which lies superjacent to inner surface of the retina. We have various classifications. In this OCT-based classification of epiretinal membrane, we have either fovea involving or fovea sparing ILM. And in another classification of ERM, which is based on the cause, it could be idiopathic, primary, or secondary, and based on the central foveal thickness with normal or thickened central fovea. Treatment essentially can be observation if the vision is maintained, or is surgical with pars plana vitrectomy with ERM removal and ILM peeling. Surgical peeling of the ILM decreases the risk of recurrence. Vitreomacular traction is due to incomplete perifoveal vitreoretinal separation, residual cortical vitreous adherent to the macula and ONH. There are various criteria for VMT: perifoveal vitreous cortical detachment, macular attachment of vitreous cortex within 3 mm of radius of fovea, association of attachment with distortion of foveal surface. It could be focal or broad. So this was given by the International VMT Study Classification. By size, it could be small, less than 250 microns, medium, greater than 250, but less than 400, and large, more than 400. This is another useful classification in which stage 0 is vitreomacular adhesion, stage 1 is vitreomacular traction, stage 2 is small hole, stage 3 is large hole, and stage 4 is full thickness macular hole with PVD. So it could be either V-shaped or J-shaped depending on the shape. Treatment again can be observation, pharmacological vitreolysis, surgical, which is the most common treatment used, for pars plana vitrectomy with ILM peeling, and pneumatic vitreolysis, which is not preferred. So octreoplasmin has been tried, but there are problems with that because of zonular dehiscence and lens dislocation. So complications of VMT include full thickness macular hole, tractional macular schisis, and tractional or foveal macular detachment. Full thickness macular hole is most commonly idiopathic. What is the role of ILM in macular hole? The scaffold for proliferation of cellular components like myofibroblasts, fibrocytes, RP, and fibrous astrocytes cause tangential traction and result in full thickness macular hole. The surgical management of macular hole includes pars plana vitrectomy with delamination of cortical vitreous, peeling of ERM, and then delamination of the ILM. The stains which can be used for chromovitrectomy, trypan blue used to be used in the past, but it stains ERM more. Triamcinolone acetonide is used to stain the residual vitreous, whereas brilliant blue G dye is excellent for ILM. ICG is not used because of its toxicity issues. So various types of macular hole closure are there, closed without foveal defect of neurosensory retina, and type 2 is where foveal defect of neurosensory retina persists, but whole rim of macular hole is attached to underlying RP with flattening of the cuff. Lamellar macular hole has an irregular foveal contour, break in the inner fovea, dehiscence of inner foveal retina from outer retina, and absence of full thickness foveal defect with intact foveal photoreceptors. In the pathogenesis, traction forces by posterior hyaloid cause intraretinal cyst. After complete PVD, inner wall of intraretinal cyst detaches and forms lamellar macular hole. This is another interesting condition called LHEP. It is initially described as thick ERM, avascular homogeneous layer of medium reflectivity covering the premacular surface and surrounding foveal defect. And Govetto et al. Described LHEP as degenerative lamellar macular hole. LHEP, unlike ERM, does not cause traction, fewer alpha smooth muscles with actin filaments, so lower contractile property is there. I'll be showing you, I'm not sure if you can see these, for some reason the images are not showing. Preetham, can you see the images here?
No, sir. There is a video, I think, sir. So you play it.
Yeah, I'm just showing, but can you see the video? I think there is a problem with the, this, 1 second. So, yeah, so maybe there is a problem in, this, the display.
Make it full screen, Saurabh.
Yeah, so I, somehow it's not showing. I just have a few cases of about 4 or 5 videos which I wanted to show, but it's not.
You can go to the folder and play from directly from there.
No, Saurabh, take your time. Take your time. So I'll just make a quick announcement that one of our speakers will not be able to join us. So that gives us a leverage of 8 minutes more. So it's each speaker can take about a minute or 2 more than the allocated time.
So I'm trying to just see the folder. I'm sorry about this.
Yeah, not at all. Don't worry. Swapnesh, I'm seeing Alok here. Alok is joining us then?
Morning, sir. Yeah, good
Good
morning.
morning, good morning. Oh, Alok, so you're joining us.
Yes, sir. I just requested.
Oh, great. So I'm reversing the bad news and giving the good news. Alok
Sorry, sir. There was a little confusion, and actually, I just checked with Pradnya.
Yeah.
All the messages had gone to her phones, so I could not.
No problem. Yeah, Saurabh, we can see your screen.
And can you see the figures there? I mean,
yes.
Yes.
Yeah.
Okay. So this is a case of, so I'll start with my cases. This is a case of ERM with macular pucker in the left eye. And I'll be showing my video. So you can see that this is a fairly chronic ERM, and the underlying retina is getting pulled when I, free the ERM. So the staining of the ILM and peeling the ILM, the overlying ERM comes off automatically, but there's a lot of traction on the underlying macula, and because of the chronicity of the condition. And then we have to stain, several times sometimes, because the overlying ERM doesn't allow the underlying ILM to be stained with BBG dye. And then air fluid exchange with C3F8 gas tamponade. And this is how the patient did, although visually she didn't really recover much, but you can see a fairly normal looking foveal architecture. This is a case of VMT. Pre-operatively, this lady had a vision of 636 spots in the right eye. I'll just quickly show you the video. So in this VMT, we have to be very careful that, this adhesion goes far out into the periphery often. So even creating a PVD, you have to be very careful. You can see the underlying retina being pulled up. There's a chance of formation of breaks. And then in the end, obviously, you do not induce an PVD as you normally do. We try to just trim and go around the attachments to the fovea. So you can see it nicely here with MIBS. I'm doing this 25 gauge. And the small port of the smaller gauge instruments, it really helps in shaving off the vitreous and then peeling ILM gently. In this case, I just, in order to not create a macular hole, I did an inverse flap over the foveal area. And this is what it looked like post-operatively, and the vision improved to 618. So in all cases of VMT, we do not have to intervene surgically. We should not jump the gun. You can see this patient with right eye 6/9 vision, and patient maintains this vision over 2 years despite the VMT. So we have to see the vision also. We don't have to treat the OCT. Another case in which, there was spontaneous macular hole closure with spontaneous PVD induction. So that can also happen. So it's a good idea to follow up these patients initially and then take a decision about surgery. So MIBS has revolutionized current VR surgery. Smaller port size with port optimization and smaller sphere of influence make these cutters more efficient, and multifunctionality, we all know about that. So this is a case of macular hole. I'll just quickly show this surgery, 27 gauge macular hole surgery. And in this, IVTA is essential because we know that there are abnormal vitreomacular adhesions. And we are doing a cabbage technique. So again, inverse flap. And I could manage this with the 27 gauge. Most of the posterior pole cases, because of the tool flex being not a major problem, 27 gauge is ideal for these situations. And this is how the patient did post-operatively with a vision of 660. I won't go into the theory details because we are running short of time, but 27 gauge MIBS, the cutters are very efficient because of multifunctionality and less leakage from sclerotomies. And this is my last case, which is a case of a 70-year-old male with vision of right eye 6/9, left eye 6/18, seen in February this year, diagnosed as PVD and ERM with lamella macular hole. So if you can see here very carefully, around the lamellar macular hole, you can see the inner retina, there is some epithelial proliferation. So this actually was a case of LHEP, which I kind of learned. So this patient progressed to a full thickness macular hole in the left eye, seen in October this year. And this is the surgery. So I learned that in case of LHEP, the diagnosis may not be made initially, and it's only intraoperatively sometimes that you see it. So nothing different as compared to a traditional macular surgery, but here is the difference. So there is this yellow tissue which doesn't stain, which is around the macular hole, and it is very tenaciously attached to the underlying macula. And with great patience, you have to tease it off and keep staining again and again because there are multiple layers of epiretinal membrane which keep coming off. But you have to be careful not to enlarge the hole. And then finally doing the ILM peeling. So this needed a lot of patience and in fact was a very long surgery. And you can again see that abnormal tissue around the macular hole, which was yellowish and was not staining at all. So this is how the patient came for follow-up on 28, just 2-3 days back, and the hole is closed and vision has improved to 624 in the left eye. But this was a case of LHEP and not just a macular hole with ERM. So I'm not sure if I have time, Dr. Preetham. Can I skip optic pit macular?
Yeah, I think, yeah, because we are running a little behind schedule.
Okay, so I will just skip this optic disc pit maculopathy. Just conclude that saying that combined vitrectomy with PVD induction with limited ILM peeling in the peripapillary area reduces both AP and tangential vitreopapillary traction and thus helps in the resolution of inner layer schisis and subretinal fluid. And avoiding ILM peeling close to the fovea decreases the incidence of macular hole formation in optic pit. Thank you.
Thank you so much, Dr. Saurabh. It was a very crisp and nice understanding of this important topic on macular interface disorders. Thank you again. And let's move on to the next speaker, and that's Dr. Alok Sen. all the way from Chitrakoot. Welcome, Dr. Alok. Dr. Alok is one of the founder members of the retina department of the great Chitrakoot Eye Hospital, very senior and astute clinician. I welcome him, and he's going to talk to us on coloboma retinal detachment. I would also like to invite Dr. Jagdish Loya from Aurangabad, who's just joined us on the chair. Good morning and welcome, Dr. Jagdish.
Good morning, sir. Good morning. Thank you.
So we can see your slides, Dr. Alok. Go ahead, please.
Thank you, sir, for the kind invitation and the kind words. You were one of my first teachers, in retina, and it's great to be presenting in front of you. I'll be sharing some of my thoughts on coloboma associated retinal detachments. So although it's rare, but important is that these detachments usually present in a very young patients, and they have a long life to live. And many of these patients are monoocular, and hence it's important that we know about these cases. Regarding embryology, we know that coloboma results from a failure of closure of this embryonic fissure during the 5th or 7th week of gestation, that is 14 millimeter stage. The most important aspect is the pathoanatomy at the edge of the coloboma, where the retina splits into two. The inner neuroblast grows over the colobomatous area and is known as intercalary membrane, while the outer layers, they roll and they are inserted into the RPE. And this area is known as locus minoris least resistancy, and is the site of breaks in coloboma related retinal detachments. So for a retinal detachment in a colobomatous eye, you need a break in the intercalary membrane as well as a break in the locus minoris, which can lead to a retinal detachment, as you can see here is first subclinical detachment, which is the OCT. The other mechanism in these detachment would be a peripheral retinal break, as in any other retinal detachment, that can, without any break in the intercalary in the margin, at the margin or the locus minoris, or a break in the periphery with breaks in the locus minoris without any break in the intercalary membrane detachment. And more commonly here, where you have a break in the intercalary membrane in the locus minoris, which leads to retinal detachment. So based on these, the detachment can be classified as type 1 and type 2. Type 1 is when the breaks are in the periphery without any intercalary membrane detachment, and the retina detachment ends at the intercalary membrane at the edge of the coloboma. And type 2 is when you have both the intercalary membrane detachment and the peripheral detachment. And of these, type 2B, and this is the classification which Lingam Gopal sir gave many years back, we are still following. So in type 1, you can still use scleral buccal and with good outcomes, while in type 2, usually you would like to do a PPV. The steps are essentially the same. Only thing that needs to be remembered is the sclerotomy ports. Even in severe microcornea eyes, you can still place them at 4 mm. Because the posterior segment is by and large well developed in these eyes. Lensectomy is required in most of these cases, as some of them will have early cataractous changes, and in severe microcornea, it is very difficult to spare the lens. PVD is usually absent and you need to do it. And in my experience, failure to recognize a PCV in these cases are a frequent cause of recurrences. In fact, this is a diagram which is from a review article published in Eye. If there is a break in the intercalary membrane and locus minoris, then you can easily drain from the colobomatous area. However, if there is no break in the intercalary membrane, then you might have to do a drainage retinotomy or drain from the peripheral retinal break. Lasering the entire edge of the coloboma is very important, and it is preferable to use a diode laser. I'll just show one video. I hope it is running. And you can see this is a type 1 coloboma. Sorry, sir. Yeah, the type 1 coloboma with the disc and the macula involved. You can see the intercalary membrane is also detached, and So what it is essential to get a PVD, as you can see, the PVD is usually not present in these cases. And here I'm getting, sometimes what happens if you use excessive tricot at this point of time, the tricot may seep inside or in the under the intercalary membrane detachment. So I prefer to lift the PCV initially and then put tricot if necessary. Peripheral base dissection, another part, is almost the same as you do in routine retinal surgeries. The facts, you can do it from the coloboma itself, and you can also identify the breaks in the intercalary membrane through which you can drain the subretinal fluid, as you can see in this case. Once the retina is settled, you start doing lasering of the edge of the coloboma, and usually, as I said, we prefer a diode laser for this. At the edge where the fovea lies, you can use low power setting and single row so as to avoid collateral damage, especially in type 1 cases. And finally, you put in gas. I'll skip the other video. So the outcomes, overall outcomes and success rate lies between 80 to 85%. And as I said, the most important thing is to ensure complete removal of the posterior cortical vitreous, which can prevent recurrences. The functional outcomes, although are guarded, but often gratifying in a monoocular patient. Regarding prophylaxis, there are a couple of papers which have suggested that prophylaxis of laser, prophylactic edge is helpful. However, these are small case series and short follow-ups. There are a lot of difficulties in doing prophylactic lasers, especially in children with nystagmus and other. So in our setting, what we do is, in presence of ICMD, if the other eye has detachment, or if there are cystoid changes at the edge of the coloboma that can be noted on OCT or a subclinical detachment, we usually do lasers to this eye. I thank you for your kind attention, and I acknowledge all my learnings from Dr. Lingam Gopal sir. And if you want to go through in detail about coloboma, this is a comprehensive, very good comprehensive review in eye that you can refer to. Thank you so much for the opportunity once again.
Thank you, Dr. Alok. A very refreshing presentation, an overview of coloboma, very nicely given. Thank you again. So before we move on to our next speaker, maybe I can take a few pointers from our chair, Dr. Lalit sir. Maybe if you have something to comment on as far as coloboma is concerned. Dr. Jagdish and Dr. Dipti also, quick words on coloboma RDs and how some tips from your sides. And in the meantime,
very nice presentation, Alok, and very nice points made. I don't think so I need to add anything in Alok's sense, but if you allow Saurav Luthras, I can,
Yeah, of course, sir. Please, sir. Please.
So Saurav, again, very nice videos. I would have loved to see the optic pit maculopathy also, maybe some other time. The only small comment I had was that I'm not very aggressive in patients of pure VMT regarding ILM-PE. Because VMT is, I feel, is a slightly difficult surgery compared to a macular hole surgery. So in a pure VMT, I may not be very aggressive to, because all of us are addicted to get the ILM out in all the patients. But my personal I'm not very aggressive in pure VMT. And also in ERM surgery, by and large, if the ERM what you showed were very, very densely adherent, by and large, a lot of times ILM may come out patchily also at that time. So these are the two comments I wanted to make, but excellent videos, Saurabh, as usual, you have shown. And the prognosis in VMT, by and large, patients do get rid of the metamorphopsia, because that is number one indication in VMT where we intervene. And as you rightly said, we do not advocate or depend on this funny treatment oculoplasm which had come, although pushed by in US, but to our thinking, it's not only costly, one injection is very expensive. And MIVS small gauge does wonderful results.
Thank you, sir. Yeah, thank you, sir. And I agree with you that in all cases, we do not have to be aggressive with the ILM. In that particular case, there was a lot of, distortion of the macula, and there was an ERM also. So I thought that, I will remove it. And in those cases in which I do remove the ILM, I tend to make an inverse flap. Nowadays, since we prefer to do inverse flap, so even if I have created a micro hole or there are chances of de-looping, I would, put the ILM over the fovea. So that would kind of, take care of that. But I agree with you that we should not be over aggressive in cases of VMT. Thank you, sir.
Another very good point you made was that foveal sparing PHF peel in VMT is often rewarding.
Yes, sir.
Hi, Dr. Ragini. Ragini is sitting quiet. How are you? So I think, Preetham, we can move on.
Move on. Yes, yes. So Prashant, are you ready? Dr. Prashant Bawanpure, sir?
I'll be sharing his video.
Okay. And he'll be speaking. Na? Okay, so I would like to invite Dr. Prashant. Dr. Prashant Bawanpure, everybody knows he's the star vitreoretinal surgeon from Nagpur, a very flamboyant surgeon, a fantastic teacher and a mentor to many of us. So I would like to invite Dr. Prashant, and he's going to speak on vitrectomy in diabetic retinopathy, one of his favorite topics. Go ahead, Dr. Prashant.
Thank you, Preetham.
Prashant, you're not audible.
My video is with, I think, Swapnesh. She's playing.
He has started it. We can see the video. So,
Swapnesh has to play it. Swapnesh?
Yes. He has already started.
It's not audible?
No, go ahead. You're audible now. Go ahead.
No, but no, this is
video. Video has a sound. Video
has a sound. Okay.
Okay.
So, Pnesh, as soon as you start sharing on the lower left, you have to, click those two buttons. You stop sharing and reshare again. Once you start share on the lower left side, you have to.
Good morning, Dr. Verma sir. Namaste. Please take care of yourself. Dr. Vende sir, good morning.
Good morning.
Good morning,
Good morning, ma'am.
Good morning, Saurabh Bhaiya. Good morning.
And advance Diwali wishes to you also.
Thank you.
Yes.
To all of you.
Thank you, sir. To you too. Have a happy, safe Diwali and
Thank you. Thank you.
Can you listen? Audible?
Yeah.
The video was not audible similarly when we did with Dr. Bhoma sir's presentation. So I think Prashant sir will have to talk because even the last time we were...
I will try sharing my screen, sir, madam, please. Swapnesh, you stop it for a while.
Okay.
Hi, Dipti.
Hi, ma'am. Good morning.
So Dipti is the dynamic young counterpart of Preetham, then Swapnesh, and now Dipti.
So I would like her to moderate, this session then.
No, sir, when you are there, she doesn't have to do anything.
Now onwards, she should, young people hearing is, often very fruitful.
When you are there, she is just there to facilitate.
So we don't want to look down on the pearl.
Often,
yes, ma'am, absolutely. When the bosses are talking, we better gather the pearls and give out some ourselves.
She is there so that she can learn from you all.
No, Deepti, I differ because a lot of our learning is from our colleagues, younger colleagues.
5% cases develop complications of diabetic retinopathy, warranting vitreous surgery.
Is it audible now?
Yes, absolutely.
Yeah.
Now it's not audible, Dr.
Prashant, it was audible in the beginning.
Don't mute yourself.
Instrumentation.
Yes.
Okay. Of vitreous surgery. Control of systemic diseases not only prevents intra and postoperative bleeds and complications, but more importantly, prevents serious adverse event, which is associated with proliferative diabetic retinopathy because there is an associated increased risk of all causes of mortality. Preoperative laser not only helps you in reducing the vascularity and thereby intraoperative bleed, but it also anchors the attached retina. It eliminates the tractional retina detachment and has less postoperative inflammation because of the reduced levels of IL-6 if these lasers are done 3 to 4 weeks ahead of the surgery. Preoperative anti-VEGFs definitely reduces intra and post-operative bleed, but beware of the crunch phenomenon and development of denser fibrotic connection between the retina and fibrovascular tissue, especially so with Avastin compared to Macugen or intravitreal dexamethasone implant. Cataract is a comorbidity of proliferative diabetic retinopathy. As well, vitrectomy increases the risk of cataractogenesis. Therefore, combining a phaco with vitreous surgery can be considered with proper understanding of advantages and disadvantages of a combined procedure. Conventionally, vitrectomy is done at an IOP setting of 30 mm. In diabetics, it is advisable to operate at an IOP setting of 20 mm or less, that is physiological IOP, as the disc is at risk, especially in a juvenile diabetics, and diabetic retinopathy is an ischemic condition which exacerbates because of the high IOP. This is the video showing the vitrectomy done at a setting of 20 mm of mercury. Infusion cannula placement is essential, and confirmation of infusion cannula in a media which is hazy because of a vitreous hemorrhage is essential. You need to clear anti-vitreous before you put on the infusion cannula in such cases. Differentiating an old vitreous hemorrhage from an atrophic RD is difficult preoperatively because of a B-scan. It simulates like a RD, as well as intraoperatively. The key here is to do slowly vitrectomy in the nasal quadrant, and then you see the egress of a subhaloid hemorrhage. And once you can see a retinal blood vessel, as you can see in this particular case, then you are sure it's not a retina, and then you can boldly proceed. Hemorrhage in the Burgess space occludes the posterior view and needs to be removed. Here, after doing an anti-vitrectomy, with the help of a cutter, you have to use a suction to pull off the clot away from the lens and then cut it slowly. And at the last, you have to exchange the hands so that you do not touch the lens. Most important step in a case of a vitrectomy is the indication of vitrectomy. But here, posterior vitreous detachment is virtually absent in almost all diabetics. And here is the importance of removing the attachment of vitreous to the posterior membranes, and that is called deepening or truncation. Here, all 360 degrees, I'm cutting the vitreous attachment to the membranes, and that is essential before you even think about doing a membrane peel. The another challenge here is about the vitreous crisis. The vitreous has multiple membranes. I have done the vitrectomy, and as you can see, there is another thin membrane over here, which is looks like a retinal detachment. But the clue here is there is no blood vessels, and once I'm sure that is not, I cut it more so with the help of the vitreous cutter, and then you can peel off the vitreous crisis membrane. Very rarely you can achieve a PVD like this in the cases, especially so in a case of a well-lasered eye where you have small polyps, and a PVD induction can lead to membrane peel or a peel of the flat small polyps. And this, which might have been the reason for recurrent hemorrhage on and off as shown here. In this case, you have a thickened posterior hyoid, and behind it is the hemorrhage, that is pre-retinal. Here, I am attempting a pre-hyoid separation with the help of a bent 23 gauge needle, or you can use any peak to achieve that. And once that membrane is thickened, posterior hyoid is removed, then the clot comes out so easily. Membrane dissection is essential, which is the reason for tangential traction. It can be achieved by using techniques like segmentation, delamination in block, or with either a unimanual or a bimanual approach. Here in this particular video, I'm doing a segmentation. I'm cutting the two ends of the tissue and relieving the traction which exists, tangential traction between. Here again, I'm with the help of cutter, I'm cutting the membrane and cutting it into small segments. So you have to cut it into small segments before you try to peel it off. This is a lift and shave technique where first you peel off the attachment from the retina a bit, create a space, then you introduce your cutter into that membrane, engage that tissue and lift it and then cut it with the help of vitreous cutter in a single go. This is lift and shave technique. In a reverse Swiss roll technique, here the cutter is placed on the surface of a membrane with its opening towards the edge of the membrane. The advantage of this technique is that rarely you can have an incarceration of the retina into the vitreous pore and thereby avoiding microgenicity. Lift and shave technique, you have to lift, but in a thin atrophic retina, it can lead to development of break. And this is the limitation where you should think about using a bimanual technique, where I'm using a cutter for this. Bimanual segmentation or a delamination technique. Here are two techniques. In one video, I'm using a cutter, in the other. Here a chandelier is used to illuminate the whole vitreous cavity. With one hand, you use a left hand, you are using a forceps, and the other hand, you are an active instrumentation in the form of a vitreous cutter or a scissor. This is an old thin atrophic RD across the posterior pole. Here, I'm holding it with one forceps, and with other curve, I'm moving ahead and removing the membrane, and as you can see the completion of the membrane over here without even a small break. This is the beauty of bimanual technique. Well, these membranes can be approached outside in or inside out, but most of the times it is the combined approach. What is inside out? In this case, you start peeling the membrane from the disc and the macula towards the periphery. Here, I have peeled off over the disc and then slowly proceeding towards the periphery. And you can see employing various techniques like segmentation, delamination, and achieving that membrane in total. In an outside-in technique, after deconing or the truncation of the vitreous, here the membrane is being pulled in the direction from the periphery and slowly approaching the disc. And in this particular technique, as you can see, the last part of the membrane which will be removed will be over the disc and the macula. And this is what is outside it. But in majority of the cases, you have to use a combination of this. Another important thing in a case of a diabetic retinopathy vitrectomy is second membrane, existence of a second membrane. This is a thin flimsy membrane which extends from the beneath surface of a main membrane towards the periphery and anchoring it there. So if you try to peel the main membrane, it can lead to development of breaks in the periphery because of this second membrane. So you need to identify this second membrane, first peel it off, detach it from its connection, and then only try to remove the main membrane. Bleeding is more common in a case of vitrectomy for proliferative diabetic retinopathy, and here the blood is more sticky and it tends to form second membrane on the surface of a retina. Various techniques you can employ. If there is a more bleed, you can use a bimanual technique where under illumination of a chandelier, with one hand I am having a fluid needle where it is helping me with blood which is pouring into the vitreous cavity and thereby allowing me to see the bleeder, and with the other hand I am using a cautery. So this can be of help when the bleed is incessant, not giving you a great view. Yes, sometimes a bleed can be really very bad. It can mess up all the beautiful work of a membrane peeling. As you can see in this particular video, I've done a beautiful membrane peel and I'm almost at the end of it when the bleeding starts. And then I had to use a combination of cautery, then I had to use air to achieve hemostasis, then I had to use PFCL to flatten the retina. And at the end of a struggle of more than 40-45 minutes, I could achieve a flattened retina. And this is what can happen if there is a big bleed. And so never let the blood accumulate at the posterior pole. When you are peeling a disc neovascular polyp, it can lead to bleed. Because of the avulsion of the retinal blood vessel, you cannot use a cautery here. Well, I'm using intermittently the pulses of high IOP as you can see here, but still not achieving. Then I finally use a forceps, blunt end of the forceps to press the bleeder, and under high IOP, I could achieve an hemostasis and a clot at the posterior pole. Subretinal fluid needs to be
Prashant,
as well
Yes,
as the
yes.
long-standing
Prashant. So maybe if you can conclude in a minute or so.
Yeah, I think
So
it is last 1 minute.
Oh, great. Okay.
use here is the fluid exchange, and you can see that beautifully that an extrusion of the SRF. Majority of the fluid you should do remove subretinal fluid and the fluid exchange, and later small part you can afford to do with fluid air exchange. Lasers as an indication, hydrogen gas and silicone oil can be used. So to summarize, early vitrectomy in proliferative diabetic retinopathy is the way to go. Conservative management in a case of a diabetic vitreous hemorrhage should not be more than 4 to 6 weeks, and that too with serial B scan looking for traction. Pre-operative anti-VEGF definitely reduces pre and post-operative bleed, but beware of the crunch phenomena. The first step is deconing or truncation of vitreous attachment of membranes during vitrectomy, and after deconing, membrane peel can be done by using various techniques, either segmentation, delamination, block membrane removal by either inside out or outside in approach. Always look for a second membrane. Hemostasis should be done timely, else sticky membranes can create a lot of nightmare for you. Most importantly, patience, persistence, skill, technique and instrumentation is key to success in the case of diabetic retinopathy. Thank you.
Thank you so much, Prashant, for a fantastic overview of this, diabetic vitrectomy, which no matter how many cases you've done, it always throws up a surprise one fine day in your surgical OT. Before I move on to the next speaker, maybe 1 or 2 comments if I can have from the chair and our senior panelists, Dr. PB sir, Dr. Lalit Verma, Dr. Jagdish, please, you can also join in.
Fantastic, Prashant. You have not left even one step which I could think of. But only conclusion would be that no two diabetic vitrectomies are same. So if you've done one good, next you prepare that it may be bad. And I believe one challenge we have heard, the two main challenges in VR is one is diabetic and other is ROP, which we'll hear from the master just now. Only 1 or 2 points. You see, pre-op stoppage of this thing in a angry looking diabetic, I am slightly still fond of it, that I will stop if the person is on 2 anti platelet agents. Because I have had one episode where could not get controlled. So from then onwards, I have made it a point that make it, because I missed that history. And second point is extensive laser is at the end of surgery in all proliferative has to be part of all diabetics. And all the techniques you have shown very nicely, and I'm very fond of that lift and shave technique, which you said that I mostly do that. And also you made a very nice comment about how to clear the anterior budget space that suck and then make it slightly safer to do the vitrectomy. And bimanual has a definite role. I believe we should switch on to bimanual, especially in the membranes which are stuck at the arcade.
Thank you, sir, for your time.
Thank you, sir. So now moving on to the next one, and that is by none other than Dr. Pramod Bhende, sir. We all know him. He's lovingly called as Dr. PB, sir, by all his students. And he's today I stand tall because he's also been my guru and mentor. Dr. Pramod Bhende, sir, the director of retina services at Shankar Netralaya, and he's going to speak to us on retinopathy of prematurity surgery, the tricks and tips. Sir, your floor is yours, sir.
Yeah, thank you very much, Swapnesh and Pritam, and good morning to everybody. So my slides are seen?
Yes, sir, we can see them.
Yeah, okay. So it's you may feel it's like a disjointed, but I'm just sticking to some tips and tips, not going to like conventional presentations. So basically, when not to operate, let's put it. When baby is having a leukocoria since birth, you just understand ROP is never be there at birth. So it's developed later on. And if you have a leukocoria since birth, that means you are not dealing with ROP, dealing with something else. Again, full-term infant with stage 5 like picture, unlikely you are dealing with ROP. It has to be something else. You look for it. Basically, diagnosis and prognosis, all this thing is important, particularly when I'm talking about parents and counseling comes with it. Well, there is no specific age when you should operate or should not operate, but generally by age of 1 year, long prolonged detachment, if it is there, prognosis is really bad. Otherwise also, and even if you somehow manage to settle retina, you are having a dealing with a like unhealthy retina, you are dealing with unilateral aphakia. So overall prognosis goes down. And as I said again, associated corneal haze, already falciform fold with no active disease, and if very florid disease, particularly very florid disease, not a contraindication, but you anticipate a lot of bleeding. So probably I would prefer to delay the surgery, wait for a month or so and take the baby for surgery, because delaying, yes, compromise the visual outcome, but intra bleeding risk you definitely minimize. Otherwise, most of the time you will just land up abandoning the surgery. Now, again, if axial length is too less, or you have extensive subretinal echoes indicating that subretinal heme, again, they are bad prognostic sign, and close configuration is bad prognostic sign. We do operate few cases, but majority people now stop operating if you have a close configuration. Well, the common surgical indications are stage 4A, 4B, and stage 5. And as I said, below 1 year, generally we take them for surgery. Otherwise, excluding other contraindications. When you should do resurgery, particularly when your primary surgery was okay, or you have minimum residual traction left, because that's particularly something like case this where surgery was done, and when patient came back 6 months later, most of the retina was settled, but there is some bridging traction holding it on. Just what I need to do here is just go in, nick this part, open this fold, and probably macula is already down here. You'll get a better vision. These are the eyes generally. Otherwise, as a routine resurgery generally is not recommended in ROP eyes. And cases where you have delayed onset RT, something like that patient was holding very good and suddenly come with a regmatinous component, sudden loss of vision, and land up with basically change in a visual behavior. And these are the eyes, again, something we post-surgery settled retina, but the pale disc, all this sclerosed vessel, but patient is maintaining 660 vision in this scenario. So it's worth operating this type of, and particularly most of them are single-eyed patients. So surgical options would be scleral buckling, lens-sparing vitrectomy, combined lensectomy and vitrectomy, or you can add on even scleral buckling along with that. The different combinations you can use. Now, thorough systemic evaluation is important. You need a good anesthesia team to handle these babies, and NICU backup is definitely necessary. Preoperative bronchodilators definitely help to prevent bronchospasm. And what we do is most of the time, trolley, I use a higher one, because what happens here, lower trolley routinely for other surgery we use, and babies are at head height will be much less. We have sometime microscope, you just cannot bring it down enough to focus it. Particularly those are having a roof mounted microscope. So just these are small things, but make your life easy. Just use a little bit higher trolley so you have a better focusing options available. So indications for scleral buckling, basically when you have a peripheral traction, that's what you can use. Techniques is not different, and you can use either encircling band, or you can have a segmental buckle if the traction is localized in a periphery, and mostly you aim to support the reach where the traction is. So certain precautions, I say technique is same, but precautions what you need to take is like a sclera is very thin, palpebral pressure fissure is very, very narrow, and so there is a high risk of, difficulty in placing the buckle, and there is a high risk of ocular ischemia as well. And because with the buckle placement, lens iris diaphragm moves forward and already a shallow antechamber, these eyes have a going into a good closure, angle closure attack. So you need to monitor these eyes very well, and in an early post-operative period, and also need to monitor vital signs because of GA. They are known to go in apneic spells. Well, when you combine buccal with a vitrectomy, something like that, if you have a posterior traction and you have peripheral traction, now to relieve peripheral traction, definitely you will sacrifice the lens. So to avoid that, what we do now sometimes is relieve the posterior traction with vitrectomy, and then peripheral area, you support that with a buccal, and select group of cases, they do very well. So coming to lens sparing vitrectomy, like about size of gauge, there are no specific guidelines, but I think surgeons' comfort is very important, and availability of instrumentation, that's a second factor which brings into attention. And if depending on pathoanatomy, suppose you have extensive dissection you want to do, probably you would prefer 25 or 23 gauge. But if you have a dissection very minimal, only posterior pole, some attachments, and you want to just trim those out, probably 27 gauge can be used in this case scenario. What I want to attention is our trocar cannula, they are long enough. And if you directly enter using the system, sometime with anterior retina, what you land up into here also, as you see, I hit the lens, I hit the retina directly, created a heme. Unfortunately, I was lucky in this case, particularly if you can make out here, there was an opening in the posterior hyaloid. I just missed the retina somehow. So you have to be extremely careful when retina is in mid-vitreous cavity and using our conventional length of trocar cannula system is being used. So we have a shorter instruments available now. We have 18 millimeter 25 gauge, where because of instrument are shorter, they are stiffer and the risk is minimized. Only problem is when a cannula which comes with it, you have to stitch to the sclera like what our conventional 20 gauge system used to be. You cannot just go with a direct trocar cannula system. But otherwise, they are definitely much more helpful. But even conventional system, if you want to use, what you can do is don't go full length. You go a partial thickness. Once you negotiate the sclera and choroid and your cannula tip is inside, you stop there, hold up your trocar in place and push cannula in so that you don't go and hit somewhere away from it. So that way you can still protect and you can manage with having our conventional system. Do not have to buy a separate, like a smaller, shorter instrument. Yes, sclera is thin, almost 0.6, 0.4 or 0.6 millimeter. So biplanar incision practically not possible. And because low rigidity and thin sclera, the chances are their instruments can keep on popping out. Your cannula can keep on coming. You see here, infusion is caught between the lead and because small palpebral fissure, and it is coming out. So, and when you are concentrating on surgery, you can miss all those things. So keep in mind and keep on constantly looking for it so that you won't miss them. Otherwise, you miss and sudden hypotony, you will end up in a problem in this type of situation. So visualization, yes, like a broad like your wide angle visualization system. These are the two images just to show the same eye. Here I use a Landis lens. You see, use a biome, difference, peripheral laser, everything can be seen here. And here you just had a posterior pole view. So definitely wide angle system is beneficial when you are using, particularly being a smaller eyes. So, but practical difficulty is when you use a biome or resight, the lens, the condensing lens is a little bit larger and your sclerotomy being close to the limbus. Sometimes when you straighten the instrument is okay, but when you start going beyond, you have an instrument hitting to the lens and you intermittently lose your view. So be careful with that. So you have other difficulty like reaching the 12 o'clock area, vitreous around sclerotomy. Sometimes your anterotactional retinal fold, close proximity to the lens. And this eyes, if you use a trocar cannula system, because the 4 millimeter length of cannula is not that easy to approach this area, and to avoid those or to get rid of this, probably what you can do is use a sclerotomy, what we used to do previously with a 20 gauge, but using 25 or 23 sclerotomy, direct sclerotomy opening conjunctiva, no cannula is used, so that you have easy access to the extreme periphery, as you see here. And particularly reaching a 12 o'clock area is much easier that way, and still you may be able to manage without sacrificing lens. So yes, the pulse pressure is low in this eyes, and conventional 25 or 30 IOP, if you maintain, what you see is sometimes a pulsation of the vessel. So you please reduce the infusion pressure while operating these eyes, and particularly when you see the infusion like pulsations. Tricot definitely help. Vitreous sometimes is very clear and very difficult to see. So to achieve good debulking, tricot definitely can be used. You may not be able to induce PVD in most of the cases, but occasionally what you see here is you have a time like you can, as much as something you are lucky enough, you can get a PVD here, but you need to be extremely careful. As much you can induce, fine, be happy. Don't try to go on extensively or aggressively as you do in other PVR cases. Otherwise, you can land up in a trouble. Now, I think with the times, because basically just quickly, I'll summarize basically where to make a sclerotomy when you use a stage 5 ROP. I would say, look at particularly this first video, where how far anteriorly retina is pulled. On the table, I just make that assessment. And depending on that, I decide whether I should go through the limbus. Of course, AC maintainer is helpful to maintain the IOP throughout surgery. So go through the limbus, or just behind the limbus, or go through the clear cornea and through the iris route, okay, or just over the iris and then plan the dissection. So case to case, you take a call. So this decision generally intraoperatively. Basically, what you want is that entirely full retina and your instrument should not be going through the retina. You finish the case actually at that moment only before actually you're starting the case. Just I'll stop here now. To summarize, vitrectomy forms an important surgical intervention strategy. Scleral buckling still has some role to play in select group of eyes. Lens sparing vitrectomy helps to achieve a potentially useful accommodative vision at a critical period of visual development. And tricot offers the benefit of better visualization of vitreous and hence better release of traction, and shorter stiffer instruments offer better and safer approach to the peripheral retina. Okay. Thank you very much. Maybe remaining part, if you have some question, we will discuss if time permits.
Thank you, Dr. PV, sir, for a fantastic overview of retinal surgery vitrectomy in ROP. I have a question myself, of some difficulties which I have faced in the recent past. Many a times you achieve hemostasis in these cases, but what happens is you think you achieved hemostasis, but there is a lot of bleeding in the post-operative period. And since you've left back a lot of vitreous cortex, this blood sticks to the vitreous cortex, and eventually it again the retina lifts up and the eventual prognosis is bad. So is there, like how in diabetic vitrectomy, sometimes we leave back oil just for the for compartmentalizing the blood. So is there any role of a tamponade in these cases, just for achieving that?
Yeah, probably not, because when you're not relieve the traction and if you add on air bubble or gas bubble, okay, so you are stretching the retina further. That is one thing. And this already cut vitreous, you induce a surgical trauma, inflammation, and that also adds on further contraction. What I would do, because it's a common problem, what you said, all of us face. So during surgery, you maintain IOP 25-30, but ensure while closer, I would go down up to 20. Because what happened, once you remove these trocar cannulas, there will subtle leak always will be there, and pressure goes down with the roll, clear rigidity. There is a collapse sometime, and there is ooze later on. What you see next day or subsequent day, you have blood clot there. So with the low pressure around maybe 20, if it is not oozing, you ensure before close your sclerotomies, then they are less likely that you will end up in a bleeding lateral. Yes, if blood clot is there, you give some time. This blood eventually will get absorbed, but because vitreous mixed blood is going to take a much longer time. Probably rare circumstances, what I did is waited for 3-4 weeks, 1 month, and then took the eye for resurgery second time. So probably part of it is already separate, but there again, the aim is to just whatever little bit debulking, you go forward and come back. Don't do too much of things. The moment you create a break, we are lost.
Right, sir. I can see, welcome Dr. Shubhadra Jalali, madam. Madam, we know the volume of work in ROP that you have, such a large volume of work. Any words from your side? We were discussing ROP surgery.
I can only say one thing. Please do ROP surgery. When I started, people thought that it is something which only few people can do. If I can do, I'm not the best surgeon in the world. I can tell you that. I'm a very poor surgeon. And people can do amazing surgeries. The more we do, the more we learn. I have stopped doing adult surgeries because I have so many pediatric surgeries. And the more I'm doing, the outcomes are so good. You will see some of that in the next session. But when I started, there were so many patients, I was so scared to touch. Then I said, okay, I'm going to do surgery on everyone. Everyone who comes and is willing to be under my knife, I'm going to do. And the more I did, the more I realized that it is not the pathology, but it is our mindset to tackle that pathology, to understand that pathology. We can do it. Everyone can do it. And now all my fellows, in the first 3 months of their posting, they learn lens sparing vitrectomy. And then as they progress, by the time they finish their fellowship, they're all doing stage 5. Everybody is doing.
Thank you, madam. Thank you for the words of encouragement. Yeah. So shall we move on then?
Excellent words of wisdom, Subhadra. A lot of people are hesitant to touch.
So moving on, the last presentation, and it's none other than Dr. Lalit Verma sir himself. And to his true iconic nature of being a teacher, he's chosen a topic, infusion cannula not seen. It's an amazing topic to choose, sir. You would like to hear your
So this is
talk on
one of
this?
the most basic topic I have chosen because I recently, a couple of months back, had a nightmare. So I thought I'll share with you. A couple of months back, I had this issue. So as I said, no two VR surgeries are same. We have to struggle virtually every day, but it's worth it. That's what I was saying. At times we are caught in a catch-22 situation, and any awkward movement may result in loss of that eye. So we have to be aware of that. You see, this struggle is only known to people who are VR surgeons, who fight for success in every surgery, and nobody else can understand your this problem. This slide is not moving. Something has happened. The slide is not okay. So as I said, no one can understand our pain or stress except a fellow VR surgeon. So in all surgeries in MIVS, we insist that cannula is first in and last out, and we always confirm. Bhavan Kule also stressed this point in diabetic vitrectomy, and we do this day in and day out. But there are some situations mentioned here, like bullous RD touching the lens, or where choroidal thickness is more, like in hypotony, uveitis, and of small pupils, and when RD plus CD is there. We have to be careful and preoperatively plan in such a way. So this was this was a couple of years back, in fact. This was a patient who had end off actually. So you did not see this tip of the cannula. So obviously before you start the infusion in this hypotenuse eye, try to depress and clear the whatever tissue is there in entangling this. And before that, you cannot start the infusion, or you have to use an AC maintainer for some time and then come to the pars plana infusion, and should not turn it on. Like you see this with the help of cutter, I'm clearing the muck here. This was another patient, hypotenuse. So here the pressure was so low that two things I did. One was needle infusion just to firm up the globe, and second was this straight entry by 6 millimeter cannula, which is often I do in patients who have hypotony or a endophthalmitis. So this is one, couple of months back, I encountered this relatively young patient, decreased vision in the right eye. Anterior segment examination, we had evidence of uveitis plus early cataract. Retina had a predominantly nasal detachment. Macula was not detached. Vision was 6/60. So we started with the conventional MIVS, as is shown here, made it biplanar entry. I should have gone straight, but made it biplanar. But I did confirm, as you see here, and cannula was inside, started doing this vitrectomy. But notice this illumination is coming through the retina, and retina has become bullous, which it was not at the beginning of surgery. Still continued because what I thought I will not frequently exchange these instruments. So there was this couple of adhesions here. You can notice some breaks in the inferior part, which was the cause of RD. And injected PFCL at this time to try to complete the vitrectomy and the membrane surgery, whatever was visible. So at this point, I shifted the illuminator probe, and suddenly we could see very brightly everything. The upper nasal illumination. Very, very basic step, but should be carefully done. And then did all possible measures to tackle with the PVR and all the membrane surgery, freed the retina, and carried on. And once the retina was sufficiently mobilized, started the airflow exchange. And PFCL is getting removed at this stage. And once I turn down the air, you see retina is becoming balloonous here. You see this air has come subretinally in the upper temporal part. Notice in the upper temporal part. Because I think the infratemporal retina became subretinal at this stage. So then shifted this also. And this time it was a straight entry, not a biplanar entry. You can see the signs of uveitis here very well. So now I have virtually 5 ports in the intravitreal cavity. And then as soon as I started this, then took out the subretinal air, which came out. And then did the conventional air fluid exchange, followed by retina settled nicely. This was at the end of surgery, put in oil because there are multiple breaks, one iatrogenically created, others were pre-existing. And then fortunately finished the surgery and came out. Did not touch the lens, did not take out the scatter at this stage because most of the job could have been done. This was the post-op period. Fortunately, retina doing well. Patient recovered 6/18 vision. These are a couple of shots I took from the video operatively. So there are some red flag signs even in the hands of the experienced people. Always ensure tip visible, which we always do. And if the illumination is less than what you are used to, beware that this illuminating cannula is good. And if the retina suddenly becomes balloonous, operatively also it can go, so the cannula can become subretinal, and air goes separately, you are 100% in trouble. So always perform an inlet just before start of surgery. Also, in this patient, what had happened was I had seen him a couple of months back before surgery, so did not re-examine just before surgery. So saw on the table itself. And however, if subretinal happens, maintain your calm. Do not do jerky movements, and frequent exchange of instruments should be avoided so as to avoid all sorts of issues. And can change the ports in relation to this bullous retina, and preferably instead of making two-step or angulated, go straight in and vertical. That helps, especially in eyes who have these issues of hypotony or CD or choroid is thickened. This should always be done that you have a straight entry rather than a bibrary. This was the basic, very basic thing I thought I'll share with you. Thank you very much for kind attention.
Many thanks, sir, for covering such a basic topic. I have a practical point to make here is, many times the OT staff who assists us, you can use them also to ensure. And, I have made it a point, to impress on them that this particular step is important. So whenever I swivel my biome into place, my OT staff always says cannula check. And believe it or not, on a couple of occasions, I have forgotten to check the cannula, and because the OT staff has told me, I've checked it at that time and seen it in the subretinal space. Yeah. So that is just one point which because they will reflexively, they could be attentive when you're not.
Yeah.
So this is one point I thought I'd make.
Agreed. Importance of having a good assistant. That's very good thing. And another thing,
yeah, please.
One more thing. Yes, one more thing to add on here, sir. Actually, a couple of weeks back, we had a similar class. We wanted our new joint consultant to just basically take class only for that, because they read for it and they know the importance of this. Because detached pars plana, where can easily miss. So unless you are specifically look for, particularly chronic arteries you are dealing with, and invariably you will end up having your cannula in a subretinal space. And younger, when you are inexperienced, you want, because self-sealing sclerotomy, you don't want to put suture, so you want to try to go more and more oblique. Okay? And that's the reason what Dr. Lalit says is very important. Don't go too oblique. Anything excess is bad. Just be in moderation and ensure, if necessary, don't mind going straight and suturing it rather than having too oblique and can create a problem.
Yeah.
So I think with that, we'll conclude the surgical retina 1 session. We have surgical retina 2 following this. And I'd like to thank all the chairpersons and all the stalwarts here, Dr. Lalit Verma sir, PB sir, Dr. Bhavan Pure, Dr. Jagdish Loya, everyone, Dr. Saurabh, thank you. And
thanks to MOS, Swapnesh, Preetham, and the entire committee for this early morning session on surgical retina. Thank you very much.
So Swapnesh, thank you, sir. Swapnesh, you can kick off the surgical 2.
Sure. So it's my pleasure to invite the chairpersons for surgical retina 2. And we have a galaxy of stars and stalwarts. The chairman for the session would be Dr. Pramod Bende sir. Co-chairman would be Dr. Natarajan sir. Convener Dr. Bodse sir. He's having a technical issue. He's trying to log in. So I'll request Dr. Preetham to stick around, and I would be moderating the session. So without much delay of time, I invite Dr. Pramod Bende sir for his topic, surgical management of endophthalmitis. I would be too small to introduce him, as he is my teacher, mentor, guide, and I have two teachers in front of me, Dr. Pritam sir and Bende sir. I would just like to refresh a memory that even after doing 10 cases in a day, tired at the end of the day at 7 o'clock, he will still look at his fellow, and he actually taught me how to hold the endo laser probe for the first time. How should be the wrist position? How should be the elbow position? Even at the end of the day when he's totally tired. So he's the teacher of teachers. So it's my pleasure to welcome you, sir.
Thank you, Sapnesh. Thanks for kind word. And it's always pleasure to be here. And MOS is like you have a still. I though I spent 30 years now in Chennai. I just look back now, and I still feel I'm still in a Maharashtra. So it's always MOS and VOS is a part and parcel of justice. I can't miss that one. And it's again, it's probably it's a mutual always, Sapnesh. Nice to have a student when you feel really proud of Pritam, and when you look at it and you take back is like, yes, that is what satisfaction you get as a teacher. And when you see a student like you people, both of you. Yes, coming back to topic, we'll start like a case presentation. This is a 68-year-old female, had a phaco done elsewhere, diagnosed as endophthalmitis on third post-op day, got intravitreal injection, refer for further management, patient underwent. This was a finding on examination. Section was open. Basically, it's a ragged section. Rather than phaco, I would say the way it was looking like, though history says phaco, it was looking like a SICS ragged section. And sutures were not proper. Section was partly overriding, open, IOL was unstable, exudate in AC and hypopia. So we did a wound repair, vitrectomy, and IOL removal. Culture grew gram-negative bacilli, and this was a post-op day, reasonably acceptable outcome with the anterior chamber looking better now. Of course, congestion will take longer time to settle down. Another case, 57-year-old male, had a cataract surgery 1 week back and then reported with a massive exudation in the anterior chamber and congestion. Section was reasonably okay, holding on. And we did a vitrectomy and IOL removal in this eye, culture grew fungus. And this is like after your AC was subsequently, second zone and intravitreal variconazole. Patient did respond, have a little bit hypopia, but eventually did well, but the persistent hypotony was the issue later on in this eye. So coming to surgical management, I'm just sticking to most of the surgical part. I'm not going back again, all definitions and everything. So intravitreal antibiotics is mainstay of management when you're dealing with a post-operative endophthalmitis. And generally severe cases, vitrectomy was indicated. So early vitrectomy or immediate vitrectomy you plan when there is no response to medical treatment, when the visual acuity is only light perception, media haze with a dense anterior chamber or vitreous exudation with a no retinal view, and we are suspecting fungus, or you have associated retained lens matter, because unless a RU inflammation is not going to subside, and you have underlying retinal detachment. Of course, retinal detachment underlying being a relative contraindication, I would say sometimes, because generally overall prognosis is bad, but you do not want to give up related few cases. You obviously would like to take a chance. And certain cases with a chronic endophthalmitis where a low virulence organism, okay, probably vitrectomy can be delayed, not in that rush. What is the rationally doing vitrectomy? It's removes the bulk of the infected material, removes endotoxin and exotoxins, and provides the material for microbiological test. And we have because your bulk is removed, so you have better access of antibiotics to microbials, and also helps to clear the medium. So while doing surgery, as I earlier said, that the first case presentation, ensure section is properly closed, and if necessary, you put additional suture when you're dealing with these eyes. If cornea can be hazy, view can be difficult, but if you debride the cornea, and sometimes surprisingly, view can be extremely good, and you do not have to worry about, don't have to plan PK as well. So membrane, fibrin, and an exudate in anterior chamber. Sometimes against you feel media is very hazy, and you just what you need to do a stab incision and peel that membrane off, whether you want to use with a forceps or a bent needle or a cutter. But quite sometimes the moment the exudates are out, see cornea also shining, an excellent view of the fundus. So really do not have to remove the IOL in every case. 4 millimeter or 6 millimeter infusion cannula, it's a surgeon's take and his assessment on ultrasonography, what you see, whether choroidals are there or thickened choroid. If you are in doubt and if it is not there, we do not hesitate to use 6 millimeter infusion cannula. And always collect the sample for your microvitreous sample for your culture that you want to give you plan your antibiotic management when you're dealing with these eyes. So this is what just to show when you collect the sample to prevent this kind of decontamination or losing the sample. As you see, we put the cap, we expel the air again to get a anaerobic culture as well, put in the big test tube, and whole thing goes in a microbiology, which is fortunately for us is within our campus. Coming to vitrectomy, there are certain pulse. What you use is basically we prefer to do as much debulking as possible, anterior place sclerotomy, and given option, I would prefer not to induce PVD in most of the cases. Exceptions are there, and the end point of the surgery would be when I start seeing the retina or maybe first order vessels or optic disc, maybe I would stop at that level. Don't go too aggressively because retina is inflamed. There is a high risk of creating retinal breaks. And this is what is end point for surgery for me. Okay, so use a low suction, high cut rate, because again, that helps you to minimize the tug on the retina, minimize the iatrogenic complications. And at the end of surgery, we obviously broad spectrum on antibiotic and steroid cocktail is injected if you suspect bacterial infection. You avoid steroids if you are suspecting fungal infection. But giving antifungal, I would reserve till I get a smear report or culture report, because we know they are very toxic drugs. Removal of IOL is basically already inflamed. Removal can be very traumatic for the eye, and so and it's not necessary in all the cases. So you manage preferably without removing IOL. If necessary, and if infection doesn't get controlled, second sitting, you can always think of going ahead with the IOL removal. But if view is very hazy, which precludes your vitrectomy, or capsular bag, our bag is source of infection and is full of exudate, obviously there is no other way you can access vitreous cavity or visualization without removing the IOL. And rarely, probably if you're dealing with fungal infection or your chronic endophthalmitis, you suspect sequestration, again, that can be indications for a IOL removal one. Now, when you remove the IOL, sorry for a poor quality of video, basically it was a really bad case. So before removal, again, as I said, we try to remove the fibrin or exudate AC, and if you manage, that's fine. Otherwise, you just remove. And generally, I prefer sometimes exudation is so much, iris is stuck, probably sector irectomy, and gently just dial out the lens and suture the section back. Doing sector irectomy probably helped me to minimize the manipulation in already compromised eye and the cornea. And both IOL and bag definitely goes to the culture. So post-operatively, you need a close monitoring for symptoms, and early symptom patient will say that my pain is less. That indicates that patient is responding. Continue topical and systemic antibiotics, antifungals, and steroids, and cycloplegics are also equally important. Repeat AC tap and intravitreal injection only if there is a persistent of inflammation or if there is a recurrence of vitreous fibrin. Most of the time, it may not be necessary if your antibiotics, organisms are sensitive to the antibiotic you are using. So there is a worsening in immediate post-operative period. It can be due to increased inflammation, not really worsening of infection, I would say, but it can be due to increased inflammation because of your surgical trauma. Now, evolving posterior highlight separation, so the exudates start coming in an anterior vitreous cavity, and you feel subjectively as if the situation is worsening. Residual peripheral exudate can disperse. Again, it gives an impression of worsening. And of course, sometimes these eyes already decompensated cornea can further decompensate, and situation as if you feel it's worsening. But sometimes, yes, it is no response to the treatment and worsening is because of that, then probably you may need to consider revitrectomy, particularly when you have reaccumulation of lot of fibrin exudate in pupillary area, or sometimes head phase when you have PVDs involving, and basically purpose there is to clear the media. So also revitrectomy is advised when to address the late complications like pupillary membranes, vitreous debris, cyclitic or ciliary body detachment, gross hypotony, dislocated IOL, or if you have underlying detachment. So there are certain issues we still not having a consensus because of suppose whether early or delay vitrectomy to include induced PVD or not, those can be debated. Combine vitrectomy and PK. Silicone oil use rather, I would say, I'll come to that. With a new MIVS techniques, we are more and more aggressive, and so the early vitrectomy is being done rather than what typically described by EVS study. Those guidelines usually we do not follow, and in every case now. PVD, as I said, I personally do not induce PVD, but if you have underlying detachment or having a extensive proliferation, probably once in a while we may have to debulk, we may have to take out vitreous, or mainly associated again trauma and foreign body. So if you are planning that, then probably what happens generally 360-degree laser along the aura and vitreous base, and then that situation probably silicone oil can be used as a tamponade, but without having a break, doing just complete vitrectomy using silicone oil. Dr. Lalit Verma and I think the other 3-4 colleagues of us, they are in favor of. There are 3-4 articles also there, and the rationale is that silicone oil itself may be antimicrobial potential, and it helps give a clear media, so better follow-up in post-operative period, and that's why early rehabilitation. But most of the time, these eyes need second surgery, and problem will be calculating the antibiotic dose in these eyes. So I'll stop, I think, here. When not to operate, basically when eye is no light perception, when you're having a underlying detachment on ultrasound, when patient reports to you, corneal opacification or abscess or melt, scleral abscess, as you see particularly these cases, and most of these eyes probably eventually need evisceration. To conclude, good clinical evaluation and early initiation of treatment is critical. Intravitreal antimicrobial remains the mainstay of treatment. Choice of systemic antibiotic, obviously availability and option of the surgeons and his experience. Vitrectomy has a definite role in endophthalmitis management, and aim is to debulk as much of vitreous as possible safely. And with MIVS, early and more aggressive vitrectomy is being performed nowadays. We are getting better and better outcome. Thank you very much for patient hearing. Thank you so much.
Thank you, sir. That was a superb overview on endophthalmitis, almost like covering the entire chapter, surgical chapter. I would invite our co-chairman, Dr. Natarajan sir and Lalit Verma sir for quick comments on the same topic.
After Natti, I think.
No, Lalit, after you.
No, Pramod has shown excellent videos, and I agree intravitreal antibiotics still should be learned everybody and form the mainstay of treatment to save these unfortunate eyes. I, for one, try to intervene early in severe cases, and because that helps to salvage these unfortunate eyes. And I try to peel off hyaloid, not at the cost of damaging the retina, but passively sometimes, or a mild suction with eye always on the retina. If you keep your eye, and it is possible to peel off hyaloid because there are sometimes posterior hyaloid pockets of pus there. So I try my best to do it in very severe cases. Not very happy and satisfied only seeing the disc. And I do indent in all of these patients and try to debulk the peripheral vitreous as far as possible. And I am a fond user of silicone oil in a lot of these severe endophthalmitis. We're not talking of mild or secondary vitrectomy, but very severe endophthalmitis where saving the eye is an issue. So because honestly, in private practice, people do not give you a second chance and they keep running from here to there. So 2 or 3 points I wanted to make: usage of oil and inducing and PVD, and early intervention and indentation. So these were my takes on this. And calculating dose, I'm not so finicky about, because it's a bad eye. It's such a virulent organism growing. So I'm not very finicky in calculating dose in silicone filled eyes. That I often end up using the same dose as in a non-silicone filled eye. So these were my few cents I thought I'll speak out. Yes.
Very good, Pramod and Lalit. I think the whole idea is to save, and I think we have to make a tailor-made for each case. And I think every patient, I don't do a hyaloid peeling as well as also the base. But I think that's where the surgeon's experience count. And I think that surgical self-education, what is good in your hand. But many times I think it looks so bad and without doing the basic excision, you do the vitrectomy, core vitrectomy, and then give the intravitreal. And I think you can see how the eye progresses. But many times they do even to 6/6 well, but depending on the virulence of the organism. So one is to have a microbiological support from when you take it from the OT and do something in your own OT. And then second is even sending for PCR. So in the next 24 hours, I think you can decide whether you have to re-intervene or not. As you rightly said, the endophthalmitis does not give you a chance, second chance. So you have to be very meticulous in planning. And at the same time, with your experience, I think you can decide which patient you need to do the hyaloid pili, because I think if every patient you do a hyaloid, you'll have a micro breaks which can happen maybe post vitrectomy because of the toxins which produces necrosis of retina. But good.
True, absolutely true, because it's not every patient, it's case-to-case basis.
I agree.
Great.
So now I invite our second speaker. It's my pleasure to invite Subhadra Jalali Madam for her talk on new surgical scleral imbrication technique for complex RD with traction. And Madam needs no introduction. The sheer volume of work has made her a legendary surgeon and a very renowned teacher. Madam, please share your presentation.
Okay, I'll start with the movie. I'll start with the surgery first. Can you see the surgery?
Yes.
Okay. So we tag the muscles. Can you hear the audio? Otherwise, I'll speak.
Yes. No, we can't hear the audio.
So we tag the muscles like normal, and then you can see I'm just making 2 flaps. The flaps are made at the equator, but you can make it eccentrically also, depending on where the traction is. And the original scleral imbrication was spindle shaped, and I have modified it to make it square because I think that gives us more space. And it's very simple. Anybody can do it. Then just pass the sutures. So only be careful, because especially in small eyes, when you are putting the reverse suture, this one, you have to go a little obliquely, otherwise you'll poke the sclera. So, I'm using the small retractor. As you see, these are small pediatric eyes. Now, the moment you remove a lot of sclera, the eye becomes soft. Just see how soft it becomes. This is without anything, but if you have doubt, you can always give mannitol, you can always do paracensis. But most of the times, if you make good thick flaps, the sclera actually starts collapsing, and you can really imbricate quite a bit. So you can see here, we can make it tight. Okay, if there is a lot of fluid, you can drain. I will show that just now before you. Yeah. Now, so here I'm showing the drainage. So this patient had combined RD. So you can just do good amount of fluid can come out. Sometimes the fluid is very thick and you make an opening. If it is not very thick and it's a fresh RD, you can always do with the needle drainage. And the original scleral imbrication, does not put any buckle, but I am putting buckles on these. This is another modification, and you will see why it's being done. And the buckle and the imbrication, both, they can be done in 1 to 4 quadrants. All 4 quadrants can be done depending on the area of traction. So this is, I'll stop here. This is, So here you can see now we are putting the buckle. So the buckle size could be 42 band, or it could be a 240 band, or it could be a 287 or 279, depending on how deep the disease is. So that the surgery itself is not difficult. I think any retinal surgeon who is doing buckles can do this. The only thing is, one needs to have the conviction that this will work in the types of cases that I'm going to show. And these are all very complex detachments. Before I learned this surgery, thanks to my discussion with Dr. Gopal, Dr. Bende, and Dr. Mahesh Shanmugam, I started doing this surgery. I could not find this surgery like videos easily. So I just started doing myself only after discussions. And then later Mahesh Shanmugam, he sent one video. So I'm just going to show the types of detachments where this was done. So what happens is that, in ROP or FEVR, once we do the open sky vitrectomy, the lens sparing vitrectomy, and then we have given good vision, the story doesn't end there. They still have a lot of issues, and then they can come back later in life with red RDs. And since I've been doing this surgery, I've also noticed that some of the acute ROP patients actually have convex detachments along with the traction. So they're actually coming in the acute stage also with reg RDs, if we look carefully. So this is one patient. He had FEVR. He's a PhD student, and this was his good eye. And you can see like what has happened. He has a big exudation here. There's a large area of traction. His macula is detached. If I do vitrectomy, which is what I was doing before, lensectomy, vitrectomy, trying to peel this off, chandelier, bimanual, 4-5 hours, and then you never know whether it's going to attach with 1 surgery, 2 surgeries, 3 surgeries, and you go on and on and on, Tramstone, everything you do. But these are really complex cases. Can it be done with single surgery? So I tried to see what is the history of, screw imbrication in reg RD, and I was very surprised that in 1950s, this is the paper from 1959, which showed that they had 4/5 successful reg RD detachments, especially with large breaks. And this was the time when still the buckling surgery had not come. So this is an old surgeon. As you see, they were doing spindle shaped openings. What I'm doing is little square shaped. And they said that these detachments actually attached. So recently in the literature, there have been few reports from Japan where they have tried to do this surgery along with vitrectomy in complicated high myopia detachments. I could not find published reports on ROP detachments, but in my patient, you can see what happened. I just did the screen imbrication, put a very broad buckle in the area. I thought there's a break because his inferior half was detached. You couldn't see any break, but there was a large VPRT. As you see, this exudation block was there. I did cryo for that. And post-op now, he's 20/30 and 6, single surgery, no oil, nothing. And his IOP was high for a couple of months, and we had to manage with multiple medications. Now at 1 year, he's off all medications, and he's completed his PhD. And he last week wanted to know, can he join corporate world and will his eye withstand? I think we have cured him for life. I don't think he's going to get any recurrence now. Single surgery. This is another one. This patient came from Latur 2 months ago. I had seen him when he was 3 years old. This is the pre-op picture. At 3 years, he had ROP, 1 eye blind, and this was his picture. And, now after 10 years, he comes. He doesn't come for 10 years. At 13 years, he comes to my colleague's clinic and, says that I have reduced vision for last few weeks. They just see and say, like, you have ROP and nothing to be done, but maybe you can come back and see madam after, 2 weeks or so. At 2 weeks, he has that faith, he comes back. And what I noticed in the clinic, he has a lot of nystagmus, vision is poor. But what I noticed was little bullous here. So then I took a fundus picture. So that's one lesson to learn in all these patients. Take fundus pictures. The fundus cameras really show you the pathology. And, if I went and did vitrectomy, I would be nowhere. This whole retina is so weak. There were 5 HST in the periphery. So I just did this technique, and you can see here at 6 weeks, everything is flat. He's very good. Now, if you're not convinced, you can see the pre-op and post-op B scans. Again, in all these patients who have traction, exudation, always do B scan because that will pick up the reg component of the disease. So you can see here, this was actually a reg RD, which has happened on the context of the traction. And you can see these are post-op pictures. Retina is nicely attached. The traction remains, fold remains. You don't have to do anything for that. The OCT shows retina is very nice. But the story still doesn't end there. You've attached the retina. And this boy, he goes to his local government hospital. He has, got a admission in Navodaya Vidyalaya. And this is the, certificate which the government doctor has given that he is unfit for admission to Navodaya Vidyalaya. He is fit for admission in blind school. The boy comes back. We see him in low vision clinic. His vision is 20/50 with the telescope. Unaided, he is 21/25 and 8. And he can read his refraction has changed from -7, which he had all his life, to -11. So I have given this certificate that child is very much fit to continue education in Navodaya Vidyalaya. He will need some help for low vision, but he has very good vision and he is quite bright and he should be able to carry on his studies. So that's the whole difference which a single surgery has made to the life of this boy and his family. Here's another patient. This patient had no reg RD, but he had a dense exudative and tractional RD, again one-eyed patient, and we have done the same surgery, and this is about 1 month post-op. The exudates are decreasing and the exudative RD has reattached. Another patient, he's a small child. He stopped playing 1 week ago at his early birth. I had done his surgery for stage 4B ROP. He's a phakic, and then suddenly now at 4 years of age, he has stopped playing. We could not take his fundus photo. He was crying all the time, but B-scan showed that now he has developed a reg RD in addition to the traction. And we did the same surgery, and you can see retina is attached, and he's back to normal, playing happily. So I share this old wine in a new bottle with some added twist. Thank you.
That's a wonderful talk, Dr. Jalali madam, and a fantastic new concept. I just have one question when you were showing the slides to ask. Our routine conventional teaching is that when you're putting a buckle in a ROP, you normally remove it after 6 months because it could interfere with the growth of the eye. So vis-a-vis that, what is the implication of this scleral imbrication? Because the eye is growing, then could these proline cheese wire and could the imbrication be undone?
So although I have done only this for last 2 years now, I started during the lockdown. What I feel, because I have done very small children also now and adults also, and even the normal buckle that I'm doing in children, I'm not transecting in all children. I don't remove it. I did transection for many years. Now I don't. I only do it if there's some indication that actually I think if we have done imbrication, these eyes will not grow. I think they will not grow. I think we have stopped their growth, and that's fine. I mean, the retina will remain attached. But we have to see the long-term outcomes. As I said, one of the patients, he had high IOP for almost a year with 3 medications, but now at 1 year, I think his capacity has improved and he's off all medications. So what will be the long-term things happening to these patients? I have to see. We all have to see. But I think that I'm so excited. I have done 25 cases now. Only 1 case failed where I had to do vitrectomy, and everybody has done so well. I think this is some very good technique for us to do in these very complicated cases and not go inside and keep on struggling for multiple surgeries.
Can I add a couple of things?
Yeah, sir, please.
Yeah. So basically, now at what Dr. Subhadra Jalali said, similarly, not necessary all the cases we are doing encirclage. So particularly when you have a traction and particular quadrant, limited one, so we put a buckle in that quadrant alone. So then you do not have to remove that one because now you do not have constricting effect. Okay, so you don't have to remove those buckles. So that's the one thing. And even imbrication also works more or less because she has few cases only 360, but most of the cases when you do imbrication, we do a 1 or 2 quadrant depending on where the traction is. And particularly Dr. Natarajan will agree with me, we all train as a implant surgeons initially, not explant surgeon. When we are doing buckling, exactly what technique is Dr. Subhadra is doing as a scleral flap, and we suture those back. Exactly. So technically, yes, I agree. It's not that difficult surgery at all. And what she has done, an excellent video she has shown. And the same thing probably holds good, that because the sclera inner layers are infolded, that itself acts as a buckle rather than having an additional buckle element. Only concern I have here is if you are using a non-absorbable suture for imbrication and then putting a buckle over it, long term probably there is a risk of intrusion of the suture in the eye. So that we will have to watch it.
Yeah, the knots are on the flap. The knots are on the flap, so they have actually a double cover. So I don't think the knots will intrude. But yes, the length of the suture, that we have to see whether it will intrude or not. So let's see. Yeah.
Right. Thank you. So moving on to the next speaker, and that is none other than Dr. Natarajan sir himself. And welcome, sir. And he is going to speak on complex rhegmatogenous RD 3D vitrectomy.
Yes. I'll share my screen.
Yeah.
So my talk is on complex retinal detachment. There's no financial interest. And this is, I'm taking a retinal detachment with a trauma. And in trauma, we want strategic thinking, which is an individualized approach, and then a systematic approach based on scientific literature and genuine personal experience. As parents Kun says, that no trial and error basis. So we approach the two-step approach. And then the first step is to do the good wound repair. That's what we recommend to all the primary ophthalmologists who can do that. And second step can be all the procedures. So we have here a 34-year male presented with the closed funnel retinal detachment with suprachoral hemorrhage following road traffic accident. A biomanual vitrectomy was done. And you'll see the retinal you can see the retinal that was torn from the temporal side and was incarcerated to the nasal side, and the entire thing. Now I actually separated the nasal side also and used chandelier illumination, and then using two forceps and unfolding the retina, and found the space between the two folds, and then used the PFCL and flatten the retina. In the beginning of the surgery, it looked like that it's an inoperable one, but I think you have to make an attempt genuinely to see whether you can open up the funnel. It's like a closed funnel. RD it's almost like a 360-degree retinotomy done, and then you can see suprachoroidal hemorrhage partially drained, and then you can see some mound in the periphery, but you can settle the retina like this, and then this patient actually had a recurrence because of PVR. We removed oil, and then we did you can see the pre-op and the post-op. The whole eye was cut into two parts, where you can see the entire cornea was central cornea was sutured, and then the patient came as said as no hope, and they were sent. And this is the pre-op and post-op. So my philosophy is eyes with no PL vision should always undergo a primary repair, even when the anatomical success is estimated to be less than 1%. So you have to operate as though the patient can. This is again, in case you have a foreign body, I'm actually not going into the detail. I'll go to the retinal detachment associated with that. And this is the forceps designed by Mahesh Shanmugam and Manish Papaye, which were published in the Indian Journal for removing the foreign body, particularly the pellets, which we did in Kashmir. And this is a patient with a pellet injury who had you can see the corneal wound repair well done by the corneal surgeon in Kashmir in the SMHS hospital. And then following that had a cataract. And in 8 days we intervened. We did a phaco with a cataract procedure, and then removed there was submacular hemorrhage also. Here you can see there was a corneal wound, and it's a aphakic eye because the lensectomy was done at the primary time because the lens was totally damaged. And here you can see the pellet being removed within the vitreous hemorrhage, and then removed through the superior conjunctival and scleral incision, and brought it out, and then complete the vitreoretinal procedure. And even if there is a subretinal hemorrhage, I don't usually interfere. And here I'm removing the rest of the vitreous hemorrhage which is there, and also do a thorough vitreous base excision. And many times you can have an exit wound, and in this case you'll be seeing where you can treat it like a coloboma choroid and retina, where you can do a laser around it, except the disc and the macula. And here you can see the exit wound is next to the optic disc, and the optic disc, the retina and macula was all right. So there was a laser done around the exit wound, and then the laser was not completed towards the macula and the optic nerve. And then you do a fluid air exchange, and you can leave it, and then have a secondary intraocular lens, either a scleral fixation or a iris claw lens fixed posterior surface of the iris. And this is the same patient with a cataract with a submacular hemorrhage post 6 weeks surgery. And here this is a traumatic retinal detachment with a expulsive hemorrhage which happened. And again, post-expulsive hemorrhage, you can see the remnants of cataract, the lens actually, and you do a AC maintainer, and then there was a vitreous hemorrhage, suprachoroidal hemorrhage, as well as subretinal hemorrhage. So here I'm making sure that the antersegment is cleared of all the blood, and then you put a port to just check whether you can start the infusion through that. But you want to clear the entire vitreous hemorrhage around the port so that we don't have a suprachoroidal effusion following the infusion, which is good. And here you see there's a total vitreous hemorrhage. There is no PVD, so you have induced PVD, and there was a retinal detachment you will be seeing where you can use the PFCL, squeeze out the suprachoroidal hemorrhage as well as settle the retina. So it will do a 2 job at a time, and then use the PFCL silicone oil exchange. And inducing the PVD and removing the vitreous hemorrhage, and then there's an underlying retinal detachment, which you use the PFCL and do all the procedures to settle the retina. And at present using the retinal brush. So the problem is if you don't have a PVD and then you have a retinal detachment, I think it's a challenge, and that's where the force with use the retinal brush is good, so that you don't have the suction which is done. And you can see the anterior segment is again cleared using the PFCL to drain the suprachoroidal hemorrhage as well as reattach the retina. So I wanted to make sure that the air is filling the anterior part, and then rest of the area you can do the PFCL oil exchange. So here I use the wound and then finally sutured the corneal wound. And this is the post-operative picture with the fundus picture, and then this is other patient. And this is a traumatic endophthalmitis, is total RD with a combined. So I planned a temporary keratoprosthesis, but you'll see that in this case, the endophthalmitis was necrotic tissues all around. And then the corneal surgeon, Dr. Kavita Rao, does the corneal button removal. But we couldn't do put a graft and do a temporary keratoprosthesis vitrectomy, but I did an open sky vitrectomy, toileted the wound, and didn't do anything for the. We didn't know what I was doing. So and finally cleared the eye with all the infection, and then did a penetrating keratoplasty by Dr. Kavita, and then give the intravitreal at the conclusion. Thank you very much.
Thank you,
Still
sir.
2 minutes are still there. Actually, that bell he rings is for 2 minutes.
Oh, okay, no problem. Yeah, so you can use the time for discussion.
Time for discussion.
So PB sir, your comments.
Yeah, and I think we don't have to make any comments. Excellent presentation. That all complicated surgeries, I think not much to really add. But yes, these are difficult cases. And what I would suggest, patient counseling with the patient and attendant is very, very important, because when they pay, they expect dramatic results. And with the comparative cataract surgeries, now everybody expects that how visual outcome should be good. And you need a huge amount of patience on a surgeon's part. You cannot do these surgeries in a hurry. It takes time, take your own time. And yes, pre-surgery counseling, I think 2 things I would like to add here. Yes, sir.
So that's why I call myself as a vitreoretinal psychiatrist. I always tell the patient I spend a lot of time pre-surgery, and I said post-surgery, I have nothing to talk, I tell them. Because everything I said, if you see, thank God. And if you don't see also, thank God. And I said, you can feel both mentally and physically, I tell them.
I agree with Dr. Pramod. You see, Natti is unique and your patients are also unique. You see, because you see, you need to have guts. Our patient, if we don't promise anything, he will run away. So patients, because PL negative, last 3 surgeries were fantastic, Natti. Virtually a lot of people may have, not done it, but you are bold enough to do it. So therefore I said, you are unique, your patients are unique.
I know. Actually, that's the reason I want to, Vatsal has just joined. Vatsal is my boss in Bombay. Your comments. Vatsal, you're muted.
Dr. Vatsal, you are muted. We can't hear you.
He's trying, I think.
Nitin
Yes.
from
To reach that level, you have to reach level of Dr. Natarajan.
Yeah. Vatsal, yes.
Hi, Nitin.
Hello.
Good
Can
morning,
I
Dr.
just say
Nitin.
one thing, Dr. Natarajan? I think also some people are now doing endoscopic surgery for
Yes.
some of these cases because you had a difficulty in temporary keratosis. Especially, we also saw, if there was a wound which was sutured from the edge of the cornea and the sclera, then you can't put that prosthesis; it will leak. So
Right.
those are the cases where endoscopic surgery is really doing very good. Here, Rajiv and Vivek, the way they are doing.
Yeah.
So I think
my
that approach-
endoscope is not working. So I am not able to repair it because the company is closed and gone.
Yeah, Kharido, sir.
We had a wire which went in through the. Actually, it was seen in the AC, and then I think the resident probably did something and went inside. And then when the ultrasound showed it in the angle, then me and Dr. Sachin Darwakar searched. And I told Dr. Sachin, enough here, half an hour I searched, you can't find. Best is to send it to Dr. Rajiv. Then we sent to Dr. Rajiv because I otherwise couldn't see the foreign body at all. And it was a thin wire it went. And finally he removed it. I think Rajiv, I have to remind him, we have to publish that. How we could see it preoperative. And on the table before giving local, we could see. And when he started doing something, it went somewhere. And he also searched both the scleral side. I went inside vitrectomy. I said, see, this is what I have to, my experience says that if you can't find in half an hour, I think I won't say waste of time. You're meddling more. You're damaging the tissue. I said, better, and patient was under local. I told the patient on the table, see, I can't find out. I'm going to close now. Dr. Sachin wants to try for some time, but after that, we are going to send you to Hyderabad. I called Rajiv immediately from the OT, and his patient also accepted. And as Pramod said, if you have a rapport with the patient and tell the fact from day immediately, there are sometimes patient gets upset, but later I think they actually believe you. I mean, that's the best part. Even now, me and Dr. Vatsal are treating one doctor patient. I mean, the patient, there are doctor, he told me, sir, you do anything. I went to everybody. I went to Vatsal also. Everybody told the same. Now, whatever happens, no problem. You do the third surgery.
Subhadra, you asked.
I had one worm in the AC. I saw it, I photographed it. By the time I put the sclerotomy, it went back. And then it was in the zonules. It had gone through the zonules and stuck in the zonules. And by the time I went behind, again, it came into AC. So it was very patient, but ultimately I caught it and took it out. But yeah, the endoscope, it's another armamentarium. If you have and learn.
Yeah, actually, newer one are good. Actually, with the LED light source, illumination is very good. Okay, and I think initial learning phase will be there because you are dealing with the 2-dimensional and 3 dimensions. So once you get used to, I think it's a good source. Of course, it has its own limitation. I think we are beyond scope of this, but it can be one of the options you're dealing with.
Subhadra, you were asking him to buy endoscopic. Nati, now you will buy or Amar will buy?
Amar will buy.
Bombay wale to kharid sakte hain, sir. Kharidna, ye nahi bolna kharab hai.
Lalit, I am only a pure surgeon.
We'll talk later. Otherwise, Preetham will get upset. Subhadra, one question to you. One question. Dr. Saswade also wants, 1 second, because Nitin, pardon me for 1 minute.
No problem.
Because Saswade also wanted, I also wanted. In all imbrication, do you necessarily put buckle or imbrication is good enough by itself?
In most of my cases, I have put a buckle. It could be a band or something. Very tiny babies, I have not put. Like, as I told that some of the patients in the acute phase of ROP are coming with traction and Regardi. But even there, most of the patients I have put a belt. Sometimes I have put a 42. Sometimes I have put 287.
Because it occurred because imbrication by and large produces itself a shortening procedure and a buckling effect.
That's what I wanted to say. Like not necessarily. You can look at amount of traction. You can take a call, sir. How much is the elevation?
Yes, it depends on how much is the elevation. That last patient I showed, he had 5 HST in the periphery, and you could see the whole retina was so much pulled towards the disc. And even that adult, in adult, your imbrication is going to be less tight.
But all your cases were fantastic, and I am forced to try this technique now.
Please try. It's really good. I'm so happy. I'm so grateful to all my seniors from SN who have shown me that this can be done. It was only my mental block which thought that this will not work, especially when there's exudation. It works. You do your cryo and you do everything. It really works.
Great.
So now I invite Lalit Verma sir for his talk on kissing arcades. So please share your presentation.
So Pritam, let me know in case you can see so that I can move on.
Yes, so we can see, sir.
We can see.
So this was a terminology which occurred to me by seeing this patient. This patient had undergone multiple surgeries. You see, I never saw an epiretinal membrane where arcades have become so close. So this patient had undergone multiple VR surgeries. ERMV, it's not very difficult to diagnose, and we heard in the previous surgical session fantastic videos by Saurabh. You see, the surgery also is not very taxing nowadays. After you peel off the hyaloid, the transferon-assisted vitrectomy, key step is to identify this edge. And by and large, it's not a difficult job. One of the easiest surgery in today's era, and results also are very, very good. You see, this was another patient had ARMD plus. You see, notice in a lot of these patients which I am showing, the arcades are in its usual position. But patient has a disturbing metamorphopsia. That for me is the best indication. Here, I'm doing this transferon-assisted vitrectomy. Then I put in air, and I'm very fond of putting under air the reti blue dye, which is a concentrated form of trypan blue. It's not a routine trypan blue, but slightly more concentrated, available with DORC also. So I make this dry, posterior pole, then put one drop, wait for a couple of minutes, and this epiretinal membrane gets nicely stained. Then take it out under air itself. The excess of this reti blue is taken under air itself, and then make it a fluid filled eye. And then the usual step is, I very fond of this 25 gauge MVR, which is blunted. This MVR is blunted. If you notice a small pick at the end of it, it's not a fresh MVR. And then once the edge is identified, you take off, and it generally, by and large, will come as a single sheet. This sheet is slightly more extensive than what you visualize on the. You see, arcade are wide apart, but patient has a disturbing metamorphopsia. And this sheet comes, and there's no need to inject any gas in these patients. You just do an air to exchange and come out. So this was another tougher membrane, but again, already operated multiple times. And this was a secondary ERM, I think, post the surgery. Again, similar steps, as I said before, under the air I'll put. Again, arcades are wide apart only. The vessels are not tortuous here. There is, I think, this is a small bubble of PFCL under the retina, which I didn't touch during this surgery. But again, identify the edge and peel off the membrane. Sometimes you see it may give palpitations once it is slightly more strongly adherent. Here it was slightly. So I had a pause for some time, then went closer to the optic nerve. Always better to go closer to the retina and then attempt rather than pulling at the tip only. An extensive membrane comes out. So these are general results. But a lot of times we combine with cataract surgery these patients, and results are very, very good. ILM peel, as I said, I do try, but do not insist at the cost of damaging. And also international literature also says that is not advantageous in all the ERM surgeries. We all get addicted to ILM surgeries, but it's not very. So a couple of more results. This was the patient who recovered excellent vision apart from his metamorphosis having gone. So this was the patient which forced him to consist of kissing arcade. This patient had undergone 3-4 surgeries, and arcade was so close. I thought, should I do it or not? Vision was very, very poor, but I still attempted to do this surgery. Patient had, you see, compromised anterior segment also. But the only difference I did here was, instead of using a blunted MVR blade, I took a fresh MVR because I had to virtually incise over the posterior pole, sometimes over the fovea also. I have another video which I have not included here, where a vertical nick directly over the, like you see, this vertical blade is directly going, a fresh MVR blade. Otherwise, you will not be able to take out this. So it is required that you take a sharp MVR blade and incise, and do not worry too much because it's a thick membrane, and damage to retina, unless you are careless, it will generally not happen in these patients. So although the membrane is very, very thick, you have to be patient, as is true for all VR surgeries, and try to peel off. This I'm doing at the optic nerve head, but always go at the base again, catch hold at the base as shown here. And this is the area which I presume was the macula because of the yellowish tinge here. So I have to be careful that you don't do anything wrong here. But fortunately, because the macula is slightly down, is further down, and it came, I trimmed it because the grip was not coming up so good, and then hold it here. You could see the replica of macula here because macula side is slightly deeper. It's a saucer-like thing. And fortunately, although extensive, virtually all the quadrants, very, very thick also, but it came off. I don't think I damaged the macula in this patient. So I had to trim this. I did not have guts to go over the previous laser scars lest I induce a iatrogenic damage there. I did put silicone oil in this patient. Fortunately for me, the other step which I did here was, which was slightly different, was massage. Took this 2 diamond dusted forceps and mechanically try to separate these. I think I missed that step here. You see here. So this I thought was important because whatever I want to do should be done here and do not depend only on the post-operative period and retinal elasticity that it will come. So then do the usual procedure. Fortunately for me, this patient is maintaining 6/24 vision, and although still I'm not very happy that arcades have gone back to natural position, and hopefully with time it may. So this is the pre and post of this kissing arcade, which I thought I'll share with you. Thank you very much for your kind attention.
Dr. Verma, can I make a comment?
Yes, Sodra.
So this type of thing usually we see because there's a persistent fetal vasculature system there. We see this very common in our pediatric cases in FEBR, ROP. So whenever there's a persistent fetal vasculature, it will cause this type of complete narrowing of arcades, and it will be very thick. And most important is what you showed, that it will be adherent to the disc, and it may be adherent just to one edge of the disc, but its tentacles will be all around the disc and the peripapillary area on the nasal side. And then the macula will be heterotropic, as you showed. It's not in the fovea. The fovea is, it is heterotropic, and there the adhesion can be very strong. So in this case, it came out. Sometimes you have to cut with the scissors. So always near the fovea, be very careful. If it is pulling the fovea, then you cut with the scissors. Otherwise, you will create a break. So maybe if you ask this patient the history, there may be something in the other eye which will tell you that he had FEBR or ROP or one of those conditions which cause, or it could just be a PHB which is there. So whenever there is a persistent PHPV component in any of the RDs, it will cause this type of problem. So it would have been nice if you would have sent that for pathology. It would have shown you that it was not just a pure ERM, but it had some, remnants of something.
I have picture of the other eye of this patient. Fortunately, I did not see anything, but I think your points are well taken. Let me see in case I can show this picture of the other eye in this patient. This fundus photograph may not be there. Sorry.
But excellent surgery. What's Lalit? Very good. But I think as Shubhadra said, routinely I send all the material to Dr. Bishwas routinely. Whatever it is, simple case, complicated like this, I always send it to him so that one day I think
this was the picture, Subhadra, of the other eye. Could not see any persistent vasculature, but you are right. I agree with you that we have to be very careful because this was a relatively younger patient, 19-year-old only.
Yeah.
And
even in this side, the arcade is little narrower. Try to see the periphery. Try to see the periphery for any vitreous condensation. You can do an FFA in that eye and just see. You can see here also it is little narrow.
Good learning point. Subhadra pointed out very
just to add here also, cases where you do a temporal relaxing retinectomy rather, I would say, and that excessive scarring, you are close enough because retina get dragged because of scar contraction, and we'll have those membranes pulling there. That is one. Also, what is important here is what you rightly do, very well shown, and actually excellent depiction here is like so many times people just think that membrane is over the fovea. Actually, fovea will be popping through the hole in the membrane, and you assume sometimes just directly poke there and pull there, you'll end up having a macular hole. So you have to start away and peel it up. You got membrane also, you see there's a nice hole. It is like a collar stud like coming out thing. So just ensure that when you don't go on a fovea, go around and it comes out. So like otherwise can easy to miss that one as a membrane because edematous macula, and you'll end up creating macular hole there on the table.
Absolutely, I agree. And thank you, Subhadra, for pointing out this. Very nice point.
So that was a great learning experience from
Manoj
Lalit Sharma,
just
sir.
asked one question. No, well, Manoj just asked whether to use shortened finesse loop instead of MVR blade.
Yeah, finish loop I do try, but I'm not very fond of finish loop because it hasn't helped me in a great way in a lot of these dense ERM surgeries. Because finish loops works for finer membranes, not for these very tough membranes. I agree with I have finish loop always on my table, but I'm more happier with this bent MVR blade and sharper things rather than, you see, scratching the retina like this is not my cup of tea.
I think I agree with you. I have similar experience. Somehow we are older generation now, I would say.
Yeah, I agree. I have grown old and I agree with your observation. But whatever, you see, what I would say is whatever works best in your hand. Manoj, I would 100% agree. You see, there are younger people are doing fantastic job and excellent job, but one technique should not be made compulsory for everybody.
Yeah,
you should try. Finish loop succeeds, well and good, A+. But if does not, don't hesitate to use this sharper also.
Thank you, sir.
And one other important thing is that there will always be retinal fold right from the disc. If you see carefully, Dr. Lalit, your video, towards the end, you could see there was a fold from the disc. So when you're holding these membranes, you have to be very careful. You don't hold the fold and you have to go over that fold. Always the retina will be folded under it.
Absolutely. Agreed. Very nice.
Yeah, so excellent discussion and a great learning experience. For the dearth of time, I would move on to the last talk of the day. That is by Dr. Aditya Kelkar on intraop OCT, the third hand. And from all of us, we wish him again congratulations for winning the VK Chitnis Oration Award this year at MOSCON 2021.
And also Red Buckler Award from ASRS. Congratulations.
I think let's clap for him, all of us. Aditya, congratulations.
Thanks a lot, sir. Thank you.
Aditya, I did see you in Pune. I'm in Pune now.
Oh, okay. So how long are you here, sir? So we can meet.
After the session.
Okay. All right. I hope you are able to see the screen.
Yeah, carry on.
Okay. So I'll present my experience of using the intraoperative OCT. And I have a video for that. And hopefully I'll be able to share the video with you. And hope you can enjoy it.
By the time the video is started, you can see the shine on your head.
That's because of the glow.
There's no sound.
Yeah. Just a second.
Throughout the world, there are ancient traditions that identify the center of the head as being synonymous with the center of the earth, the center of the universe, and the very center of creation itself. This center is often depicted as egg-shaped and is identified in some cultures as the third eye. Advent of ocular coherence tomography in the 1990s has been groundbreaking in ophthalmology. Over time, OCT has become an invaluable diagnostic tool in OPD, aiding in preoperative diagnosis and postoperative monitoring of many retinal diseases. Similarly, in the operating room, OCT has evolved from the earlier handheld model where surgeons needed to pause surgical procedures to acquire images, which increase the operative time and risk of contaminating the surgical field. Latest versions of microscope integrated OCT incorporate OCT optical pathway into the surgical microscope. And combining this technology to Barrow 3D heads-up viewing system, allows surgeons to view OCT images concurrently with surgical fields on 4K high-definition displays. Seamless integration of this technology into ophthalmic surgeons' toolbox has set a new paradigm in the surgical management of ophthalmic diseases. In the world of retinal surgeries, intraoperative OCT establishes a connection to the retinal rim. We share with you our experience with the IOCT, the third eye in retinal surgeries. While performing macular hole surgeries with inverted ILM flap technique, the flap gets displaced at times after fluid-air exchange, and this can be promptly picked up by IOCT. Surgeons can thereafter take the necessary steps to reposition it, as IOCT gives excellent image quality even after fluid-air exchange. When this dilemma presents itself, IOCT helps solve it on the operative table itself, ensuring smooth flow of the surgery. Retinal detachments in some cases can have coexisting tiny macular holes. IOCT can pick up even the smallest of the ones, thus allowing the surgeon to make adjustments to the surgical plan. Tackling vitreous hemorrhage leads one to wade into unknown waters, as preoperative OCT is not possible in these cases. IOCT is of tremendous help in such situations. It captures abnormalities such as epiretinal membrane or macular edema. This in turn helps the surgeon in customizing the procedure, such as clearing the ERM or adding anti-VEGF on table for the benefit of the patient. When in two minds about the completeness of ERM peeling, especially in cases with retinoschisis with atrophic macula, IOCT gives the much needed valuable feedback about the completion of the ERM removal. Not only the central macular area, IOCT is helpful in scanning the periphery as well. In a case of silicone oil removal, when one is faced with the doubt of an attached or detached retina, IOCT is helpful in such scenarios. Most of the retinal surgeries have transformed from the 20 gauge to the sophisticated 25 gauge instruments. These ports usually do not need sutures. IOCT here captures leak from the sclerotomy port, helpful in taking the prompt decision of suturing the wound leak. Alignment of autologous retinal graft over macular hole and demonstration of snug fit of the amniotic membrane graft in a case of optic pit surgery. Nuances of various surgical steps in this post-traumatic subinternal limiting membrane bleed, making it a very useful teaching tool. However, few limitations encountered are light scattering and shadowing effects due to surgical instruments, hence limiting its applicability, especially for peripheral pathologies. This hinders the visualization of the instrument-tissue interaction as well as the underlying tissues. Integration of OCT imaging technology into the vitreoretinal surgeon's surgical toolbox has made quite a revolution. It has shown to make a positive impact on surgical techniques, intraoperative decision-making, and distinguishing anatomical planes in various types of cases, such as retinal detachments and macular surgeries for enhanced safety and better outcomes. Hence, just like PFCL is said to be the third hand of retinal surgeons, we find it befitting to call the intraoperative OCT third eye of the retinal surgeons.
Thank you. Thank you for your patience.
Thank you, Dr. Aditya. That was a wonderful presentation. I would like to invite comments from PB sir and Natarajan sir.
Certainly, Aditya is a wonderful presentation.
Thank you, sir.
Really very well done. And I think just couple of limitations what you added, I think that's completes the whole story. Because definitely, I think people are now coming up, certain companies are working on different type of materials, some plastic or acrylic where acrylic like material where the instrument, the shadow which is casting with a casting or the metallic instrument, particularly where you want to pick up the tissue, exactly there you get instrument shadow. And that's the major difficulty what we have with this. And I think newer instruments are coming away to, so having a without shadow we'll be able to manage. I think that adds on, I think we'll have a complete scenario then.
Yes, sir.
I think excellent. Is there a learning curve using the? Somehow I thought OCT.
The OCT, yeah, initially it takes a little while to get used to the foot switch controls. But once you're used to the foot switch, basically, I think we are dependent on the assistant to do the OCT. That's the mistake that I did initially. But there are foot switch controls in the microscope. So if you start using it initially, it will be a problem. But within about 5 cases, you will master it.
Okay. There was another difficulty here because looking at particularly when you're using microscope, when you're concentrating on a surgery and you have a OCT coming next to it, so like refocusing there and looking at it, you get distracted. But with now 3D visualization, you are using Ingenuity and everything is one big screen and it's a one visual field. I think it's added advantage of Ingenuity, particularly when you have like intra OCT. I think definitely it will go together now.
Very, very convincing, Aditya. Very, very convincing. I also had similar apprehension what Pramod was saying, that distraction. But with Ingenuity and head-up surgery, I think this no longer is a limitation. Only thing is it keeps adding expense to already expensive VR surgery. But wonderful, wonderful, convincing video. I think it's a prize-winning anywhere on the earth.
So we would have loved to go on and hear more comments from the galaxy of stars who are present here. But for the dearth of time, I would request that we close this session and hand it over to the next IC. Once again, thank you to Dr. Pramod Bende sir, Natarajan sir, Preetam Samant sir, Lalit sir, Shubhadra ma'am, and Aditya for wonderful videos and a great learning experience for all the audience who is watching. Thank you so much for joining with us.
Thank you, everybody. And again, thank you and have a wonderful Diwali, everybody. Happy Diwali.
Thank you. Happy Diwali.
Same to you. Same to you, Pramod.
Thank you, sir.
Okay, bye-bye.
Bye-bye.
So it's over to, I think, Dr. Nitin Prabhu Desai sir is here.
Yes, sir. He's
there. Yeah, Preetam, we can continue here or we need to log in as an audience other side?
So you
can continue, sir. Please continue, sir.
Okay, thank you. Thank you.
Yes. Good morning. Prabhu Desai sir, welcome and over to you for the IC instruction course.
Good morning, Nishikant.
Good morning, sir. I'm in Ranthambore.
Oh.
Amazing.
Santosh also is there.
Really?
Santosh Agarwal. No. What I meant is he is there in the Zoom. Hi,
Oh,
Nitin.
I thought
Okay.
it was.
Hello. I think we can start because we are already late. 10
Yes,
minutes
yes.
late.
Please start, sir. The floor is yours completely. The floor is yours. Go ahead.
So good morning, everybody. So in just 1 minute.
So I'll be sharing screen for Dr. Ashish Vaidya sir.
Yeah, first,
I'll be sharing this.
Preetam will be starting with Nishikant.
Okay.
Let Nishikant go first.
Yeah, Nishikant, start your presentation.
Yeah, I'll just share my content. 1 minute.
Nishikant, if you have any problem, we have the backend team also having your video.
Oh, is it? Can they start? Yeah, can they start it then, please?
Swapnesh, can you please ask them?
Anybody from Numerotech? Mr. Sai, are you there?
I'm here, Doctor. Can you please play my presentation?
Dr. Nitin Prabhudesai has emailed to
And
your...
I emailed you.
I haven't received, Doctor.
Okay, shall I try from my laptop?
Sure, sure.
Yeah, sir, please go.
Swapnesh, do you want me to take my presentation?
I am ready with your presentation. I can present it. You can talk, sir.
Can you hear me?
Yes, yes, we can hear you.
Voiceover. Okay.
So
Borse, sir, you try it once from your end only because it had started.
It had started, is it?
Yeah.
Okay.
I think Nishikant is taking that off.
Yeah, you can see that. Okay. Okay, see my screen now?
Yes. Yes, sir.
Okay. So I'm going to talk about pneumatic retinopexy, which is an art which is slowly going down due to various reasons. So it has actually been historically started in 1911 by Home, etc. And it was actually Hilton and Grizzard who really made it so famous when they reintroduced it in 1985. And we were fortunate enough to talk to Dr. Hilton when he came to Shankar Netralaya in 1995 and all. So what is basically pneumoretinopexy? It is a fantastic office-based or OPD procedure which helps us to use intravitreal air or gas to achieve retinal reattachment with just a retinopexy, that is a cryo or a laser, and there is no surgery involved at all. So what we use here is a high surface tension or buoyancy of the air or the gas, which goes ahead and tamponades the retinal brakes, which close the retinal brakes and cause enhancement of absorption of the SRF. And we side by side achieve chorioretinal adhesion by using either cryopexy or laser, and that leads to retinal reattachment. And this mechanism is a fantastic mechanism that allows us to reattach the retina. Now, many times we have to decide whether to use the cryo or the laser. Many times we use cryo because we can do it in the same time if you're giving anesthesia to the patient. So, you can do the cryo at the same time prior to the gas injection. And because of that, the visibility is good because the gas bubbles don't come in the way. And especially if they're anterior, then it becomes very easy for us to do a cryo. The only advantage of laser is it gives you lesser reaction and it gives you a faster sticking. So the problems of laser are lesser for PVR, etc. But we can get recurrences that are slightly more with laser as compared to cryo, because cryo tends to just form a very dense scar with the vitreous and all together. So what are the initial criteria for pneumoretinopexy? That the retinal break should not be a large one. It should be lesser than 1 clock hour. It should be on the superior 1/3 because the gas will not reach there. There should be not too much of a PVR, and the patient should not have any orthopedic issues by which the patient should be able to maintain position. Of course, if there is a history of glaucoma, we have to be careful because the IOP can rise and there should be no cloudy media at all. And therefore, the good candidate is the one, like I mentioned, the one who's got a superior 8 clock hours of tear. And the multiple breaks, if they are there, it should be less than 1 clock hour of each other. So how do we do it? under anesthesia, which can be topical if you're going to use laser later on, or a local anesthesia if you're going to do cryo. We go inside the eye and inject an air bubble. And once the air bubble is injected, we give a position to the patient so that the air bubble goes and covers the break with the help of the surface tension. And once the retina is attached, we can do a laser, or if you have done a cryo already, then we don't need to go ahead and do the laser. Basically, many a times you can give subtenance injection of lidocaine, which helps a good amount of anesthesia. Don't forget to do a paracentesis, because the IOP can really shoot up with the gas bubble, and we inject 0.5 to 0.6 ml of pure SF6 through the pars plana, or sometimes even see.
Is the presentation good?
I think, can you hear Dr. Nishikant?
No, I think it's the slides are not moving forward.
Yeah.
There must be internet problem there, not Thambo.
I think we can call him.
Let's see.
So should we take the next talk by then? Or we'll wait?
Just talk to him now if he's receiving the phone.
So Dr. Nishikant is trying to patch back. In the meantime, maybe we can ask then Dr. Ashish to start.
Yeah, Preetam, can you hear me?
Yes, we can hear you. And Swapnesh is going to play,
Yes.
play your slides, no?
Yes, I
No,
request the backend team.
options. Yeah, I think I can try and play my slides, because the slides that Swapnesh has a voiceover also.
Oh, great.
So if you can see, I don't know if you can see me. I think Nishi is still sharing his screen.
I request the backend team to stop share, because they will have that option of directly stopping share from their end. Sai?
Yeah.
Yeah. So should I share, or Ashish sir, you are sharing it?
Okay, I'll try and just share it. I will share. Yeah, one second. Share
Where is it?
screen.
Without permission. Go back.
No.
Is your screen being shared? Just ask.
Yeah, can you see me the slide?
Yes.
Yes, sir. Yes, sir.
Okay. So, good morning, everybody. I'm here in Dharamshala on a trek, and I think I've just got back with the reception. I don't know if you can see behind me, there is the Mount Himalayas, which are there. And I think it's a fantastic location to give a talk from.
We are envying you.
At the outset, I would like to thank the MOS and Nitin Prabhu Desai for this. So my talk for today is, how does laser work in a retinal detachment? In retina, one has multiple choices. Just now I'm trekking, and you can go this way, that way, or you can go the other way. But it's always nice to make the right choice and not the wrong decision. Chororetinal adhesions can be formed because of laser, cryo, or diathermy. The cryo adhesions, as Nishi also said, are much stronger and they are more destructive. But they can work in a thin layer of SRF, but there are again higher chances of PVR and inflammation. the diathermy is almost given up. In a study, laser flare photometry showed that in the first 10 weeks, there was significant breakdown of the blood ocular barrier when cryo was given as compared to laser, but then visual acuity was the same after 10 weeks. So what is the goal of laser when we do it? It causes a firm chororetinal adhesion which completely surrounds a retinal break. It needs to counter the vitreoretinal traction and prevent the liquefied vitreous from passing into the subretinal space to generate a retinal detachment. One must give at least 3 near confluent rows of laser. But remember, this is with a slit lamp with a 300 to 500 micron spot size. If you are doing it with the indirect ophthalmoscope or with an endo laser, one may need up to 5 rows of laser. That's what I prefer, usually around 5 rows at least of confluent laser. It's important if you're treating the far peripheral tears and retinal dialysis, the treatment has to be extended till the ora serrata, as the most common reason for treatment failure in these cases is insufficient laser placed around the anterior margin of the retinal break. So one must extend that laser right till the ora serrata. When you do laser, what are the prerequisites? There has to be apposition of the retinal pigment epithelium and the retina. If there is a very thin layer of SRF, maybe the red laser may work. But if there is a significant amount of SRF, the laser will not work. The burn has to be of a sufficient intensity. Usually a low white burn is sufficient. It needs to be strong enough to relieve the traction, and the tamponade has to be there till the reaction sets in. In another experimental study, in a normal patient, when they give laser, the adhesive force was reduced to 50% of normal at 8 hours. So it actually reduces initially, for which the tamponade and positioning is very important, but increased to about 140% by 24 hours. But in a retina which was experimentally detached and then the adhesion was created, it needs 2 weeks to reach its strongest, which is 3 times normal. And hence, for the first 2 weeks, it is very important that the patient maintains position and doesn't do too much of activities, too much of movements. If a small amount of subretinal fluid is also present, then the time course for this is even more delayed, and many times the reaction may not even happen. So in such cases, we may need a very strong laser. When we do laser, lasers are of different types. You have the green versus the red laser. There's also the yellow laser. It depends upon the extent of the laser, whether focal laser to the breaks or 360-degree barrage, and what is the role of retina demarcating laser. Let's see the green versus the yellow versus the red laser. In the green laser, the absorption by melanin and hemoglobin is there, and it is least absorbed by xanthophyll. And hence, because of this, the retinal photoreceptor cells are relatively more preserved. The red has better penetration through the media opacities, and it also can work in a thin layer of fluid, but it is more painful and difficult to titrate. Now, what is demarcation laser photocoagulation? Sometimes if patients have a very small subclinical retinal detachment, one can wall off the retinal detachment with laser and hence prevent a surgery. So for this, one needs a shallow, non-bullous detachment. It has to be stable, very often an inferior detachment with already some amount of demarcation lines present. It should be a relatively tense RD and no corrugation seen, no bullous element seen. Because if a bullous element is present, lots of fluid is present, then demarcation will not work. In a study of macula sparing retinal detachment in teenagers, now these patients would not have had a posterior vitreous detachment. In most of the eyes, in 32 patients, there was very good results. However, in another study, Al Motassaeb et al. Found that 38.5% patients with symptomatic retinal detachments required intervention second to because of progression. So it's not a good idea to do it in patients who have a symptomatic retinal detachment or if there is a lot of fluid under the retina. Personally, I usually don't advocate doing it. The second question is, what about laser to the retinal breaks versus 360-degree prophylactic laser? Again, there's a controversy about this as to which really works. Now, in this study, they did a 360-degree laser in patients who underwent a phaco-vitrectomy for macular hole. And in these patients, none of the patients developed a retinal detachment. While if the patients who did not receive the 360-degree laser, about 5 patients out of 35 developed a retinal detachment. While if you already have a retinal detachment, then it does not make a difference whether you do 360-degree laser or you do a focal laser. Again, in another study, localized laser is to be as effective as 360-degree laser application, and it may give a better advantage in terms of lower invasiveness, reduction of complications, and time saving. Cryotherapy can give rise to a lot of PVR and hence is usually avoided, especially with very large and huge breaks. Here, if you see the primary retina detachment outcome study, it also said that giving focal laser was much better. But again, other studies show that intraoperative 360-degree laser retinopexy was much better and resulted in fewer retinal redetachments. So it's again controversial whether to give it locally or to give a full 360-degree laser. Now, what are the complications? You can have anterior segment complications as corneal or lenticular opacification. You can be transient visual loss, photocoagulation of the fovea, macular edema, hemorrhage, choroidal effusion if you do a lot of laser. And it's important to remember that 360-degree laser can give rise to neurotrophic keratitis, which can be permanent. What about prophylactic laser? It is absolutely essential in patients who give acute PVD with horseshoe tear, patient with symptomatic breaks with traction on the edge of the lesion, if there is increasing amount of fluid, and fellow eyes of the patient with retinal detachment. A simple lattice in a 25-year-old patient who is not symptomatic laser may not be required at that stage. However, one must keep into mind risk factors also. These are axial myopia, cataract surgery, ocular trauma, contralateral retinal rhegmatogenous retinal detachment, and acute PVD. So a lattice with acute PVD, I will definitely tend to be on the side of lasering, even if there are no breaks which are seen. So in the end, one needs to make the right decision. And sometimes the right decision is a tough decision. And with that, you can have multiple solutions, which can all lead to the final goal of retinal reattachment and no further retinal detachments. Thank you.
Excellent talk, Ashish.
Thank you. I hope it was heard. And you can see the scenery also. Thank you.
Yeah, Ashish, a very good talk. Any comments from Vatsal sir about laser photocoagulation?
So I'm going to show some photographs of actual patients. Since you told me I might have to cover,
Right.
Take it there,
Okay, fine. I think then we'll move to the next talk. I think Ashish will have to
Yeah, I'm trying to stop share.
stop sharing.
Yeah. I think I stopped sharing.
Okay, fine. Can you see my screen now?
Yes.
Okay, good afternoon, everybody. So, retinal detachment is an important problem which every retinal surgeon has to face. And as we discussed just now, there are multiple options to treat the retinal detachment. We just had talks from Dr. Ashish and Dr. Nishikant, where we discussed two relatively non-invasive procedures, of attaching the retina, but they are usually useful only when the retinal detachment is partial, that is pneumoretinopexy and laser photocoagulation. Now, in the next few minutes, I'll be discussing with you a very important technique of scleral buckle to manage primary rhegmatogenous retinal detachment. Now, when a patient presents to you with such type of a partial retinal detachment and a definite single break, I think it's a straightforward case for scleral buckle. Or if you have again a break here and a break here, and you operate him with scleral buckle, day one, you can see the retina is well attached. You can see the ridge of the buckle well. And at 1 month, again, the patient is quite fine. So in specific situations, if we use a scleral buckle, it really gives a very good result. Even if the patient has multiple breaks, we can treat them with the scleral buckle. So a definite single break, absence of significant PVR, a young phakic patient. A phakic patient is really important because inducing PVD in such patients is very difficult. So whenever possible, we try to settle this retina with a scleral buckle. Even if the patient is aphakic and if the pupil is well dilating and the vitreous is clear and the breaks are usually small, we can use scleral buckle techniques in these patients. Pseudophakic patients also who are well dilating and a clear vitreous are good candidates for scleral buckle surgery. However, said this, if you have this multiple breaks with rolled margins, doing a scleral buckle even in the absence of PVR may be difficult. And with the present day MICS techniques, I think vitrectomy would be a preferable choice, about which Dr. Samant would be telling us in the next few minutes. Or if there is a significant PVR, almost PVR D2 or PVR D3, I think there's no point in considering scleral buckle in these particular situations. Also, for giant retinal tear or a giant dialysis, scleral buckle is not a technique of choice. So if you decide to do a scleral buckle, it's very important that your surgery is preceded by a proper dilated indirect ophthalmoscopy and a proper retinal drawing. Now, it may be a little old-fashioned about talking about proper retinal drawing, but I think it is really important because it helps in your proper documentation, planning the treatment, and also executing the treatment. If you know where the retinal break is, if you know how the retinal break dimensions are, it is really, you don't waste time on table and you can quickly locate those breaks and treat them effectively. Also, it helps in reviewing and following up the patient because you know that how the detachment was before and how your surgery has worked. And if there is a recurrence, you know it's the same break which is leaking or you have a newer break. And also helpful if you, if after you do the surgery, if you're not able to follow up the patient and if your colleague is watching this patient, if he has a pre-op drawing, he knows exactly how the patient is behaving following the surgery. So a quick drawing like this on your OT chart would be good because you can just have one look at the drawing and you know what the case is, especially if you're seeing the patient for surgery after the primary examination has occurred a few weeks back. And you can have some landmarks to quickly locate those breaks. And you can have a surgical plan. You have this, you know where to apply the buckle, where to drain fluid, and how to put the encircling element. Usually the surgical anesthesia is local in adults, local with sedation if the adult is very anxious, and general anesthesia only for children below 15. Most of the children above 15 do cooperate for a local anesthesia, and we can perform these surgeries with quite ease. Now we'll just go through quickly the various steps we do in scleral buckle surgery. Obviously, you need to have the conjunctival peritomy because you want to expose the muscles. So you do a 360 peritomy and you take 2 radial cuts to relax the conjunctiva and help you to approach the posterior pole. You do post-conjunctival peritomy. You try to separate the intermuscular septums so that you can reach the muscles. And you start hooking the muscles. Usually the sequence is that you first hook the inferior rectus, followed by the 2 lateral recti, and lastly, the superior rectus. Once you isolate the muscle, you pass a suture under it so that you can manipulate the muscle. And you again pass sutures through all. And once the sutures are passed, you start inspecting the sclera. This is very important because especially in the quadrant where you're going to apply the buckle, you should be sure that there is no ectasia or there is no already a very, very thin sclera, which would cause hindrance to your creating the flap or even in passing sutures if you're doing an explant technique. So once you see the sclera, you use an indirect ophthalmoscope to mark the break from outside, and this is a diathermy mark. You can also use a blue pen, any colored pen to mark the retinal break. Once the retinal break is marked, you do cryo to it. And once the cryo is done, you start making the scleral flaps. Dissection is needed in case you are planning an implant technique. And I'll be showing you the steps of implant technique in this case. So here you start dissecting sclera. And obviously you should know that what is the obvious scleral thickening. If it is too thin, you have to be very careful. And probably you can use a blunter knife to start the dissection. So you mark the initial extent of the break. The simple technique is to go about 3 mm all around the break. That is 3 mm anterior, 3 mm posterior, and 3 mm on the lateral sides. If you have multiple breaks, you mark all the breaks and then accordingly go 3 mm outside those breaks. Once you start dissecting, you mark both the edges, and sometimes you can have such problems when you have a sort of a thinner cornea, thinner sclera. You can see I specifically put this slide here because the sclera can just give way and choroid starts popping out. But still, you can continue with the dissection if you do it carefully. So here we have completed the dissection. The sclera is the choroid is still holding on, but you have to be very careful in manipulations. Once the dissection is done, you place a buccal element, and your buccal element is decided upon the size of the flap. You can use a 276, 279, whatever you feel fits into that particular dissection. And once you select the buccal, you select the size of the buccal by placing it on the dissection and cutting it to the required size. You usually trim the edges so that they don't impinge on the thinner sclera. Once your main scleral bed is dissected, you then form a scleral tunnel for passing the 240 encerclage. Now, sometimes in the past, we used to even take sutures for this, but I think passing through the scleral tunnel is an easier technique and it is less traumatic to the patient. So you make the scleral tunnel in all quadrants where you don't have the main buccal element. And once these tunnels are made, you then pass sutures to hold the buccal. Usually we use a 40 or a 50 ethibond to hold the buccal. These sutures are passed and not made permanent. And once you make the sutures, you pass the buccal along with the encircling elements under the sutures and place it. Once this is done, you then place the 240 element through all those encircling, all those scleral dissections you have made all around and come to the point where you have made the initial major buccal dissection. Once the buccal is placed, the encircling element is in place, then you make a drainage site. Now the drainage site is decided usually upon the extent of the retinal detachment. You prefer to do it under the horizontal recti. It's not too close to the vortex veins. So your site should be in such that once you drain, the fluid should be drained mainly by gravity and there should not be any incarceration of the retina. So if you are going to drain in a very shallow RD, you have to be very careful that you make the opening in the right place and the right force. So once you expose the choroidal knuckle, you use a sharp 10-0 needle to make an opening in that choroid and then drain the fluid. Fluid drainage also should be done gently. Too much pressure should not be applied, so that especially when the fluid drainage is coming to an end, you know this by if you start seeing pigments coming out through the opening in the choroid, you know that your fluid drainage is coming to a completion. So once the drainage is complete, then you tighten up the scleral band and you tighten it adequately, so you should not create too much of an pressure on the eyeball. Once you tighten it, you check with the indirect ophthalmoscope about the adequacy of the scleral buccal, whether you have covered the breaks properly, whether the height of the buccal is adequate, and whether you are not caused too much of a pressure rise, because you have to check the optic nerve to see whether the optic nerve, the vessels are pulsating or not. If they are not pulsating, that means you know that your pressure is not too high. Once you pass once you make the scleral buccal sutures permanent, you can then tighten up the 240 encircling element and you pass a knot over it and tighten it again adequately, not causing too much of a pressure rise. Once that is done, then you give a wash over the scleral buccal, see that there are no fibers left there, and then start closing the conjunctiva. Once the conjunctiva is closed, then you may probably inject an antibiotic to take care of the infection part. So these are the steps which we do to perform these surgeries, and if done properly, I think in most cases you get a fairly good result. And once the anatomical success is achieved, the patient's vision gradually improves over the next 4 to 6 weeks. That's the time when you do the refraction and give him the proper correction. Thank you for your patient hearing. Okay, Preetham, I think you're next online. Any discussion on the scleral dissection points? Preetham, you have to add anything in your?
I think you've covered it. So you've covered practically everything. Dr. Sasavade sir is here. Hello, Dr. Sasavade sir.
Can I talk?
Yeah, sure.
Yes, sir. Excellent presentation. Only thing that what I have learned in my buckling surgery that rotate the knots towards the posterior side. So there is never an exposure of the suture and exposure related complications. Even buckle. That's a good point.
Especially, I think if you are doing a very anterior buckle.
Yeah.
Especially 276 or so, those buckles tend to sutures come to 10 forward.
Yeah, they come to forward, and even cosmetically also doesn't look good sometimes. These are greenish, bluish tinge sutures.
But the flip side is they're easy to remove also.
Yes, that's true.
Yes.
In the discussion before we missed it.
You are still doing.
Manoj and Preetham.
Yeah.
Ashish made a point about 360-degree laser.
Yes.
So do you do routinely in your patients?
So I have stopped doing that, sir. So because I believe that number one, if you've seen the break, it's the break that requires the closure. That is number one. Our visualization techniques have improved so much. We are no longer in the era where we used to wonder that are we missing out certain breaks. I mean, now we can depress also. We have wide angle viewing systems. During surgery, we can depress and check the rest of the retina and see areas we've not seen pre-operatively. And the last thing is, if you're lasering more of the normal retina, we have to remember that if at all a recurrence occurs, then each of those areas essentially becomes a potential hole. So I've stopped really lasering 360 degrees on the buccal. I only treat the breaks.
Yes,
I agree with that. Important message we should send, because I've seen many people getting treated unnecessarily, large areas of the retina with laser.
Yeah, I agree with Preetham, but there is another side of it also. There are RD cases. Most of the time, even with the depression and with the good visualization system, we always tend to miss the breaks. And nowadays, we are not putting the belt buckle also. So those cases who are having high risk of recurrences, it is always better to do the mild laser 360 degree. There is no harm in doing the mild burns. It works very well. So the recurrence rate 10 years before and today's recurrence rate, if you compare ourselves also, I don't see any recurrence nowadays, because might be a good technique of the surgery as well as the implementation of the 360 degree lasers in such cases.
Vatsal bhai, any comments? And yes, Manish will come to you.
I do not believe in 360 degree laser because recurrence is primarily due to PVR and not necessarily missed breaks. And I think one has to be careful in surgery, because in my slide, I'm going to mention that iatrogenic complications is one of the cause of redetachments. So I wouldn't do it as a routine.
That's true.
Yeah, Manish, a quick comment.
So I sometimes do lasers, especially if the patient is coming late for SOR. I do laser on a slit lamp laser a week or 10 days before removing the oil, because this oil itself can cause membranes and can pull on the retina in delayed oil removal cases. So with those patients, I thought that it works. Otherwise, I also don't do laser 360 degrees, but late oil removals pre-op a week or two, I do 360 degrees.
Okay, let's move on with Preetham's talk now.
Sure. Let's share the screen.
Yeah, please.
Can you see my screen?
Yes.
Yeah. So many thanks to Dr. Prabhu Desai for having us here on this instruction course. So I'm going to cover a large topic in a short time with some salient features. and that is principled and techniques of vitrectomy in retinal detachment. So, I'm going to, my presentation is in 3 parts. I hope everyone can hear me and see my slides.
Yes, please.
Yeah. So I'm going to speak about the indications, then go to the principles, and then speak about the modern vitrectomy techniques. So when do we prefer vitrectomy for retinal detachment? Dr. Prabhu Desai did mention in his talk that advanced PVR are those cases where where the vitreous is diseased and you would like to go inside the eye. Whenever there is RD, rhegmatogenous RD accompanied by, let's say, vitreous hemorrhage, macular hole, or say intraocular foreign body, a giant retinal tear, probably a dropped nucleus or a dislocated IOL, then obviously you have to go inside the eye, that is do a vitrectomy. In the MIVS and the sutureless era, whether we like it or not, the incidence of surgeons doing buckling has definitely gone down. Whether it is, senior surgeons or junior surgeons, if you look back, I'm sure everyone will agree that their indications, their numbers of buckles have gone down. And especially for cases like, let's say, a localized superior RD with a single break, or a pseudophakic superior RD with a superior break, you can easily get away with sutureless vitrectomy, and the patient will be much more comfortable, will have early rehabilitation, can go back to work earlier. So it is debatable whether we should be doing our routine conventional scleral buckling or straight away do a vitrectomy in cases like these. So the principles is now the most important aspect of RD is PVD induction, and triamcinolone is a good agent that we've discovered in the past few years. The induction can be done actively or passively, but one has to be careful in a retinal detachment case, like you see in this video. Can you all see the video on the right hand side?
Yes, please.
You can see how you can see the Weiss's ring, you can see the vitreous is detached here, but you can see the bullous RD underneath it. So one has to be extremely careful. And maybe once you start the vitrectomy, you can put a small bubble of PFCL and then remove the rest of the vitreous. One can also do a forceps assisted PVD induction in case the suction doesn't work, especially for young retinal detachments. One must ensure complete vitrectomy when you're treating a retinal detachment. The rationale being that any residual vitreous will help the PVR, will help the proliferation of the PVR, and that will lead to a recurrence of RD. If possible, wherever base excision should be done to achieve complete vitrectomy, base excision will be easier in aphakics and pseudophakics, but can be done also to a good extent in phakic patients. It will be challenging in pediatric and young RDs where the vitreous is formed and really attached to the retina. Then flattening and settling the retina. So the fluid air exchange which is done flattens the retina. And if by fluid air exchange the retina does not flatten, and one indication of that is you will have subretinal air once you do your fluid air exchange, that will tell you that the retina is intrinsically contracted because of advanced PVR, and that will warrant doing a relaxing retinotomy. This is a whole topic in itself which we are going to discuss today afternoon. And in those situations where let's say there is, after doing fluid air exchange, you're left with a pocket of fluid near the optic nerve, there you really don't have to sweat or worry, because if your brake is attached, then this residual pocket of SRF is going, you don't have to worry about those residual pockets posteriorly. Next is doing endolaser and cryopexy to all the brakes, which is done under air or can be done under PFCL, and has to be done before inserting the tamponade. Now, when we look at tamponades, PFCL is a temporary tamponade that we use. It acts as the third surgical hands. It helps in doing vitrectomy without causing any iatrogenic breaks. It also helps in keeping the retina immobile. And as you can see here in this case, this is a large myope with a giant retinal tear. You can see there the entire retina on this side is rolled up. And after doing the initial core vitrectomy, PFCL bubble is put. You can see the PFCL bubble put on the posterior retina, and that has helped to roll this giant retinal flap back. And after doing lasering the edges of the flap, we then remove this PFCL while doing a PFCL oil exchange. You can see a PFCL oil exchange being done here, and the last part of the PFCL bubble being slowly, you can see the margin of the PFCL contracting and slowly coming into the flute needle while oil is being injected from the top. So PFCL has really made life easy and has achieved better results in vitreoretinal surgery. You can see the laser marks on the GRT. And then there is this gas, intraocular gas and silicone oil tamponade, which we use for tamponade, which has to be accompanied by prone position post-operatively. The next important principle of vitrectomy is whether to put an encerclage or not to put an encerclage. So there, I usually keep one dictum, that is where in those situations where I'm not happy with the amount of vitrectomy I've done, like let's say in phakic RDs or probably young or pediatric RDs, in those situations, probably I would use an encerclage. In those situations where there is advanced PVR and the retina is stiff, although I've managed to settle it, I'm not sure that the RD will recur. Those cases I'll put an encerclage. Probably inferior breaks, because we all know that there will potentially be a layer of fluid between the oil and the inferior retina. Those situations I would probably put an encerclage. How has modern vitrectomy changed vitreous surgery? Well, you can see here in this video, this is a video of a vitrectomy which I'm doing way back in 2014. It's a 20 gauge vitrectomy, and you can see how I'm trying to clear the vitreous popping out of the sclerotomy here. This procedure was called as a toilet of the vitrectomy site, and it was important to do this because otherwise you would have the retina falling into this port and you would end up with iatrogenic breaks. So this free flowing with sclerotomy was a concept that time. But now with the advent, and then there were also sclerotomy related complications, like you can see here a hole here right at the sclerotomy. This is the retinal break which I have created at the sclerotomy site, and then I would obviously have to treat this retinal break and do a fluid air exchange. But the other problem which our trocar cannula system also prevents is inadvertent ocular hypotomy. You can see here the trocar cannula being put inside, and the valve trocar cannulas have made our life much easier in avoiding the ocular hypotomy, which can sometimes be really disastrous, can cause suprachoroidal hemorrhage, especially if you're doing a myopic retinal detachment. So these are the valve trocar cannulas which we nowadays prefer to use in retinal detachment. But one has to remember that it has a valve. So when you are injecting a tamponade like a gas, you have to make sure that you vent the cannula. This is venting the valve cannula. This is important. So to vent a valve cannula, you get a vent which comes with the trocar cannula set, or you can simply put another non-valved cannula into place over there, and you can allow the gas to come out through here. You can see the gas being injected and this valve cannula is being vented. So these are some of the finer aspects of the modern MIVS trocar cannula system that we use for retinal detachment. Of course, needless to say, the high-speed vitrectomy also has made life much easier, because of which there is a less chance of iatrogenic breaks. Your vitrectomy gets over in a short surgical time. The concept of duty cycle also has changed things. So duty cycle is essentially where the rate of cutting is altered, keeping the cutting rate same. So see, now you can see this is a cutting rate is the same 2,500, but this particular port is open for less amount of time. You can see this is open for more amount of time, this is open for less amount of time. So this is a maximum duty cycle, or what is called as a core technique, and this is a minimum duty cycle, which is a shave. And if you see here, the core where the port is open for a longer time, you can see the amount of turbulence it is causing in the vitreous. Whereas here in the shave technique, the vitreous is so steady and it's not really turbulent. So this is definitely going to be more safer to not cause iatrogenic retinal breaks. Here showing you it actually in vivo. You can see how using the core technique, my cutter inadvertently catches hold of the anterior flap of this horseshoe tear. And this is the core vitrectomy going on with 4,500 cuts. And in the next, in this clip, we are in the shave technique with again the same amount of cuts, and you can see the retina is absolutely steady. Only the vitreous is coming into my cutter. So this is how the duty cycle helps in rhegmatogenous retinal detachments. And last, just to conclude, some of the other things which have changed the way our success in retinal surgeries is the advent of chandeliers, better illumination, wide-angle viewing systems also have made life much easier. Chromovitrectomy, better tamponades, better instruments. This has all changed. You can see a chandelier being used over here. Now this is a retinal detachment with the intraocular foreign body, and the foreign body is impacted right here, just superior to the superior arcade. Now, to remove, to yank this foreign body out without a chandelier means it would cause a lot of retinal damage. So instead, I put a chandelier, I do a bimanual dissection to sort of disinsert this intraocular foreign body from the retina at this point, and then get the intraocular foreign body out through an extended sclerotomy. You can see here using a magnet, bringing it out with a forceps. You can see my macula is still intact. The foreign body comes out, and then I repair the rest of the retina. You can see this patient is still phakic. I'm trying to save the lens also in this situation, and here I'm treating the break caused by the foreign body. So with this, I would like to conclude and say thank you here. Thank you so much.
Thank you, Pritam.
Thank you, Pritam, for your excellent presentation. I think you have covered all the points, and there's not much more to be said. Anyway, Manoj, with your practical experience, anything to add?
Nothing to add. Pritam has shown all the Steve charts, which we all learned in the book in the 2 dimensions. He has shown in the video format. Everything is cleared now. There are few questions to Pritam. What is that chromovitrectomy? And second thing, that I am not comfortable with the chandelier. I don't know how you can teach me.
So chromovitrectomy essentially using the dyes, the dyes which we use, especially when you are faced with, let's say, a macular hole with a retinal detachment where it's staining the ILM.
Yes.
That's just the word used for using the dyes.
Yes.
And chandeliers per se, so chandeliers I would probably, in those situations, where you have impacted intraocular foreign bodies, or probably where you have to dealing with combined retinal detachments like diabetic retinal detachments, where you require bimanual dissection of these membranes. I think these are the situations where you would use chandeliers. In a routine rheumatogenic RD, I think you could still get away without chandeliers.
Yeah, any special precaution or technique is there for chandelier?
So I usually, insert the chandeliers just adjacent to the 12 o'clock or the 6 o'clock position. So what happens is, you can, and I usually put 2 cannulas, one at superior and one inferior. So you can even change the position of the chandeliers intraoperatively, because depending on where it is casting a shadow and where it is into the, the dark side of the instruments. So, you can do that way. And otherwise, I think it's fantastic to do a bimanual dissection with the help of chandeliers.
Okay, thank you. Thank you.
Okay. Let's ask Dr. Vatsal sir to start his talk, please.
Yes, I'll share the screen. Is my screen visible?
Yes, yes.
Okay, so mine is going to be a summary of all the talks and how I treat this patients, So I'm going to share with the photographs. We had done a small study of 100 consecutive cases where we did analyze our all detachment surgeries, especially vitrectomy. And we, in our limited experience, we felt that phakic or pseudophakic eyes, vitrectomy did not make difference. And I think my results were good with 23 gauge vitrectomy with C3F8 gas, and for inferior breaks also, vitrectomy with gas without buccal worked well in our hands. Now we'll just share the indications. Now, this was one patient with multiple horseshoe tear subclinical detachment. And as you see on OCT there, you can see the hole quite well. And this was a patient which was buckled by Dr. Hitendra Mehta and has remained well, So this was one of the indication. This was another patient, young patient about 20 with horseshoe tear and localized detachment, though it looked like bullous, and this has been lasered over 2 years. It has remained well. And this is a recent patient who had giant tear operated in other eye and it was not doing well. And this I had multiple breaks, and this patient was lasered by somebody, but the break has all remained anterior to the laser marks. And it's, I think, 3 months patient has not gone for surgery, is about 13-year-old. So it would be a difficult question, but right now it's holding. These are other patients with multiple horseshoe tears where lasers have been done and they do reasonably well. My feeling is that if patient does not develop detachment for a month or 2, they would continue to do well. Similarly, this patient has horseshoe tear here, all are lasered well. Now, this was another interesting case which came with a large horseshoe tear inferiorly, looking almost like giant tear. Lasered, he remained well for 1 month, but then he developed detachment and needed surgery. Pneumoretinopexy, I do not do as a primary procedure right now. Why? Because there was one patient who had superior hole and detachment, underwent pneumo, was fine for 3 weeks, developed redetachment, underwent vitrectomy with 23 gauge vitrectomy without buckle. Unfortunately, patient had a new break and inoperable retina. And I had similarly another patient where I did pneumo, but it didn't work so well. So right now I don't do much of pneumo. Now, as Nitin showed and Preetham showed, whether to buckle or do primary weight, that's always a question now, since we are comfortable with both the procedures. Now, this was a patient who was about 52, had a break here, had a fold here. I thought of doing vitrectomy, but our friend Hitendra Mehta did buckle and patient did well. Similarly, another patient with a horseshoe tear here, equatorial, localized detachment at about 38 years age. As you see here on OCT, you can see the hole here. I had suggested vitrectomy. Hitendra did buckle and it has done well. So these are the cases where either of the technique can do well. Now, this was another patient that Prabhu Desai had shown a buckle being done, and I had done primary vitrectomy for this patient with 23 gauge and laser, and it has done well. So I think there are more than one ways to go about this. Now, this was a patient who was high myopic. I had done vitrectomy, but it did not do well. The other eye of the same patient, he had detachment, high myopic, and here I had done buckle, and the buckled eye has done well. However, though we say that vitrectomy has cataract development, this patient is about 32, 33-year-old and high myopic. Even after a buckle, after 1.5 months, he had a mature cataract, and though there was no question of lens touch in buckle, but this was a patient who developed detachment. Another high myopic patient had detachment inferior break. So here I have done vitrectomy with gas and a belt buckle because this was high myopic eye, and I felt maybe this would be safer because patient is one-eyed. This is the other eye of the same another patient where inferior break. I done 2 vitrectomies, but still there was detachment. This patient, other eye, had superior detachment and inferior break. I did vitrectomy with belt buckle, with gas, and it's almost 2 months post-op. The retina is nicely attached, and this eye also axial length is about 32 millimeter of mercury. 32 millimeter length. Now, I'll just share some of the giant tear. This was inferior giant tear, only vitrectomy with 23 gauge and gas, no buckle, and retina remained well. Unfortunately, I did not have wide angle camera there, so we could not take picture, but the retina has remained beautifully attached without buckle and inferior break. Another superior giant tear, I did vitrectomy with gas, C3F8. After 1.5 months, patient had redetachment and underwent revitrectomy with oil and retina reattached. Another one-eyed patient with giant tear, as you see here, I did vitrectomy with gas alone. Though the age has rolled, the retina is remained attached for almost more than 1.5 years now. Now, this is an interesting case, giant tear, as you see here, almost 120-degree giant tear, vitrectomy with 23 gauge and C3F8, a good laser. The retina remained attached for almost 1.5 months, had inferior detachment, as you see here. You can still see the bubble here. I did buckle, and I thought since retina was nicely attached, I used SF6 gas here. Now, having used SF6 gas, within 2 weeks, he had superior detachment. And then I had to use silicone oil, and the retina has remained nicely attached. So these cases can work different ways, and I think there's no single treatment, but you have to customize treatment as per the patient. This was a young boy about 12 who had anterior PVR, and you can see the retina behind the lens. And this boy underwent vitrectomy, lensectomy, and silicone oil and buckle, and has remained well. Now, this was a patient who had 4 horseshoe tear, different meridian, and I did vitrectomy with C3F8 gas, retina redetached. So I did re-vitrectomy with silicone oil, but probably I did not put buccal, and there was persistent traction and there was persistent detachment. So probably re-vitrectomies, I feel I would put buccal if I have not put at least encircling element earlier. Similarly, another patient who had early PVR C1, C2 and a inferior break, horseshoe tear, large horseshoe tear, underwent vitrectomy with C3F8, had redetachment and the break had just opened. I thought I'll put a revision buccal only because this was almost 2 weeks after surgery. So I put a revision buccal, patient had redetachment. And then I did re-vitrectomy with oil, retina remained attached, patient had undergone phaco with IOL and ERA removal and silicone oil removal, and retina remained attached. So to conclude, I think one has to decide his or her choice, expertise, and the present knowledge to treat retina detachment. Fresh retina detachment should be treated promptly. And I think PVR is the biggest cause of redetachment, and timing of resurgery is important. Thank you for your patient hearing.
Thank you, Dr. Vatsal, for an excellent coverage of the topic. I think your documentation is very, very good. I think we just have to say we just learn from your cases. And I think I'm also very happy that you're very frank about your cases. You have treated redetachments and you have been very, very nice to just share them with us.
Thank you.
I think Pritam, can we conclude because we are already late?
Yeah. I think we should conclude so that the next, because we have to pass on the session.
Yeah,
So,
I think I'm the co-chairman for the next session, so I'm here only.
Yes.
Thank you, sir.
Thank
you, everyone, for a very kind.
Thank you.
Thank you. We are so happy even Nishikant could join us from Ranthambore.
Yes.
Yeah. So the virtual world is really Raj.
Yes.
Yes.
So with that, we hand over the session for the surgical retina 3 session. And, I would like to invite again Dr. Nitin Prabhu Desai, sir, who's co-chairing this session. Dr. Mandar is here. Good morning, Mandar. Welcome, Dr. Mandar, again a very prolific and experienced retinal surgeon. And Dr. Sachin, the star from Pune. Hello, Sachin. Sachin was one of the most sincere students way back in Shankar Netralaya, and I was doing my fellowship. Who was doing his post graduation, then did his VR fellowship. So I would like to welcome all of them to the chair. And without delay, we'll start the first topic by none other than Dr. Manish Bapai. I call him the forceps man because he has, he has all these tricks up his sleeve and new innovations. And the foreign body forceps which he has developed is an amazing instrument. And I'm going to ask him to speak today on ILM peeling in special situations. Dr. Manish, please go ahead.
Thank you, Dr. Pritam, for those kind words. And I'll share my screen. Give me a moment, please. My slides are visible?
Yes, sir.
At the outset, I would like to thank Dr. Ragini Madam, Swapnesh, Sumit, Dr. Pritam, and MOS Scientific Committee for giving me this opportunity. I'll be talking about ILM peeling in spatial situations. ILM, as we know, is a thin acellular membrane which forms innermost retinal layer, it is formed by footplate of Muller cells. It has important role in retinal histogenesis, or axonal growth, and navigation to optic disc. Embryological absence of ILM causes dysgenesis of the retinal layers. However, there is no specific function which is there in adult retina. Peeling of the ILM, it is one of the most commonly done procedures nowadays, and it helps in removal of tangential traction in the macular area, regaining the macular anatomy in tractional maculopathies. It appears to be safe when performed in atraumatic fashion and is proved to have better anatomical closure rates in macular hole surgeries. And probably more importantly, the surgical videos look really nice. However, it is, so these are the common indications we all know: full thickness macular hole most commonly done indication for ILM peeling, whether it's idiopathic, traumatic, or tractional. Rhegmatogenous retinal detachment with or without PVR, depending on surgeon's choice. Epiretinal membranes, diabetic tractional retinal detachments. I will not be covering diabetic tractional retinal detachment and diabetic macular edema because subsequent speaker is going to speak on this. Then vitreomacular traction and macular foveoschisis, optic pit maculopathy, Valsalva-Turson syndrome. These are some of the indications. It is not without complications. There is retinal trauma which can happen, intraocular dye toxicity, Mueller cell dysfunction, paracentral macular hole. There is microperimetric changes which causes microscotomas and reduced sensitivity in area of ILM peeling. Dissociated nerve fiber layer, which are hyperreflective arcuate striae in the optic nerve fiber layer. So these are the complications of ILM peeling. So it is not something which is totally harmless procedure, and we have to be judicious when we decide to do the procedure. Let's look at some of the cases. This is the case of rhegmatogenous retinal detachment. This was a young patient who had retinal detachment. In young patients, when I prefer to peel ILM because it makes sure that we are removing the PVDs properly induced, and we have complete removal of vitreous, as well as the chances of recurrence of chances of ERM formation are reduced. So in this case, I have not used any LPFC to support the retina, and it's done in piecemeal fashion. Well, this was a patient who had PVR changes, where again I have not used any LPFC, and we can quite easily remove the membranes and the ILM as well as the PVR membranes in this case without using the LPFC. We have to be very judicious while using removing the membranes to avoid any macular trauma. Okay, we can see we have removed all the PVR membranes along with the ILM in extended fashion, and this patient has done well. Here the ILM is being removed. This is a patient who had PVR changes and very tight macular pucker. I tried to remove the membranes without help of LPFC, but LPFC helps in these situations where we can use it as third hand to keep the retina flattened, and then use forceps to remove the ILM and the premacular membranes in these cases. So there are many articles about, there are 170 review articles about different indications of ILM peeling on PubMed. So many more articles which are published, and the chances of ERM formation in rhegmatogenous retinal detachment, if the primary ILM peeling is done in rhegmatogenous RD, it is helpful to reduce subsequent surgeries. The chances of recurrence are less, as well as ERM formation is less. Epiretinal membrane, many surgeons, many of us prefer to do ILM and ERM removal together. Like in this case, where I'm peeling the ILM, so the ERM on top comes along with it, and we have complete removal. We ensure complete removal. In these cases, the chances of recurrence of ERM are much less if the ILM peeling is done along with it. Whether you peel along with the ERM or separately, we get lesser chances of recurrence of ERM. But what is seen is that even if the ERM recurs, it is not visually significant. So we have to really judge whether we want to remove ILM if the ERM and ILM peeling is done separately. This is another case of optic disc pit, where this was a 12-year-old child where we have done surgery to do the vitrectomy, and then ILM peeling is done. After PVD induction, ILM peeling is done across. Now, this is, we have to be very careful in doing this, because if it's peeled across, there is a risk of full thickness macular hole developing, and we have to be very slow. And the video is made fast for saving time, but we have to do it very slow, and if possible, go around the macula. In this case, the ILM is stuffed into the optic pit here, and as the time passes, we can see the macula falling back, as well as improvement in visual acuity. Now this patient child is having vision of 6 part. She came a couple of months back, and she's after a year she's almost having flat macula and vision of 6 part. In cases of idiopathic macular holes, small macular holes, we peel the ILM. I prefer not to do inverted flap technique. I just do simple ILM peeling it from arcade to arcade. Can be done in a piecemeal fashion. It's important to have atraumatic peeling without causing any retinal damage, and do as large as possible when you are not planning to put any flaps back into macular hole. While this is another case of chronic traumatic macular hole, young patient, where the inverted flap technique is done, where the initial small peel is done around the macula, and it's not detached from the edge of the hole. And then it's the flap is trimmed with very low suction and high cut rate, and it's left to fill the macular hole. And then the peripheral peeling is done so as to remove any tangential traction around. This is a case of Valsalva retinopathy, large premacular hemorrhage, which is actually sub-ILM hemorrhage. Here, this aspiration scraper is used to remove the blood clots initially, and then after doing staining, the ILM is peeled so as to get the complete removal of the ILM and the blood clots along with it. This is in case of vitreomacular traction, which is quite common. This is where I'm using aspiration scraper to gently induce PVD. So because violent induction of PVD in these cases can cause macular hole by deroofing the macula. So gentle PVD induction is done all around the vitreomacular traction, and then vitrectomy is completed, and then the same instrument can be used to create initial flap, ILM flap, which can then be completed with the ILM peeling forceps. Again, there is no flap which is left on the macula. It's complete removal of the ILM in this case. This is another case where this was a patient who had sub-silicon oil membrane formation, and the high myopic eye, the forceps couldn't reach the ILM or ERM removal forceps. So ERM. So here again, the aspiration scraper was used to kind of grab the edge of the ERM and ILM, and I could peel the membrane in toto. We can see when the ILM is coming along with the ERM in this case. So once it is removed from all around, at the end of forceps is used. So to conclude, it's a relatively safe procedure in experienced hand for various indications. We have favorable anatomical results in majority of the patients. However, decision to peel should depend on individual case, depending on anatomical and visual benefits, and intra-op and post-op complications have to be kept in mind. It's not necessary to remove ILM in each and every case. However, where it is required, it can be done. It should be done in safe manner. Thank you for your kind attention.
Thank you, Manish, for the excellent talk. Any questions for Dr. Manish? Okay, one small question, Manish. For the resurgery of the macular hole, the primary surgery has caused a type 2 macular closure.
Yeah.
Do you have an indication for resurgery, and when do you operate, and any specific things you do for the same?
So basically, if it's, I would operate if the whole edges of the hole are raised. If there are cystoid changes which are seen and edges of the holes are raised, then I would probably then I would do resurgery. I have tried putting the ILM graft from other side, but it's difficult to hold it in place. But in these cases, I have found a technique followed by Dr. Manish Nagpal to be very useful. If you just do proper peeling, if your peeling is proper, if you've ensured that, then you can just massage the edges of the macular hole, and then you can get anatomical closure quite well. One thing is that we are leaving, we are doing a lot of inverted flap techniques nowadays, but that is also one of the reasons for non-closure of the hole, because if the flap moves out of the macula and then it keeps pulling on the macular hole, it can reopen. It has happened in one of my case where after going in, I realized it was the flap which was causing the whole non-closure of the hole. So that is something we have to be careful about. I think massaging the macular hole edges works quite well in resurgeries.
Nitin, can I make a comment on this, Nitin?
Yeah, please.
Yeah, Sachin, you can email me. I'll have a presentation where there were about 6 patients of primary surgery done by me of macular hole. And I've just done OPD C3F8, where I have seen on OCT there is no ERM and these holes have got beautifully closed. So if you want, you can share me your email. I'll send you the photographs, just without any operation.
Okay. You're just injecting a gas in the OPD?
Yeah,
Yeah.
like pneumoretinopexy.
Okay.
And make sure patient maintains position and 3 head closed, I think, without any surgical intervention.
What is the amount of gas you're putting in?
About, I think, 1 cc or 1.25 cc for C3F8 and paracentesis.
You don't have pressure problems with them?
I monitor the pressure.
Okay.
Means I call patient daily. And now with Silverstone, probably you can do OCT also daily and you will know what is happening.
Right. I think that is one good thing we can try in many younger patients.
I think in that situation, you have to do complete OPD FG in a vitrectomized eye. Otherwise,
not necessarily, because you have done primary surgery. So I just inject gas, and just do maybe paracentesis or remove fluid from 6 o'clock position.
Okay.
It's a pure gas, no, sir? You're injecting?
Yeah, I use pure gas.
Okay.
For Manish, I have one question, if time permits. In last 10 years, we are almost peeling the ILM in all macular holes, as well as in ERMs, macular pucker cases. Theoretically, there are so many contraindications and so many research papers about the removing the molar plates by removing the ILM. Have you come across any practical situation where you feel the ILM peeling should not have been done?
So it's not about feeling whether it should not have been done, but I have definitely seen a couple of cases of paracentral macular hole, paracentral retinal holes forming. In these cases, I have a OCT actually because of short of time, I couldn't show it, but there is you can see in the papillomacular bundle, you can see a small retinal trauma in relatively atraumatic surgery where the patient has closed macular hole and vision has improved, but not to 6.9. I think it was 6.18 the patient reviewed. So I think especially in cases where it is not absolutely necessary, like ERMs, if there is not a thick macular pucker, if you are operating on 612i or 618i for ERM, I don't think we really need to go behind removing the ILM as well. We can just do a ERM removal in such.
Yeah, correct. Correct. Thank you.
Yeah, thank you, Dr. Manish. I think we'll move on to the next talk. The next talk is by Dr. Swapnesh Sawan. I don't think need an introduction. All of us know him, a prolific retina surgeon in Mumbai. Has done an excellent job for MOS and BOA, and he's a too good administrator with a very good skills. He has done his fellowship from SN. Today he'll be talking about triple membrane management techniques. Dr. Swapnesh, you can start. You're visible, you're audible.
Okay. So thank you, Scientific Committee of MOS, for accepting this, and very warm welcome to all of you. And just beginning my talk, Dr. Manish has made this presentation quite easy for me. So ERM patients present to us with metamorphopsia, drop in visual acuity. There is a puckering of macula and underlying macular edema. There could be some fibrotic changes in the extracellular matrix at the interface. And also there could be underlying breakdown of the blood-retina barrier. So there is a double mechanism at this, where the damage is caused by the mechanical traction by the PVD, which damages the Muller cell and causes the Muller cell gliosis, and it also involves the inflammatory cytokines and growth factor causing underlying fibrosis. So good prognostic factors in our case selection could be shorter duration of symptoms, lesser central foveal thickness at the baseline is not such a good prognostic factor. Good integrity of ISOS photoreceptors can increase the confidence of the surgeon to prognosticate the patient. So we should evaluate the OCT as well as the macular status and the rest of the retina and the other eye also in these cases before promising any patient. So moving on to the videos, this is one of the simple ERM cases where I have used a brilliant blue dye, and you can see the inverse staining of the ILM around, and there is no staining of the actual ERM area. So using a max grip forceps is what I prefer, and is a run-of-the-mill surgery where we are peeling from arcade to arcade. Obviously, the basic principles of complete vitrectomy and inducing a proper PVD, checking for the peripheral breaks, hold true in all these cases. And the modern viewing systems have made this surgery quite predictable. And so this is the OCT picture of pre-op and post-op. Going to the next case, you can see that this is a more complicated case where there is a lot of puckering occurred, and almost the arcades are coming closer to each other. And Dr. Lalit Verma sir had shown a very nice presentation and called this actually kissing arcades. And we could extrapolate one of the recent OCT biomarkers as in this case also, where there is a disintegration or a disorientation of the inner retinal layers, and so we should not promise much to the patient in this particular case. So a typical 3-port vitrectomy, and beginning with the vitrectomy around the ports, going on to the anterior and the core vitrectomy. A fluid gas exchange, again using a brilliant blue dye. So some of these thick ERMs may have appendages going beyond the arcades, and it's important to identify them. I usually switch to the green ring, the macular lens of the ReSight to make my visualization much better. But it's not a bad idea to start peeling even with the yellow ring, which is a wide angle viewing ring of the ReSight system. Even with the higher magnification, we can get a good view. So also looking at the appendages, because some membranes might be tough to remove, and they might have some tentacles which are extending beyond the arcade. So undue increased traction while pulling all this can cause iatrogenic retinal breaks and bleeds. So thankfully in this particular case, after the initial hiccup, it came out nicely in toto. But in this particular case, I have restained to detect any residual ILM layer which is there, because the orientation of the arcade vessel had really gone haywire. So I thought that in this particular case there was a high chance of recurrence of ERM, if any bit of ILM was left behind. So double staining technique definitely is advocated by some of the surgeons, especially where you have a gut feeling that the ERM may recur, and a typical closure with a FG and C3 effect gas injection. This is how the result seen, and you can see the orientation of the arcade vessel going back to better, closer to the normal levels. However, the OCT picture is not so promising, and I would like to discuss at the end of this PPT about what to do about this residual edema and how do all the panelists tackle it. And this is the last case in my presentation where the ERM is much more extensive and extending almost beyond the equator and causing traction and almost schisis-like picture. So over here, again, examination of the periphery was very important, and I could see very small holes in the peripheral area, but and I've done endolaser to that particular area before I start the peeling of the ERM and the ILM. So not to miss any micro breaks which are there, because the retina over there, obviously the laser power was very titrated so that the laser itself will not cause any retinal damage. Again, beginning in a correct plane is very, very important in these particular situations. And you can see the appendages, and very well seen in this particular case where the appendage is extending beyond the arcades. So not having a very aggressive pull helps in these cases, and going bit by bit, area by area, like piecemeal, really helps in removing and getting a good removal, showing the underlying retina that there is no hole which is created. Obviously, we can again double stain and see whether there is any bit of ILM left behind, and a closure with C3 effect gas. And this is after, if you had noticed, I had shown this patient in 2016, and now after 2 years, I have achieved a good anatomical success. And in between, the patient had a lot of areas of still anatomically, it was not looking that great, but after a long time, then it improved. So we have two options in these particular cases. Staining of the vitreous is usually advocated with IBTR. It could, in cases of diabetes and RVO related ERMs, it could help in reducing the underlying macular edema. Dexamethasone, I don't have any personal experience, but there are few papers mentioning that. Also, a controversy regarding ILM peeling, it can reduce the retinal sensitivity and significantly increase the incidence of microscotomas, as pointed out by Dr. Vapai sir. And also there is a pilot study which also advocates ERM removal with foveal sparing ILM peeling, but that's too much of an effort to do, because you want to get out of the case with as less further trauma as possible. So at least I have never tried that. If I have to remove the ILM, I just remove it in toto underlying the ERM. And so yes, these were the few controversies. Question to the panelists is definitely, what are their methods to reduce the post-operative not so good anatomical success we get in certain cases after removing the ERM? Do people, especially in two categories, in idiopathic ERMs, what do they do? Do they re-inject gas and advocate further positioning for the patient? And as Vatsal sir told, that that might help. Or in cases where it is diabetes and RVO related ERMs, do they go ahead, and what is their drug of choice to make the edema settle down? Because now we have a vitrectomized eye, and the half-life of all these drugs is questionable. Thank you very much for giving a chance.
Great presentation, Swapnesh, as usual. I think when it comes to ERMs and success, one good preoperative evaluation also helps, where you're looking at the ISOS junction, the ellipsoid layer. I think there itself, sometimes you're able to judge the prognosis and foretell, the future, because everything looks good anatomically after the surgery. But then those functional surprises that you get, I'm sure many a times before surgery, you can predict them. Dr. Prabhu Desai, anything from your side?
Yeah, he was asking regarding the cystoid edema. Obviously, we won't be in a hurry to treat that because if the basic pathology was the ERM, we would definitely wait. And in his own experience, he has seen that it may take at times years together to have that anatomy getting better. Yes, but in case if he's sort of a one-eyed patient and you want faster recovery, sometimes I consider giving an IVTA after a 2 to 3 months observation if the edema persists on the OCT. Then I may consider giving him IVTA so as to clear up the remaining cystoid changes.
Thank you. So I think we'll move ahead.
Can I just make a quick point?
Yeah. Manish, please go ahead. Sorry, I missed you. Please go ahead.
Yeah. I think it's very important to, especially if you're dealing with a thick ERM, I think it's very important to counsel the patient about delayed visual recovery over a period of time because they expect quick recovery. Everybody has said it's a pretty easy surgery and all. So I think it's important to counsel the patient about delayed visual recovery. And I think it just takes its own time, up to 6 months to a year, and the vision gradually, we've seen it improve and retina fall back in its place.
Yes, and other point as Sapnesh has mentioned is don't miss the periphery because you are doing a simple surgery. You'll end up with breaks. If you miss them, you end up with more problems, as even Dr. Vatsal has shown in some of his cases. So I think always if we are concentrated on the central part, don't miss the periphery. That's very important. I think we can go with the next presentation.
Yeah. So the next presentation is I would like to invite my dear friend, Dr. Nivian Madhivanan, all the way from Chennai. And his name is not only Nivian Madhivanan, he is Nivian Madhivanan Einstein. Nivian is always looking at new ways to do old techniques. He's always looking at innovating instruments, and he always has fresh thoughts with him. And keeping that in mind, his topic for today is CM T-Flex IOL, a new option for aphakia. So welcome, Nivian, and please, the floor is yours. Go ahead.
Thank you, Preetham, for those kind words. Actually, put me under pressure before my presentation. So, respected teachers, senior ophthalmologists, my dear friends. So, is my screen visible?
Yes, Nivian.
So, I'm going to talk about the new CM T-Flex IOL, a new option for aphakia. So, as you all know, like every innovation comes with the question why, and so did mine. So, for more than 20 years, I think we've been doing scleral fixated IOL, starting from the suture technique, and then Chariot revolutionized it by externalizing the haptic. And there were many modifications of those techniques from there on. Then we had the glued IOL technique where you put the glues for the flap. Then the X-Nick technique from Aravind, where they externalized the haptic through the needles. And then now the MNA technique where they used to cauterize the end. And so these are all modifications of the existing techniques. So that's why I thought, why not a new option or a new IOL that is fit for these aphakic patients? So there came the CM T-Flex. As you can see, it's a single piece hydrophilic lens with a specialized T-shaped haptic. So these T-shaped haptic, when brought out of the sclerostomies, open up and prevent it from falling back. So there will not be any tucking or suturing. So let us go through some of the case scenarios. So this is a sclerophakia case with a 360-degree subluxated lens. As we all know, for every secondary IOL, the 0-180-degree marking is very crucial because it prevents for the stability of the lens and also for the rotation of the lens causing any astigmatism. So 2 by 2.5 scleral partial thickness flaps are actually fashioned using a crescent knife on either side. So once that is done, 1.5 millimeters away from the limbus, a 23-gauge sclerostomy is made. So here we have the lens also to deal with. So what I did is use the same needle to pierce into the substance of the nucleus to prevent it from falling back. So as we are surgeons, we know once it goes back, it's a totally new ball game. And this helped because it was relatively a soft cataract. So after a limited vitrectomy, I made a puncture through the posterior plate, and then with the combination of aspiration and cutting, the entire lensectomy could be performed easily. As you can see, this was a very soft nucleus. Care was just taken so we don't drop any of the fragments below. And then after a vitrectomy, so this is the CM T-Flex IOL. As you can see, the specialized T-shaped haptics. The loading is like any other normal foldable lens in any cartridge, which goes through a 2.8 millimeter incision. So it can go through a clear corneal incision and making sure the T haptic comes out first. So you can, using the Pranav forceps, you can see there this broad tooth forceps so that it doesn't chip away the lens material. You can use to grasp the head of it or even the neck of it. But at this time, we don't actually pull the lens because it can detach it from the optic. So we inject the rest of the lens slowly. and we can leave the trailing haptic at the wound, or sometimes with the pupil small over the iris also. And then gently it is brought out of the sclerostomy. As you can see, it actually pops out, the pop, and the T opens up. And then that is it for the one side. You can see the T junctions outside. Yeah. So this is just a small animation video clip to show how the lens is injected, and grasping the T head on is the best. Actually, you can hold the neck also, and then gently brought out, and through sclera it opens up, and these specialized haptics actually prevent it from falling back. So for the second haptic, we use the handshake technique. So here again, we have different forceps called the Nishi grasping forceps, which has serrations, so that it gives you a good hold without causing any damage to the lens. And then grasping the other head, it is gently brought outside. So once both the T-flex haptics are outside, you can see that is almost the end of the surgery. These lenses having large optics are always well centered, and the centration doesn't depend on the amount of haptics that you tuck, and the trocars are removed. And we usually use glue, but you can also use sutures or even with that. We have been having almost more than 2 years follow-up. Actually, this came out 2 years back, but thanks to COVID, it took some time for the patency and for the lens manufacturing to come out. So these were the immediate post day one pictures and some of the 1 month pictures. And we've also been doing studies on UBM to see the position of the lens, because we have some angulation between the haptic and the optic. So that prevents the rubbing of these haptics to any pigment release or any glaucoma effects. And also doing some OCT over the flaps to see how in long term, whether there's going to be any exposure of these flaps that are kept outside. We do have some local and international publications that have come out. Moving on to some of, then we started taking it for more of the challenging cases. So this was one more of a case, a young person who was a traumatic aphakia for a long time with glaucoma. So he was planned for a combined surgery, a trab with a secondary IOL implantation. So the glaucoma surgeon actually performed the trab superiorly. So mitomycin C was used. And then after that, we took over, and then the flaps were made. As for any secondary IOL, one of the major key is to make sure that you remove all the vitreous. And I always prefer to stain it with tricot, but when you can see the vitreous so clearly. So good vitrectomy is a key for any secondary IOL procedure. So this is the Nishi grasping process with crisscross serrations, which actually helps to hold the forceps. And this is the Pranav forceps. It's just a broad tooth in the center. So the other forceps, sometimes if it is sharp, it can actually bite into this hydrophilic material. So here again, going through the clear corneal incision, the lens is injected, making sure the T comes out first. It actually makes it easier, and then make sure you get a good hold of it before injecting the rest of the lens. Once the rest of the lens is injected, then we gently bring it out of the sclerostomy. So once you see that the T again opens up, and then using the handshake technique, the other side is exchanged to the other forceps. And these being these hydrophilic material actually is forgiving, so it's less traumatic to the ocular tissue and actually flexes, causing less intraocular damage also. But here in this case, we had the second thing to deal is we had the Sommering ring also. So after that, gently we had to make sure that the thing was dialed into the anterior chamber. So sometimes it is difficult just to aspirate these remnants of the nucleus. So using the T-flex as a scaffold, the Sommering ring was brought into the anterior chamber, and using very low parameters, it was phacoemulsified, making sure we don't lose any of the fragments behind. And then any of the synechiae that was there that was released, that is where the pupil actually looks irregular. There are few attachments superiorly. So once that was released, you had a nice round oval, round pupil, and you can see the PI there. So this was almost the end of the surgery. And the patient is really doing well, the good, nice filtering blood. And you can see the traumatic old scar on the cornea and well-centered IOL. So in this shortage of time, we just wanted to answer the question that it can be done without the trocar also. In some cases, we all know the most common thing is the hypotony, that is this thing. So either you can use the trocar or we can use the AC maintainer, or in some cases, we can actually do it even without that as long as the eyeball is formed. So this was one of the such cases where we did not use the trocars. We just But in the end, we had to make sure there was no vitreous that was remaining and which was stained with tricot. Complications are there as we have any secondary IOL procedures. The haptics can break if you have excess pull or more force. So there is a short learning curve. It can slip through the other side when you try to pull too hard or when we have large eyeballs. So that has been one of the things. We haven't had any late dislocations as such unless there's been a physical damage to the lens or any arthritis or glaucoma in our short experience with almost 30 IOLs now. And we haven't had any exposure to the sclera. So once again, thank the entire MOS team and like to have a special thanks for Sapnesh and Preetham. It's always been a great pleasure to be a part of this MOS and always looking forward for this wonderful experience and always inspired and learning from Manish sir's surgical videos. Thank
Always
you.
a pleasure to have you, Niven. So any comments, Sapnesh?
No, wonderful technique, and I think it's a great adaptation and great innovation from Nivian as usual. And we would be looking for Nivian for everybody would be interested in what is the make of this IOL, what is the cost, and how can we get a hold of it within Bombay? Who is the distributor?
The Appasamy, we have Appasamy who's actually manufacturing these lenses. So, and from this year onwards, it's currently available in the market. They priced it at, I think it is around 1,500 rupees. But I think I can promise the entire panelist here, I'll make sure you all get a supply of these lenses free of cost from Chennai. So it'll be great if you could all use it and then give me your feedbacks. So more of negative feedbacks to actually know whether it is actually easy to use and is it going to be an alternative. So that will be very useful and helpful.
What if you had created that T-junction a bit longer? Would it have mattered?
The overall diameter is like we have kept it as 14. So it's a good question.
No. I'm telling about the part of the IOL which juts out.
Okay.
If that is longer, then it gives a pseudo confidence or actual confidence to the surgeon that it won't slip back inside.
Yeah, it doesn't slip back inside, but then it'll be hanging, no? Like sometimes like the Emani technique where you really don't know how much of the lens is actually hanging back. So that is one thing that we wanted to prevent actually.
Okay, great, super. So and the A constant, if you know.
We have the standard is 118.0.
Okay, optical biometer.
Yes.
So,
thank you,
Dr. Nivian.
Thank you.
Shall we proceed to the next one?
Yes, please. I think we can.
Oh yes. So we have Dr. Mandar Jonglekar. Is he ready with his presentation, Mandar? Mandar?
Hello. Yeah.
Yeah.
It will take some time. I have some connectivity issues.
Okay.
Can you take with next
probably
one?
Then we'll go to Ashwin. Ashwin, you're ready? Ashwin, are you ready with your presentation on diabetes, diabetic weight? Or we proceed to Shamik then. Is Shamik around? Maybe I'll just try and call Ashwin and see if he's...
Yeah, sure.
Meanwhile, a quick question. We just save time. While doing ERM with ILM peeling, sometimes one stock of the ERM is very deeply incarcerated. Sometimes does happen. You can't remove it totally. Do you trim around it, leave it back, or you really go for a full-fledged removal of that? If one of the end of the ERM is deeply incarcerated retina, how do you go?
If it is away from the foveal area, I just leave it and trim it all around. But if it is bang on the fovea, then as written in many of the literature also, that it is ILM flap. It's like an inverted flap technique, somewhat like an inverted flap technique that we do, and we hope for the best because we don't want to cause iatrogenic macular hole at any cost.
I think Ashwin is ready.
Okay.
I am ready. Can you see my screen?
Yes, we can see your screen, Ashwin. So Ashwin Bafna is again a very astute clinician and a prolific surgeon, vitreoretinal surgeon from Mumbai. He's an alumnus of the Arvind Eye Hospital. Ashwin, go ahead. You're going to present on principles of diabetic vitrectomy. Go ahead.
Ashwin, turn your video off so that the streaming is smoother.
Yeah, turn your video off, you'll get a better bandwidth. Ashwin, turn your video off and you're muted.
Now can you see me?
Yeah, we can hear you. Now share your screen and keep your video off.
Yeah, you can see my screen now?
Yes, yes.
Okay. At the outset, I would like to thank Preetham and Swapnesh for this opportunity. My topic today will be principles of diabetic retinopathy. And I would also like to thank the MOS faculty, the organizers for this opportunity. So I just kept this talk very simple and short. I've tried to explain things which make these difficult surgeries easier to some extent. Opinions shared here are solely mine, and I'm open to suggestions by all. This presentation includes relevant steps, but there may be many more. And those who wish to contact me, I have an email ID, and this is how I look, so that if you see me sometime, you can always pop up a question. So all of us are aware about the indications of vitrectomy, which are evolving in this era of vitrectomy. I'll not go into details of that and jump to the topic. So a history taking in any surgical case is so important. It gives you a lot of pointers, like what is the requirement of the patient. And remember that we all are working for the patient benefit. So it is important that we hear out the patient, what are his expectations, and according to that, we can always prognosticate what amount of vision he'll get back, what are his expectations, all that we'll come to. A good clinical examination for any surgery is very important, especially in diabetic vitrectomy. The initial presenting visual acuity is so important that that will tell you what will be the final outcome. And many a times we as retina surgeons always see dilated patients and we forget to check the pupils. So it is very important that we tell our optometrist or whoever sees the patient initially that he should check the pupils, especially when the vision is poor. That will tell you a lot of information about the associated optic nerve pathology or gross retinal pathology which may be present in these patients. And very important factor is doing a B scan. And I call it in these diabetic vitrectomy is a B scan by AI, or what we call as artificial imaging. Because the operating surgeon, when he does the B scan by himself, he can actually visualize how the condition of the vitreous is and its association with the retina, which is very important when he approaches the patient during the surgery. If you have a simple almost incomplete PVD, which is attached to an optic nerve and free from all other sides, you know that it's a relatively simple case and easier to approach. So you always assess the vascular status of the retina and may opt for a pre-operative anti-VEGF depending upon the vascularity, which can be given anytime 3 to 5 days prior to surgery, which is usually what I follow. The first step in the diabetic vitrectomy, or in any vitrectomy, is rather anterior vitrectomy. It is this little step which makes every vitrectomy journey very great. So don't rush into it and just give it some time, because I've seen many times that people just put in their trocar cannula, they put in their cutter, light pipe, and just start. You have to just put in their biome and just start doing vitrectomy. But you give adequate time to anterior vitrectomy, it will avoid a lot of complications. Remember, vitreous is a mass of collagen. You have to first cut the anterior vitreous, then go into the core. It's not like you do the core first and the anterior vitreous will come on its own. Never. And many a time during anterior vitrectomy, you will see the V's ring coming in case of RD, or the blood coming in case of diabetic vitrectomy. So it is a very important step. We should not rush into this step. A good core vitrectomy will give you an easy access to the membranes which are about to be. So you have to remove the core vitreous above the membranes first to approach the membrane. So that also is a very important step in a diabetic vitrectomy. So you got every surgeon goes down a lot of wrong doors till he finds the right one, is what I call this step. And most often my fellows or colleagues ask me, where do you open the posterior hyaloid phase? So there is no correct rule for that, but still you can have some set of rules which you can follow. You are actually supposed to open the posterior hyaloid where it is elevated maximum. So usually for a right eye and left eye have a different approach. In a right eye, suppose if this is the hyaloid which is present at the posterior pole, and the right hand is where I hold my cutter because I'm a right hand surgeon, and left hand is where I hold my light pipe. So I usually start in right eye in the superior temporal quadrant because that is the easiest accessible area for me. And that's where I try to open the hyaloid if possible, if it is elevated maximum there. Similarly, in the left eye, I open it in the superonasal quadrant. After doing this, so here you can see in a video that I am doing my core vitrectomy. And then I go to the nasal aspect. This is a left eye. So I go to the superonasal aspect where I give my suction and cutting at the same time. You have to be very patient. The vitreous will come with your suction of the cutter. So be patient. Once the vitreous posterior hyaloid is phased, you will see that the blood actually gets down into the cutter. So once you have opened the hyaloid, you always try to peel from above downwards, because that is the easiest way. You will actually see the attachments. When you start peeling from above downwards, you will start seeing the attachments of the vitreous to the retina, and that will make your job much easier. Rather than you peeling from downwards upwards, it becomes very difficult. And always let the hyaloid act as a third hand. That's what I would call. Don't keep cutting all around the membranes. So that's the wrong way. All of us know that the posterior membranes are attached to the anterior part by a lot of vitreous fibrils. So you just don't start cutting them all around. Rather than that, if you want, you can cut it in the area of the membrane and leave the rest of the hyaloid, so that hyaloid acts as a traction to pull your membrane up, and that gives you a plane to dissect it. So in this video, I'm just trying to show that I've opened the hyaloid in the superior part, and then I'm gradually peeling the membrane using the suction and the cutter simultaneously. So gradually you can start peeling from above downwards, and I'm not cutting the vitreous here in the inferior quadrant. If you see, I'm not cutting the vitreous at all here. So here I'm trying to release. This membrane has an attachment temporal to the macula. One is on the disc, and the third, which I noticed later on, was in the nasal periphery. So I then start seeing the membrane. I start trying, once I feel from the temporal part, I start pulling it up from the disc. But when I see that there's a lot of traction towards the nasal side, I go on to the nasal aspect and try to pull it up. And then when it is free from the nasal aspect, the entire membrane actually comes off very easily. And then lastly, on the disc, I just trim it off over the disc and release the entire membrane in toto. So this is one technique which I call as the OTT peeling, where I keep the cutter on top of the membrane. I apply the suction and the cutter. The part of the membrane, when it's free, it gets into the cutter and it's taken away by the cutter. This is called as the over-the-top peeling of the membrane. So this video will actually demonstrate how I do that. Is when I make an opening over the disc, because that's where there was a blood behind the membrane, and that was where the hyaloid was most elevated. So here I made the opening here into the posterior hyaloid phase with my cutter. Then I use a forceps to gently lift it up and then extend this opening. Then I just use a forceps, just lift it up from the disc and just extend the opening. And then I just use my cutter to aspirate the blood so that I get a better view of the underlying retina and the macula. So using the cutter even aspirates the blood, and that's how I get a better view. So here, as I start cutting, the blood comes out and the membrane gets into my cutter. And what I'm doing now is that I'm staying on the membrane. I'm not going on the other side of the membrane. I'm staying on the membrane, and gently, as I'm cutting, as I'm using my suction, the membrane peels off on its own. So that's how. Though it makes the job easy, and it actually makes it safe also, because you don't have retina coming into your cutter. And the retina is always away. Suction actually causes lot of less traction onto the retina and prevents breaks. And it maintains the plane of dissection. And keep your options open. So when you see the patient here, you can see that I'm sitting temporally. This is the left eye of the patient. I'm sitting temporally on purpose, because when I went, I had noticed that the hyaloid was elevated in the superotemporal quadrant. In the left eye, it would be very difficult for me to approach. So I approach this patient from temporally, and you can see that the hyaloid there is elevated, and you can see that shadow there, which tells you that the hyaloid is, the membrane is elevated. Now I just lift it up with my cutter. Then I think I wanted to do a bimanual dissection because it was a very thick, densely attached membrane to the retina. So I put in a chandelier on the opposite side, and I use a cutter and the forceps to peel this membrane. So gradually I negotiate my way. I hold the membrane with the forceps to keep it up, and then it gradually I tend to I go in, and thankfully I had no retinotomies in this case, but a lot of bleeding. So I'd put in oil at the end of this thing, and after oil removal, this patient had some 624 useful vision, and he was a one-eyed patient. Here again, you can see the over-the-top peeling of the membrane, where you can see I will put the cutter just next to the cut edge of the membrane, and the membrane will get into the cutter there. Now you will see it. So it peels off very easily if you apply suction. Be patient, be on the membrane there. The membrane just peels off on its own. You don't have to use any forceps or anything. This is a very, very useful step if you use properly. And here I could see the attachment of the membrane to the retina. So I gently dissect it with the cutter there. So you address the bleeders at the end of the surgery. Usually use the cautery. Whenever you see the bleeder, it keeps the field clear. Use lower power because remember in diabetic vitrectomy, the retina is ischemic. It may create breaks at high power. Never use the cautery on the optic nerve head because it may damage the nerve fibers. Whenever you have breaks in diabetic vitrectomy, you ensure complete removal of membrane. Otherwise, it will cause redetachment. So you examine the macula and decide whether you have to peel the ILM or the ERM needs to be removed. Because the next speaker is going to speak about it, I'm not going to go ahead. So examine the periphery for any residual breaks or fibrovascular proliferation. A good endolaser beyond the equator is must in these cases. And you assess whether you need any kind of tamponade to stop the bleeding, or if you have breaks, you may need to use tamponade. So in summary, good assessment before the surgery, plan the case. Anterior vitrectomy is very important step. Open the posterior hyaloid, identify the correct plane because it reduces the bleeding and makes the surgery more easy. Always peel from above downwards. Minimal pull on the membranes to avoid a break. And use adjuncts when needed like triamcinolone, BBG, cautery, chandelier, or tamponade. So our greatest glory is not in never falling, but it's rising every time we fall. So you should attempt these cases because once you attempt, slowly you'll start building up your confidence and you'll attempt more of these cases. Rather than getting afraid of the complications, attempt these cases because these patients have nowhere to go. Thank you.
Ashwin, that's a good presentation. Any questions for Ashwin? I think if there are no many questions, I think we can go to the next speaker. Dr. Shamik Ambadkar, is he there? Ready? Dr. Shamik?
We can take Dr. Mandar Zogaekar.
Yeah, maybe. Yes, can I share?
Yeah, please.
Yeah. So my talk is on the slide is visible. The slides are visible or not?
Yes, Mandar, go ahead.
The Yamada is intrascleral fixation, double needle technique, tips and tricks is the topic. I thank the MOS and organizing committee and secretary for giving me this opportunity. So, Yamada technique is a glueless and sutureless modification of the intrascleral fixation techniques, which was originally given by Gabor and propagated by Agarwal, who popularized it, Dr. Agarwal. The most important tip is a complete vitrectomy and removal of capsular tissues. Because if you don't remove the vitreous, your haptics and needles are going to entangle in that, and you are going to have a problem. So this is the most important tip and trick. So there are the salient features of this technique. One is the threading of the haptic. You insert the needle, you thread the leading haptic in the one bore, then you insert another needle from the opposite side 180 degree apart. Then the trailing haptic is threaded inside. Then both are externalized and a flange is created by applying the heat. This is the basic technique of the Yamanate's intrascleral fixation technique. Then this haptics are pushed inside and the flange is impacted in the scleral openings so that it doesn't move and it remains stable. So this is a small surgical video of the technique. So the needle is, markings are made first. I will talk about that later in the tips. So first, The lens is delivered. Use a retrocternal forceps. Use a retrocternal forceps to grab it and thread it inside. Put another needle 180 degree apart for bring it to the pupillary area. Then use total forceps to grab it and thread it inside the needle. Once you have threaded an optimal length, both are externalized simultaneously. And then flange is created by applying heat cautery. And then they are pushed inside. Then you get a well-centered this is the same. So how you graduate from the other surgeries to this surgery and make this surgery a successful surgery? So these are a few pointers that I can give. Just firstly, you have to practice before the surgery, then mark the axis and orientation to the wound is important. And I always stress on using 2 needles at a time and try not to touch the cautery to the flange. So this is what we do. We try to practice beforehand to get a feeling how which lens you are going to use and which needle you are going to use and how you are going to thread it. So you get a grip how it feels. Then markings are very important because that's how we are going to introduce it. So first you have to mark 180 degree axis by some toric marker, which should be perpendicular to the roughly perpendicular to the axis, to the wound. The second marking is introduced 2 millimeters from the limbus from the first mark, and another is 2 millimeters to the clockwise direction on the both sides. This should have an angle of 10 to 15 degrees to accommodate the haptic orientation. Because this angulation is 5 degree, it should be around 5 degree inside, curved inside, so that it accommodates this angle. So the correct holding position is important. Sorry, just a minute. So this is we are holding it too far away. Set. So if you hold it too close to the haptic, it won't thread. You have to hold it at the correct position. It's not threading now, it has gone out. And then we have to hold it slightly away so that it threads inside. This issue arises mostly with the trailing haptic because leading haptic is usually easy to thread. Then flange correction is an important thing because when you create a flange, you have to take very important step is not to touch the haptic with your heat, because once you touch the haptic, it forms a kind of disc and not a conical structure. You can see this conical structure is forming, which is very important to form so that it goes inside and gets stuck into the scleral wound. It prevents the flippage and externalization of the haptics in the postoperative period. You can see it again. The heat cautery is applied from a distance so that it forms a nicely conical flange. So why 2 needles? So when you move one needle, if you just do one needle and move it outside, the other haptic comes to this position. From this position, it is very difficult to thread it because the needle is going to come from this side and it is going to be a very difficult problem to thread it inside, and this will cause twisting at this angle and may have damaged the lens in this process. So what maybe the problems with the two needles is that one of the is that slippage of opposite haptic in the vitreous that can happen in the beginning stages. To prevent that, you can hold the you can externalize one haptic and hold the other haptic with a inside the either the don't external take away the needle or hold it with your assistant holds it with a needle, or you can use some silicone tips to hold it. Use 27 gauge, not 26 gauge, because 27 gauge is readily available here, and 26 gauge gives a bigger opening, and 27 gauge is very easily available and it's easily threadable. And keep one. So when you get a smaller pupil, you don't have to worry because initial threading is always easy. The problem arises when when you thread the trailing haptic, but you have to use your needle to stretch the pupil, and that's it. You can just thread it without any issues. Sometimes okay, I think just the last one. Sometimes this IOL will flip because of my hand touch in early phases. This has flipped. I just rotated it and it came in at the place, and then I can just go inside and thread it inside and complete the surgery. So very important is not to panic, think of the situation and do the needful. Thank you.
Excellent videos, Mandar, as usual.
Yeah.
Which is the common preferred lens you use, Mandar?
I use Sensar or Technis 3-piece.
There is less flippage in those lenses?
Yeah, because the angulations, the other option is accuracy, which is but their haptic is slightly bent. So
okay.
The tip is slightly bent, so I find it more easy in Technis and Sensar. No financial interest actually.
Okay, no problem.
But Mandar, suppose if you inadvertently, if you cauterize a tip of the haptic,
yeah,
then is there any way to bail yourself out, or you just have to use another IOL then?
You can cut it and actually reflange it.
Okay.
But you have to do it on the both ends.
Yeah.
The same thing.
So they're equal. Okay.
Equal length. So that I think you can do it once. That's your opportunity.
Any other questions for Mandar, or we'll move on to the next one? Shamik is there? I'm not seeing Shamik for the last presentation. I think if Shamik is not going to be there, I think we'll conclude the session. Sachin, any last words before we conclude? Nitin sir, shall we conclude?
I think we should conclude. The talks were excellent. We had a good discussion. I think we got the take-home points quite well.
Okay. Thank you so much, everyone.
Thank you.
Bye, everyone. Thank you, everyone.
Bye.
Yeah.
Bye.
Thank you.
गुड आफ्टरनून सर्वोदय सर. सर म्यूट आहात आपण, अनम्यूट करा प्लीज.
Good afternoon, madam.
गुड आफ्टरनून.
गुड आफ्टरनून गीतांजली मॅडम.
गुड आफ्टरनून.
राधिकाचा बर्थडे आज, म्हटलं तुला जॉईन व्हावं लागेल संध्याकाळी, व्हर्च्युअली बर्थडे सेलिब्रेट करावं लागेल.
ओके.
रंजना मॅडम पण जॉईन झालेले आहेत.
हा, गुड आफ्टरनून रंजना मॅम.
स्पेशली व्हिडिओ तयार केला मॅडम मी, इतका सुंदर. लॉट ऑफ एफर्ट्स. We are really proud that she is doing such a nice job in Jalgaon for this organic farming. त्यानं प्लॅटफॉर्म दिला जळगाव नॅचरल्सच्या ह्याच्याने. आता मी व्हिडिओ मध्ये बघणारच आहे आपण.
हो हो हो. रागिणी मॅडम पण जॉईन झाल्या आहेत बहुतेक दर्शना. We can take a permission and start the session.
Yes, 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 yes. Hello, Ragini ma'am. Multiple sessions log in असतात ना मॅडम? आपले बाकीचे लोक पण येणार आहेत का?
हो, मी सगळ्यांना लिंक पाठवलेली आहे.
अच्छा, ओके. Ragini ma'am, are you there?
दर्शना.
Yes, yes ma'am. Good morning.
Good afternoon. चालू करो. Hi सर्वोदय sir. Hi गीतांजलि. Hi Dr.
Hello, madam.
Ranjana. Hi Preetam.
Hi
Dr.
madam.
Ragini, hello.
Hi,
Oh,
hi.
Dr. Prasad has also joined.
Hi.
Hi Dr. Preetam. Hi Preetam, you're going to sing?
Beyond
Darshana, time. Yes, all yours, Darshana, all yours.
Yeah, ma'am, this time we have brought up a new concept. This is Passion Unlimited.
Wow.
The videos which you will see now will have something very different and done in such a passionate way that it makes us think what type of people these are. They do incredible work in the things which they are passionate about.
Then I know. I have first-hand information about Sarvadeh sirs. I have also been gifted his paintings. What you see, I have seen with my own eyes.
Right.
Thank you, madam. Thank you very much.
So it keeps.
Darshana, you and Gitanjali rock.
Thank you, ma'am. So the first speaker is the first video is from Dr. Ranjana Porse, who is an anterior segment surgeon from Jalgaon. She has an incredible work in water conservation and organic farming. She is also studying. She's a teacher in art of living and is into a lot of things related to farming and more of research in all these fields. So let us see video of Dr. Ranjana Porse, which will itself explain everything.
Namaste. Myself Dr. Ranjana Porse, consultant ophthalmologist from Jalgaon. I am a volunteer and teacher in Art of Living Foundation. Inspired by my guru, spiritual guru, Shri Ravi Shankar ji, founder of Art of Living organization, I decided to work in rural development in 2012. I got opportunity to work as a district coordinator for water conservation. Till now we have worked in 14 villages of Jalgaon district according to Shirpur pattern, a concept by Suresh Kanapurkar, a geologist. In this pattern, we do deepening and widening of pre-existing nalas or rivers and construct cement or earthen barns from reach to valley. Funds were raised from Art of Living, government and from villagers' contribution. This project became a huge success. Villages where farmers found difficult to grow one crop a year, now they could grow 3 crops a year, and this improved their living condition.
ऑगस्ट सप्टेंबर महिना ओलांडल्यानंतर सुद्धा ही विहीर रिचार्ज होत नव्हती आणि याच्यात 10 जूनला पाणी आल्यानंतर दुसऱ्या तिसऱ्या दिवशी त्या विहिरीत 50 फूट पाणी आलं. दरवर्षी आमच्या अक्षरशः म्हणजे श्रावण महिना संपूर्णही पाणी येत नव्हतं, म्हणजे पोळाही झाला तरी पाणी येत नव्हतं विहिरीला. आता यावर्षी अगोदरच पहिल्याच पाणीमध्ये भरलेली.
6 वर्षापासून आमच्या गावामध्ये कामच नव्हतं, कारण पाणी पडायचं वाहून जायचं. आता यावर्षी आर्ट ऑफ लिव्हिंग आमच्या गावामध्ये ते नाले खोलीकरण केले ना, त्यामुळे या शेतकऱ्यांची विहीर खूप पाण्याने भरलेली आहे आणि त्या पाण्याचा फायदा त्यांच्या पिकाला झाला आणि त्यांना फायदा झाल्यामुळे मग त्यांना या आमच्या मजुरीला फायदा झाला.
While doing this project, we noticed that soil fertility has significantly declined because of chemical farming, and crops from such soil can't be healthy, and this in turn requires use of lot of chemical fertilizers and pesticides, and the vicious cycle goes on, and ultimately we eat nutritionally empty and toxic food. Such food is increasing different types of diseases like diabetes, heart disease, malnutrition, infertility and allergies. Chemical fertilizers and pesticides have destroyed soil microorganisms which have major role in soil fertility. It has also destroyed friendly insects and birds, which in turn causes more pest attacks on crops and thereby rampant use of insecticides. This has also contributed to global warming and climate change. Overall, it has disturbed environmental balance. So me and my husband, Dr. Girish Borse, decided to practice natural farming ourselves under guidance of Padma Shri Subhash Parekarji, who brought this concept of natural farming in India. Since then, we are Sunday farmers. Our purpose of doing natural farming was to guide farmers from our own experience. Initial years were difficult because convincing farmers was a tough job, but we continued awareness programs in the villages of Jalgaon district. We conducted many training programs for farmers, guided them through regular meetings, farm visits and WhatsApp groups. While doing this, another challenge came in front of us. Farmers practicing natural farming were not getting good selling price for their farm produce. So we decided to provide them a platform where they could get good selling price, as well as consumers can get healthy, natural and chemical free food. So we started a store, Jalgaon Naturals. Mr. Deepak Sonar, who volunteered for this noble cause, he is managing marketing and providing a link between farmers and consumers. Jalgaon Naturals now provides everything from cereals, pulses to fresh vegetables, fruits, lakdi ghani oil and many more. Now our aim is to spread awareness amongst people to eat healthy, natural and chemical free food. After all, health is our real wealth. Thank you.
Excellent, madam.
Thank you.
Yeah, it's a really good initiative. I mean, you are thinking much beyond ophthalmology as doctor, for farmers as well as for health of everybody. That is really incredible.
Thank you.
She is so well read also. She
Yes.
reads so much related to all these things, organic farming, be it water conservation, everything. We are really proud of you, ma'am.
Yes.
Thank you, Darshana.
Next is Walimbe sir, madam.
Yeah. Dr. Prasad Walimbe, everybody knows him actually. He is ophthalmologist from Pune. Specialty is pediatric ophthalmology. He has written books also like step-by-step wind surgery and all. But his passion is going to Himalayas. You know, that passion doesn't stop him. Even during COVID also, he visited recently to that area. So over to his passion.
Can you share the video, please?
Yeah.
Just a moment.
Hi.
You please share it from there.
He is sharing.
हिमालय हिमालय नजर जाईल तिथपर्यंत पसरलेल्या गगनाला गवसणी घालणाऱ्या हिमाच्छादित पर्वतरांगा, ढगांनाही वाकुल्या दाखवत अथांग अत्युच्च अशा आसमंताची सलगी करणारे अतिउंच बेलाग आणि अनभिषिक्त हिमसुळके, धडकी भरवणाऱ्या खोलच खोल दऱ्याखोऱ्या, मनाचा थरकाप उडवणारे हिमप्रपात आणि संन्यस्त ऋषींप्रमाणे युगानुयुग हिमालयाच्या माथ्यावर विराजमान असणाऱ्या हिमनद्या, मन मुग्ध करणारे खळाळते प्रवाह आणि स्वर्गीय सौंदर्याने नटलेली वनराजी वृक्षवल्ली आणि या नंदनवनात सुखे नैव असे राहणारे सर्व पशुपक्षी आणि प्राणी. हिमालयाच्या या विलोभनीय, अद्भुत, अद्वितीय, अवर्णनीय आणि अमर्याद अशा या सौंदर्याचं वर्णन करायला शब्द अपुरे पडतात. हिमालयाचं रौद्ररूप मनश्चक्षूंपुढे जरी आलं तरी मनाचा अगदी थरकाप होतो. पण त्याचबरोबर भव्य, दिव्य आणि उत्तुंग अशा या हिमशिखरांच्या भव्यतेपुढे मन आदराने नतमस्तक होतं. 2400 किलोमीटरपर्यंत पसरलेल्या या लांबच लांब पर्वतरांगा 15,000 ग्लेशियरचा भार सांभाळत अगदी दिमाखात भारताच्या सीमेवर हजारो वर्ष उभे आहेत. अवर्णनीय अशा या हिमालयामध्ये एक सुप्त आकर्षण दडलं आहे. एखाद्या गिर्यारोहकानं एकदा का या हिमालयाच्या कुशीत पाऊल ठेवलं की तो परत परत या पर्वतरांगांचं दर्शन घ्यायला उत्सुक असतो आणि त्या दराखोऱ्यांचं सौंदर्य त्याला कायमच भुलवत राहतं. अशाच एका सुंदर हिमालयातील ट्रेक दरम्यान सुचलेली एक छोटीशी कविता सादर करतोय. हिमालय. जैसे हरळा माझी पुष्प मोगरू, जैसे हरळा माझी पुष्प मोगरू, की परिळा माझी कस्तुरू, जैसे वृक्षामध्ये कल्पतरू, तैसा नगश्रेष्ठात हिमालय मेरू. जैसे हरळा माझी पुष्प मोगरू, की परिळा माझी कस्तुरू, जैसे वृक्षामध्ये कल्पतरू, तैसा नगश्रेष्ठात हिमालय मेरू. तव तेजाने दीपवला भास्करू, तव तेजाने दीपवला भास्करू, तव साक्षीत्वाने स्तंभिला सागरू, ऐसा नगश्रेष्ठ असे मस्तकू, ऐशा भारतभूचे मी लेकरू, ऐशा भारतभूचे मी लेकरू. धन्यवाद.
अप्रतिम डॉक्टर प्रसाद.
धन्यवाद.
वॉज वंडरफुल. नाही म्हणजे तुझं तिकडे हिमालयात जाणं हे पॅशन आहे, बट द फोटोग्राफी आणि काव्य, सो या सगळ्याचा एक सुंदर मिलाफ आहे. म्हणजे तुला ते क्षण मिळाले, त्या क्षणांचे फोटो आणि त्या क्षणात मनाच्या आतलेही फोटो कवितेच्या रूपातून सादर झाले. सो दॅट इज वंडरफुल.
आणि सर तुमच्या दोघांचं काय सांगावं, मॅडम आणि तुम्ही. परवा आम्ही मॅडमची स्किट बघितली, त्याच्यात पण तुमचा उल्लेख होता. दोन्ही एकदम फुल टॅलेंटेड, पॅशनेट कपल.
ऍक्च्युअली विनोद मारला होता या गडावर जातो, त्या गडावर जातो.
Right.
Pranav is a genius.
Yes, really,
Prasad sir
really.
is a genius. And we really enjoyed that skit by Madam. Prasad sir,
thank you. Yes,
it was
yes.
a Kavita in motion.
Oh, thank you. Thank you, madam. Thank you, madam.
Dr. Prasad, the only
Yes,
thing
madam.
left to do is that you take madam with you and let her write all her skits and all that in the Himalayas.
Definitely. Okay,
तिला
okay.
इथे सोडून जाऊ नका. मग ती काय is she in all that sorrow sits and writes all the skits, so she will write in happiness when she's with you.
Very true, very true. Very nice, sir. Thank you so much.
Thank you, madam. Thank you. Thanks.
Very nice. It's a lovely passion to have.
Thank you, madam.
And have that fitness, fitness to go every year, you know. So
But what happened during COVID times, Dr. Malimbe?
He went,
No.
madam.
You went?
Yeah, of course, when the second wave was down, that time, of course, we with all due precautions, we went over there.
Okay.
आणि तिथं कसं माणसंच नसतात, कुणीच नसतं, त्यामुळे सोशल डिस्टन्सिंगचा काही प्रॉब्लेमच नसतो.
Problemच नाही.
There is nobody there to transmit any virus.
And the virus must have shivered off over there in that cold. Very nice.
Thank you, madam. Thanks for the opportunity.
Next, we have Bhagli ma'am, our own cultural committee member, who is having lot of hobbies of traveling and photography, painting. So all in one, we present her video.
Happy birthday, Radhika. Is she there?
I told her to join. I don't know. Belated happy birthday, ma'am. Now I'm seeing you.
Thank
Yesterday
you.
I could not see you.
Yesterday I was invisible.
The video is stuck, I guess.
It's not playing.
Yeah, video is not playing. Sai Dada.
I wonder how Sai Dada manages all the 4 halls, you know.
Terobi madam, belated happy birthday.
Thank you, dear.
You're playing now, madam.
It stopped again. Multi-talented.
Yeah, multi-talented and full of life.
Full of life.
Yes.
Yeah, there she is.
Yes. Yesterday, the investment session was also so good.
Her paintings were awesome. Awesome. Really nice.
So those are just water paintings. Usually what I do is I take some pictures. So
Okay.
3-dimensional ka 2-dimensional ho jata hai, and then it is very easy to paint. So everybody should take that tip and try it.
No, but your colors are nice and warm, you know, so
Yes, yeah.
it
I
adds
like to
life
do
to any painting.
watercolors so they look fresh. Yeah, they look fresh.
Very nice, ma'am.
Thank you. Thank you so much. Thanks.
Yes, next.
Who's next?
Next, Sarvadi sir.
Saravde sir. Saravde sir needs no introduction actually.
We really see his paintings and just it's unbelievable, huh? In LBO we see his paintings and they are so
Lifelike
full of,
paintings.
yeah.
Shall I run the PPT?
Yes, please.
Yeah, yes, yes.
Good afternoon, everybody. At the outset, I would like to thank Mart Ophthalmic Society and especially Gitanjali Madam for giving me the opportunity to present something about my painting. I have been painting since my childhood. I paint in all media, while oils and watercolor are my favorite, but I also paint with pastels, color pencils. This just I would like to talk about. This lady is an old woman with glasses. Those who are from aphakic era will identify their aphakic glasses. And this is done with watercolors. Next slide. This is an oil painting done of a sadhu from Himachal Pradesh. I had gone on a tour of Himachal Pradesh and I made this at one of the temples. I liked his beard, his hairs, the robe he was wearing, and the sort of the vessel he is carrying in his hands. This one is done with oils. Oils are great for capturing the character of the person, and in oils, if you make an error, there is always a chance that you can correct it. At that time, there was a Kumbh Mela in Nashik, and I titled this painting as On the March to Sinhasta. At my Jahangir exhibition, I had an opportunity to sell this painting to a foreign collector. Next slide. This, I think, everybody comes across some patients of cataract. This side, lady with a irkal sari and. Bas. I didn't get. I'm sorry. What is happening?
Please continue, sir.
So this is an acrylic painting of a tiger. Recently, I have been diversified into painting wildlife, the birds and animals, and this is one of the painting of a tiger I have seen in Tadoba. Next slide. Now everybody likes flamingos. They are elegant, tall, with their slightly pink shade of the feathers at the tips and the bills. They are a symbol of health. And at the outskirts of Pune, near Bhugwan, you can see hundreds of flamingos. And at one of the outings, I saw these flamingos clicked with the camera and then painted in acrylic. Next.
आलात ना वेळेत सापडलं ना मी एकदा बघून घेते.
Bhagli madam, can you mute yourself, please? Bhagli madam, it is disturbing. Sorry.
This one is of a sambar. Those of you who have gone to the safari in Tadoba, Jim Corbett, Page, like there are a lot of trees, tall trees of sal and sagwan, and the trees when you go in the summer months, everywhere the dead leaves are falling. And in the morning when we went out to on the safari, we were expecting a tiger, and suddenly this sambar came. It was lit by a rim light coming from behind in the morning, and I thought that he's saying good morning to us. Next slide. This one is of the two owls done in watercolor of owls from Bharatpur. This, I think, mother and her child. Thank you very much.
Fantastic, sir. As I
Incredible.
always say, it is unbelievable that these are paintings. They look like photographs.
Thank you very much, madam.
How do you play with light and light effects are there in most of your paintings? I would like to know, how do you create those light effects?
Actually, painting is all about the light only, madam, because that makes the lead the subject and bring the subject to the life. So you should give particular attention to the form of the light and the shape of the shadows. If you pay careful attention to those, then you can accurately depict them on your paper or canvas. Otherwise, the painting will look flat and without form. So light is the master in painting. Colors are secondary. If your light and shades are correct, even a black and white painting will also come to life.
Dr. Saravde, I must congratulate you on the beautiful array of paintings that you have displayed. And the most important thing is that, you know, the colors are so vibrant. Each painting looks like a photograph, as Gitanjali said. It is like very lifelike, and there is a three-dimensional quality to each of the paintings. You really feel those owls are like, you know, coming out from somewhere and sitting on top, and there's something in the background. So it's beautifully it's really lifelike.
Yeah.
Really beautiful paintings.
Thank you,
Sir, sir, I want to know, you are head of the department. So I know how tough it is and how busy you are. So how do you get the time and, you know, with so much of minute details, especially the flamingos or even that sadhu with all those details. And he has not shown one of his painting. That is his mother's painting where she wears, you know, sweater. You should see that sweater looks so real. You know, as if it is wool coming, those buttons, you know, so many details. So how do you manage the time and everything?
Madam, time is gold, time is money. And I cherish the holidays. And when there is a holiday like second Saturday, fourth Saturday, and Sunday, I don't go out of the house. All shopping, etc., is done by my wife or my other people. Because, madam, painting is such a hobby that you need at least 4 to 6 hours at a stretch to do some work.
Dr. Saravde, I'm so happy that you mentioned that your wife does all the shopping. So तुमचं फोटोग्राफीचं योगदान त्यांना पण जातं.
Yes.
Madam, to be frank, it is a team effort, madam.
Yes,
Because
yes.
they all
She's your best half, not better half.
Yes. Really, it was a treat to eyes to see those paintings.
Sir, एक पेंटिंगला किती वेळ लागतो? दिवस लागतात का 4-5 तासात होतं?
Yeah, madam, it depends on the type of painting. The one you mentioned, like my mother, because portrait likeness is important, and I will not be painting full time, so it will take around 10 to 15 days as I work. That includes Sunday holiday, full day painting, and as time permits in the evening. And actually, they say that they don't pay in the evening light, but I have installed good lights in my home so that I can continue painting during the night hours.
Okay.
Your sadhu also, you know, I mean, even that this which he's wearing, that orange cloth which he's wearing, the details of all what is written and all is really phenomenal, you know. And so I have a suggestion for you, Dr. Saravde. Why don't you take a picture of all of us of the cultural committee and make one photograph for all of us together?
That's a very good suggestion, madam.
And you know, you will love painting it because all are women only, you know.
It will be such a nice thing if such thing happens.
Yeah,
क्या बात बोली मैम ने?
Yeah, I know. It would be a treat.
We will be honored.
Honored.
Your next project, Dr. Saravde.
that will keep me busy for a while.
Yes.
And one quote I want to tell you about portrait painting is that there is a great artist, that is Sargent. He was a very famous portrait, but he always used to say that portrait is a thing. There is always something wrong, whether at the nose or the corner of the mouth, because there will be somebody person who will point out that the mouth is not exactly right.
No, we won't point out such faults. We'll take. I'm sure it's going to be brilliant.
Thank you, madam. Right, right. Thank you very much. I
Thank you
really
so
enjoyed
much.
presenting my presentation over here.
No, it was a treat for the eyes. It's really nice.
Yes. And it's an amazing talent. Yeah. Thank you, sir. Thank you for joining. Thank you for sharing your.
Thank you, Gitanjali, for getting him in.
Thank you.
Yes, Darshana, who's next?
Next is a video by Dr. Chitra Khare, ma'am, who has a passion unlimited for pottery and various other things. We'll see her video.
That was wonderful. Madam Dr. Chitra Khare is a very senior ophthalmologist from Pune. She has been teacher to many of us from BJ Medical College and Sassoon. She was among the first VR surgeons of Pune, and now she is 75 plus and still she is maintaining this hobby of making potteries and different animals, and they are so beautiful. I mean, she is not able to speak much nowadays because of her old age, but still her fingers, the surgeon's fingers keep working, you know. So her fingers give those beautiful shapes. I don't know if her sons have joined, Dr. Bhushan Khare and Dr. Kiran Khare. Both are ophthalmologists, because I had requested all three of them to join. I really don't know if they are here, but it was a wonderful. And Khare madam, we are really grateful to you on behalf of Maharashtra Ophthalmological Society and personally from me, for sending your video and your art to share with everyone. It's a fantastic art.
Really, it stands true to the name, Passion Unlimited.
Yes.
Seeing Suhas sir, seeing Ranjana madam, Chitra madam, Valimbe, everyone, like you feel so incredible things these people are doing. It was really nice to have all of them.
Yes.
Manjari ma'am has joined.
Yes, that's what I was going to say. Another very passionate lady is with us, Dr. Manjari Malekar Oak. So let's listen to her poem. Dr.
Before
Manjari?
you go on to Manjari, I want to congratulate Dr. Khare, because this is something which, like, you know, sort of she's adhered to, right, even at this age, because she wanted to do it as a child, and now she's getting the time to do it, and she does a beautiful job on it. And really, hats off. I mean, the fingers keep working, the mind keeps working. That is very important.
Yes. Over to you, Dr. Manjari.
Can you share my this thing poem which I've sent on?
Hi, Manjari.
Hi. How are you?
I'm fine.
Good.
Darshana, you are muted.
Darshana's email.
Yeah,
I've
yeah.
sent my this.
Ma'am, you had sent on my this thing WhatsApp. It has to be sent to support at MOSI. So if you can just read it for us, we'll enjoy it more rather than showing it.
Actually,
Please, ma'am.
I'm not on my laptop. Otherwise, I would have shared it on my this thing.
Let
Laptop.
me
That
try
picture.
if I can.
That picture, na.
Yeah. पंकज ये शेयर करोगे क्या?
Last Sunday, madam, in the evening session.
Pardon me?
Last
असेल का?
I have, but it is better to have it in front of the audience. That is why. If it is taking time, otherwise I'll.
Yeah, Manjari, it will be better if you read it out because the next session would start in 2 minutes. Okay.
My poem's name is क्षण सांडता व्यर्थ सर्व जीवन. आपण सगळेजण खूप भूतकाळात ऐकतं भूतकाळात असतो किंवा भविष्य काळात असतो. आपण वर्तमानात नसतोच आणि जो हातात क्षण असतो तो आपण जगला पाहिजे तो प्रत्येक क्षण. त्याच्यावर माझी ही कविता आहे. जगतोस असा तू जीव मुठीत धरून एक एक क्षण भासतो जणू असे अनंत. कफल्लक तूच न जाणे तयाचे मूल्य निसटून जाता नकळत होतसे अमूल्य. घे जगून पूर्ण क्षण तो स्वतंत्र प्रत्येक उलगडे ते मर्म क्षणैक विश्रांती घेत. भार असे तो भारी अन वंचना अनंत ओझे तिथेच टाकून कर साभार परत. आहट दूर अस्पष्ट न ऐकला तो क्षण हृदयी ऋतता शल्य मन होतसे विषण्ण. स्वतःसाठी जीवन नाही जिणे साफल्य कृपणा आणि करंटा मी हातात वैफल्य. कधी रे जाणसी तू क्षणाचे संपूर्ण मर्म करत रहा सतत तू निष्कामते कर्म. हळूच निसटे काळ पश्चात्ताप मागून सांडतेच वाळू जणू त्या क्षुद्र मुठीतून. संपूर्ण विश्व बांधले ते एकाच चक्रात उलटे कधी न फिरते काही या जगात. कालचक्र नाव त्याचे घडे तो उत्क्रांत एक धडा शिकवी जीवन असे दृष्टांत. विश्वकर्मा कार्यरत साक्षीच तो अनंत रहाट गाडगे चाले अविरत अविश्रांत. धन्यवाद.
Superb.
Manjari, very nice. Manjari, for all those who know her, is also a very multi-talented person. She not only writes poetry, she sings also, and she has just recently completed all her Bhagavad Gita adhyayas. I think she's done very well. She got very fantastic marks during her examinations. So, and she knows a lot of Sanskrit also. So, like Manjari, keep
Now
it.
I am teacher of Sanskrit Bharati. I am learning as well as teaching.
Very good.
Very nice. Very nice.
Very good. And
I was able to show your poem, ma'am.
Yeah, I know.
Thank you so much. Thank you for sharing.
Keep writing, keep sharing. This is Passion Unlimited. Last Sunday we had a poetry session, and I have already declared that more and more poetry session on MOS platform we are going to organize. So you are welcome.
Definitely.
I think Darshana, the next session, people have already joined, and we should say sorry to them because we have extended.
Thank you so much to all the participants. It was really, really a treat to see your videos. We will have such programs again and again. Thank you so much.
Thank you.
Over the next session.
Just now I came from a cricket match. Cricket match organized. That is why Darshana, I said to Darshana that I will be busy with something, but I could manage to just squeeze in and present
You did
myself.
it very well, very well.
Thank you
Oh,
for giving me
Manjari,
the opportunity.
it's better that you learn to play football because then you can football your husband.
Yeah, thank you, and it was a wonderful program.
Thank you for joining.
Thank you.
Thank you.
Thank you.
Good afternoon. Uh, Good afternoon, Karubi madam.
Hi, good afternoon. How are you?
I'm good. I'm good. We are ready for the next session. Let me see whether our participants have joined.
I saw
Good afternoon,
Somil
sir.
had
Good afternoon,
joined.
Karapi ma'am.
Hi, good afternoon. How are you?
I'm good, ma'am. How are you?
I'm fine. Somil was also, I saw him joining, but
Yeah,
then
he's there. He's there.
he's there.
Hello, ma'am.
Hi.
Mahesh, you can start.
Yeah, I'll do that. Yeah. So good afternoon, and without any further delay, let me start our next session for trauma. I think our session begins on trauma and the principles of management and the various varieties of trauma that we see. So we have today with us a wonderful array of speakers, a beautiful mix of young and old, of experience and youth. So our chairman today is Dr. Vatsal Parekh. He's a senior consultant from Mumbai City, and he's a retina specialist who has probably one of the first batches from Shankar Netralaya. Our co-chairman today will be Dr. Manish Papaye. I don't see him, but he's a very senior person and senior retina surgeon from Nasik. Dr. Ashish Jain, I just saw him, I think.
Yes, sir. Hi, sir.
Yeah, hi Ashish.
Hi, sir.
And I'll be moderating the session. So without any further delay, I think let me begin the session with our galaxy of speakers. The first speaker, Dr. Rushikesh Naigaonkar. Dr. Rushikesh is from Jalna, Ganpati Netralaya. He's a senior consultant. Is Dr. Rushikesh here?
Yeah, there I'm sharing
Yeah.
screen.
Okay, Dr. Rushikesh. So I think Dr. Rushikesh, without further delay, let us please start with your presentation on posterior segment management of penetrating trauma.
Can you all see the presentation? Mahesh,
Yes, sir.
you all seen the presentation?
Yes.
Thank you, organizers, for giving this opportunity to me to have this presentation in front of the audience. The topic given to me is posterior segment management of the open globe injury. We all come across a lot of patients with penetrating trauma. With Diwali on the cards, these patients have already started pouring in. Some patients are lucky to have minimum or no posterior segment involvement, and some patients do have posterior segment involvement, but it's not significant enough to need any treatment for that. Most of these cases resolve on this own, and some cases, especially the ones which I have narrated here, may need or almost always need a surgical intervention. The indications for treatment are, in cases of open globe injuries, the posterior segment complications are non-resolving vitreous hemorrhage, retinal detachment or incarceration, non-resolving hemorrhagic choroidals, endophthalmitis, intraocular foreign body, submacular hemorrhage due to direct retinal impact, and ruptured and dislocated crystalline lens or intraocular lens. So the mainstay of management, of course, is the surgery, and the goals of surgery can be divided into the primary goals and the secondary goals. The primary goals would be to have a watertight wound closure, because that is of utmost importance, and without that, any further intervention won't be possible. Restoration of the structural integrity, of course, is very important. We must avoid any tissue incarceration in the wound. We must prevent infection as far as possible, and the IOP management, especially in the later stages of the management, is very important. The secondary goals are management of the cataractus, ruptured or dislocated lens, proper handling of the choroidals if there are any, IOFB management if it's there, and restoration of the anatomic relations to the possible. and visual improvement to the extent possible is the ultimate goal. Now, each trauma case is a different case, and we need to have an individualized approach for all these cases. There are a lot of views as to how we should approach these cases. The approach can be a primary combined approach where we combine the primary wound repair along with the posterior segment management, or we can have a staged approach, which is like you manage the open globe injury first, like suturing the wound first, and then after 7 to 14 days we can do the second surgery. The possible issues with the primary combined approach are the corneal edema and the media haze, wound leak, uveal congestion leading to a lot of intra-op bleeding. Hypotony, of course, is a major issue where, in fact, sometimes you don't even not in a position to insert the trocars and cannulas in place. If there is no clot lysis, it is very difficult to remove the blood clots, and some of these cases may need keratoplasty if the visibility is very poor. The advantages are relatively lesser inflammation and scarring, and reduced cost to the patient and reduced hospital stay. However, the staged approach, that is second surgery, the posterior segment surgery, usually after 7 to 14 days of the primary repair, is the preferred approach, where the media haze is slightly reduced. We have better understanding of the possible intraocular damage, especially on B scan and MRI. Proper surgical approach can be planned as to depending upon what you see on the ultrasound B scan and on clinical examination, of course. And there is reduced uveal congestion, so there is the possibility of intra-op bleeding is much lesser. The clot lysis and liquefaction of the suprachoroidal heme would have occurred by then, in most of the cases, and so the drainage, near complete drainage can be achieved in such cases. We can have a better anticipation of the intra-op complications, and we can prepare ourselves better for all these complications. And the possible prognosis, we can have some understanding of that so that we can do a better patient and the relatives counseling. Delayed approach for the secondary glaucoma management, non-clearing vitreous hemorrhage, secondary IOLs, optical keratoplasty, and any complications of the previous VR surgery can be addressed. So proper pre-op evaluation is very important, and this is important for planning the timing of surgery, planning the approach, whether you are going to do primary keratoplasty in the first setting itself, or what instrumentation you are going to need, the size and location, and so on. Proper lens management can be decided whether you want to preserve the lens or whether you want to do lensectomy, whether it will be a pars plana lensectomy or a limbal approach. And you have better anticipation of the intra-op difficulties, like corneal media haze is there, then you may need to scrape the corneal epithelium, and proper counseling of the patients can be done if the evaluation is good. So these are the things that we need to look for in the pre-op setting as to visibility, the clarity of the media, whether there is any hypotony, pre-existing hypotony, whether there is any occult scleral rupture which might have missed at the time of the primary wound repair, the corneal tear repair, hyphema if it's there, and whether there is any corneal blood staining, what is the lens status, whether there is any anterior posterior capsular rupture, zonular dehiscence, and whether the lens is subluxated or dislocated, vitreous hemorrhage, how dense it is, whether there are any membranes inside, or whether there is any vitreous incarceration in the wound, retinal detachment, and if there is any associated subretinal hemorrhage, intraocular foreign body and the possible location of the foreign body, and the clot lysis status of the hemorrhagic choroidals. And optic nerve head avulsion, of course, can be picked up if a proper P scan can be done, and if required, we can do a MRI. This scan is very important. We can get a better idea as to what we are going to deal with. So this can give a fair amount of idea as to what could be the possible picture, intra-op possible picture. Now, the basic principles of vitrectomy are we be putting belt buckle or segmental buckle wherever required and wherever it's possible because of the scarring. We should avoid scleral wound to fix the cannulae. The appropriate size of the cannula should be used. You need to use 6 mm cannula if you are anticipating choroidals. Use of AC maintainer if the cannula is not visible to begin with, and then you can switch on to the infusion cannula if required during the later stages of the surgery. Management of the cyclodialysis cleft and choroidals. Clear the vitreous from the corneal wound and the scleral wound. This is very important. Otherwise, this could lead to a lot of complications in the future. We must induce PVD in all the cases, and base excision to the extent possible is of utmost importance. Removal of all the pre and subretinal membranes, because otherwise they would lead to recurrences in future, or they can lead to subretinal gliotic membranes in future. Removal of subretinal hemorrhage. Relaxing retinotomy or retinectomy for the incarcerated retina to release the traction. Use of PFCL wherever necessary, and silicone oil tamponade is the preferred mode. As I said earlier, if the media is not clear, sorry for the quality of video here, it's slightly hazy. So we may need to scrape the epithelium if required. Suprachoroidal drainage should be done wherever required to the extent so that the surgery becomes easier. We may need to do relaxing retinotomy and even retinectomy to release any incarceration of the retinal tissue in the scleral wound, and this would allow us better settlement of the retina. And removal of the subretinal blood is very important, because this would improve the functionality of the visual improvement of the patient in the future. Lens management, we should always try and preserve the lens if it is clear with intact capsules and venules. But if at all we plan to remove the lens, the pars plana approach is the preferred approach. We can use the limbal approach in case of hard cataracts. We must remove the entire lens matter, because this can become a nidus for inflammation in future. Capsular rim preservation is to be decided on various factors like age of the patient. Like in adults, it would be relatively safer to keep the anterior capsule. But in pediatric age group, especially if there is incarceration of the retina or the vitreous, then sometimes this itself can pull the ciliary body and lead to hypotonia in future. Vitreous in the wound, epithelial and fibrous in growth, and anterior PVR. These are the situations where we would decide against preserving the capsule. IOL placement is preferably done at a later date once the capsular corneal suture removal is done, because this would help us address the A-scan issues and the IR power calculation issues in a better manner. We can, of course, plan a combined cataract surgery like PC IOL with a scleral fixated IOL with either vortex sutures or Yamane or glued IOL, with or without iridodialysis repair wherever it's necessary. The possible intraop difficulties, as I've discussed a few already, like corneal edema, which may need scraping, or even keratoplasty if it's a significant corneal edema. The subluxation of IOL, we should try and reposition the IOL if possible, and if the support is adequate. If the support is inadequate, then we'll have to even remove the IOL and do secondary IOL placement like a scleral fixated IOL or any other suitable method. Non-visibility of the cornea during surgery this issue needs to be addressed aptly. Otherwise, this can lead to disastrous complications like suprachoroidal even bleeding or choroidals. AC maintainer can be used in such cases to begin with. We can approach the infusion cannula and tease with the help of either a cutter, light pipe, or even MVR based on whatever instruments you have in your hand. Cyclodialysis cleft should be identified pre-op if possible, and then suture it adequately. So to conclude, never delay the primary wound repair. Watertight primary wound closure is the key. Timing of vitrectomy is of utmost importance. And each trauma case, as I told earlier, needs individualized approach. A holistic approach of treatment is required, considering the entire eyeball in toto. Never give up. Modern vitrectomy instrumentation and techniques can give rewarding results. Document all the pre, intra, and post-op findings, and these are very important from the medical legal point of view in all cases of trauma. Good pre and post-op counseling is very important, and this would avoid a lot of litigations in future. And always under promise and over deliver is the key as far as managing trauma cases is concerned. Thank you.
Thank you, sir, for a comprehensive overview. We are running short of time, so I think I won't take any questions right now. We'll make the questions at the end of the session. We'll move to our next speaker with permission of the chairman, Parik sir.
Yes, sir. Please.
Next person is Dr. Ashish. Dr. Ashish,
Hi, sir.
please go
I'll
ahead.
be presenting a short video on
Yes.
the intraocular foreign bodies, different case scenarios. So is my video visible?
Yes.
Yes, please.
Okay,
is.
thank you.
Your audio is muted, I think.
Okay, just a minute, sir.
All the effects are seen, but the audio is muted.
Now is it heard?
No.
No.
Okay, I'll just start again. Yeah, now I think
body
heard.
lodged
Is it
in the
heard?
subconjunctival region, which is removed with the help of a superior rectus metal forging. Metal hitting metal at high speeds, so much so that Odin, the father of Thor, was not spared from the hammer injury, thus presenting intraocular foreign body case scenarios. In case 1, we see a foreign body lodged in the subconjunctival region, which is removed with the help of a superior rectus forceps. In case 2, we see a traumatic endophthalmitis. After lensectomy and vitrectomy, we retrieve the foreign body with the help of intravitreal forceps. The foreign body is then removed with the help of a handshake technique through a limbal incision. Case 3 is a traumatic endophthalmitis with the IOFB lodged in the superior pars plana region, thus necessitating the removal of the IOL. Following which, the intraocular foreign body is removed with the help of a McPherson forceps through the limbal incision made for IOL explantation. Case 4, we have a case of traumatic endophthalmitis with the foreign body lodged in the pars plana region. A lensectomy is done with the help of a cutter. Following that, a peripheral vitrectomy was done in which the foreign body was seen enmeshed in the exudates. The foreign body falls into the vitreous cavity, which is then retrieved using a magnet. The intraocular foreign body is then brought out with the help of a handshake technique using the intraocular foreign body forceps through a sclerotomy port. In case 5, we see a large ceramic foreign body lodged in the anterior retina, which is brought out using a superior rectus forceps because of the large configuration of the foreign body. Case 6, we see a wooden foreign body lodged anteriorly enmeshed in the exudates. Following vitrectomy, a laser is done around the retinal break. Following that, the foreign body is brought out with the help of an intraocular forceps through the limbal route. Case 7 is a case of firecracker injury. A decompensated cornea requires a temporary keratoprosthesis, which facilitates vitrectomy. During vitrectomy, a gunpowder was seen dispersed throughout the vitreous cavity. Also, in the anterior region and in the pars plana, the gunpowder was noted to be deposited, enmeshed in the vitreous. It was removed with the help of the cutter, following which a corneal grafting was done. Case 8, we see a pre-retinal IOFB. After induction of the PVD with the help of a cutter, the IOFB is disengaged with the surrounding vitreous. The IOFB is then brought out with the help of a magnet through a scleral port. The PFCL used helps preventing the damage to the posterior pole during such maneuvers. Case 9, we see the IOFB lodged in the retina. A laser photocoagulation is done before removing the IOFB. A curved corneal scissor can be seen to remove the vitreous attachment of the IOFB, which is then brought about with a Macpherson forceps. Case 10, we see a retinal detachment along with a large IOFB in the superior arcade. A chandelier-based illumination system is used for removal of the IOFB with the help of bimanual vitrectomy. This IOFB is brought out through the scleral incision. Case 11. We see a subretinal foreign body. The barrage laser is done around the retinal injury. A MVR blade is used to tease the retina, which helps in removal of the IOFB. The IOFB is later removed with the help of a magnet. In a similar case, we see a large intraocular foreign body lodged at the optic nerve head subretinally. The MVR is used to tease the retina above the foreign body. Using the sharp tip, the foreign body is elevated and brought out from the subretinal space. This foreign body was later removed with the help of a magnet. Thus, a high suspicion should be kept in every case of trauma and a CT scan should be ordered. Magnet is a useful tool for ferrous intraocular foreign bodies. A limbal incision should be placed 180 degree apart from the IOFB for better accessibility. Lensectomy, when required, to be done without hesitation. Vitreoretinal damage if suspected, the IOL should be deferred. PFCL helps in preventing accidental injury to the posterior pole. A bimanual vitrectomy with chandelier. Thank you.
This is excellent.
Brilliant.
I think I
Brilliant.
haven't seen such a beautiful collection till now.
I would like to thank Preetham sir and Saili ma'am for these amazing collection. It is surgeries done by me, Preetham sir and Saili ma'am at DJ Hospital, sir.
Excellent. Next, we invite our good friend and dynamic Mahesh to talk on endophthalmitis. Mahesh.
Thank you. Thank you, sir. Before that, let me congratulate Ashish for excellent variety of videos with lots of, I think, scenarios. Brilliant. Yeah. Thank you.
Thank you, sir. Thank you,
Thank you, sir. I'll begin my presentation. Is my screen visible?
Yes, please.
Yes, sir. Okay. Thank you. So I'll be briefly covering the topic of endophthalmitis in the cases of trauma. As we're all aware, the management depends on the amount of injury, whether there is a foreign body. The time since injury is a very important determinant factor for the final visual outcome, as also is the presenting visual acuity. To identify a gram-negative like a nocardia is one of the worst case scenarios. So identification of the organism becomes a very important part of prognostication and treatment. As also the choice of antibiotics, nowadays we find that many of these organisms are quite resistant to the routine antibiotics of 4th generation cephalosporin. So identification and institution of correct antibiotics as per the case is of vital importance for the prognosis in case of endophthalmitis. Obviously, a removal of an intraocular foreign body contributes largely to a stable globe and to good vision. Early vitrectomy has the best outcomes when it comes to anatomy as well as in cases of giving vision. To look at it as from the extent of injury, a corneal wound would be would probably give a better outcome compared to a corneoscleral wound. This has been proven in multiple studies because the limbal wound tends to affect the ciliary body and can lead to eventual hypotony and phthisis. Having an IOFB, which is metallic, has a slightly better outcome compared to a non-metallic IOFB, especially if it is operated early. In the late scenarios, IOFBs have the same outcomes. Also, the velocity at which the IOFB has injured various tissue matters a lot to the final visual outcome. As discussed in the previous slide, a delayed presentation has a poor visual prognosis. While at presentation, if you have a tissue loss, if you have no light perception, and if you have ancillary trauma to the orbital wall, you are more likely to have a poor prognosis. I'll just pause here for a very important part of the slide of this presentation here is about the medico-legal part of documentation of trauma. I think the first thing that we need to really consider is documentation of what we see. So a clinical photograph is very vital, be it in the form of a mobile photograph or a slit lamp photograph. But this is a very vital part of documentation of what was the anatomy at presentation. Visual acuity at presentation, if we have a video of this makes a lot of sense. So also, as we start talking about the prognosis at every juncture, if you have an audio video recording in our room, I think we have started using this in most of our cases, even for routine cataract cases. But this has been a lot of help for us for preventing later allegation. In hindsight, patients say no, whatever allegations from patients. So this is the very important part of endophthalmitis management in trauma. I think here I want to compare the traumatic endophthalmitis with a routine post-surgical endophthalmitis. On the left-hand side, you can see that the endophthalmitis vitrectomy study found that most of the organisms were gram-positive Staphylococcus epidermidis variety. Whereas in the right-hand side of the slide, you see the organisms are a polymicro. It's a polymicrobial infection. We are more likely to encounter gram-positive variety of the Enterococcus species and also lots of gram-negative variety. The role of ultrasound B-scan in endophthalmitis, I think here I would like to say that a closed globe injury would lend itself for ultrasound B-scan. Obviously, in an open globe, you would rather not touch the eye at all with a B-scan probe. It has medico-legal value again in terms of documentation of the retinal status or the choroidal status, or also documenting a presence of an intraocular foreign body. Sequential ultrasound B-scans can tell us about the vitreous membranes, whether they're reducing. Identification of vitreous membranes versus vitreous hemorrhage becomes a slightly problematic issue in ultrasound. But I think retinal status and choroidal status can be easily documented and they can be followed for prognostication. To look at vitrectomy for endophthalmitis, I think there are certain tips that I would like to share here. The first and foremost being the type of anesthesia that we use. Given that a globe has been ruptured, there is endophthalmitis, general anesthesia is a preferred anesthesia so that we don't distort the globe any further. Having access to the antechamber or to the vitreous for culture and sensitivity of the organism is a vital first step of treating endophthalmitis. Knowing well that the eyeball is going to be soft, so the approach should be that you want to have an AC maintainer or a long cannula in the posterior segment, which is about 6 millimeters or so that you are clearly inside the vitreous cavity. The first step would always be to clear the anterior segment with a thorough wash. And if there is a bit of cataract, I think we should not hesitate to do a lensectomy and remove the cataract. As I was saying, if the infusion cannula is not seen, then the ideal way to go about would be to use the AC maintainer and go about cleaning the anterior segment. But I nowadays, I'm going to show you in the video as well. I also use an endolight or sometimes other techniques to identify whether the infusion port is inside the vitreous cavity. A generous anterior vitrectomy is a vital part because the membranes in the anterior part of the vitreous tend to be more thicker compared to the posterior part, and there could be traction as we insert and remove instruments inside the vitrectomy ports. And posterior vitrectomy, gingerly starting around and then moving to the periphery is the ideal way. If you approach a foreign body, I think metallic foreign body, clear as many membranes as possible. Retinal trauma, the site of the impact, I think you need to make sure that you don't use any vacuum over there and laser the edges of the impact site. LPFC is a good idea, especially you don't want the subretinal heme to trickle and also the foreign body to hit on the macula. Use of appropriate intraocular magnets and foreign body forceps and silicone oil post-operative in case of any retinal detachment. I think a generous cover of broad spectrum antibiotics perioperative is a vital part of the management, as well as intraocular. I nowadays use piperacillin tazobactam for most of my cases with a repetition as and when necessary. So brief video of how I go about doing my surgeries. As you can see, I'm putting the infusion port. It's a 26 number needle which I put inside and check the tip of the 26 number needle before putting the cannula inside. Making sure that we remove as much of thick material from the anterior chamber and cleaning up the anterior chamber. There could be haze initially with the cornea becoming suddenly hazy, but as soon as the IOP is well managed and the wounds are cleared, you can see here the cleaning up and the clarity improves. Approach the anterior vitreous slowly, carefully. Make sure that the vitreous cutter is fresh and not dragging on the vitreous. Gingerly, as I said, go towards the disc and the posterior pole. You can see a bit of air bubble in the anterior vitreous. Gradually approach the periphery. Don't be in a rush to induce the PVD. A PVD induction is not necessary always. If it's possible, yes. If it's not, we can leave the vitreous and clear as much murky vitreous as possible. Those tiny stuck-on appearance of exudates on the retina with the hemorrhages, we leave them as it is. Do not try to vigorously aspirate on those exudates. And as you can see, the vitreous starts clearing and you can easily institute your intravitreal antibiotics with the clearing of the vitreous. Thank you so much.
Thank you, Mahesh.
Thank you, sir.
Can you stop sharing, Mahesh?
Yeah.
The screen?
Yeah.
It was, I think, excellent collection and good lecture. Next is Saumil talking on out of the box foreign body management. Saumil has been, I think, since I know him, he has always out of the box thinking. Saumil, are you ready?
I'm ready. Mahesh, can you stop sharing your presentation?
Yeah. Is it stopped?
No,
it's not.
There.
Still there.
It's still there? Hold on. Hang on a second.
I think audio visual people are there, probably.
Yeah, I think it's
Sai Numerotech. Anybody from Sai Numerotech?
Yeah. Is my presentation visible now?
Yeah, it's visible.
Yeah, it's visible.
Please go ahead.
Okay. Thank you, MOS, Pritam and Swapnesh, for the opportunity. Mine is also an equally traumatic presentation after the trauma presentations that we've seen of the previous two speakers. Though lesser in magnitude as compared to what Ashish's videos had. Amazing stuff, Ashish and Pritam and Saili. So I'm going to be continuing the same topic, giving you more examples. And forget the fancy title, the irony of ironic foreign bodies. The irony is in the fact that the approach is a little bit out of the box, not the usual conventional way people would approach it. Secondly, all these ironic foreign bodies, the magnet has been of least use to me when I've approached them, as you will see how. So the first patient is an intravitreal pars plana foreign body. This I've presented before, probably it may be a repetition, but I always like to begin with this case because it gives you a good insight as to how you can approach stuff. Pars plana iron foreign body with 6/6 vision, very clear lens, no retinal tears, well-healed, self-sealed scleral perforation. In fact, the patient keeps on asking us as to why we are actually operating him, especially when you tell him that your foreign body is here somewhere on the pars plana is seen on the CT scan and everything else is clear. You have 6/6 vision, but upon removing the foreign body, you can have a risk of detachment. You'll require another surgery. You may have to remove your lens, put an IOL, and you no longer probably be left with 6/6 vision. So the patient actually wants to opt out of the surgery and the surgeon decides, let's see if we can have an alternative approach. And this was my approach to the surgery. What I do is take a stay suture, open up the conjunctiva, mark the foreign body site as you see over here with a pink marker, open up a sort of a scleral flap at the site of the pars plana where I'm going to approach the foreign body. So mind you that I'm not going intraocular at all. I'm all the time staying extraocular. After raising the superficial flap, I make a deep flap, very similar to a deep sclerectomy. This acts like a trapdoor in case things were to go out of hand. And you see a choroidal knuckle right through. I cauterize the choroidal knuckle so as to prevent bleeding. Just make a tiny nick over there. And as I see a little bit of a vitreous bulge there, I put my magnet in and out comes the foreign body. So no harm, no foul. You don't go intraocular at all. You cut the little bit of vitreous that is there near the wound. You suture the superficial as well as the deep scleral flaps individually. On following up the patient postoperatively, he never developed a cataract. Yes, I did do a little bit of cryo around the area of the foreign body to prevent maybe retinal trauma and retinal tears later on, but the patient continued to maintain good vision. So this was an intravitreal magnetic iron foreign body, which I removed through the anterior route, and quite likely so because the patient had a traumatic cataract, almost total cataract, which was removed by lens aspiration after suturing the corneal tear. This foreign body was approached through a scleral tunnel rather than making just a corneal wound so as to not damage the corneal endothelium. Did vitrectomy, induced PVD, probably should have put PFCL to prevent the backlash of the foreign body on the retina, picked it up with a magnet, with a handover technique, passed it on to the intraocular forceps, and with the help of a Vectis, removed it out through the corneoscleral wound. A relatively smooth process, not that much damaging as compared to removing it from the pars plana, which could damage the retina. Did an endo laser, and that was the end of the surgery. So things are not going to be that easy from now on. It was the same intravitreal, very similar case, intravitreal magnetic iron foreign body, which I had to remove to the pars plana because the lens was clear in this case. So couldn't remove the lens out. And since I thought, let's say it's a very small foreign body and the vitreous looks very, very clean, I might as well get away with a very small pars plana incision, which I do. I put in a magnet there. And now what I have to do is align the foreign body in the direction so that it comes out through a much smaller incision. And it does not really, maybe the choroid is preventing, or I really do not know, the magnet is not probably strong enough. The foreign body is too small for its magnetic effect. So what I do now is try to do a handover from forcep to forcep and it falls down again. Probably should have put PFCL. The third time around, I remove it with the help of an intravitreal forceps. Not using the magnet has not come of any use here. So again, similar case, intravitreal magnetic iron foreign body, which I'm removing through the pars plana because of a clear lens, but this time the foreign body is not that small. It is also a little bit oddly shaped and it has really sharp edges. So I do a vitrectomy, I make an extension at the pars plana. You see the lens is absolutely clear. And I make approximately a 3 to 4 millimeter wound in the sclera. Try to pick it up with a magnet, and you see over here, see the tentative, the body keeps on falling. Probably it's not as magnetic as I thought, and it's not aligning itself in the direction, the way it has to come out along the long axis because of its polarity. So I try to hold the magnet and I'm actually thinking here, I don't want to touch the lens. The eye is phakic, the lens is absolutely clear. I give an attempt opening out the scleral wound with a lens forceps, but all I let out is a choroidal knuckle and a whole lot of vitreous, and the foreign body remains inside. So this is another attempt 7, attempt 8, probably attempt 9, and the foreign body keeps falling. I don't feel magnet is the right way to go about removing this. Again, the magnet over here, I'm ruminating as to what I should be doing. The lens here is clear. I do not want to sacrifice it as far as possible. The last attempt that I made is roll over the foreign body so that I can grasp it within the reach of my forceps. And then I try to remove it, holding the long axis along the direction of the incision that I've made. And I'm able to successfully remove this foreign body through the pars plana. And you see the lens has been clear all this while, and the patient has had a good outcome. So intravitreal magnetic iron foreign body with pars plana removal, again through a clear phakic lens. A similar case as previous. Again, the foreign body, this is more rectangular, more squarish as compared to the previous case that was rectangular. Here also, I think this is an IOL here. So at least I have the relief that I'm not be touching the lens in any case. So I extend this wound a little bit, and all this while trying to use a magnet. It's not going to get the foreign body out. It just got caught here in the wound, and just by the flow of the fluid along with the forceps, I'm able to get the foreign body out. Again, magnet is of assistance here, but has not been of that great use. The last case is actually not an iron foreign body, but I want to include it as a part of it because it's a copper foreign body. Some people say you can keep it inside, but you are having, though the patient has 6/6 vision, the patient has a chalcotic lens, probably will develop copper toxicity later on in life. There are no retinal tears, well-healed self-sealing scleral perforation, and this is how I approached it. Did there excessive cell staining because of the chalcotic cataract? You see there is copper staining there, and you do a hydrodissection, you complete your cataract surgery, put in an IOL, and then go on to removing the foreign body. The foreign body here is actually a copper wire, which you will see suddenly in the periphery of the retina coming into view, and it is very, very badly entangled in the vitreous, so much so that you have to actually free it from all the vitreous adhesions as much as possible. And now seemingly it is lying on the retina, but there is still this tuft of vitreous that is adherent to the foreign body. And now you pick it up and try to separate it from the remaining vitreous. And slowly, once the foreign body is completely free from all that action, you try to remove it along the long axis, and you remove it through the 23 gauge cannula itself. Now you laser the area of where the foreign body has ricocheted on the retina, and you check the periphery well. And this patient also went on to develop a similarly good outcome of 6/6 vision as what he had pre-operatively, but we still had to remove the foreign body. So thank you. That's the end of my presentation.
Omil, I had just 2-3 points to make. I always remove the fibrous capsule of the foreign body. Maybe the patient you showed there, you could remove the fibrous capsule and you could take out with the forceps. So always remove the fibrous capsule because then the magnet would work better. And number 2, I usually make the scleral incision with a Bart Parker blade, because I try to err on larger incision, because sometimes if the incision is small or if the choroid is not properly perforated, the foreign body may not come out. And thirdly, previously when we was young, means about 30 years back, there used to be giant magnet. For the same purpose, what you showed it beautifully well. But there was a giant magnet they used to use. There was no intraocular approach that time.
Correct, sir. So points well taken, actually, sir. I didn't have an electromagnet with me, but I felt that could have been the need of the hour.
Lovely. I think great videos from you, Somil. I think even I agree that some of the cases you can easily use a forceps to get the foreign body right up to the edge of your wound, and then extract it with a forceps. You need not always use a magnet for all the foreign bodies. Thank you so much. We move on to our next speaker, Dr. Kaushal. He'll be speaking on blunt trauma and management of it. Dr. Kaushal, is here now?
Yes, sir.
Yeah.
Is my screen visible, sir?
Yes, please.
Yes. Just. Yes, sir. Good afternoon, everyone. So I will be presenting on blunt trauma and posterior segment presentation. Is my screen visible and my audio is audible?
Yes.
Yes, yes. Please go ahead.
Thank you. Thank you. So I'll just, in a brief, talk about the BETS classification. So eye injury on the basis of full thickness or partial thickness can be classified as open globe injury or closed globe injury. Open globe injury is further classified into laceration and rupture. And laceration is further classified into intraocular foreign body penetrating injury and perforating injury. In closed globe injury, we have lamellar laceration and contusion. So the mode of blunt trauma, it may be a direct injury or an indirect injury. And the mode of injury following this blunt trauma can be either because of the 4 factors. Number 1, the mechanical tearing of the tissue of the eyeball. Second, damage to the tissue cell, which directly hampers the physiological function. Third, the vascular damage, which causes ischemia, hemorrhage, and edema. And fourth, the trophic changes due to disturbances in the nerve supply. And the most common site of injury is basically the just behind the insertion of the recti muscle. Secondly, at the equator. Third, at the corneoscleral limbus. Fourth, at the insertion of the optic nerve. And fifth, at the previous site of any intraocular surgery. The mechanism of injury, it basically depends on the direct impact on the globe, whether there is a which causes further the compression wave force, then the reflected compression wave force which causes countercoup injury, the rebound compression wave force, and an indirect trauma from the surrounding elastic tissue and the bony margins. Whenever there is a blunt trauma, there occurs there occurs decrease in the anterior posterior diameter, and there is an increase in the equatorial diameter, leading to damage of the tissues which are arranged in circumferential patterns, leading to the 7th ring of trauma, causing iris sphincter tear, iridodialysis. Then we have angle recession, damage to the trabecular meshwork, then cyclodialysis, zonular dialysis, and lastly retinal dialysis. So just a brief about cyclodialysis. So in cyclodialysis, there is separation of the ciliary body from the scleral spur, and which is seen gonioscopically, and in OCD or in UBM will aid in the diagnosis, as here we can see that there is a scleral, there is a choroidal cleft, and there is a communication between the anterior chamber and the suprachoroidal space. Usually these cyclodialysis cleft do not require treatment, but if there is changes because of chronic hypotony, then the following treatment can be considered. Belt buckle with cryopexy or a direct cyclopexy can be done. Now, posterior segment injuries. So because of the anteroposterior compression and the equatorial enlargement, there is damage to the blood vessels of the iris, ciliary body, retina, and choroid, leading to vitreous hemorrhage, retinal hemorrhage. And in a case of vitreous hemorrhage, it is better to get an ultrasound done, because we don't know what about the underlying structure, and these may aid in the diagnosis of retinal detachment, choroidal detachment. And next is commotio retinae. So commotio retinae occurs due to the outer retinal layer damage due to the shock wave that traverses the eye from the site of impact. It is most commonly seen on the posterior pole, but may occur in the periphery as well. It is usually seen within a few hours of trauma, and it clears 3 to 4 weeks, and no is required as such. However, commotio retinae can be classified into retinal concussion and retinal contusion, the concussion being a milder version with a reversible vision loss, whereas in contusion, there is intense retinal whitening with retinal hemorrhages and persistent vision loss. Traumatic macular hole, the mechanism of injury involved in traumatic macular hole is contusion necrosis and traction of the traction, which is because of the trauma. Macular hole is seen after severe Berlin's edema, or when there is severe cystoid macular edema following trauma, or whiplash separation of the vitreous from the retina. It may not develop immediately, but it may take some time to develop. In many of the cases where in younger age group, when the size of the macular hole is small, which is less than 1/3 disc diameter, and where there is no surrounding puff of fluid, these macular hole may get closed spontaneously. But if it doesn't get closed spontaneously, then vitrectomy with ileum peeling and gas tamponade might be needed. Retinal tears and breaks. The dialysis is the most common type of retinal break post-trauma. However, HST, opper-credited hole, macular hole, GRT are also noted. The traumatic retinal breaks are predominantly noted in the area of vitreous base. Cox et al. Reported that 59% of the cases with traumatic RD had break limited to the aura, and Johnston et al. Reported that 85% of the patients with traumatic retinal tear developed RD. So retinal dialysis. In dialysis, as we all know that the posterior edge is attached to the vitreous base, and it accounts for 8 to 14% of the traumatic RD, and it is caused by mechanical disruption of the retina by force which is transmitted via the vitreous base. And it may develop at the time of injury or months or years, even years after injury. The most common site is superonasal and inferotemporal. Skiffen postulated that the nasal periphery has narrow vitreous base, so greater susceptibility than the rest quadrants, and ITQ being because of the orbital anatomy, it is least protected. So this is the other common site of dialysis. So choroidal rupture. A choroid rupture usually occurs because of the inelastic nature of the RPE Brooks complex and choriocapillaris complex. So a choroidal rupture can be a direct choroidal rupture or an indirect choroidal rupture. Direct choroidal rupture are usually rare and they tend to occur parallel to the aura. Whereas indirect choroidal rupture are usually noted near the posterior pole and they occur in a concentric fashion and in a crescent shape to the optic disc. The majority of tear occur temporal to the disc and involve the fovea. But 10% of the cases of choroidal rupture are associated with CNVM, and the factors which are responsible are old age, macular location, and greater length of rupture. As normal treatment of CNVM, these CNVM also require intravitreal anti-VEGF for the treatment. Now, chorioretinitis clopit chorioretinitis clopit is a closed globe ocular injury which causes rupture of the choroid and retina, but the sclera being intact because of a high projectile which lies very close to the globe. The fundus findings shows retinal hemorrhage, intraretinal hemorrhage, vitreous hemorrhage in a bare sclera. The visual prognosis usually depends on the extent and location of the intraocular injury. In spite of severe intraocular injury, these patients have low chances of RD because of marked proliferation of the fibrous tissue, causing firm adherence between the retina and the choroid to sclera. The treatment is usually observation and surgical if there is a concern of globe rupture and or RD alongside scleropedia. A traumatic optic neuropathy can be direct or indirect. It ranges from simple contusion to complete avulsion of the optic nerve. The most common cause of traumatic optic neuropathy is indirect injury to the nerve. The signs are decreased vision, decreased color vision, RAPD, and visual field defect. CT scan is must, and a 1 mm axial scan should be obtained, which helps in diagnosis of compression of optic nerve by hematoma, bony fragment, which impinge on the optic nerve, which would require future surgical intervention. Treatment observation versus high dose steroid, and high dose steroid should be given within 8 hours. However, according to crash study in patients who had head injury, when high dose steroid was given, there were increased fatalities which were observed in these patients. Optic nerve diversion, the patient will complain of immediate visual loss after trauma, and now on B, and this can be easily picked up on B scan, where an optic nerve which is not seen to reach the optic disc and an area of hypolucency was seen anteriorly just posterior to the optic nerve head. Scleral rupture. The scleral rupture, it may occur in severe blunt trauma, and it may be direct or indirect, indirect being more common. And the site in phakic eye, it is just posterior to the insertion of the recti muscle, whereas in pseudophakic, it is at the limbus. Most of the time, the scleral rupture is occult, and we can easily recognize this by the visual acuity of patient being PL or no PL. There is severe chemosis, large subcurrent hemorrhage, ocular hypotony, hyphema, abnormally deep or shallow AC, and associated vitreous hemorrhage. Management, careful globe exploration, and early primary repair is key to the treatment. Chorioretinopathies from indirect ocular injury. Pusch's retinopathy. Pusch's retinopathy is described as a chorioretinopathy which is associated with indirect trauma and non-ocular injury. It is seen in severe patient with severe head trauma, and the fundus findings include cotton wool spots, retinal hemorrhages, optic disc edema, and Pusch's flecken. The condition resolves spontaneously on its own, but it might take at least 1 to 3 months for the findings to get resolved. Puschel-like retinopathy, in this the fundus findings are typical of Puschel retinopathy, but there is no history of trauma. However, there is associated systemic history like patient having acute pancreatitis, pancreatic adenocarcinoma, renal failure, and preeclampsia. Terson's syndrome. Terson's syndrome is now recognized as intraocular hemorrhage associated with subarachnoid hemorrhage, intracerebral hemorrhage, or traumatic brain injury. The hemorrhage may be present at various levels, and these hemorrhage usually take around 3 to 6 months to get resolved. But if the vitreous hemorrhage persists, then vitrectomy can be done. Shaken baby syndrome is a kind of abusive head trauma. It is usually seen in age group of less than 2 years. It is caused by violent shaking of baby with impact injury to head, and ocular findings are always bilateral, and there is associated poor vision, RAPD, periocular bruising, and subconjunctival hemorrhage. Retinal hemorrhage is present at multiple levels and mostly over the posterior pole. The treatment, mostly it will, the hemorrhages will clear spontaneously within 4 weeks. But if the hemorrhages doesn't clear, vitreous hemorrhage doesn't clear, then a vitrectomy is needed. Thank you.
Thank you, Dr. Kaushal. I think it's a thorough revision of blunt trauma. I think I was reminded of some of these Kansky chapters. With this, we are coming to the end of the trauma session. Before we end, I think I have a few questions for Parikh sir. Parikh sir, if you're around. Sir,
yeah, he's there. Can I interrupt for a second? I just want to say thank you to Vatsal bhai, you Mahesh bhai, Manoj Dada, Preetam, and everybody who took part. Thank you so much. Thank you, Vatsal sir. Hi Somel. Thank you so much, Ashish. Thank you. Sorry I interrupted. Thank you so much. I've been quietly listening. I didn't want to interrupt because not that I know anything in retina.
You know everything.
that means you know everything, ma'am.
No, not at all. You know, you have to blame Preetam and everybody, you know, Ashish and Ashwin and all, Saili for me not knowing anything in retina because they are the best.
Madam, when the matter comes to you, then you are the final judge.
No, not in retina.
You know everything.
Vatsal bhai knows me for the last so many years since I was a student.
So your audio is muted.
Sir, you're muted, sir.
Ragini, they have to thank you because you are not putting your head. They can learn so many things. Otherwise, they would not have a chance to learn.
I completely agree.
Yeah. Okay. Good afternoon, Gomad sir.
Okay. Well, with this, we'll move on.
Thank you so much.
Thank
Sorry
you,
for interrupting, Mahesh Dada. Please continue.
No problem, ma'am. Thank you. Any questions from anybody in the audience? No, I think,
You're
sir,
finishing in time.
Sir, last question before we close this session. Yeah. In your experience, any particular case which comes to your mind, sir, which was very difficult, Parikh sir?
See, I had a case of traumatic endophthalmitis where I did vitrectomy. I couldn't locate the foreign body, and I think I had fracture or something. Patient needed resurgery, so I referred to Anand Gupta, and he found the foreign body. So I think a vigilant look for foreign body is a must, you know.
Anything, Somil, you would like to add?
I feel the session was very enlightening. Excellent plethora of videos and very nice inputs from you as well as Vatsal, Parikh sir.
Thank you.
Thank you.
Thank you so much, Dr. Naigaonkar, Ashish, Somil, Parikh sir, and Dr. Sanghvi. Thank you so much. We move on to the next session. Thank you.
Thank you, Dr. Mahesh. So we'll move on to the next session, which is vascular disorders of the retina. And I'd like to welcome Dr. Sharad Gumad, sir, who will be chairing and who will be co-chairing the session. We have the first talk by Dr. Vircon, but he's not. You know, he has a little bit of difficulty connecting right now. Am I audible?
Hello, Piyush.
Good afternoon, sir. Thank you so much for joining in, sir.
Yeah,
we
Piyush,
have Dr. Ishwarchandra, sir.
Yeah, Piyush, I have a request. Hello.
Can
Yes,
you
sir,
hear?
please, sir.
Yes, yes, we are able to hear you.
Nothing.
Yes,
No,
sir,
no.
we can hear you, sir.
One of my close friend actually died, and I'm coming. So I thought I'll finish my talk and go. And you
Yes,
can.
sir, please, sir.
Okay. Sorry for the.
So may I invite Dr. Natarajan, sir, to please give his talk on screening to surgery in diabetic retinopathy.
Yes.
So like we all know, Dr. Natarajan has really taken diabetic retinopathy screening to a whole different level. And as AI's past president, he ensured that there were a lot of screenings that were done all throughout the country, especially our state. It's a topic that is very close to him. And so we can't see your screen yet, sir. Your
Yeah. 1 second. I'm just thought I think the desktop something is wrong. 1 second.
Sure, sir.
Now you can see the screening, the screen.
Yes, sir, we can see it.
Okay. Yeah. So preventing a proliferative diabetic retinopathy blindness from screening to surgery. So there's no financial interest to disclose. So I made this program, as Dr. Piyush mentioned, as an All India President, screening through teleophthalmology to prevent diabetic blindness, and we called it Jot Se Jot Jalao. So the global prevalence, it's going to diabetes keep increasing, and we have 77 million diabetics in India, and by 2030 it will become 101, and by 2045 it will become 134.2 million. So all of us have to be wiser, so that we recommend primary checkup at the time of diagnosis in every patient with diabetes, and prevention is better than cure. So we have this plan of action: screen, diagnose, and treat. So the process flow is to have a pre-camp awareness, and I think everybody and anybody should do that. Means doctors, optometrist, diabetologist, physician, IMA members, maybe the even Ayurvedic. Everybody should do at least a screening, assembly of diabetics, capturing of images, uploading, and diagnosis by ophthalmologist or using the AI. So we have a problem in the health system: one ophthalmologist per 100,000 population, low awareness or ignorance, and 70% of Indian population resides in rural area or urban slums. And the technical difficulties are unreliable internet coverage, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus cameras, and portability of conventional fundus camera. And here we are using role of artificial intelligence, and I like to define intelligence is the capacity to analyze, think, make a decision, and categorize. And artificial intelligence involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. So this is a best thing available. As I said, no financial interest. This is made by Remedio, and it's an iPhone attached to a infrared device, can be mounted on a suitable bike for transporting for screening purpose, can be mounted on any table. It is chargeable. And then I call this as anybody can screen for diabetic retinopathy. What I mean by this is I've trained my room boys, the community health workers who are only 7th pass or fail, who can handle the mobile phone and the infrared device and take pictures and send it and you can see This is the video which shows anybody can focus and take a photograph. You can use 1% tropicamide and then focus and take a picture and then apply it to AI, and then the AI will say which is a referable diabetic retinopathy or which is a software is called Meteos, made by a company from Singapore. Again, I don't have any. This blue, what you see, is the one which picks up the lesions and then says referable and no need to refer for diabetic retinopathy. That means at the spot, within 30 seconds, the person can find out whether you need a referral or not. And then simultaneously, the same images can be posted to the main place where the ophthalmologist can check it up later, and then there's no emergency, so the person can check. And this is a comparison on Fundazon phone with the size, and this is a AI, the blue one, which picks up the lesions. And then, so this is again how we can make the diagnosis. So we also did a study. Is artificial intelligence reliable to pick out those in need for seeing an ophthalmologist? So we published the results in JAMA Ophthalmology as an original investigation. Diagnostic accuracy of community-based diabetic retinopathy screening with an offline artificial intelligence system on a smartphone. I'm happy this was quoted in the American Academy as the future of diabetic retinopathy screening, but I'm happy to say we are already using the first of its kind in the world, and we are ahead of Google use of offline AI for screening for diabetic retinopathy, using a non-skilled worker, train them only for this and make them a semi-skilled worker in the Municipal Corporation of Greater Mumbai Dispensary by the Aditya Foundation. The pilot study, we did 231 out of 255 patients considered for prediction of referable diabetic retinopathy using AI. And we did a field trial. The average diabetes was about 5.5 years. Patients with no diabetic retinopathy, 187 according to ophthalmologists. And AI found 172 patients with no diabetic retinopathy, which means 8% were overdiagnosed by AI. And this was the most viewed within a month, most talked about article of 2019. It was in the top 5. And reliability of AI for screening population for diabetic retinopathy in need of ophthalmic checkup by eye doctors 100%. And then advantage of using AI, early referral of referable diabetic retinopathy, greater awareness about diabetes, its effects and importance of regular follow-up, greater chat time to referable diabetic retinopathy, timely medical surgical intervention to prevent complete loss of vision, and more job opportunities, more working hands, skill development of less educated. This is our NGO, the name given by the former president, and he inaugurated the van. And I have the best friend, Mr. Shivanand. And this is the first one in the project in carrying Forus Trinitra camera in a motorbike, which was inaugurated by my grandmother, my late father, and Shivanandan and Ravichandran. So I do, in case, in spite of the screening and the patient comes very late, we do the when to operate, site-threatening traction retinal detachment, non-clearing vitreous hemorrhage, combined traction and recmotogen retinal detachment, taut posterior hyaloid, rubeus iridis with the vitreous hemorrhage, and vitreous surgery, which surgical objective is to thorough removal of the vitreous bleed, endolaser for the non-perfusion areas, reattachment of the macula, removal of traction. So the whole idea is to restore, maintain vision. So this is a 48-year-old with bilateral vitreous hemorrhage, and you can see I'm using the 23 gauge vitrectomy, 3-port Pascal vitrectomy. The patient had a visual acuity improved from counting finger to 618, and both I had similar picture at present performing the anterior vitrectomy, then the posterior vitrectomy, and you can see the fibrous tissue arising from the optic disc into the vitreous cavity. So anterior posterior traction and all the is relieved, and also the anterior traction is relieved only with a cutter. And then I actually do a diathermy, and after the diathermy, I do this cutting out the fibrovascular stalk. But in spite of that, you can see it will bleed. Now I'm doing the diathermy, endodiathermy. And then after the endodiathermy, I do the using the cutter. I cut the stalk, but I can see that still it bleeds. So we can instead of increasing the intraocular the pressure, I always do a diathermy. I don't like to raise the intraocular pressure because the optic disc can be compromised, and already in a diabetic the optic disc is pale. But I think best is to do a good diathermy and then do the control the bleeding, and then I use the cutter. You can see the entire retina. Then again to do a pan-retinal photocoagulation. You see, except the optic disc and then I do a fluid exchange using the retinal brush, and then complete with a non-expansional gas mixture. And then this is a proliferative diabetic with the traction retinal attachment with the visual acuity of 2/60 pre-op, and you can see I'm using the proportional mode. I'm using the 25 gauge 3-port pars plana vitrectomy. I'm glad I introduced the minimal invasive vitreous surgery along with Mark Kumayan, the man who made the artificial retina first in India in 2004. So we have also used 27, but I think it's unnecessary, adds the cost. So in 25, you see here, I cleared the pre-retinal vitreous hemorrhage using the cutter only. Minutes, or 1 minute. So this is the, you can see the, I use the proportional mode where I push the fluid between the fibrous tissue and the retina, and then thereby we can make a cleavage and then clear of the entire fibrovascular proliferation, as you see here, and complete the pan-retinal photocoagulation, and followed by a non-exponential mixture. And then this is the post-operative visual acuity 6/9. You see the optic display, the same eye. And this is a combined traction retinal attachment. We do the cataract, and then we also do the intraocular lens. And then you can see the PFCL was used. And then finally, remove the attraction between the optic disc and the brake. And then I do the laser around the brake and complete the, do a pan-retinal photocoagulation, fluid air exchange. And then you can see a cataract, vitrectomy, buckle, sorry, endo laser and gas, everything so this is a twin light vitrectomy, which we use it using the it's a dark one with a 20, and here you see the by both hands can be used, catch the fibrous tissue, and then use the cutter in between and remove all the traction. The aim is to have a no iatrogenic break. Once upon a time it was 20%, and now we want to reduce it to as low as possible an iatrogenic break. So the whole tissue is cleared, and then the pre-retinal hemorrhage is cleared, pan-retinal photocoagulation is done. So this is I use 3D fantasy vitreous surgery, and all the time I do that. And then the benefits are you can, I mean, everybody can see what you are doing, and then this is the setup I use, and then whatever I'm seeing, the entire operation theater can see. And then this is the one again I'm actually skipping. Thank you very much for the opportunity to give a talk. And if any questions, I'd like to answer.
Thank you very much, sir, for this lucid presentation, right from screening and then going on to those fantastic videos. I think you've covered pretty much the variety of diabetic vitrectomies that we get to see in our usual practice, yes, and some really nice pointers that you could give us. Do we have any questions from anybody that we can ask, sir?
I can see Dharma, Manoj is there.
Yes, sir. What is the twin light? I am seeing something new today.
Actually, twin light was done when I bought it in 95, I think, from Class A card, made by. So now what I do is, it is like a 2 elimination like this into the vitreous cavity. So that there is no shadow, if you have seen. So it eliminates the entire vitreous cavity very well. And it's actually like a 25 gauge 2 light sources, which you can do with the 2 Paul Tornambes light source also.
Okay,
this was designed by Eckhart and made by this one. So I have the old video, and after a long time I started using it recently, and I think I should put the new video. And
we presented a video in 2005 new retina, sir.
That's correct. Same thing.
Same video, twin light user.
I think the second case I skipped today, and I think even Nazimul was there once, I think, the OT that time. Anyway, I like to buy all these toys all the time. My second mentor was not happy to buy new instruments, but I always want to do the newer things all the time.
Yeah, that's good. Thank you, sir.
Thank you. So, Piyush, I'll ask. I think Dharmesh, you know Dr. Vasudev Ginde, you remember him?
Yes, sir.
No, unfortunately, he passed away early morning. So I just came there for that. That's why excuse me. So I'm going there to the house. Okay.
So thank you so much, sir, for still giving us the time, and our deepest condolences.
Yes, thank you.
So with that, we move on to our next speaker. If Dr. Sarang is there, Dr. Sarang, are you there? Dr. Sarang Lambat? Okay, perhaps Dr. Devendra Venkatramani?
Hi, Piyush. I'm here.
Hi, Devendra.
Very well,
Excellent.
thanks.
We've got a major reshuffle going on right now. So from diabetic retinopathy, if you're ready with your presentation, Dr. Devendra, then we can
sure
perhaps start yours. Perfect. Very nice of you. So Dr. Devendra Venkatramani is, like you all know, a very dynamic retinal surgeon practicing in Navi Mumbai and Pune. And he shall be speaking on how AMD treatment has evolved.
So thanks, Piyush. Thanks, Piyush. It's a pleasure to be part of this August meeting as well as this lovely session. And I'll just clarify the topic a little bit. It's more how it has evolved in the last 1 year. And 2020, when it dawned, I distinctly recall all of these forwards on WhatsApp wishing ophthalmologists one to another that it's the year for ophthalmology, because now this is we hope that all our patients will get 20/20 vision. And it was a year full of positive expectation. And then it ended up being the pandemic that is going to define hopefully the rest of our lives, and no more pandemics after this. But it also marked an important watershed, because this was the year in which brolucizumab was launched, and there's a lot of hype and buzz and interest about this molecule. So let's see how practice has changed with the introduction of this molecule. So just to give a little bit of an overview about fluid and neovascular AMD, we all know that fluid is the most important aspect of treatment and also retreatment of patients with neovascular AMD. And fluid can be in different compartments, whether it's subretinal, intraretinal, or sub-RPE. And these were findings from the CAT study, which showed that sub-retinal fluid was the most common, followed by intraretinal, and sub-RPE the least. But whatever kind of fluid, all the guidelines suggest that we really need to dry the retina as best as we can, whether it's the EURetina guidelines, the Royal College of Ophthalmologists guidelines, or the American Academy of Ophthalmology. And all of these are OCT-based guidelines that talk about retreatment on the basis of fluid persistence. All retinal fluid is considered pathological, but as of now, we really don't treat sub-RPE fluid, although it may be an early sign of disease activity. It's more or less our treatment and retreatment is restricted to the presence of intraretinal or subretinal fluid. Now, the Hawk and Harrier, which were the two pivotal trials that examined the role of brolucizumab versus aflibercept in neovascular AMD, showed these very interesting findings. If you can look at these graphs and try to make sense of them, you can see that the best corrected visual acuity is much poorer in those patients who had high disease activity, which was defined as the presence of intraretinal and or subretinal fluid at those various time points. So if the macula dries faster or remains dry, it is going to end up with, that eye is going to end up with much better vision than if it had any disease activity defined by intraretinal or subretinal fluid. So before 2020, we had the other anti-VEGFs, that was ranibizumab, aflibercept, and bevacizumab. But with all of them, there were certain limitations, like the residual or recalcitrant activity in some patients, in which there was recurrence of intraretinal fluid or non-disappearing fluid. And also that these drugs were not sufficiently durable or long-lasting, and there was a need for multiple repeated injections that were constantly adding to the burden of the patient with multiple visits. So I think everybody agrees that these should be the qualities of an ideal anti-VEGF, and it remains to be seen now whether brolucizumab really has succeeded on all these counts. So with the introduction of brolucizumab, which was arguably the most clinically advanced molecule, simply because it has the smallest size, and therefore from the antibody fragment, you have this minimal micro-sized molecule, which can therefore be packed into the same volume. This is called molar dose. So the molar dose of brolucizumab is much higher than any of the other anti-VEGFs, and therefore this can result in a higher potency within the eye. So as I mentioned earlier, it's the smallest molecule. It has rapid systemic clearance, but effective penetration into the retina and choroid, probably because of its very small size. So Hawk and Harrier, as I mentioned earlier, compared brolucizumab with aflibercept. Without going too much into the nitty-gritty of the studies, the findings were very illuminating. They found that over 50% of brolucizumab patients could be maintained on a 12-weekly, almost a 3-monthly dosing regimen after receiving 3 loading doses. So this was very heartening to see that at the end of 1 year, the patient had received only 6 injections on average in at least half of the patients. Just an illustrative case of one of my patients who I was initially treating with ranibizumab almost on a monthly basis. And the moment I switched over to brolucizumab, which was in March 2021, you can see that the macula is immediately dry and subsequently remains dry for almost 3 months. So it is not just the statistical data, but also anecdotally we find this. The central subfield thickness fluctuations, which we see with aflibercept, which are also seen in the View 1 and View 2 trials, this sawtooth pattern is not seen with brolucizumab, and you can see a significantly thinner, flatter macula at every time point when you treated the patient with brolucizumab versus aflibercept. And there was obviously a reduction in intraretinal and subretinal fluid, which was significantly less when you compared that with brolucizumab at each of these disease activity visits. So the subretinal fluid reduction was very promising, almost half of what you could expect with aflibercept. And another illustrative case of mine, this was persistent intraretinal cysts in a patient who was receiving very intermittent treatment with bevacizumab simply because he could not follow up very frequently. He's an octogenarian and he found it very difficult to come on a monthly basis. And there was always this persistent intraretinal fluid. And then when we switched over to brolucizumab in July, you can see that even 3 months later, the cysts are at a very, very small level and there's a good improvement in near visual acuity. So it does goes to show that the brolucizumab has a superior drying effect compared to anti-VEGFs. And it also dries the sub-RPE fluid, which is very heartening to see because, this is probably a disease activity indicator. And if you can somehow flatten those PEDs, which is not one of our treatment criteria as of now, we may be able to change the course of the disease. So this is another illustrative case showing that. A very important subgroup of patients where I find that we've really changed our disease management is PCV. And what has changed is principally the unavailability of PDT, which has now led us to move on to anti-VEGF monotherapy. And in PCV patients, we have got excellent results with brolucizumab. This is a post-hoc analysis of PCV patients in the HAWK trial. And here you can see that they had excellent change in the visual acuity from baseline up to week 96 for PCV patients, and also a very good, very large proportion of patients maintained on a 12-weekly dosing regimen after the loading doses. And again, superior drying of the retina compared to aflibercept. So in conclusion, I would like to say that brolucizumab has given us a molecule which has better fluid resolution, faster fluid resolution. Patients also perceive a visual benefit much earlier on in the course of the treatment. It has a more durable effect, at least for 10 to 12 weeks. 10 weeks plus or minus 2 weeks seems to be the median requirement as per the Braille study, which is an Indian study with the real world scenario. Better compliance of patients because of longer treatment intervals, and also the economic factor, which is very favorable compared to other molecules. And it has an excellent effect on variants like PCV. So I'll end over there very quickly, and I'd be happy to take any questions if there are any, either now or towards the end.
Devendra, excellent presentation. Can you hear me?
Yes, Swapnish. Thank you so much.
Yeah. So while you are there, could you share your experience in non-AMD cases like diabetic macular edema? You must have tried.
No, I haven't. I haven't. I know people have, but as of now, brolucizumab is approved only for NAMD and PCV. We're waiting for their approval for DME and vascular occlusions. So I so far have not tried it. I've not even tried it in non-AMD CNVM. I know a lot of people who have, and I can say that they have had excellent results as well.
No, great presentation.
Thanks so much.
Fantastic, Devendra. So I was going to ask you the same, but then you've answered that. Now, what about your practice protocol now? When you have the treatment naive patients, do you offer them brolucizumab right on to begin with, or do you still prefer going the trial and tested the method of offering them ranibizumab first?
That's an excellent question, Piyush. Actually, when I started using brolucizumab more than a year ago, I found that I would be safest if I followed the Hawk and Harrier trials. And those were all done in treatment naive eyes. So all of my initial patients were treatment naive. In fact, the examples I showed you, the first one which I showed you was actually the other eye, fellow eye, was a treatment naive patient in which I had initiated brolucizumab. So now, after that, I've started using it in recalcitrant patients as well. But I have used it in both subsets of patients with very good results.
Fantastic, fantastic. Any other questions that anybody has? For Dr. Devendra? Okay, so then we'll move on to the next talk. Is Dr. Dharmesh?
Yeah.
Is there? Dr. Dharmesh, sir?
Yeah.
Dr. Dharmesh, like we all know, is a fantastic vitreoretinal surgeon practicing in Bombay, a very high volume surgeon, and he'll be speaking on biosimilar ranibizumab, his experience.
Yeah. Good afternoon. Hi, Piyush. Thanks. Slides are visible?
Visible, sir. And
yeah, as we know, the biosimilars are there in the market since long, and we are all using it since quite a long time, and there are newer things are coming in the market. So what are the biosimilars? Are the near identical copies of the innovator biologic or reference product, which do not have significant difference in terms of efficacy or safety in clinical use. And they have the potential to reduce the cost of treatment up to 30% without compromising on dosing interval or the safety. Now here I'll just present the phase 3 study of the efficacy and safety of C plus biosimilar ranibizumab versus innovator ranibizumab, that is Lucentis, for a patient with the wet ARMDs. Now it was a prospective multi-center randomized double-blind 2-arm parallel group active control comparative clinical study was done, and it was done to evaluate the efficacy and safety of biosimilar ranibizumab. And it was a period from July 2018 to November 19, and it was done across the 16 centers in the India. So these are the list of centers all over the India. There are many cities, and the famous retinal practices has taken part. And the study objective was to compare the efficacy of intravitreal injection of ranibizumab biosimilar compared to Lucentis in preventing vision loss, as determined by the proportion of patients who lost fewer than 15 letters in visual acuity in ETDRS chart at 16 weeks compared to the baseline. And secondary objective was to evaluate other efficacy parameters, immunogenicity, safety and tolerability of the ranibizumab biosimilar up to 24 weeks. Methodologies: the number of subjects that were total enrolled for biosimilar ranibizumab was 106, and in Lucentis group there were 53 subjects. Dosing was biosimilar 0.5 milligram or Lucentis given once every 4 weeks, and the treatment period was 24 weeks. Initially, it was a double-blind period for 16 weeks, followed by open-label phase till 24 weeks. Now, inclusion criteria was an active primary or recurrent subfoveal lesion with classical occult CNVM secondary to ARMD, male or female patients more than or equal to 50 years, and text-corrected visual acuity as per the ETDRS is 20/40 or 23/20, Snellen equivalent in the study eye. Now, exclusion criteria is the who has taken the PDT treatment 6 months within or non-study eye in 1 week prior to randomization, previous external beam radiation therapy, TTT or subfoveal focal lasers, or laser photocoagulation for juxtafoveal, extrafoveal in the study eye within 1 month prior. And there was any intraocular surgeries, including cataract within 2 months or concurrent any other ocular condition which required surgical intervention, or uncontrolled glaucoma patients were excluded from the studies. Even patient with idiopathic autoimmune or uveitis, any conjunctivitis, keratitis, any other scleritis or endophthalmitis, or history of diabetic mellitus or diabetic retinopathy were excluded from the study. Now, the results in the primary outcome: the ranibizumab biosimilar has a comparable efficacy profile when compared with the innovator. which was innovator was 100%. This was 98.11%, and the p-value was not significant. Both at 16 and 24 weeks. Now for secondary outcome, the comparable efficacy profile when compared with the innovator. So both at the 16 and 24 weeks, it is comparable, where the p-value is 0.38 and 0.161. So proportion of patients will be at least 15 letters in the visual acuity. Now when we compare at day 1, day 16, day 24 of the biosimilar and compare it with the original molecule Lucentis, the visual difference in the mean number of letter gain from baseline to week 16 or 24 was statistically not significant between the two treatment arms. And when we compare at 16 and 24 week, the efficacy in the secondary outcome where the visual equivalent is 20/40 or better. So these are the number of patients who have improved in the vision. Now, proportion of patients with the visual acuity equivalent to 20/200 or worse, they have been also comparable as compared to the original molecule. And the change in the central macular thickness assessed on the OCT at both 16 and 24 weeks are comparable with the original molecule. And the safety assessment, safety profile is in biosimilar and innovator, both are the same, where adverse events are noted in 26 or 12 patients, and only one patient in the study has been noted death of the patient, but it can be due to ischemic heart disease from previous 3 years, and they have casualty is unlikely related to the study drug, or no other serious adverse events has been reported. An immunogenicity assessment, all the sample analyzed in the study were negative for anti-ranibizumab biosimilar ranibizumab antibody or anti-Lucentis antibodies, or no apparent immunological mediated safety or efficacy reported in the study. So in a conclusion, ranibizumab is comparable efficacy profile compared to the innovator. Adverse events was comparable between two treatment arm. The safety profile during the study in line with known safety profile of ranibizumab, and immunogenicity is there. Just show you the few case studies. This case one is presented with the diminished vision in metamorphosia. Right eye 660, left eye 618, right eye macular scar, left eye was wet AMD. This is the first and the second after first injection. After second injection and after third injection, patient improve up to 6/9 with the reduction in the metamorphosia. Case 2 is the BRVO, where we have given, and this is pre-injection and post-injection OCT. Case 3 is the old BRVO already treated, develop again BRVO in the same eye, and we have given injection and the improvement is dramatically seen on the OCT. Case 4 was a treatment-naive PDR patient with a cataract and DME, and they have given for both the eyes DME with 3-meter vision after cataract laser and bilateral injections. The vision they have improved to 6/9. Sure. Thank you. Thank you very much. So any questions I'll take now.
Thank you, Dr. Dharmesh, for the fantastic presentation. Any questions that anybody would like to throw at Dr. Kar? So maybe we can take some questions later on, sir, if somebody does have any questions.
Yeah, sure.
Right now we move on to the next topic, which is OCT biomarkers in diabetic retinopathy. And may I invite a surgeon from the Orange City, Nagpur, Dr. Sarang, are you there?
Yeah. Swapnesh, yeah, good afternoon.
That's me, Piyush. So my
yeah,
video
Piyush,
is
sorry.
No worries, sir. So we can see your screen. We'll
Okay. So am I audible?
Yes.
you can see your slide.
Great. So good to see a lot of familiar faces after a long time, and I would like to thank the Maharashtra Ophthalmological Society Scientific Committee for having me over here, and it's a fantastic afternoon. I hope you have enjoyed the previous presentations, and I'll take you through some biomarkers in diabetic retinopathy. So nowadays, biomarkers are taking up an uh, important place in analyzing what's happening to the eye and especially to the retina, and they can be evaluated as an indicator of a normal biological process, a pathogenetic process, or a pharmacological response to a therapeutic intervention. And they are important in detecting and monitoring a disease, identifying a patient's most at risk or progression, predict prognosis, explain residual risk, explain how the drugs work, predict response to treatment, monitor safety of treatment, and many more kinds of such important aspects where we would like to know what's happening to these to these patients and what's the response. So there are numerous biomarkers, mainly clinical, which can be general or ocular, or biomechanical and molecular. We would be focusing more so on OCT related biomarkers in diabetic retinopathy, and moving on to retinal thickness. So we all know that it's a very important way to assess a retina by knowing its thickness, how thicker it is, and there have been various parameters. Most commonly being used is the central subfield thickness, and it tells you an overall what's happening to the retina, how thick it is. And but it's very important to note that whenever the thickness goes beyond the stretching capability of the retina, then it can lead to significant damage to the bipolar cells, and eventually leading to decreased signal transmission and eventually having an impact on vision. But many a times these cases do not gain optimal vision post resolution, and that's why it's not so important to assess the thickness of the retina, but to know more about the morphology of the retina. And uh, it's not a very reliable parameter of assessing a vision of a patient. So it's very important that you should focus more on the pattern of the diabetic macular edema, extent of the involvement, and differential involvement, especially if the inner and outer, whether it's involving the inner or the outer retinal tissue. And it is mentioned that cross-sectional area of the retinal tissue between the plexiform layers in CME is a better predictor of visual acuity than the macular thickness itself. So this is how a typical macular thickness map what we get, and we can easily know what's the volume change, and it helps in overall knowing whether the patient is responding or not. But many times the correlation with the visual acuity is not so good. Going to the intraretinal cystoid spaces, so now we are trying to focus more on the morphology, and intraretinal cystoid spaces, as you can see over here, can cause photoreceptor damage, especially if they are located in the outer nuclear layer. And mainly the larger cysts, which are more than 200 microns, we are seen in the late stages of DME and have a significant impact on macular function. And it has been noted that treatment with anti-VEGF therapy leads to decrease in the number and size of these outer nuclear layer cysts. So it's an important biomarker which tells us what's going to happen to the patient. Another important biomarker is presence of hyperreflective signals within the cyst, and which is associated with severe disruption of the blood retinal barrier, as you can visualize in these photographs. And it has been studied by Kashani and colleagues that these kind of intraretinal hyperreflective signals are called as suspended scattering particles in motion, especially on the octa, which is gaining a lot of interest, especially in analyzing these vascular disorders. And this is an extravascular signal on octa, which is due to Brownian motion of the particles, and mainly seen at vascular and avascular junctions. And it has been found that anti-VEGF agents do not seem to directly change their natural course. So this also tells you that probably this patient is not going to do so well. This is a clinical example. This was a 55-year-old male, known diabetic since 22 years, visual acuity at presentation 6 by 12, and we gave him anti-VEGF injection with a steroid combination. You can note that there is a significant cystoid involvement, and which is reaching up to the outer nuclear layers, and probably this is not going to do well for the patient. And you can see that there is a fair enough control of the edema, but the visual acuity improvement is not so good. So we all can know that probably these cysts which are having hyperreflective foci within are not going to lead to a good visual acuity outcome. Coming to a subfoveal neurosensory detachment, which is also an important biomarker, especially in AMD cases, and also it has been found that it overall has a good prognosis if you have subsensory neurosensory detachment, both in AMD as well as in diabetic macular edema. And almost to the extent of 30% of patients can have this. And more often, this is linked to the albumin disturbance in the blood, and that has a significant direct impact on the presence of a neurosensory detachment. But as I've said, that it has been associated with good anatomical and functional gains. And it has been found that the steroid implants or use of steroids in such cases, since they have increased interleukin levels, which is a marker of inflammation, as we have known in COVID, that the steroids do work well in such cases of subfoveal neurosensory detachment. This is an example of a male 56 years of age. You can very well appreciate so many things happening in his macular area, and also he has PDR, presenting visual acuity of 6/18 and 6/24, and he eventually improved with combination of injection steroids and macular laser to 6/6, and that's how having a subsensory fluid, if you see, you know that this patient is going to do well. Have I exceeded the time? Should I continue?
No, sir. Please carry on. You have plenty of time.
Yeah. So another important aspect is presence of hard exudate. These are ominous visual signals which we get in, especially in cases of diabetes and even in AMD. And these are specifically hyperreflective spots more than 30 microns, and the reflectivity is almost similar to the RP. This is distinct from the hyperreflective foci, what we see, because the reflectivity is similar to the RNFL layer. And eventually it has been found that probably these hyperreflective foci get eventually evolve into hard exudates. And hard exudates especially are lipoproteinaceous, and they also help in monitoring progression, especially the quantitative measurement of these hard exudates. They do correlate with the lipid levels, and definitely in these cases also intravitreal steroids do have a better role in resolving edema associated with hard exudates. Coming to hyperreflective retinal foci, these are distinct from the hard exudates in a way that the hard exudates will show some back shadowing, but the hyperreflective foci won't show back shadowing. So that's how you differentiate between hyperreflective foci and hard exudates, and they are mostly less than 30 microns, absence of back shadowing, and reflectivity is similar to RNFL, as I have said. And it has been found that after resolution of the subsensory retinal detachment, there have been formation of hyperreflective foci in the subretinal spaces. And it is found that initially they are in the inner retinal layers, and subsequently they migrate towards the outer retinal layers, and many a times they go towards the choroid, where they are called as hyperreflective choroidal foci. And they do decrease after treatment with pharmacotherapy. And again, here also implants do much better role, especially in cases where hyperreflective foci are present. This is a classical example where a patient of 53 years of male came to us 8 years. He was diabetic since 8 years, and he was 6'6" at that time, but he had significant proliferative diabetic retinopathy, some amount of diffuse edema, and we did both eyes anti-VEGF followed by PRP and macular laser. So yeah, he didn't report to us for almost 3 years, and that's what we got at the end of 3 years post-treatment, that his vision dropped down to 6/60, and you can very well appreciate that there is presence of hard exudates at the fovea. There are multiple hyperreflective foci. There is presence of an ERM and a taut posterior hyaloid, and we had to subject the patient to vitrectomy. And you can see the contour has come up very well post vitrectomy, but the visual acuity improvement is not so good because the hard exudates present at the fovea, they have destroyed the photoreceptors. So it's a poor prognostic factor, especially if the hard exudate are present at the fovea. Coming to disorganization of retinal inner layers, so this is a very important entity which has been explained, especially in diabetic maculopathy, that drill lesion, and it has been seen that in the central 1 mm zone, if the drill lesion is more than 50%, then these patients don't have a good visual prognosis. And recent studies have correlated that the amount of maculopathy, the macular capillary non-perfusion, and severity of diabetic retinopathy do have a direct correlation with the drill lesions. So this is an example of a drill lesion. You can see that the inner layers of the retina are indistinguishable, and these patients do have less vision at presentation. Many times, whenever the macular edema resolves, eventually a drill lesion appears. So these patients, if the drill lesion is very close to the fovea, they have a significant impact on vision. Coming to another biomarker is a bridging retinal process, where it has been seen that these processes, they are constituted by the Mueller's and bipolar cells, and they do have a good prognosis. So this is an example of a 53-year-old female. She was diabetic since 10 years, and you can see these bridging retinal processes, these arrows, and we did anti-VEGF therapy followed by laser. So mainly in diabetes, you require all sorts of combination of treatments, and these patients did very well, and she improved to almost 6/6 with this kind of combination of treatment. So probably this bridging retinal process must have an impact on the final visual acuity, as has been described in the literature. Another important factor is the photoreceptor outer segment length, and it has been shown that it has a direct correlation.
Sorry to interrupt.
Yeah, please.
Can we just rush through, sir? Now we have just one more presentation remaining.
Yeah. So should I sum up?
Yes, sir, it would be nice if you can.
Yeah, sure. So the integrity of the ELM and EZ is an important factor, and again, torque posterior hyaloid, as we all know, that this is a case. These cases do respond very well to vitrectomy. Another very important choroidal biomarkers, so hyperreflective foci, choroidal thickness, and choroidal vascularity index, they do have an impact on the morphology of diabetes and the response. So thank you very much, all of you, for patient listening. Thank you, Piyush. Thank you, Swapnesh and Ragini madam, for having me over here.
Thank you, Dr. Sarang, for taking us to all these biomarkers. It's so important to know about them and just incorporate our understanding within our practice so that we can prognosticate to patients as well. So with this, we quickly move on. We won't have any time for questions. So we move on to the next topic, which is quite interesting. It's by Dr. Sneha Saurabha, and the title of the talk is Patched by the Side. I'm quite intrigued to know more about this. Madam, are you there?
Yes, sir. Can you hear? Is it audible?
I can hear you. If you can share your screen, please.
Are my slides visible?
Yes, ma'am. Please do go ahead.
Okay. Very good afternoon to everybody. I would like to thank Maharashtra Ophthalmic Society organizers and the scientific committee for giving me this opportunity. I'll be presenting 2 short cases of the same topic. The first case is a 77-year male presenting with right eye blurring of vision for 15 days, which was sudden in onset, painless, and non-progressive. He was a known hypertensive, diabetic, and he had a history of CVA 3 years back. His best corrected visual acuity was 6/12 in both eyes. Anterior segment showed senile immature cataract. On dilated fundus examination, the media was clear in the right eye. Disc and retinal vasculature were normal. There was a dull yellow deep lesion. There was a dull yellow deep lesion of about half this diameter.
Your slides are not visible. Not able to see the slides. Just enlarge it and move the slides.
Okay. Now, sir?
Now visible.
Okay. The media of the right eye was clear. There was a dull yellow deep lesion of about half this diameter with irregular margins superotemporal to the fovea, like a patch by the side of the normal fovea. Rest of the fundus was within normal limit. Autofluorescence showed no corresponding abnormality. The right eye media was clear and the left eye media was clear, and the fundus showed only ERM, no other abnormality. The OCT of the right eye along the macula, along the horizontal meridian was normal, but the sections along the lesion revealed a hyperreflective band in the middle layers of the retina, including the outer plexiform, inner nuclear, and the inner plexiform layer with normal fovea. OCT of the left eye was normal except ERM, epiretinal membrane. Case 2 is a 71-year male presenting with blurring of vision of right eye for 2 days. He was diagnosed to be hypertensive 1 month back. His best corrected visual acuity was 636 parts in the right eye and left eye was normal. Anterior segment was within normal limits. Right eye, the fundus showed hyperemic disc with dilated tortuous venules with multiple retinal hemorrhages in all the quadrants with dull FR. Left eye was normal. The right eye OCT revealed small SSRD, that is subfoveal serous retinal detachment, with hyperreflective material in the center with minimal intraretinal fluid. Patient's BP left eye OCT was normal. Patients from the history and the clinical picture, we diagnosed him to have ischemic CRVO, non-ischemic CRVO with macular edema. But his BP was 210 by 110. And further investigating, his serum homocysteine was raised. So we started him on treatment for the same, that is tablet homocheck and antihypertensives, collaborating with the physician. As the SSRD was very minimal and his BP was raised, we decided to observe him, controlling his systemic factors. After 3 weeks, his vision remained 636 in spite of the OCT showing resolution of the subretinal fluid. Here there shows irregular hyperreflective lesions in the middle layers of the retina. So this accounted for the low vision, which is actually termed as PAM. PAM is paracentral acute middle maculopathy. It is basically an OCT-based finding seen in the retina, manifesting as hyperreflective band in the middle layers of the retina, that is outer plexiform or inner nuclear layer, which is seen in SD-OCT or above OCTs. It was first reported in 2013 by Sara et al. Initially, it was considered as a variant of AMN, that is acute macular neuroretinopathy. But AMN is seen more commonly in younger and it has a more female preponderance. And the OCT shows involvement of outer retinal layers as well. In PAM, the basic pathology is the ischemia of the deep retinal plexus. So mostly they are seen in older age group and they present as acute scotoma. How to differentiate it from cotton wool spots? The PAM lesions are more deeper, they are more dull, they are less opaque, and they do not follow the retinal nerve fiber layers. PAM can be primary or secondary. The first case here, which I presented, was a primary where there were no other ocular abnormalities, and the second case was secondary to venous occlusion. Coming to the management, there is no active intervention that is required or available as well. We investigate for the ischemic event and treat for the same, collaborating with the physician. What is the prognosis? The lesion may self-resolve completely, but generally they cause focal retinal atrophy leading to permanent scotoma. Take-home message is not all hyperpigmented lesions are cotton wool spots. PAM does give answers to certain unexplained visual losses in cases of venous occlusions or certain surprises after cataract surgery. PAM has no active intervention. Advancement in technology helps in better diagnosis. That is, PAM was detected only after SD-OCT was developed. So embrace the new technology. These are my few references. Thank you very much. Thank you once again for the opportunity.
Thank you very much, madam, for the wonderful presentation. And we're just shy of a minute for the session to be over. So I'd like to thank all the speakers for finishing in time, and the chair and the co-chair as well. Now I request all of the viewers to stay put because we have an excellent session coming up. Madam, can you stop your screen sharing? Yeah, thank you. So we have an excellent session coming up with the most interesting cases that some prolific surgeons had in the past 1 year. And I request Dr. Sharad Bhumaj sir, if he's there.
Yeah, I'm there. Yeah.
Over to you, sir. Looking
Yeah.
forward to this.
Thank you.
Thank you. Thank you.
Yeah.
Piyush, can you hear me?
Yes, I can hear you, sir.
Hello, everyone. Good evening.
Thank you very much. In spite of difficulties, thank you for manning this session.
Thank you, sir.
Hello.
Yes, we can hear you, sir.
Yeah. So we start our instruction course on the interesting case which some of our surgeons have faced and managed in the last 1 year. So basically the idea is that, they share their practical difficulties and how they solve that practical difficulty. And in that process, what we learned and what the surgeon learned from them. So there is some change in the order. Dr. Pritam Samant has to attend another session. So first up, I asked Dr. Pritam Samant to share his presentation and screen and start. Dr. Pritam, are you there?
No,
Hello.
He doesn't seem to be there.
Okay.
Sir, Dr. Pritam could be there in the debate session because he is one of the judges over there. He'll join shortly. I'll let him.
Fine. So then till that time, we'll follow the order. And so I'll start sharing my screen and I'll be presenting my first case. So are you able to see my screen?
Yes.
Yes, we are able to. Yes.
Yeah. So this is a case where I saw her 4 months back, and she is a 16-year-old girl, and she complained of vision loss in the left eye. And on examination, we found that she had multiple angiomas in both eyes. So you can see in the right eye that there are 3 angiomas which are visible in this photograph, and multiple angiomas in the left eye along with a retinal detachment. So this is how we saw this patient, and the vision was 1 meter only in the left eye. So because of the bilateral angiomas, we just worked up the patient, and you can see that by fluorescent angiography, we are seeing clusters of angiomas in both eyes, and there was a retinal detachment in the left eye. So because it's a bilateral disease, we have to work up these patients. And first up, we did the laser for the right eye angiomas. And then we sent the patient for investigations. So we did an ultrasound of the abdomen and MR angiography and MRI. So what we could found was that the MRI of the brain along with the angiography was absolutely normal. So there were no angiomas or vascular malformations in the CNS. And on the ultrasound abdomen, there was a suprarenal mass. So this patient was referred to a nephrologist, and he worked up the patient with all the investigations, including the catecholamines in the urine, and they reached the diagnosis of pheochromocytoma. And this patient underwent excision of the tumor. So after the systemic workup, we now felt that she is kind of due for some treatment in the left eye, though she did not have a vision in that eye. So this is at this time we took up the patient for surgery because the angiomas were absolutely multiple. There was a detachment, there was PVR, inferior PVR, and the vision was PLPR. So we had no option but to operate this patient. So I'm presenting you a short video of the surgical steps which we did. So you can see this is the left eye of this patient, and you can see multiple angiomas. And initially we opened the conjunctiva, placed a band, we examined with indirect and hoped that we could get away with the external drainage and a buckling and cryo, but that was not possible because of the very posterior location of the angiomas as well as the lot of PVR anteriorly. So we next decided to go for the vitrectomy, and you can see there are multiple layers of the vitreous, and we could peel them one by one with multiple staining with the triamcinolone. And this is what you're seeing. And then after the vitrectomy, core vitrectomy, we proceeded to the peripheral vitrectomy. And then you can see the lot of fibrosis and pulling up of the retina anteriorly, especially in the area of the angioma. And we switched over to dissection, and we just separated all the fibrotic elements and the separations from the pars plana and ciliary body. So there was kind of anterior traction and the retina was pulled up. Next, we shifted to the bimanual technique, and then we tried to dissect the hyaloid. And after doing the whatever to the extent possible internal dissection, I decided to place a external support in the form of a 279 scleral buckle. And then I examined from inside with indentation and then tightened the buckle. Unfortunately, very high indentation effect was required. And in spite of that, there was a kind of, multiple radial retinal folds when we tightened the buckle. So I thought that this is not going to work for this patient. So what we decided is that, we have to excise these angiomatous lesions. And to do this, to prevent torrential hemorrhage, we need to ligate these feeder vessels. So the next thing what we did is, we dissected out the feeder vessels and isolated them, created a plane where we can pass the suture. So now how to pass the suture? So we took a 9-0 proline suture, which we use for scleral fixated IOL. We snipped it to the length required, and we just bent it a bit for us to introduce it in a better comfortable way, and then switched on to valveless trocar so that we could comfortably insert these needle inside. So now we have to use the serrated forceps, otherwise the simple flat forceps will not work. So we used the serrated forceps, and we threaded the proline suture through this opening and dissection which we had created. And with the 2-1-1 knot, we could tie these feeder vessels. And we repeated the same thing for the second feeder vessel also. Now, after doing this, we then cauterized the residual vessels and the inferior retina where the traction was there. And then after that, we did the excision with the bimanual technique. So you can see that there is no bleeding, and after that there were multiple angiomas. So under PFCL, after flattening the retina, we applied laser to all of these angiomas, and because the retinectomy margin was pretty posterior, we also did the prophylactic ILM peeling. So based on this, we could laser the retinectomy margins, and then examined the periphery, and at the end injected oil and tightened the band. And that's how the case went off. And post-operatively, the patient is doing fine, and we expect gradual recovery of the vision. And this is the post-operative picture with the laser marks and the attached retina. So this is the interesting case which I had managed, recently, and this is what I wanted to share with you people. So I just invite comments from the panelists and the discussants.
Excellent, sir. Did you cut the 9-0 needle also, or was it?
Yes, we have to cut the needle so that you have to make it short because the needle is very large. So we cut the needle and then curve it a bit, and then you pass it inside through a valveless trocar.
Beautiful.
Very nicely done, Dr. Sharan.
Yeah.
Did you use any buckle or anything like that to support inferior retina?
Actually, because I had already excised most of it, but the retinectomy margins were still below the horizontal meridian. So I have placed a band, 240 band, and I have tightened the band. So I have placed the external encircling element for this patient.
How long is follow-up till now?
It is only, 1 month follow-up.
Okay.
And the oil you've used is heavy, or the 1,500?
No, 5,000 oil.
5,000.
Densiron is not available, so 5,000 oil. Yeah. So we just wait for the outcome, and what happens in the long term is more important than what happens just 1 or 2 months, immediate post-op. So we'll be following up this patient, and hopefully some amount of vision the patient is going to recover. And the other eye is doing fine with laser. And even systemically, she is quite stable now because she has been managed by the other specialties, also worked up and managed. Yeah.
Excellent.
Is it possible to manage with the cautery only endodiathermy? Now we are having powerful endodiathermy, and we can stop the bleeding of any vessel in the on the retina.
I think you can.
Intraocular pressure also can be managed with the constellation and all.
Yeah, I think you can, but I thought that a lot of diathermy will be required, and still it bleeds a lot.
Yes.
So I just thought we should ligate the vessels, and I thought that it helped a lot because the field was absolutely bloodless. There was no blood loss during, no obscuration of the field during the surgery.
It requires a lot of expertise for doing this one.
Yeah, unless you try, you're not going to do it. Yeah.
Okay, thank you. Well managed. Very well.
Yeah, thank you.
Good thing to know and learn from you.
Yeah. Pritam, I think you can just start your case, and so that we can. Yeah.
Okay, so let me start sharing. Are you able to see?
Yes, we are able to see.
You're able to see the video?
Yes, we are able to see.
Yeah, okay. So I am just before, I just have the surgical video to play. So why this was, something case which I remember, because this was a recurrent RD referred to me. And it was not only was this patient one-eyed, but this patient was also a politician. So, the tempers were very high, and although I've managed done a lot of relaxing retinotomies, but I remember this particular case. So I'm going to share this video where managed to do a good relaxing retinotomy and a lot of subretinal gliotic removal, and I would like to share some pearls and principles of doing the same. So can you see the video playing?
Yes.
Yeah, so you can see it's an inferior RD actually. You can see the bulbous nature of the RD, inferior one. And the superior retina part of it is in fact attached. So, my plan was to do a 180 degrees or a 270 degree inferior RR and try and settle this RD. As you can see, I'm injecting PFCL. The PFCL is an extraordinary instrument which, it clearly shows all the PVR. As the PFCL stretches out the retina, you can see the PVR over the posterior pole. So I'm using my forceps to peel the PVR from the macula. You can see the end grasping forceps lifting the membranes from the macula. You can see over here, this is probably the previous surgeon's endodrainage site which he has used over here in the top left corner of the screen. Some more PVR that I'm dissecting, but it was pretty sure to me that it will not. There's a lot of subretinal gliosis also. It's a tough retina, and I knew it would not settle by just doing an FG. So I decided to do a RR. Now you can see over here, I'm doing endodiathermy over here. You can see in the far left-hand corner. This is a diathermy. One has to remember that one should not do diathermy under PFCL, like this diagrammatic representation, because the energy will run off to the choroid and RPE. So while doing diathermy, it is important that you keep the PF7 level away from the point of diathermy, and the retina is lifted up so that your diathermy does not run off onto the RP and the choroid. Also, when you're doing diathermy over the blood vessels, don't just cauterize the superficial retina, because some bleeders would still remain and they will bleed at the end, causing edge PVR. So when you're over the blood vessel, go through and through the retina, create a hole over there so that you completely cauterize the blood vessel like you're seeing in this diagram over here. So these are some of the pointers one has to remember. After doing a nice diathermy, then I proceed to do the retinotomy. I prefer to do it with a cutter, as you can see over here, although you can also use a straight scissors or a curved scissors to do the same. As you see, I've done a good diathermy, so there's no bleeding over here. And I'm doing the relaxing retinotomy and joining all the areas of the diathermy, as you can see over here. And then it is important to amputate the anterior stump of the retina, one must not leave back this anterior stump, because this particular anterior retina, it can sometimes cause a lot of ischemic changes. It can cause cyclitic membranes. So it is important to cut off this anterior part of the retina, which I'm doing right now. Then I go for the subretinal SRG removal. For that, I remove some of the PFCL and allow again the retina to fold back. You can see over here, I'm removing the PFCL from the posterior pole, allowing the retina to again fold back posteriorly. And there's a lot of subretinal glaucis extending across the globe. You can see the subretinal glaucis here. So I use my forceps to remove the subretinal glaucis from this side, from the nasal side, which comes off pretty easily. You can see over there. But the temporal is a little bit tough. It is not coming out. So what I do is I use the spaghetti technique, where you start rolling. You roll the forceps in such a way that the subretinal glaucis envelops around the forceps. You can see over here, I'm rolling the forceps. Sometimes this is a very difficult thing to do logistically with one hand while you're using the endo laser in the other. So you can also use a negative action forceps for this particular maneuver. And after having rolled it like a spaghetti, it then starts coming out. You can see how the entire subretinal glaucis envelops itself around the forceps, and then with a slight tug, it snaps off and it has come off. I'm still left with a lot of subretinal glaucis still under the macula over there. So what I do is with the help of my light pipe, I roll the retina and identify the subretinal glaucis. Now, it's very important not to touch the choroid here, because the choroidal touch at the macula can cause a bad subretinal bleed. So I remove this last portion of subretinal glaucis from under the macula. And one indication that all the subretinal glaucis is removed is when you look at the posterior part of the retina, it should look clean and absolutely clear. This tells you that the subretinal PVR is removed. And then with this, I proceed, then again inject the PFCL. And this time, of course, I'm injecting the PFCL so that it overrides all the margins of the relaxing retinotomy. You can see the retina is nicely flattened, and then I proceed to do the laser. Now, this one thing which I've observed in a lot of cases is these cauterized margins sometimes roll over. You see, I'm gradually unrolling it. But one trick or one procedure which I found useful is to make these small radial cuts at the margins, especially those rolled up margins of the cauterized retina. You can see I'm making small radial cuts away from the blood vessels, obviously, because otherwise these blood vessels will bleed. I'm making these cuts. These radial cuts help to settle the retina and do not allow the retina to roll over even post-operatively. Also, they allow a good, you can see over here again a diagrammatic representation. You want the retina to be flat opposed to the choroid. But what happens is the moment you cauterize these edges, it rolls up. It rolls up away from the choroid and contracts. So what helps is, with your curved scissors, if small radial snips in between the vessels, this is what helps to again flatten it back. As you can see over here, these radial cuts like petals, they fall back again on the choroid. So this is a useful maneuver which I found. And then you can see how the laser burns are taking up very nicely once that particular retina is flattened. Again, I proceed with lasering the margins of the retinotomy there. And then at the last procedure after the laser is complete is the PFCL oil exchange. You can see first, once I start the PFCL oil exchange, I inject the oil till it starts coming out of the two ports. Once the oil starts coming out of the two ports, then you switch on to the posterior segment visualization, and then you proceed with the PFCL oil exchange. You introduce your Charles flute needle, and the important thing is to keep the Charles flute needle beyond this meniscus, the oil PFCL meniscus. Make sure it is beyond this meniscus into the PFCL bubble, and you can see the flow of the oil coming from the cannula, and then gradually you go ahead with the PFCL oil exchange. Here you can see the oil coming in and the PFCL being removed, and this is the last bubble of the PFCL which is coming out. You can see the margins of the last part of the PFCL, and there it will come into my flute needle. So this is an interesting case which I thought I had done a few months ago. I don't have the post-operative pictures, but yes, this patient is doing well. I have removed the oil also. Patient has about 636, 624 vision, and it went well. Thank you.
Yeah, nice presentation.
So politician has blessed you.
Yes, I think both myself and the referral surgeon have heaved a sigh of relief. Thank you.
Yeah. Anybody has any comments or discussion points regarding this video? I think I will just ask Anand to present his case because it is related to the same issue. I mean, same thing. Anand, are you there? Anand Kumta?
Yeah, I'm there.
Just present so that it's related to this presentation. Yeah.
Yeah, I just had one comment on Preetham's excellent, brilliant surgery. In PVR cases for the epiretinal membranes and PVR, what I would do is I would double stain. I would do a fluoride exchange. I would do a double stain with trypan blue as well as brilliant blue. And that would help me to identify all the fixed folds. And I would also peel the ILM as much as possible, even trying to go beyond the arcades as much as is possible. That's the only comment, but the tips on the radial cuts were fantastic, and I'm very, very, very impressive video.
Thank you, Anand.
Shall I? Okay, I'll just start sharing my screen. Is my screen visible?
Yes.
Yeah. It's yeah.
Okay, so I have a few surgeries that I have done, video clips of some interface vitrectomy surgeries that I've done under silicone oil. And this term was introduced by Dr. Steve Charles, where it means that surgical processes are performed at the interface between vitreoretinal tissue and surface tension agents, such as silicone oil, intravitreal air, and PFCL. And we have all been doing interface vitrectomy under PFCL and sometimes also under air. But this will be a few cases under silicone oil. So basically it's a 2-port 25 gauge vitrectomy. So I'll start with a surgical video. This is a 44-year-old female, high myo, partially one-eyed, who had undergone a vitrectomy with silicone oil a month ago and had come with a recurrence. And this was the surgery. And since I was not very sure whether I was going to remove oil, I used one 23 gauge port. And this was the recurrent RD that you can see here. And here, that's the fixed fold that I'm teasing out and then peeling off. Then I made a drainage retinotomy, drained internally. And since there was hypotony, I topped up some silicone oil. Then I drained some more. You can see the tessellations coming up and the retina flattening. Then I did endolaser to the edges of the drainage retinotomy, topped up some more 5000 centistoke silicone oil, then finally removed it. This was the fundus photo 1 week post surgery, and this was after silicone oil removal. Case 2 was a one-eyed patient with aphakia who had undergone vitrectomy with silicone oil a month ago and had presented with diminished vision. So this was again 2 ports were 25 gauge ports were made. There were multiple fixed folds, so they were initially teased with a 25 gauge MVR knife, and they were peeled off with an ILM peeling forceps. That is the first fold. This is the second fold. There's an iatrogenic break here. There's a third fold here. This is the fourth fold. There was no anterior PVR in this case. Then I freshened the edges of this iatrogenic break and used it as a drainage retinotomy. And as I was draining internally, you can see that the retina is flattening. And I compensated the hypotony by topping up with silicone oil, 5000 centistokes. Some more drainage. Then endolaser to the edges of the retinotomy. And some anterior laser as well. So this patient also was attached, and this was the fundus pick after silicone oil removal. The third case is a recurrent RD with macular pucker. You can see this very thick macular pucker, which is typical of perisilicone oil proliferation. So I was trying to get an edge with using a slightly bent 25 gauge MVR knife. The pucker was peeled off. Whatever oil was lost was replaced. Then a drainage retinotomy was created here. You can see the retina settling, the tessellations coming up, topped up some more oil, and endolaser. So this is a case with recurrent RD with multiple subretinal bands. First, there's an epiretinal membrane here and a fixed fold. You can see this subretinal band here and here. There is a retinotomy was made for removal of the subretinal band. Topping up silicone oil. The last subretinal band was removed. This was the last case, recurrent inferior RD with a lot of anterior PVR. There was a fixed fold here which I removed. And I proceeded to do a inferior 180 degrees retinotomy using endodiathermy. And as mentioned by Preetham, I proceeded to remove all the anterior PVR and the residual tissue anterior to the retinotomy, because it's a very big, important cause of ciliary body dysfunction, cyclitic membranes, and sometimes even rubeosis if that part is not excised. Then topping up oil. And since there was some fluid remaining, I made another drainage retinotomy posteriorly. Then I drained, topping up of oil. And this is what I've been doing lately. I'm using a laser in the continuous mode rather than the repeat mode. I find that to be better than, it's more contiguous than single spots. Then some more laser. This was the picture of pre and post surgery. And this is just to reiterate whatever Preetham had also mentioned about removal of this anterior tissue. So advantages of this procedure is that it's very fast. It takes about 10, maximum 15 minutes. It's less invasive, less inflammation, less anesthesia risk, less PVR, decreased surgical trauma, realistic assessment of traction, good visualization. Unlike while using air, no IOL fogging occurs. Viscous dampening of retinal motion. The retina is less mobile under silicone oil, though not like the way it behaves under PFCL. It also prevents increase of subretinal fluid during traction removal. It limits the RD, because silicone oil removal can precipitate macular detachment. And oil is contained at the interface, the bleeding is contained at the interface of the oil, so it can be easily removed. And this is mentioned by Steve Charles, and I have also seen this, that many surgeons have performed fluid exchange or endophotocoagulation and air silicone oil exchange for a PVR case, only to find that the retina was partially detached the next day because of surface tension disparity. So I found this to be a very useful technique in re-surgeries, and the cost is also very less, time is very less. And basically you can use the single, you have 2-3 ml of silicone oil left from your previous surgery, and you can time it in such a way that you just need 1 or 2 cc of silicone oil for this case. So
very nice
thank you.
presentation, Anand. I want to ask you two questions. One is that, in how you manage the retinectomy, is there any problem with the oil causing problems for the cutter function? And
No,
the second question is that
yeah.
in which case you will not do, you will go the full thing, that you remove oil, you do the resurgery and then put in oil again. So these are the two questions I have for you.
I think if it's very, very severe PVR, probably it might be a better idea to do it. But my indications have been expanding as I'm doing more and more. Like I never thought I would be doing anti-retinectomy and all under silicone oil. So I think
diathermize and do it.
Yes, yes.
Yeah.
Sarath, can I add?
Yes, sir.
Definitely.
Yes, sir.
Yeah. You see, I had done 4-5 cases under silicone oil for membrane removal and other thing, macular pucker, where I don't want to remove silicone oil permanently. Recently, I was wondering and I gathered courage and I talked to Kumta and I operated a patient recently about 2 weeks back. And I think it's a very easy surgery. We have to remove the mental block. I personally feel I would reserve it for patients where I have done primary surgery. So I know what all things I have done, and there is a time limit, could be probably 2-3 weeks, 4 weeks, when you feel that there is a definite ERM age developing, and you can pick that up in recurrent detachment, because initially if you see post-op, if you take photographs, you will have a ERM developing, but after 3 weeks or 4 weeks, or after 5 weeks, you will see a definite age of ERM. And at that juncture, if you operate in with silicone oil, your surgical trauma is reduced a lot, And if there is not much recurrent PVR, then this should work well. So I personally feel that I would reserve it for cases where I operated first time. So I know what has been done.
Agreed totally.
And Dr. Paritosh, you have any inputs?
I think this would be possible only when you are using the high viscosity silicone oil with the 1000 or the 1200, 1500, 1600 ones. This may not be a very good idea. Personally, I still don't subscribe to it because I use 5000 only when I feel that it may not be possible to remove oil ever in such an eye. So in the eyes where I have injected the normal silicone oil, I prefer to put in an infusion line, and I work under the oil till the till the oil bubble is there, because that then starts floating over the BSS and it supports the peripheral retina. I keep working under it. So it's something like a sandwich technique. Till the final oil bubble comes out. Now, the reason why I feel this is better is because the very fact that a PVR has occurred, pro-inflammatory cytokines and other cytokines supporting PVR are already existing in the interface between the retina and the oil. So I like to just do a clean, clear-cut job, So, but excellent surgery, Anand, very nice. The other comment which I have is that at least in my hands, the continuous mode, I tend to over-treat certain areas and and maybe normal treat other areas. So the over-treated areas can be a nidus for future PVR. And the third comment about continuous laser is that you should give a break in between, because if you keep pressing the foot pedal for a long time, then your laser diode is likely to blow up faster and will increase your costs eventually.
Any other, Dr. Manoj, do you have any comments to make? Dr. Sasavde is there?
Not there.
Okay, fine. So we proceed with Dr. Paritosh Kamdar's presentation. Sir, please start.
Yeah, I'll just share the screen. No, again, it's saying, I'm sorry, it's saying it's failing.
I think just close and try again.
Yeah. Sharad, I'm sorry, just if you can continue
Yeah,
with the
Vatsal bhai
discussion.
can
I don't
start
know
his,
what is
yeah.
happening.
Dr. Vatsal, can you start your
Sure,
presentation?
Can Sai help me, please? Can Sai help me? Because last time I thought we were done with this last weekend.
Shall I, Sai is there, or shall I share my screen if Sai is helping me?
You go ahead, Vatsal bhai, you please go
Okay,
ahead.
okay,
But if
okay.
Sai could guide me.
Okay. Okay, is my screen seen?
Yes, yes, it's seen.
Okay, so I'm going to present two cases, where there is iatrogenic macular hole during or post surgery for vitreous surgery for some other reason, and what has happened to them. This was a learning curve for me. Now, the first patient had been operated for detachment by somebody somewhere else and had persistent epiretinal membrane or macular pucker, and there was cystoid macular edema due to it. So the primary surgeon had advised surgery, and I thought, let me try treating this with normal cystoid macular edema treatment, and she responded only to come back again with the stoppage of the treatment, like acetazolamide and Nipalect or something, and steroid drops. So I operated this patient, removed the ERM. I'll show you the video, and removed the ILM. Now, when I removed the ILM on table, I thought there was a small macular hole formation. Unfortunately, I do not have intraoperative OCT, otherwise that would have made it clear. And I used just SF6 after peeling the ILM, and the hole is closed well. So this is the first case which I'm going to show. Now, this is the pre-op OCT. This is the membrane here, and this is the membrane seen on OCT with cystic spaces. And this is post-op photograph, no membrane and no hole, only cystoid macular edema is there. Now, if you see the video, this is the membrane which was there. Okay. I'll just try to play video from outside. I'll show you the photograph. Okay. Now, this was the photograph of the retina, this is the intraoperative picture. And I definitely felt that there was a small macular hole, probably de-roofing of the cyst. But as you saw, this as closed, patient was given SF6, I injected SF6 in position, and this has closed. Now, second patient, I had done vitrectomy for detachment probably somewhere in 2019, and he had cataract operation done elsewhere probably 5-10 years earlier. And he had subluxation or dislocation of the IOL. So and following my surgery, he had epiretinal membrane, but his visual acuity was fairly good. So I didn't opt to operate again. So this time when I did IOL exchange, I removed the epiretinal membrane also, and I put scleral fixation IOL with Goretex suture. Post-operatively, he had little vitreous hemorrhage, which cleared within 4-5 days. And when I did OCT as a routine, to my surprise, there was macular hole with edema. Now, I was in two minds what to do to this patient, whether to put gas again or just treat conservatively. So probably I just treated conservatively. This is a pre-op photograph of OCT showing ERM and a lamellar macular hole. And this is post-op. Probably I think there's a full thickness macular hole. And I just continued treating with Dimox and routine CME treatment, and this has closed and has remained closed. So basically, I had these two cases to show we should take adequate care not to de-roof the cyst, But I think if it occurs, probably it may not be so harmful as we think it to be. Shall I try for video or it's okay, I think?
I think, the deroofing of a cyst will cause a lamellar hole most
But
of the
if you,
times.
yeah, if
What
you
what
saw
may
the,
look to you introp like a macular hole, possibly sometimes it's not a macular hole, it is actually a lamellar hole. And anyway, you need to have gas, and you have shown that it closes.
but if you see the OCT, I think what I showed you, the OCT, a lamellar hole will not have that edges lifted,
No, you have shown there can be a lamellar hole also. That's what I said.
Yeah. Because the edges of OCT, what I showed you,
yeah, it was lifted. Yes,
it was lifted, So I thought I'll just share this to patients,
Yes.
Has my screen been closed or it's still there?
It's closed.
Closed, na?
Yes.
Okay. Right.
Kamdar sir, is your issue solved? Are you ready? Okay. In the meanwhile, I think Dr. Anand, how you perform retinectomy under oil? Can you share some? What are the settings you use and what exactly you do?
I do it with. You mean the vitrectomy settings or the diathermy?
Yeah, vitrectomy. How much cutter? Cut rate.
Actually, I nowadays I have shifted entirely to the 10K cutter, and so around 7,000 cuts, and about 300 vacuum. And there is a tendency for the cutter to get blocked, so I keep a separate cutter if I'm planning to do this vitrectomy under silicone oil, and I assume that cutter is not going to work again.
Okay.
I keep it.
So under oil, after doing retinectomy, are we able to achieve good retinochoroidal apposition to do good laser?
Very good. So sometimes I need to make another drainage retinotomy, which I do frequently, more posteriorly. But a lot of subretinal fluid gets drained even from there. The only thing I do, the extrusion needle sometimes tends to get blocked. So what I do is I prime it with BSS first before putting it through the oil bubble.
Would be active extrusion.
Active, always active extrusion. I never use a fluid.
It would be passive, it would be active extrusion.
Yes, sir.
But I think your own cases, Sarat, this is a good technique to do.
I have tried, but I have not been uniformly successful. And then, then I just remove the oil and do the stuff, and then.
No, I think, see, basically what Paritosh was saying, if you have 1,000 or 1,200 centistroke oil, and if it has emulsified, then it would be difficult. But myself and Ananda using 5,000. So I think that emulsification part would not be an issue, or visualization won't be issue,
Okay.
And as Paritosh said, suppose you are removing oil totally also, you are removing chemokines what are there, but again, that is again a hypothetical situation. You are not seeing cytokines or other things what is there,
When you do a drainage at that time, all the fluid that is under the silicone oil bubble also would come out. So that would probably theoretically have all the inflammatory and other factors that,
Yeah. And just I wanted to ask,
there's
how
always a
good is
layer
the apposition at the retinectomy margins to do the laser?
It's very good. It's very good. And then sometimes I do a little post-op laser as well.
Okay.
See, what is that interface tension? What I definitely remember one patient. I had done vitrectomy for combined detachment, and retina was beautifully settled. At redetachment, I removed oil, and under air, the retina was beautifully settled, and there was no way the retina was contracted. And I saw the patient within 6 hours, and she had shallow detachment.
Correct.
So probably under pressure of air, even if there's some traction remaining, your retina may
That's
appear
exactly what
settled on
Steve
table.
Charles has mentioned. Even I've had the same experience.
Correct. Paritosh, are you ready?
Not yet. I think they got an error. So just sending it again.
Paritosh is also a uveitis champion. Problem with Paritosh is that he has brain, so he finds many challenging cases. Correct, Pari?
So in the meantime, sir, Vatsal sir, your case where the macular hole was seen post-operatively, why did you not do a fluid air exchange in the post-operative period? Because that works very well, almost always closes the macular hole.
I have done.
And sometimes if it's a little larger, you can just drain through the center of the hole.
No, means I have done even OPD fluid gas exchange.
Yes, sir. Yes, sir.
And that has worked. But this patient, somehow I thought, let me just treat conservatively and see after a week. And after a week, it was normal,
Okay.
So there was no great logic, but I thought, let me wait for a week and then do it because he was operated just 4-5 days back. And sometimes I feel that Mother Nature is better doctor than all of us.
I'm not able to, I will try to send it by V-transfer. I don't know what is happening. I'm going to log out and log in again from this.
Yeah. No problem, Paritosh.
Or let me see if I can share the screen. Let me try once.
Yeah.
Yes, very good.
Yes.
You are there, Paritosh.
Great.
You are very much there. Simple way.
Play. Yes, good.
Great.
Sai, I am able to present it. Thank you. Sai and...
Okay, doctor.
Okay. So this was a senior pathologist. He was referred by his cataract operating surgeon for retinal detachment with complaints of sudden diminution of vision of 10 days duration. He had a past history of both eyes, iritis and 211 and 13, but no recurrences thereafter. Those days he was just treated with topical steroids and also low dose oral steroids. He had developed posterior subcapsular cataract in the left eye more than the right eye. So left eye underwent cataract and IOL surgery in June 2018. The papers showed that there was apparently a diagnosis of macular edema post-cataract surgery, which cleared with topical steroids. We don't have too many details or imaging available of those days. But the patient complained of intermittent blurring of letters temporally since about 3 months post-cataract surgery. But sudden decrease in vision since the last 10 days. He had dyslipidemia, bronchial asthma, and the presenting vision was 6/24 N18. Applanation was 14 in both eyes. There were non-fixed folds inferiorly. There was shifting fluid. There was, in this two-dimensional photo, it's not very obvious, but there was shallow fluid which was involving the macula also. I couldn't find any retinal break. There was choroidal detachment. Other eye had meridionals and broad WWOP. And the disc in the other eye looked little suspicious for glaucoma, for which perimetry was done later and it was normal. Now, I just want to know from amongst the panelists that who would have done vitrectomy and who of us would have attempted a scleral buckle. Incidentally, the title printed for my talk in the brochure is wrong. Huh?
It is. Okay.
It's more of an RD mystery than a uveitis mystery.
What appearance of retina you see temporal to macula? Is it because of the photograph or?
Sorry, come again.
The appearance of retina temporal to the macula, that subretinal appearance, is it due to photograph or?
Yeah, it's basically a montage. So that's why that
due
part
to photograph,
is. Yes.
Yeah.
But there is fluid in this portion. These are the folds inferiorly. So
and there is no break in the periphery superiorly. Near
I
aura.
could not find it. I could not find any break.
But there are some RP alterations temporal to the macula.
That's
Some,
what I asked him. Maybe
depigmented
buccal-
area. Yeah.
Yes.
Maybe buccal could be working, but only as you said, there's no flaw. There is fluid shift also.
Yes.
That is what you mentioned. So that I think needs to be probably angiography, maybe a good idea. I think you've already done the B scan, right?
Yes. Anybody else has any thoughts about it? Okay. So anyways, B scan was done where Deepak thought that, okay, choroidal effusion was there, but it was more characteristic of an exudative detachment than rhegmatogenous. Notwithstanding, I said, let's also take a second opinion because the patient was extremely becoming very restless and felt that if fixed folds develop, PVR develop, his vision might get rammed forever. So again, the other gentleman also, he could not find any break. He asked for a repeat ultrasound. And the repeat ultrasound showed no particular change as compared to before. So any thoughts from the panelists so far? Any additional thoughts?
Maybe trial of steroids, just a wild guess.
So this was the situation in our case that, this is a classic chart from Benson's textbook that we all read during our fellowship. So our patient, he had sudden onset of decrease in vision and a pseudophakic, more in favor of a rhegmatogenous RD, but no breaks were found. Now, there are pseudophakic RDs where they might be so tiny that one can miss breaks. There was a study which was carried out where some of the best retinal specialists also, they missed about 5% of the breaks. So there was central as well as peripheral involvement here. It was convex, but there were folds inferiorly, which is something which is going against an exudative RD. There were no pigmented cells, which is against a rhegmatogenous RD, and there was shifting fluid. And pressure was normal, which is another factor which goes against a rhegmatogenous RD. But a chronic rhegmatogenous could go either ways. Even increase in pressure could occur, but not a recent one. So basically what clinched or what made me hold on and not go ahead with surgery was this finding on the FAF. You see all these hyperfluorescent dots all around. And there is hyperfluorescence in the outer retina as well as at the level of the RP. And there are these folds, chorioretinal, more of choroidal and RPE folds, what's like a seasick pattern, as they call it. So that made me suspect lymphoma. Anyways, we went ahead with a fluorescein angiography. Vatsalbhai very rightly said so. So there were these hyper and hypo fluorescent dots, some of the window defects and then late staining occurring, but some hypofluorescent dots continued to remain hypo, but there was no gross leakage seen. ICG angiography showed foci or patches of dilated choroidal vessels, but again no gross leakage. There was late staining over the central over the macular region, and this was a situation. He was already on atropine and topical steroids. We consulted with his oncopathology colleagues and an oncologist also, whether about the possibility of lymphoma. And I did a PCR for MYD88, that was negative. MRI brain and spinal cord were within normal limits, and PET was negative. There was exudation in the under the ciliary body also, but progressively the exudative RD was going down. We started oral steroids at 1 milligram per kilogram per day, and he had a complaint of the superior field being defective because in keeping with inferior fluid, which was still there, but the subretinal fluid started decreasing, balloons started decreasing, the fold started decreasing. On OCT, the hyperreflective foci started decreasing, the folds started decreasing, and eventually there was no subfoveal SRF. So this is the change which occurred from the beginning, that is in December, and eventually all the SRF had cleared off. So this is the picture eventually. Some of these hyper FAF spots had decreased, and some of them had gotten converted into hypo FAF spots. The disease continued to remain unilateral. In October, there was no detachment any longer. This October, and this is the final picture as compared to what it was before. So the dilemma still remains that what are we dealing with? Now, there is also an entity called benign lymphoid hyperplasia of the uvea. A definitive diagnosis of that could be made only if we were to do chorioretinal biopsy, which was suggested to him initially. Before I sent the aqueous for MYD88, I even suggested to him that let's do a vitreous biopsy, but he was just not willing for any invasive procedures. So the chorioretinal biopsy also has not been done. But anyways, he's resolved. Vision has come back to 6.6 and 6. He's able to do his binocular microscopy now. The steroids have been tapered. We are down to I think 2 milligrams on alternate days now. Already I did a very slow tapering of the oral steroids, and there's been no recurrence of the exudative detachment. The factors in favor of a non-malignant situation here are that okay, it has responded, not recurred with tapering of the steroids. The factors against are that the response to the steroids was also little slow. With a purely benign one, the response is very fast, but here the response went to across over, for the SRF to clear, it took it took a few months. So that's the point against. The other thing is that point for a benign lesion is that it is unilateral, and that we found nothing on the PET scan nor on the MRI. But the points prompting me to keep a close watch for him over him is that it was quite a very widespread lesions, and some hypopigmented lesions still persist, some which correspond to some hyperreflective areas on the OCT and hyper FAF spots on the FAF. So we'll just keep a watch, but so far so good, and that's where we stand. So I mean, I'm open to comments and suggestions and ideas from all of you, gentlemen.
It's great case, I think, but maybe a year or two later, repeat MRI may help, pick up.
Yes,
lymphoma.
Yearly MRI is what they recommend for about 5 years.
Correct.
CSF analysis.
Sorry?
CSF analysis is indicated.
He refused any interventional
invasive.
thing, though you are right. I mean, CSF analysis should be done, but that is especially if we found something on the MRI. In the absence of any MRI lesions, again, patients may or may not agree to this thing. And he certainly didn't agree to anything invasive. The most invasive thing that he agreed to was allowing me to do that aqueous tap and send it for PCR. That's all. Now that MYD88 PCR also, I mean, a negative thing does not conclusively rule out a malignant lymphoma, whereas a positive one confirms it. So that's the diciness of it. But clinically, he's responded. That's a good side of everything.
But it was a question, when did you do OCT? Initially only or little later?
Yes. I didn't show you people
but you had done it the first visit only.
Yes.
Okay. Yes.
The choroidal elevation was seen in the first visit?
Yes, it was seen. Yes.
Yeah. So that must be the thing which will alter along with the fundus fluorescence, autofluorescence.
Yes.
It is the contour of the RP on the OCT which will help you to. What are the indications for immunosuppression in such cases? If it's not responding to steroid, did we give intravenous steroid also or only oral steroid?
No, only oral steroids. Though I had suggested to him to start methotrexate, because if it was primary intraocular lymphoma, one would have given him intraocular methotrexate. Apart from, I mean, since vitreous was not too involved, perhaps vitrectomy may not have been indicated for other than for a biopsy, but one would have given him intravitreal methotrexate. So I suggested that since you don't want any invasive thing, shall we start oral methotrexate? But I discussed with the oncologist as well as the physician looking after him, as well as the oncopathologist. So all three of them said that no, if he's responding to steroid, don't play around with methotrexate.
Excellent case, Paritosh.
Thank you.
Very nice.
Thank you.
Any other comments from the panelists? Otherwise, I think I thank everybody for their excellent cases.
Also not there.
Yeah, so we can hand over the mic to Dr. Swapnesh and the
Thank you, sir.
organizers. Yeah. Thank you,
sir.
Swapnesh.
Thank you for a very, very interesting session. Can you hear me?
Yes, I can hear you.
Yeah, thank you. Paritosh,
Thank
sir,
you.
peripheral blood smear, did you try?
Sorry, peripheral?
Blood smear.
Yes, it was normal. Yes.
Okay. Great. So anyways, a wonderful case. And for the dearth of time, we will move on to the next session. Thank you once again, Sharad Kumar.
Thank you.
And thank you all.
Thank you very much, Sharad. Thank you, Sharad. Thank you,
Thanks,
MOS,
Sharad.
for giving me
Yeah,
this.
thanks.
Thank you very much.
Bye. Thanks, everybody. Bye.
Thank you.
I
Bye.
pass on the baton to Saumil if he is around. Dr. Saumil?
Saumil will come a little late. I'm
Sure.
here.
Yeah.
And we'll start the next session.
Thank you, madam. Thank you so
Can
much.
we unshare the slides of the last one?
Dr. Paritosh, can you answer? Yeah.
Okay, so welcome everyone to this session of enigmatic, retina cases, and it's a pleasure to be here in the meeting. I have my first presentation, but before that, I want to introduce my other panelists here, the co-chairperson, Dr. Santosh Agarwal, and convener, Dr. Himanshu Deshmukh, and Saumil will be a little late, he said, but he should be joining.
Madam, just wanted to let you know, Dr. Alok Sen is having a family medical emergency, so he has excused himself. And there is one addition, if you have got the older version, one Dr. Mishra is, if he joins, he's going to present a case on CME. So I'll share it on your personal WhatsApp.
Okay, I will have Santosh to announce the speakers and Santosh, go ahead.
Yeah. Good evening, everybody. Just Chairman Dr. Subhadra Jalali, Madam, I welcome you, and my co-panelist, convener Himanshu Deshmukh, and Dr. Somil Seth. He is not there. So first talk will be by Dr. Subhadra Jalali, Madam. Everybody knows Madam very well. She is a ROP expert working at LV Prasad Eye Institute, Hyderabad, and she is mentor, guidance. We get guidance every time for ROP cases. We refer her the surgical cases of ROP, and she does the work very well. Thank you, ma'am. And over to you, ma'am, for your talk. Thank you.
Okay, thank you. So today I'm going to, speak on the babies again, neonatal FEBR, and most of these babies I have treated on the day of birth. So that is the highlight of this talk, how to do that. So we all know that FEBR is bilateral, and we see all these different difficult cases with detachment, traction, exudation, thysis, neovascular glaucoma. But if you consider that the disease is congenital, it always starts in utero on 26, 27, 28 weeks of birth. Once the vasculogenesis is over, the angiogenesis is defective. So, why are we seeing all these advanced cases? Can we do something better? And that is what I'm trying to say. So this is the story of a 3-year-old. You can see at 3 years of age, his one eye is already thysical, and he's been going around the country with his left eye, this one, and nobody's doing anything. They're just watching. And a simple lens sparing vitrectomy, where we cut that stalk, which is going from the disc up, which is the persistent fetal vasculature stalk, and extensive laser, and this child is cured for life. Notice that child also has little hypoplastic disc. So disc anomalies have been reported. But what I want to highlight is that treatment is vitrectomy. Whenever there is traction, whenever there is exudation, do vitrectomy, they do really well. But 3 years was not good enough. We had to see him earlier because we've already lost one eye. Now here we have two sisters. The top one is one sister, elder one, and after 3 years, the other sister is born, and you can see these phenotypes. So one wonders why the family was not informed in the first state itself that your next child is going to have a problem and needs to be seen. The first sister was seen at 7, the second sister is seen at 2 years. And here we have a newborn baby, 6 weeks old, had leukocoria at birth, referred as retinoblastoma. And what we see is at 6 weeks that one eye already has, a detachment, what we see in Norris disease, dysplastic retina, no tissue seen. The left eye already, the arcades are closed. There's a traction and there's an extensive avascular retina. So this is stage 4B or 3B. And there's no exudation in that eye. So 6 weeks is not good. By 6 weeks, already lost one eye, and the other eye also, a lot of it has lost. So can we go lower? So here we have a term baby who's born, and on the day of birth, I was called to see this baby, born with neovascular glaucoma. You can see enlarged globe, traction, and the other eye already had vitreous hemorrhage. Fortunately, the next day, 2 days of birth, we operated and we could salvage the other eye. But this shows that if we wait for term baby, we may get a situation like this, and we cannot help the child at all. So now 6 weeks is not good, 3 years is not good, 1 day is not good. We have to go down. So here we have a patient, you can see, who presented to us again at 2 weeks of birth, has extensive retinoschisis, hard exudates, and this is before laser. And this patient, we just did only laser. And only laser, you can see all those angry looking vessels have gone. We did laser only to the avascular retina, nothing to these areas, and it has scarred, and patient is sort of quite stable now. So this is the other eye of the same patient. You can see before laser, and this is 1 month after laser. All the hard exudates which were streaming into the fovea, into the arcades, they've all gone away, and the schisis is now flat. So yes, if we do laser very early, then we can just stop all that exudation and folds and all that we see in these patients. So here is a mother who was 16 when she first came to me. She was already one-eyed, and from 16 years till 25 years of age, I have treated her with everything that I had: anti-VEGF, cryo, prophylactic buccal, laser, again cryo. Nothing worked. She went into no PL. I think I should have done vitrectomy for her, but I had warned her that your child is going to get the same problem. And you can see here one son, he comes to us at 1 month of birth, already has new vessels, but there's no plus. So this is a milder phenotype. We could treat it. The other child also avascular retina, although there were no new vessels in the second child, but we treated because we knew the story of the mother and we didn't want to have, vitropathy and traction and fold. So what I want to highlight is that in the earlier you see, it is possible to see these children before exudation occurs, before the folds occur, and then just laser will take care of the situation. So what I started doing almost 10 years back was, we have a protocol now that every baby who comes to us, or any blind or any patient who has FEVR and is going to have a child, we tell them that this is the protocol you have to follow. We have to identify that this is FEVR. We counsel the family that there is a blindness to the next child, and they must inform us as soon as they get pregnant, usually by 2 months of the pregnancy. The reason for this is that we want to get a very accurate last menses date. We want to get the dates absolutely correct because, in our country, many women in 4-5 months, they will forget the last menstrual date. Even at 2 months, sometimes they forget. So we want to get the date correct. And then we deliver exactly between 35 to 36 weeks under proper antenatal monitoring of an experienced obstetrician. We tell them to make the, mother gain good weight. All the antenatal monitoring is done. I do the fetal scan for eye development at 18 weeks. With the TIFA scan, we can image the eye, and then again at 30 weeks. The reason for this is that I don't want to deliver a child with an ophthalmia or microphthalmia. So, I want to rule out that there's no other congenital anomaly. Of course, we want to have a normal scan at the time that we are delivering. And always we want to examine the baby on the day of birth or next day. We don't want to wait longer. And, if they're not in my town, I send the same letter to their local retina specialist. I'm thankful to all the retina specialists who have been seeing these babies and then referring them, immediately after birth. So I'm showing you the results of 12 families in last 10 years, and 8 of them followed this protocol and 4 did not. And these 8 compliant newborns, 5 had bilateral FEVR, which needed immediate treatment. And all of them we did laser, but all of them progressed to traction in the next 4 weeks, and then we had to lens sparing vitrectomy. So this is one boy, he came to us at 10 years, already one-eyed. I treated his other eye, which is this one. And when I was treating this eye, he had a 2-month-old sibling in the mother's lap. I examined the retina. This is what we found at 2 months: vitreous hemorrhage, traction. We did laser, and very soon we did lens sparing vitrectomy. You can see the hard exudates came up later, but he was okay. And then when the 3rd child was born in this family, I examined on 1 day of birth. This is on the day of birth. Already retinal hemorrhages, early vitreous hemorrhage. We could do the laser, 3 sittings of laser, developed hard exudates at 3 months, did the laser, and now he's fine. No traction, no vitrectomy. Here's another child. This child, one-eyed, has a macular coloboma, has extensive hard exudates, so much of fibrous proliferation. I don't know when he's going to detach, but his brother saw it 1 day of age. Now he's 8 years old, again treated with laser, no traction, no fibrous proliferation. Here is the child. This is the latest one, which I have just treated on 15th of August. The older brother cannot even open his eyes. He's so miserable, blind. His cousin is also blind. This is an FEVR, a large joint family. Day 1 of birth, child was delivered on 15th August. I saw on 16th, total vitreous hemorrhage, very little area seen, 2 sittings of laser. By 20 days, you can see the retina has not grown beyond zone 1. There's also hard exudates, and there's a persistent fetal vasculature causing traction. We added more laser and then did vitrectomy, and now the baby is absolutely okay. So 1 baby developed secondary glaucoma, and that we had to treat. Now, out of those 4 babies who did not come to us on time, 3 of them presented with leukocoria and permanent blindness. So we have a high chance of detecting these babies. 60% of the babies that we saw had very severe disease, and we could salvage all of them, those who came to us on time. So I want to conclude by saying that to reduce the blindness due to FEVR, we need to screen within 1 day of birth. We need to deliver them at 36 to 37 weeks, and we need to follow them very closely. We should do the laser immediately, and if they have any traction, go ahead and do the vitrectomy, and then their eyes will be salvaged. Mostly their visual acuity now, after many years that I'm following them, they usually have 20/80 to 20/100 vision because their fovea is not very well developed. Thank you.
Thank you, ma'am, for your excellent talk. Ma'am, I have 2-3 questions. One is what is the incidence of FEVR in the newborn?
So
What
we
is the
don't
incidence in India?
So we don't know what is the incidence, but I can tell you out of 20,000 babies that we have screened for ROP in our centers, various babies, in the preterm babies, we found 7 to 8 babies where we could diagnose that this is FEVR, what is now called as Roper, that this is FEVR and not ROP. Because the retina was in zone 2, it remained in zone 2, and the new vessels developed in zone 2, and over 4, 6, 8 weeks, the retinal vessels did not grow. So we know that the tempo, even in a preterm baby, the tempo of disease will tell. So of course the incidence is low, but we have to be careful because of the numbers that we see and because of the consanguinity we have. So always whenever we are in doubt, dilate the parents, dilate the siblings. In 20 to 30% we found positive. Just look at the parent, one of them may be one-eyed and you know that this is FEVR.
Yes, yes. Ma'am, second is how to differentiate in early months from the ROP. How you will differentiate in early months?
So ROP usually will not have the same tempo. ROP, what you will see, if it is a zone 1 disease, till the ROP starts, the vessels are normal till that edge. Okay, and it will start at 3 or 4 weeks of birth. One. Secondly, the tempo of the disease, the way it progresses is different in these eyes. You may have no plus in these eyes, or you may have very fulminant plus. Both things are possible. And as I said that, the weight will be better. They may not have had oxygen. And whenever in doubt, if you just watch, you will know that the retina is not getting vascularized. In ROP, always the retinal vessels will grow into the avascular retina. But in FEVR, there's an arrest of vascularization. It will never ever grow. And as I said, examine the parents. See, the protocol that I have put forward does not require us to do genetic testing. Of course, if we had genetic testing, then things would have been little easier, though not always good, because even with genetic testing, only 30-40% we will get positivity, others will still be negative. It will require us to do amniocentesis, which has its own risks. So that is why the protocol that I have put forth can be followed by any of us. It is very easy to follow, and it doesn't require you to do genotyping, gene testing, and amniocentesis and things like that. So just watch the parent, tell them to deliver 3 to 4 weeks in advance. By that time, usually the children are 2 to 2.5 kg, and they are relatively safe to deliver at 35-36 weeks. So the ROP risk and hyaline membrane disease risk is lower, though not zero. And then we can just go and examine them in the NICU itself within 24 hours of birth. And you will see the finding. The FEVR does not occur in zone 3. So that is very good. It will be either in zone 1 or 2. So it's not that difficult for anybody to see.
And what is the chances of recurrence, madam, after treatment, in spite of good treatment?
So if we have treated at this neonatal age with laser, and if any traction, we've done the vitrectomy, I have not seen any recurrence. But if they come little later, then they can have repeated recurrences. And again, those recurrences we can set off if we do early vitrectomy, rather than, pushing in there. I don't like to give anti-VEGF to these children because already their VEGF is abnormal. There's an automatic arrest of the vascular angiogenesis. Now, if I give anti-VEGF, I'm just adding to the disease burden. So unless there's really fulminant or it's very vascular, where I have to do the dissection, then I might give just 1 day before surgery. Otherwise, no anti-VEGF for FEVR patients.
Okay, ma'am. Thank you very much. Anybody else have some question? Any question?
So somebody has written a question, can we have unilateral? Yes, sometimes I have seen unilateral, maybe only one case. There also, I would like to do FFA, examine the parents and see that, is there some abnormality in the other eye which is not clinically visible? And sometimes those abnormal loops are visible in the other eye. It can be an asymmetric disease. But I have seen only one patient where I still think it's FEVR, but the other eye is not showing either FFA or clinical change. So I would think if it's unilateral, I would think more in terms of Coats disease or more in terms of persistent fetal vasculature. The other differential diagnosis we have to see, there are many other diseases that can be there. So examine the baby. They can have systemic features of microcephaly, and that is a different disease, DOX6 mutation, or they can have stubby fingers or mental retardation or hearing loss, incontinentia pigmentosa, dyskeratosis congenita, where there will be history of frequent blood transfusions. So other systemic things also we should look for along with the pediatrician.
Okay, thank you very much, ma'am, for your excellent explanation. We will move on to second talk by Dr. Prashant Bavankule on 3D vitrectomy for stage 4 ROP. So Dr. Prashant needs no introduction. He is a renowned vitreoretinal surgeon from Nagpur.
Santosh, everyone knows me now, at least in Maharashtra. And it's so humbling to be talking in front of Dr. Subhadra Jalali. After such an inspiring talk, you have kept my talk. I feel a bit dwarfed, Thank you, madam, for an inspiring talk. And this is just a tribute after having discussed with you on my way back from Bhubaneswar to, we were in Orissa for one of the Orissa state ophthalmic meeting. I had a long discussion when we traveled back, and that inspired me into vitreous surgery for ROP, which I was always trying to hide away from. So this is our short series, which I will present. And this we now do it on a 3D system, 3D digitally assisted system. So, well, friends, everyone knows what is stage 4 ROP, where you have a partial retinal detachment. These are the treatment options, but once the traction increases, it becomes generalized, then the lens sparing vitrectomy is only option. Well, when do you do a scleral buckling in stage 4 is when the traction forces are less than 4 to 5 clock hours, when you have done laser. And there you have a success rate of 60 to 75%, but it is an indirect traction relief. And importantly, you need to ligate the exoplant after 3 to 6 months. And in spite of ligating, you can land up with a myopia of -9, around -9. And that's why lens sparing vitrectomy, which madam and other group has propagated with a success rate in stage 4 as high as more than 60% with a good visual outcome, is a procedure of choice. Well, anti-VEGFs definitely reduces the vascularity, gives you an advantage. Well, the dose has to be the half dose. This study shows that it should be given earlier than 7 days to avoid crunch phenomenon, but most of the times we inject a day or two ahead of the vitreous surgery. Otherwise, it leads to more increased traction. Whether vitrectomy is easier in a naive versus post laser, yes, of course, these various studies have shown that laser or beta anti-VEGF increases the anatomical as well as the functional success rate of a vitreous surgery in stage 4. Try to spare the lens, but in exceptional circumstances when you have significant anterior traction, peripheral traction more than 6 hours, or the retina is sticking, that is retrolental membrane, that is the only stage when you need to sacrifice the lens. Well, we started with microscope. Now we have been using since last 3 years digitally assisted surgery, and we are convinced with the use of it because it provides a magnification along with depth and field of view, which is unparalleled and uncomparable to microscope. So some of the cases where I would show this is a magnification at which we can operate a ROP case, which was not imaginable in a routine microscope. Well, usually field of view and depth goes inversely with the magnification. But look at this particular video, which shows the field of view. In such complicated cases where you have multiple membranes having multiple attachments at different places, such an enlarged field of view gives you a definite, better understanding of the pathoanatomy of the disease and thereby leading you to a more definitive surgical results. Now look at this depth. At this phenomenal magnification, you will see this is a membrane and this anterior loop. Can you imagine the depth which you are seeing? The retina appears to be deeper, and this is the loop which we are dissecting. So confident we are at my level of such minimal experience with ROP. It really boosts your confidence to do. Well, bleed is the only time when the digitally assisted system becomes sometimes occurs. Well, if you use a filters like this, it dwarfs down or it tones down the red color and facilitates the surgery with the help of it. And all this you have to do at 1/10 of a illumination, and 1/10 of the illumination in prolonged surgeries like ROP definitely means less chances of phototoxicity. So coming to the aim of surgery, these are the various ridges, traction points, that is reach to ora, reach to lens, reach to ridge, and optic nerve to this. These are the points which have to be ligated. Unlike other conventional vitrectomy where you do core vitrectomy, PVD, that is not needed. You just need to ligate or cut this traction points, and that is the end of the surgery. Now this is a video under 3D system where you can see at a high magnification where I'm cutting reach to ora. Here I'm just peeling the membrane, and then with the help of a vitreous cutter, you can just trim off the reach to ora connection. Well, reach to lens, you can see at such a high magnification, again, this particular loop was almost behind the lens. Now we have trimmed it with the help of a vitreous cutter, and then I'm cutting the anterior loop. And this is ridge to ridge, where in between the ridge, there are membranes which need to be dissected either by bimanual technique or with a vitreous cutter. Initially, we attempt only with the help of a vitreous cutter, and then it can be done. And this is disc to ridge, where I'm peeling off the membranes. There are multiple levels of membrane which need to be peeled to relieve these traction folds which exist with this type of a fold which exists. Well, this is another video which shows at a high magnification the membrane peeling being done. This is just a relatively easy case where you have a residual fold and this traction which needs to be cut, and then you peel off the membrane over the ridge, and that's the end of the surgery. This is a case of a retrolental membrane where you have to sacrifice the lens to have an access to the membrane which was just behind the lens. And after doing a lensectomy, you can visualize the membrane, which then was dissected with the help of a vitreous cutter, and by bimanual technique, we did the surgery. Then we moved behind. This is just behind the lens. And at the end, under microscope, I'm depressing and going to the periphery and dissecting as much as membrane possible in the post periphery. And look at the magnification at which I'm operating. It's unimaginable with a microscope. So this is another case where you have an anterior loop with a traction disc drag, where you are dissecting the membranes on the disc, and this is how I'm relieving the traction membranes from the residual fold over there, and then doing the peel. This PGI group has proposed that nasal bridge of the kits are smaller, and so you can sit on the nasal side, especially for very advanced traction and temporal peripheral. Well, we attempt, and we do find it quite comfortable even with the 3D visualizing system to sit on the nasal side and take care of a 180-degree away traction. So this is another one of the complete videos which will show you various steps of a vitrectomy which is being done in a stage 4. First we do vitrectomy, then cut the ridge to ridge connections. The vascularity was there in spite of the laser. It bleeds. You might use minimal cautery to get a thing. This is small. I'm doing segmentation of the membranes slowly one by one and cutting off all the attachments anteriorly to the ridge, to the disc. And you can see near completion, you have relieved most of the traction, and then you do simple fluid air exchange, and that's the end of the surgery. And this is the last stage in last video in our video bouquet, where you can see again, such a vascular traction points over here. They really bleed, and you have to be very careful, because a single break in such cases spells doom for the poor patient. And so you have to be very careful, very slow. And the beauty of this surgery in a digital system is the magnification which you can appreciate in each of this video, and the depth which it is giving. And in such complicated system surgeries, definitely I feel it is more advantageous to use a 3D system and be comfortable. So to summarize, vitreous surgery is definitive surgery in stage 4 ROP. Pre-op lasers and anti-VEGFs definitely increase the post-operative success rate. The goal is to relieve all 4 tractions, unlike other vascular retinopathy surgeries. And 3D digital surgery eases the complex procedure by allowing unique combination of a magnification with extended depth and field of vision. So these are few of the pre-op photographs and the post-op photographs of some happy patients. Thanks a lot for everything. And thank you, Subhadra Madam. This is just a small tribute from my side towards big efforts which you do for all the babies. And I'm humbled to share in front of you this all my small effort.
I think you have taken big steps. So,
yeah, that was our transit between Bhubaneswar to which place was that, ma'am? 2 hours. It really inspired me. Then I started. Yes, Cuttack to Bhubaneswar.
Okay, any questions we have for Prashant?
Ma'am, just one question from my side. Ma'am, what is the field of view, Prashant?
Yes.
Because if your magnification is more, your field will be less. So
exactly.
Is it difficult for you to operate in such less field?
No, that's what I said. This system, usually if you go by the physics, field of view and depth is inversely proportional to the magnification. While with this system, the magnification is 40% more than the highest magnification which the microscope offers. And you have an extended depth of field, which is 1.6 times more than the routine microscope, as well as field of view, which is more than that of a microscope, in spite of magnification. That is the beauty of this system. And that's why you could see that when I'm operating in a periphery, you could see such a big ora serrata and all. It really
any
makes
disadvantage?
Yeah.
Any disadvantage?
See, the only disadvantage is when there is a bleed in a digital image, the red color enhances and it really it means glares at your eye. So you have to use a proper filter. If you use a red free filter, you tone down the red color and you manage. So for us, it's more than 12 babies and almost 20 eyes, which I have done in last 2 years. And I'm extremely convinced that it is better than microscope to operate such complicated cases.
Okay. Thank you, Prashant, for your excellent talk. Beautiful talk. Our next speaker is Dr. BP Kashyap. I think he's not there. Dr. Alok Sen, how to recognize ocular syphilis. Dr. Alok Sen, please.
I think he was not going to be able to make it. There was some family medical emergency. That's what somebody mentioned earlier.
Okay, okay. Then Dr. Saurabh Luthra, sir.
Yes.
Leopard can't change his spots, ocular lymphoma.
Yes, thank you so much, Dr. Santosh. I thank MOS for this opportunity. I'll be sharing my screen on this interesting case, which we have been managing for the past 10 months or so. So are my slides visible?
Sorry. Yes, sir. Yes, sir.
So this was a 57-year-old female, first presented to us 10 years ago with decreased vision both eyes, was diagnosed with vitritis, left eye had a dense cataract, was managed with topical steroids. Systemic investigations at this time were largely non-contributory. Subsequently, she had disc edema and was diagnosed as left eye optic neuritis, managed with IVMP, which resolved a month later. This is all about 11 years back. The saga continues. 2 more episodes of bilateral low-grade vitritis in the following year. Uveitis panel again at this time was non-contributory. She subsequently was 6/9 OU after left eye cataract surgery. She was lost to follow-up for a period of 7 years. She presented again in January this year with a vision of counting finger close to face in the right eye and 6/18 in the left eye. There were vitreous cells in both eyes. Right eye showed advanced glaucomatous cupping. The media was grade 3. Left eye media was grade 1, and there were multiple pigmentary changes and intraretinal hemorrhages along the arcades. So this is the pre-treatment ultra-wide field color fundus photo where you can see that the right eye media is very hazy, and in the left eye you are seeing these pigmentary alterations with hemorrhages. Pre-treatment swept source OCT was done. Right eye showed sub-RP hyperreflective deposits with associated neurosensory detachment, and left eye showed a uniform band-shaped sub-RP hyperreflective deposit. The Brooks membrane appeared intact with both eyes. So this is the swept source OCT pre-treatment, where you can see in the right eye these deposits, and in the left eye you can see this hyperreflective band. The fundus autofluorescence showed in the right eye the media was hazy, but in the left eye there was a granular pattern of hyper with hypoautofluorescence, like a leopard spot appearance. So this is what we saw on the fundus autofluorescence. And this is an ultra-wide field fundus autofluorescence showing leopard spot appearance in the left eye. Fundus fluorescein angiogram showed in the right eye there was peripapillary leakage, whereas left eye showed punctate hyperfluorescent defects with characteristic hypofluorescent lesions. Again, a leopard spot kind of appearance in the left eye on FFA. The systemic investigations at this point of time were non-contributory. CSF did not show any atypical cells, no morphological evidence of lymphoma. A PET scan was done, which showed no abnormal hypermetabolic focus or mass lesion. EBUS was done for the mediastinal lymph nodes, which did not show any evidence of metastatic carcinoma, and immunohistochemistry did not show any evidence of lymphoproliferative disease. A diagnostic vitrectomy in the left eye was done at this point of time, and which actually showed positive cells for lymphoma, and where the T cell markers CD3 and 4 were positive, while B cell markers were negative. This is these are the cytology smears showing numerous atypical lymphoid cells, and CD3 was positive. So this is courtesy of RP Center, where Dr. Seema Kashyap has done this, and we took the help of Dr. Rohan Chawla at RP Center AIMS for this. So a diagnosis of bilateral primary vitreoretinal lymphoma was made of T-cell origin. She was started on a regimen of bilateral intravitreal methotrexate injections. A total of 25 injections is the course with the induction, consolidation, and maintenance phase. So far, she has received 20 injections. Adverse effects of corneal epitheliopathy and transient IOP rise have been seen, but which were managed with mild topical steroids and anti-glaucoma medications. In June, the vision improved to 660 right eye, 624 left eye. Repeat FFA and SD-OCT showed resolution, and thus she appeared to be in remission. This is what the OCT looked like in June this year. And this is the FFA. In September, again, she had a recurrence of subretinal fluid in the right eye. She underwent a right eye vitreous biopsy. However, this time the immunohistochemical markers for both T cell and B cell were non-contributory. A repeat PET CT scan was non-contributory. Post vitreous biopsy in the OD, the subretinal fluid had resolved. So this is the latest picture. This is just very recent. Right eye is 1/60 and left eye is 636 parts. And you can see the leopard spot appearance still present in the left eye, although there is no subretinal fluid at this point of time in both eyes. So she has recently received, just a week back, the 20th intravitreal methotrexate injection in both eyes. So primary intraocular lymphomas can be primary or secondary. 60 to 90% of primary vitreoretinal lymphomas involve the brain, and 15 to 20% of patients with primary CNS lymphoma will develop a primary vitreoretinal lymphoma later. More than 95% of primary vitreoretinal lymphoma are the large B cell type, whereas only less than 5% are of T cell origin. And these are the various clinical features to look for. Gold standard is histopath examination via a transpars planar vitrectomy with 25 or 27 gauge. The specimen is obtained with a low vitrector cut rate. The diagnosis is very challenging because of the analysis has to be done within a very short period of time. And recently, this MYD88L265P in the aqueous tap has been shown to be positive for lymphoma. These are some of the cytology findings in lymphoma. And in the treatment of lymphoma, if it is ocular involvement only, treatment depends as whether one eye or both eyes. If unilateral, then local therapy in the form of external beam radiation therapy can be given. For bilateral eye involvement, there is no uniformly accepted regimen. Intravitreal methotrexate and or rituximab, to a combination of systemic chemo and radio to both eyes and brain, to a combination of systemic chemotherapy and intravitreal methotrexate has been used. Bilateral radiation is not favored. No consensus about treating isolated primary vitreoretinal lymphoma with systemic chemotherapy for preventing CNS relapse. Our patient presently So this is just a summary of the treatment regimens which are there for lymphoma. So we can have various findings on OCT, and you can see that there can be a discrete pre-RP nodules to subretinal infiltrate, to a mixed intraretinal and subretinal infiltration, to irregular indistinct RPE, as you see in the D figure here, to E, you can see a diffuse hyperreflective foci in the posterior vitreous, and in the F picture, you see a subretinal infiltrate as a confluent band, as was seen in the left eye in our case. So what is the take your practice message? The diagnosis of primary vitreoretinal lymphoma is challenging, as presenting features are non-specific, often masquerading as chronic uveitis or vitritis. Diagnosis is often delayed due to lympholytic effect of steroid therapy. Looking for imaging biomarkers on OCT, such as hyperreflective subretinal infiltrates, sub-RP deposits, RP undulation, and clumps of vitreous cells, and the finding of leopard spot on fundus fluorescein angiography and fundus autofluorescence help clinching the diagnosis. Thank you. And the patient still continues to be on follow-up.
Very nice.
Thank you, ma'am.
So anybody has any question for Saurabh? So Saurabh, do you have any explanation why there was a lull period of many years? Like, do you think that was a different disease and this is different disease, or you think it was the same condition which?
Ma'am, I think that's the most, good question. And that's the most puzzling thing for us also. But we don't really think that the primary episodes of vitritis almost 11 years back and, another 2 episodes of vitritis and 1 episode of optic neuritis were, because at that time also we did put the patient through a lot of imaging, even systemic evaluation, but we could not, get to the diagnosis of a lymphoma. And the fact that the patient has gone on to live for, another 11 years, I mean, it again goes against, a primary diagnosis of lymphoma at that point of time, because usually these patients do develop, systemic manifestations within a few years of diagnosis of PVRL.
So it is known that if we give immunosuppressive therapies for
Yes.
any disease, they are prone to develop cancers later in life. So do you think it's like, she was on immunosuppression actually for a non-lymphoma condition, and then that somehow precipitated the onset of lymphoma after many years?
Ma'am, she wasn't on any immunosuppressive therapy for systemic conditions. And as far as the vitritis episodes were concerned, they were mostly managed with topical steroids and at the most a very short course of systemic steroids. So she did not at any point of time receive any immunosuppressive therapy for the eye condition or the, systemic condition. There was no history, ma'am.
And is there family history of cancers, or anybody else in the family had any malignancy in the past?
No, ma'am. So that again is not forthcoming, and there was no clear-cut history of any systemic malignancy in the family, ma'am. It wasn't elicited, ma'am. So we couldn't elicit a history.
Any other questions?
Saurabh, beautiful case. Thank you, and very nice summing up of things about lymphoma. But the right eye, did that patient have a peripapillary CNV by any chance?
So that's again a thing which was puzzling us, and in fact we did the OCTA also through that area, could not demonstrate any vascularity. So it appeared more like a like a Shrem kind of thing, but it was not vascularized. So in the angio there was some leakage, but we also did OCTA and especially concentrated on that peripapillary area of subretinal hyperreflective material, but could not really demonstrate any vascularity. And the fact that she did not worsen with the methotrexate, and we never gave her any anti-VEGF, also again goes to show that it's unlikely that that area is a CNVM.
Methotrexate also will have had some anti-inflammatory effect, which could have suppressed CNVM if it was there.
I agree, sir. So, I mean, but still the main thing was that on OCTA, we did not see any vascular pattern within that, it was not like a vascularized Shrem. It was just, a hyperreflective material with no vascular, flow signals within it.
Any role of steroids in such cases?
So that's a good question, and what I've pointed out that if we had given steroids, it would have led to remission temporarily, and often that is the reason that before biopsy, if the patient has received steroid, we will miss the diagnosis altogether. So because of the lympholytic effect of steroids. So before taking these patients up for biopsy diagnostic vitrectomy, we have to discontinue steroids for some time so that we can have a high yield of lymphoma cells.
Okay. So I tried to check in the literature how many days we have to stop the steroids, but I could not get that answer. So I stopped for at least 3 weeks.
Yes, ma'am.
So, but it doesn't say, it just says stop, but for how long it doesn't tell us.
That's not very clear.
So if we have given subtenon or something, then it is difficult. But if you have given topical, then I think 2 or 3 weeks minimum.
Yes.
And then, as Saurabh said, no, the sample has to be sent to the lab immediately. So the lab should know that you are doing this case, because many times the biopsies we do in the evening. So this should be done early enough for the lab person to come and collect it and plate it and centrifuge it immediately, and keep some of it for the immunohistochemistry, immunocytochemistry.
Yes, ma'am. And that's why we took the help of RP Center, because we couldn't have done it here in a smaller city like ours. So we took Rohan Chawla's help, and through their histopath department, I mean, we could manage to clinch the diagnosis.
So thank you, Saurabh sir. I think Ragini madam is there. Please unmute, ma'am. Do you want to say something?
No, I just came to say hello to Subhadra ma'am and congratulations to you. Hi to Prashant, hi to Saurabh bhaiya, hi to Paritosh bhai, and just to be there.
Thank you, ma'am.
So happy that all of you are there, and salute to Subhadra ma'am. And congrats, Santosh. This time you did it.
Thank you, ma'am. Thank you, because of you only.
You sat down so many times for other people. This time you deserved the post, because तुमने 2-3 साल लहाने सर का सुन के बैठ गया. This time I think the people voted for you.
Yeah, thank you very much, ma'am. Thank you very much.
Prashant was flying to Nagpur today morning and Saurabh Bhaiya, hi, good to see you.
Evening, ma'am. Thank you so much, ma'am. Nice to
Paritosh
see you.
Bhai, hi, sorry. Hi, Sharad Bhuman sir. Sorry to interrupt your session, ma'am. Lovely to see you. Sorry to interrupt your session.
Okay, we'll go ahead with the session now.
Yeah.
Thank you, Ragini. Okay, Santosh, we can ask the next speaker.
Yeah, myself only. Myself, I am going to speak on.
I will do the privilege of introducing Santosh Agrawal, who has done a vitreoretinal fellowship from Shankar Netralaya, practicing in Aurangabad, and now yesterday got elected as president-elect for Maharashtra Ophthalmological Society. So over to you, Santosh.
Thank you, Prashant. He is my good friend. That's why he is telling so many nice things about me. Thank you. So my topic is tele-ROP screening and management, an ideal model. So as you know, retinopathy of prematurity is a disease affecting the retina of premature infants. It is characterized by immature, incompletely vascularized retina. And contemporary neonatology practices in the premature infants have increased the survival rate, which have escalated the risk of developing ROP. And it is the leading cause of preventable infant blindness in the world. Today's scenario, the incidence is in India, 5 million babies born premature every year. The incidence of ROP is around 40 to 50%. It is greater in rural and remote areas. Annual live births in India is around 26 million, and ROP screening required is about 5 million. It is very large, and merely 100 and 150 ROP experts are there in India. So we need to look at all those problems. Again, the referral rate to the ophthalmologist is very low from the pediatrician side. 58% pediatricians refers, 8% pediatricians refers only sometimes, and 34% pediatricians never refer. So, and also there is a non-availability of ROP expert ophthalmologist. That is the problem in the present scenario. Also, the apathy on the part of pediatricians and ophthalmologists. Apart from that, the patients are also ill-informed. They have some financial constraints, and they are not aware of this disease. Now, the BIO is the gold standard. That is a binocular indirect ophthalmoscope, by which we traditionally look into the retina of premature babies and diagnose the ROP condition. That is a gold standard, but it has limitations. It is very difficult to perform. Many times you skip the areas of fundus periphery. You have to see the periphery 360 degree, and many times you can't see because of the uncooperative nature of the children or infants. It is time consuming. You have to go to the NICU. You have to spare time for that. You have to draw the diagram, and it is subject to phenomena. So documentation is also poor. So now comes the wide angle or wide field imaging for ROP screening. That is the evolution that happened recently, and by a trained or accredited optometrist or ophthalmic assistant can do that. And it was developed and validated by KID ROP organization led by Dr. Anand Vinekar. And also Australian has also validated this type of screening, and government of India also accepted, and now they wanted it in all states. So in India, Forus Neo camera by Bangalore-based company, that is Trinetra, has come out with the camera. It is wide field, portable, and it is very low cost and novel. As against RedCam, though RedCam is the gold standard or it is the best camera, but it is very expensive. As against that, the Forus Neo camera is compact, portable, and it has low cost. Another advantages are it is accessible to rural areas. The mass screening is possible. In our model, our optometrists perform the screening in 3 minutes only. So tele-ROP is possible with this method, and it is an objective method. It is a reproducible method, and documentation is very well possible with this method. So this is the indirect ophthalmoscopic method. Now, left side is the red cam, right side is the Forus Neo camera, which is very compact, and we can take it to the remote places. Now, what is our model? We have come out with a Arambha ROP screening project in a private. It's a private project. It is a partnership project. It is a joint venture. And we adopted the team approach. That is 2 vitreoretinal surgeons and 1 pediatric ophthalmologist in our area. We have come together and we form ROP screening project. We got inspired by Dr. Anand Vinikar, Dr. Jalali Madam, Dr. Sucheta Kulkarni. We ourselves first refined our knowledge. We made different neonatologists. We visited NICUs and we took a lot of efforts initially. We have also hired optometrists who got trained at higher centers. We maintained good communication. We maintained good coordination between patient, neonatologist, and ROP expert. In one day, we followed one route, one city, and around 30 to 40 babies are screened in a day. We treat the babies at tertiary center, our own center, or in the NICUs. So this is the brochure which is given to the neonatologist or the ophthalmologist. This is our team. This is the examination record we keep on hard paper also. This is the leaflet given to the patient for awareness in NICUs. This is the poster we paste in the neonatologist or pediatrician's clinic. Now this is the Forus Neo camera, very compact. We can take it to anywhere. We can mobilize it in a rickshaw also, in car, bus. So this is the screening is done in the NICU. It's just like a sonography probe, very easy to use. And the optometrists bring the images to us in our own clinic. We don't have to go or visit the NICUs. We just interpret the reports. And not only fundus, but also intersegment photos we can take. And we can rule out congenital anomalies, congenital cataract, glaucoma, etc. And apart from ROP, we can diagnose different congenital problems like coloboma, RD, retinoblastoma, and also we can rule out albinotic fundus. So this is the ROP case. This is before treatment. You can see stage 4. There is a fibrovascular proliferation is seen in the periphery. We have lasered it and it got quite, and we referred it for second opinion to Dr. Subhadra Jalali Madam. I want her opinion whether surgery is required in mandatory in such cases. This is a 4A again, second case. We did laser. It got quietened, but still we want to take second opinion. We referred it to Dr. Madam. This is another case of APROP. We given the injection, intravit injection, and it got resolved. This is another case again, APR. With the injections. This is again the case with the rich stage 3 ROP in zone 2, zone 3. We did laser. So our screening place was in the NICU or our own center. It is a unique ROP screening model. Narayan Netralaya has conducting the same type of model. HV Desai is also conducting. And we are the unique in running this project as a joint venture in private, covering about 8 districts and 3 civil hospitals and 2 medical colleges. This is our data. Up till now, we have screened around 5,559 cases, and ROP were 12.35%, and treatment was given in 3.52% cases. So this is our data. What are the problems with our model? We need skilled assistant. There is a lot of traveling. There is many times image quality may not get proper. And there is an apathy on the part of pediatrician, but we have to train him. We have to make him aware about the severity of the problem. And some patients many times refrain from repeated follow. There is some resolution problem in the periphery, and the illumination problems are there. Now company is going to sort out those problems. So this is the unique model which can be adopted in India, especially in private sector, to curb the incidence of ROP and huge burden of childhood blindness. It is a low-cost indigenous camera, tele-ROP screening, and team approach of experts can make it successful. Documentation helps in counseling and data collection, and also in medical legal issues. So it is the ideal model. I wish it should be adopted by many others in India. Thank you very much, ma'am. Thank you very much, all panelists, for patient listening.
Thank you, Santosh and team, for that excellent presentation. So anybody has any questions before I give my comments? Any questions to Santosh? Yeah, you can unshare, Santosh. Yeah. Anybody has questions? So excellent work, Santosh. I just wanted to say a couple of things. One, don't put indirect ophthalmoscopy as the old way. You know, the photography, the telecamera, the indirect ophthalmoscopy, they're all complementary to each other. There are some things which we see better on cameras. There are some things we see better on indirect. So don't discard old white-haired people. They are still, useful. So I would say that, you just say that this was one way we were doing, and now we have an additional way of doing. And depending on the situation, you can use one, both together, one after the other. And then there are many other cameras also which are now available. So about the awareness, that's what I wanted to highlight. So recently we had triplets who were delivered in a remote part of Andhra Pradesh. And that man, very smart, he has gone on the net to find out about premature babies. And then he has seen my video talking about ROP, and he has asked his pediatrician, should my babies get ROP screening? And the pediatrician said, no, it's very rare, and I don't think your babies are going to get that. So I don't think it's that important. But the father himself traveled with all his 3 1 kg babies to our center, and by the time he came, 2 of them had stage 4A tractional detachment, 1 had very advanced AP-ROP. Fortunately, we were able to salvage all those 3, and that story is coming out. But what I want to highlight is that all of us should work equally on awareness as we work on, our work, because this is a public health problem. We have to go step by step. We don't have to offend anybody or do anything. But, whenever I get any baby with stage 4 or 5, I send the NNF guidelines to that, sir who has not referred. And I also give posters, and I send on WhatsApp the posters that please, help your patients. And the parents not coming on time, again, very important when they are in the waiting area. When your technician goes, then he should roll out a standee, which is showing the different stages and how the children will become blind, especially photos with blood. If you show photos with blood, then the parents can understand blood. Otherwise, they think that, you are seeing something and this is some research work and you just want to earn money. So they have all sorts of doubts. And involving the local collectors, local people, keep on pushing on the awareness. Now World Prematurity Day is coming on November 17th. Everybody should put out, posters, radio talks, small things in your newspaper. So push it. The more we do, the public will ask for it, and the doctors will also be aware.
Surely, ma'am.
We all should take that is very, very good, and especially in local languages. And the more we are also, shifting to a lot of technicians or fellows, optometrists doing, there is some resistance from doctors. The pediatricians, they want, the faculty only to come, especially for the very tiny babies, especially for very delicate babies whom they have saved, or VIP babies. So we do accept that request. But yeah, we are also taking help of technicians and other fellows. And now more and more general ophthalmologists. We are having general ophthalmologists now who are taking up the camera and doing the screening. So that is also helping.
One question, ma'am. I have shown 2 cases of 4A, that elevated retina in the periphery. Yes. I did laser, but I was not convinced. Yes. How much laser we should do, and when to refer, or when we should intervene surgically?
Yes. So I think that's a very, very important question. I keep on telling this to all people who refer to us, that the first step is that whenever you are treating, whether with anti-VEGF or laser, please get hemogram done on that day or next day. The disease will progress and your treatment will not work if the baby is anemic. We have seen this repeatedly. Or if the baby still has lung problem. So telling the parents to keep the nose clean, use nasoclear nasal drops, do chest physiotherapy, do nebulization, whatever, in consultation with their doctor, and see that the hemoglobin is at least 10 and the RBC count is normal. If not, they should give the transfusion. That is one step, very, very important, whether you are referring for surgery or you're doing treatment yourself. The second thing is, if there's a persistent fetal vasculature stock, if there is a stock which is going from the disc to the periphery, these eyes will worsen more than when there is no stock. So that is one group which you must see carefully. And the moment you see that, that fetal stock is there and it is going towards the ridge, those patients have to be referred early. Now, if the traction or the elevation is more than 3 clock hours, those are the patients who will worsen, more. And of course, if the plus has not gone, then they will worsen. So if there is an early traction and still the retina is attached, and you can laser behind the ridge. So laser anterior to the ridge, laser behind the ridge, see again in a week, do some add laser, and then follow every week. And the moment you see, and then, examine all around. Many times people examine only the temporal side, examine inferior, examine superior, look at the persistent fetal vasculature front. And if you think that the traction is now more than 3 clock hours, then please refer immediately after giving the transfusion. So these are some of the, clues.
Thank you, ma'am.
Thank you very much, ma'am. Thank you.
I had a couple of questions, ma'am. In cases where the vasculature has not developed and the baby is like 3 months plus and baby is bigger, and it's difficult to examine these babies, just by holding them, and we don't have a ret cam. So what is the way around this? If there's a delayed maturity in these babies, so how can we, kind of examine these babies once they reach that particular size where it's difficult to restrain them? And the other question is that medico-legally, if patients don't follow up on the time that they're told, how do we, kind of, apart from documenting that they were called for a visit and they didn't come, what else can we do to avoid, medico-legal issues in these cases?
So one thing is, of course, that your notes should be very meticulous. When you're sending them off, don't say come in 2 weeks. Write come on 30th of June 2014 and write JUNE. Because one patient I wrote 767/6/2021, he came on 6 July. And when I asked him, I said, I have written 7 June, but you have come on 6 July. He told me, I live in Dubai and there they use the USA system. So then I learned that, okay, it is my mistake. I should have been more conscious. So now I always write JUNE, so we all learn. So write the exact date when they have to come, where they have to come. So that should be very careful. And your findings, your findings have to be there. So, last time the litigation happened in Delhi, it was because the doctor has done ROP screening and he has written ROP screening done, no ROP come in 2 weeks. The court did not accept that. They said, where is it is written that you have done dilated examination of the fundus? Where is it is written that you have, because we don't enter dilated drops. No, we don't enter what time sister put the drops. So at least in the notes, we have to write ROP screening done by so-and-so. Pupil was dilated, media was clear, retinal vessels are in zone 2, the vascular pattern is normal, there is no looping, there is no hemorrhage, so there is no ROP, and now the patient has been called back on 6th June and the parents have been informed. So once you've done all that, you are free. You have already told them, you have also made a phone call, you've seen that they didn't come. After that, it's not your business, okay? And you already informed the treating pediatrician that this patient I was following. If you can convince them to come, it will be good. So I think our notes are very important. And of course, the conveying to the parents, giving them that brochure when they come first, giving them access to the YouTubes. There's so many YouTubes now available. So giving them those informations, both by the NSU pediatrician and by us. And beyond that, we can't do anything. But our notes, they are complete, then we are safe.
I can add, ma'am, one thing. What we do additionally is that we have a follow-up sheet. And on follow-up sheet, we have 2 copies. One is with us, one with them. So the copy which they carry have my signature, and the copy which we retain for us have their signature at every visit, which clearly mentions the follow-up date.
Yeah. So like an immunization card, many people, we are giving that vaccination card, and they also remember, because what happens here is she was in the sasural, now she went to Mackay. Here the husband was in charge, there in Mackay, brother is in charge. We have all these problems. So if the card is there, that also helps, because it will show the serial thing, and then the mother can read the date, even if she can't read other things. At least she can read the date, even if she's illiterate.
Thank you, ma'am.
We also remind the patients, ma'am.
And that other question, Saurabh, which you had about the follow-up. So, so previously I was doing no monotherapy, I was doing combined therapy for this reason. But more and more, I'm doing only monotherapy. That is because I use only Avastin, where the recurrence rate is very low, less than 10%. Especially if we have taken care of the systemic issues, which I talked about, then the recurrence rate is very low. And second thing is, even if the recurrence comes, it will come little later. So if you are using non-Avastin drugs, then 40%, that means every third or fourth baby will have a recurrence, and it will occur very early. So you have to follow very closely. So one is what drug you are using. Second is what is the health of the baby, gaining weight, not gaining weight, anemia, lung problems, still on oxygen, sepsis, pneumonia episode. So those things matter. And fourth is when they become big, fat. If I'm not very comfortable, I always take them under anesthesia. At least one time I will examine under anesthesia to know what is happening. I may not do laser. Previously I was doing laser. Now if there's a peripheral avascular retina and the vessels have shown up, have shown growth. So what has happened, growth, then I'm comfortable. I think Tapas has collected some data, and he has shown that those patients who have slower vascular growth, they may have more recurrence than those who have, a more relatively a little more better growth. But that data we have to analyze. But yeah, I think as you follow for 4 weeks, 6 weeks, 8 weeks, 12 weeks, you get an idea what is the tempo of disease. They can still recur, but I think they recur because we have sort of missed that something was smoldering there. But if it is completely gone and the circumferential vessel has formed and now the vascular network is started to branch and show normality, then I think the recurrence will be less. But we all are learning. We all are learning. Please keep up your learning. See your cases properly. See Tapas' article. See, he spent 3 years drawing every vessel. And when we went back to those vessels, what he had drawn, what was happening, we learned so much. So this is a new therapy. I think the more we see, the more we do, we will learn. And we are all, excellent clinicians. We will get that, skill of knowing which babies we have to laser, which babies we can follow, what is happening to that retina. But yeah, bigger babies, whenever you're in doubt, even post laser, they can get recurrence. Whenever in doubt, please don't hesitate to see them under anesthesia.
Thank you, ma'am.
I have picked up new vessels under anesthesia where I had thought that everything is okay. Even I had lasered a baby under GA, and then, she lost one eye in spite of my doing that. I thought I have done a good job. Fellow is not done. Under GA I did, still she lost one eye. So, so I think sometimes they may be having some underlying FEVR or whatever. So whenever in doubt, just do an EUA. We can all do that.
Thank you.
Okay, I have to leave. Thank you so much. Having one more session. Bye. We've completed the session.
Thank you, everybody,
Right?
for your excellent talk and nice discussion. Thank you, ma'am. Thank you, Prashant. Thank you, Saurabh sir. Thank you, everybody. Thank you, Sapnesh.
Thank you.
Thank you.
And sir, congratulations once again for
thank
winning
you,
the
thank you,
election.
Sapnesh. Thank
Thank
you,
you,
Sapnesh.
Shubhadra
Thank
madam. Thank you, Saurabh sir. Thank you, Prashant sir. Prashant sir, we have kept him busy all day since morning. Saurabh sir also since morning we have kept him busy. Thank you so much, Agarwal sir, Shubhadra madam. So that's the end of the retina session, and we are coming to the end of a MOS Vircon 2021, a successful conference. Last thought by Agarwal sir.
You are the key person, I think, for the whole conference.
Great show.
Thank you
I
very
should
much.
say, great show. Everyone, the scientific committee, really, Ragini madam, Swapnesh, and what's his name? Sumit. They have done fantastic job beyond imagination. So now finally you are winding up and going back to Nagpur, Mumbai, or still in Pune?
No, I've reached Mumbai. Last 3 hours on the way we were trying to moderate, and on the way we were trying to manage.
Okay.
We have just
You are
reached
in the
Mumbai.
car only.
Yes.
Absolutely fantastic, and it was great meeting everyone at Pune. Chalo, once more, thank you everyone. Thank you.
Bye.
Bye.
Thank you, everyone. Thank you.
Thank you, Luthra sir. Thank you.
Thank you.
गीतांजली मॅडम.
हा बोल दर्शना.
यांना फोन करू का रागिनी मॅडमला?
हो संपलंय ना इथलं सेशन, सगळे सेशन संपले असतील तर
झाले 5 मिनिटं झाले संपून. म्हणजे मग कसं आहे आपले सगळे ते प्ले तरी होतील जितके सांगितले. काही काही गोष्टी ना सिंक्रोनाइज नाही झालेत त्याच्याकडून सईकडून. मसूरकर सरांचं सॉन्ग आणि तो म्हणतो पण होऊन जाईल तुमचं इव्हेंट सुरू होईपर्यंत.
ओके ओके चल मग आता सगळे जमेपर्यंत 6:25 वगैरे होतीलच. त्यामुळे हा सगळ्यांना फोनाफोनी करून जॉईन व्हायला सांगू मला वाटतं.
हा मी नॉट एबल टू जॉईन वाया लिंक. ही कशाला नाही? इट्स वर्किंग.
हे कुणी लिहिलं?
इट्स वर्किंग ना. हो राधिकाने.
ती कुठली लिंक?
ती त्याच लिंकनी मी तर जॉईन झाली आता.
हो मी पण.
बरं डॉक्टर शुभांगी निगवेकर ट्रॅव्हल करताय. त्यांचे 2 आहेत एंट्रीज. मी सांगू का याला की एक त्याच्यातला तो सॉन्ग नंबर आपण
मी तिला कळवलं की 6:30 ला जॉईन व्हायचं तर तुमचा प्रोग्राम 16 नंबरवर आहे बस.
नाही त्यांनी अजून एक सांगितलं ना तुम्हाला, ते सांगत होती मी बघा आज दुपारी घ्यायची म्हणत होती. हा खूप सुंदर आहे ते कोविडवर, म्हणजे खूपच मस्त आहे, घेण्यासारखं आहे. मी तो घेतलाय. मग तो जुना सॉन्ग मी सांगू का त्याला डिलीट करायला फोल्डर मधून? म्हणजे हा म्हणजे ते एकच याचं पर्सनचं 2-2 ठेवण्यापेक्षा
करेक्ट. मग त्याच जागी 16 जागीच तिची पोएम ठेवून द्यायची.
त्या जागेवर मी ती 7 नंबरवर ठेवली आहे सध्या ती पोयम. ती 15 ला शिफ्ट करते. 15 आहे त्याच्या तन्मयच्या लावणीनंतर ती. कारण ना यांनी ते याला नंबरिंग नाही दिलं ना, हर्षुल लाईव्हला नंबरिंग नाही दिलं यांनी. तर याची नंबरिंग आणि आपली नंबरिंग मध्ये थोडा फरक आहे.
थोडा फरक आहे. बर ठीक आहे.
तर शुभांगी कुलकर्णीचं 7th नंबरची आयटम मूव्ह करते 15 नंबरवर. म्हणजे पण परत खूप नंबरिंग चेंज होईल. 15 नंबरची नाही तर त्याला डिलीटच म्हणजे काढून टाकायला सांगते सध्या.
तोपर्यंत आपण आहोत ना दोघी, तर आपण ते मॅनेज करू नंतरचं. म्हणजे हर्षुलचं घ्यायच्या जस्ट आधी ना.
हा आणि हर्षुलचं थोडं लवकर घेऊन टाकू का मग? म्हणजे तुमचा डान्स पीओएस फॅशन शो झालं की समजा मसूरकर सरांचं सॉन्ग झालं की घेऊन टाकायचं का हर्षुलचे?
चालेल. हो
7th नंबरवर.
हो चालेल, अगदीच चालेल.
हो
मग त्याची दोन्ही गाणी झाल्यानंतर पाहिजे तर हिचं पोएमचं काहीतरी बघू.
ती पोएम 7th नंबरवर घेतलीये. एक घेऊ शकतो, ती पोएम छान आहे. आणि त्याच्यानंतर मग एखादा डान्स घेऊन पुन्हा ते करू शकतो आपण हर्षुलचं लाईव्ह.
हो
तितकं तर आपण आहोत आता.
हर्षुल जेव्हा जॉईन होईल तेव्हा वनश्री
लगेच आपण अनाउन्स करून टाकायचं जे असेल ते. चालेल.
त्याला किती वाजता? 7 वाजता सांगितलंय ना जॉईन व्हायला?
6:45लाच सांगितलंय.
6:45. मग ठीक आहे, मग आल्या त्याचं लाईव्ह घेऊन टाकू आपण. दॅट विल बी बेटर.
चालेल ठीक आहे. त्यांनी आता मला त्याच्याकडे जी लिस्ट आहे ना ती मला पाठवली आहे. मी तुम्हाला शेअर करते आणि कल्चरल ग्रुपवर शेअर करते. मग ते जे रॅम्प वॉक आहे ना शेवटीचे, ते अर्ध्या मिनिटाचे सगळे मी शेवटी टाकून दिले 29 पासून. आणि आता ते फक्त त्याला सांगायचंय की हिचं सॉन्ग 28 बरोबर आहे टाकलंय त्यांनी. सगळंच बरोबर केलेलं आहे. अर्चनाच्या डान्स नंतर हिचं रुपालीचं सॉन्ग आहे आणि मग सगळे रॅम्प वॉक आहे. मी पाठवते तुम्हाला आणि कल्चरल कमिटीला. पाठवलं. फायनल आहे, मग फायनल टाकते याच्यावर. आणि शुभांगीचं जे आहे ना ऑन 15th जो दाखवतोय तो आपण डिलीट करू शकतो बरं का? ते सांगा म्हणजे मी करते डिलीट.
हो चालेल. तिचं एकच गाणं मागे एक गाणं झालंय, आता एक पोएट्री घेऊन. दॅट्स इट.
हा दॅट्स इट. इवन आय फील की
दोन दोन नको.
हो हो तेच ना. चालेल मग.
आणि काय राधिकाच्या डान्सच्या आधी काय असं हॅपी बर्थडे वगैरे करायचंय का?
हा म्हणजे ती तर विश करूच ना तिला आता पण ती जॉईन झाली. मैं वही बोल रही थी रागिनी मैम को फोन लगाती हूँ और शुरू कर देती हूँ. रागिनी मॅडम पण निघायचं गडबडीत आहे. मी फोन लावते थांबा त्यांना.
तुझी किती वाजता आहे गाडी दर्शना?
माझी आता ना 7:15 निघावं लागेल. आता इथून मला तिथे येरवाडा जायचंय पिकअप पॉइंट कोंडव्याहून.
ओके.
लागेल ना?
हो हो. तुझी गाडी कितीला आहे? 8:30ला आहे का?
9ला पिकअप आहे.
9ला पिकअप आहे. मग ठीक आहे. 7:30ला निघाला तरी चालेल.
तेच ना, सगळं वाइंड अप करून जायला पण वेळ लागेल खाली. मी लावते मॅडमला फोन आणि सांगते. सुरू करायला सांगितलंय आपल्याला. मी हे करते MOS आणि याच्यावर टाकते की वी आर स्टार्टिंग आणि आपण मग अनाऊन्स करू मॅडम. विल स्टार्ट विथ गणेश वंदना. मॅडम 2 मिनिटात लॉग इन करताय. हाय राधिका, हॅपी बर्थडे.
हाय राधिका, हॅपी बर्थडे.
Thank you, ma'am. I still cannot join this. What do you call the computer?
तू काय कर, कॉपी कर पासवर्ड आणि मीटिंग ID. खूपदा काय होतं ते हँग होऊन जाते. दुपारी माझं सेम झालं होतं. मी मोबाईलवर केला होता दुपारचा सेशन. मला असंच झालं होतं.
पासवर्ड आणि ID कुठे आहे?
ते मीटिंगच्या इन्फॉर्मेशन मध्ये जाणं.
मीटिंगच्या कुठल्या? ओके ओके.
तुझ्या मोबाईलवर जी लॉग इन केली ना तू, त्याच्या लेफ्ट हँड कॉर्नरला जी इन्फॉर्मेशन असते ना त्याच्यात बघ आणि कॉम्प्युटरवरती टाक.
मीटिंग सेटिंग्स का?
हा, इन्फॉर्मेशन
नाही.
इन्फॉर्मेशनचा मार्क असतो तिथे. लेफ्ट हँड साइड वर येतं ना पंकज?
मीटिंग इन्फॉर्मेशन त्याचं भी देतो. सेटिंग्स के आजूबाजू
सेटिंग्स दिसत आहेत पण त्याच्यावर काही हे येत नाही.
मीटिंग इन्फॉर्मेशन म्हणून एक असतं, मोबाईलवर दिसतं. त्याच्यात मीटिंगचा ID मिळेल आणि हे मिळेल पासवर्ड 1 2 3 4 5.
स्क्रीनशॉट घेऊन पाठवाल का? स्क्रीनशॉट घेऊन पाठवाल का तुमच्या इथे दिसत असेल?
मी मीटिंग ID सांगतो ना. कोणता हॉल आहे?
ईश्वरचंद्र. सांगताय थांब. पंकज तुला.
मग मी डायरेक्ट झूम वरनच जाऊ का?
तू झूम वर जॉईन झालेली आहे ना मोबाईल वर, त्याच्यात कॉर्नर मध्ये बघ.
डॉट झूम नाही, मला कम्प्युटरवर डॉट
मीटिंग आयडी टाकायचं.
न्यू मीटिंग आयडी आणि पासवर्ड.
जॉईन अ मीटिंग. This is taking time. हा, मीटिंग आयडी
देतो.
थांब हा, देते. पंकज देतात.
झूम लिहिलेलं असं ना, त्याच्या खाली टिक केलं ना की मीटिंग आयडी येतो. 913
आयडी इज 913
2122
2122
3088
3088 आणि हे
12345
12345 पासपोर्ट. एक मिनिट, आय विल जस्ट ट्राय.
आले की तुम्ही जॉईन झाले दिसतं.
नाही, मी जॉईन आहे ते मोबाईलच्या थ्रू आहे.
हॅपी बर्थडे.
थँक्यू सर. 9132 88. हे मला ना काहीतरी ओपन झूम लॉन्चर असं क्वेश्चन विचारतोय, त्याच्यामुळे ते पुढेच जात नाहीये मगासपासून.
राधिका मॅडम.
हा सर.
नाही झालं का? कनेक्ट नाही होते.
काय म्हणताय?
कनेक्ट झाले की नाही?
मी इथे मोबाईल वर आहे, इथे ह्याच्यावर नाही येत आहे ते मला.
मीटिंग आयडी टाकून पण नाही होते का?
नाही, ते काय होतंय, मीटिंग आयडी टाकला तर ते एक मिनिट मी सांगते तुम्हाला, एकच मिनिट. हे टाकते 223088 3088. हे बघा, जॉईन म्हणलं ना मीटिंग आयडी टाकून की त्याला जी विंडो येते ते लॉन्च मीटिंगच्या इथे URLच येत आहे डायरेक्ट, पुढे जात नाहीये लॉन्च मीटिंग पासून पुढे.
लॉन्च वर क्लिक कर बरं.
त्याच्यावर काहीच येत नाहीये पुढे, मला काहीच येत नाहीये.
तुम्ही ऑफ करून परत नवीन झूम हे करा आणि करा.
नवीन झूम मधनच गेलीये मी आता सर, एकदम नवीन.
बरं, ऍटलीस्ट तुझी बॅकग्राऊंड हिट आहे, टू फिट आहे ती काढ जरा.
कशी काढणार आता बॅकग्राऊंड? नाही, स्टॉप व्हिडिओ नाही ना ते.
कानडे सर, गुड इव्हनिंग.
हॅलो, गुड इव्हनिंग मॅडम.
गुड इव्हनिंग.
आलो, एक 2 सेकंदात.
मग मला आता ह्याच्यातनच जॉईन करावं लागेल. आय एम नॉट एबल टू जॉईन वाया माय कम्प्युटर.
राधिका कोणती बॅकग्राऊंड चांगली वाटते मला सांग की ठीक आहे की दुसरी मी सांगते.
I cannot join.
ही ठीक आहे.
दोन्ही चांगले आहेत.
नाही
लाईट ब्ल्यू छान दिसते.
तुझ्यासारखी करून बघते.
करून बघा. ऑलराईट नाही लक्षात जॉईन हो सुरू करतोय. विलायती लो वो रुजुता लिंक पाठवून मला सापडत नाही. मॅम स्टार्ट करा. हा अनाउन्स करून टाकू आपण.
हो करून टाक दर्शना.
येस
लाइव स्ट्रीमिंग हुआ क्या? पहले साई से पूछो.
साई दादा, आर वी रेडी? Can we start?
Madam, 1 minute. I'll send you the final index, and after that we can start.
Okay.
लाइव में उसने रिले नहीं किया तो करना.
Madam, I have sent you a WhatsApp. Can you just check and we can start once you're okay?
It's good to go. The final this thing.
Okay, madam. Right.
Can you share the YouTube link of this to Dr. Pankaj Shah? A very good evening and welcome to all the participants of this final event, grand finale of Vircon 2021, the Gala Dhamal Masti Night. I am very happy that all our cultural programs throughout the year were very hit and everyone loved it. Our cultural committee received a lot of appreciation, and I made a lot of good friends in the form of my cultural committee members like Dr. Gitanjali, Radhika, Rujuta, Meenakshi madam, Vaishali Une madam, Karovi ma'am. So we promise you a great entertainment tonight. Dr. Ragini will be joining soon. So we start this program with a Ganesh Vandana by Dr. Rujuta Majwe. Please enjoy.
Excellent, Dr. Rujita.
Nice.
Nice. Very nice. Ganesh Vandana and Pinga. Both dances were beautifully done. Thank you for joining.
Thank you.
आता पुढचं आपण गाणं घेतोय. डॉक्टर कानडे सर.
Finalist and winner of Idol.
Winner of MOS Idol. Dr. Kanade is an excellent singer and he likes to sing old Hindi music, Hindi songs. So, Dr. Kanade sir, please.
Hello all, I am Dr. Nitin Kanade. I am consultant ophthalmologist from Nasik. As you all know that I got first prize in MOS Idol in above 60 group. Today I will be singing a song from movie Murder 1, which was released in 2004, and the song was sung by Amir Jamal. The song goes like this.
कहो ये आंखें बोलती हैं ओ सनम ओ सनम ओ मेरे सनम मोहब्बत के सफर में ये सहारा है वफा के साहिलों का ये किनारा है कहो न कहो ये आंखें बोलती हैं ओ सनम ओ सनम सफर में ये सहारा है वफा के साहिलों का ये किनारा है बादलों से ऊंची उड़ान उनकी सबसे अलग पहचान उनकी उनसे है प्यार की कहानी मंसूब आते जाते सांसों की रवानी मंसूब बादलों से ऊंची उड़ान उनकी सबसे अलग पहचान उनकी उनसे है प्यार की कहानी मंसूब आती जाती सांसों की रवानी मंसूब तमल्ली माँ बला है तब जहां की अयली हवा तमल्ली माँ तमल्ली बारे ऊपर भी वाला बंसा तमल्ली वाली शिला हत्ता बलू वया कहो न कहो ये आंखें बोलती है ओ सनम ओ मेरे सनम मोहब्बत के सफर में तू हमारा है अंधेरे रास्तों का तू सितारा है तमल्ली अलैहि बिस्तार इलैया अलैया बिंदार इलैया अलैया बिल्लिकू यकुन या हबीबी महताज तू ही जीने का सहारा है मेरी मौजों का किनारा है मेरे लिए ये जहां है तू तुझे मेरे दिल ने पुकारा है कहो न कहो ये सांसें बोलती है ओ सनम ओ मेरे सनम लबों पे नाम तेरे बस हमारा है सनम ओ मेरे सनम, मोहब्बत के सफर में ये सहारा है, वफा के साहिलों का ये किनारा है। ख्वाबों में तुझको संवारा है, जज्बों में अपने उतारा है, मेरी ये आंख जिधर देखे तेरा ही तेरा नजारा है। ख्वाबों में तुझको संवारा है, जज्बों में अपने उतारा है, मेरी ये आंख जिधर देखे तेरा ही तेरा नजारा है। ख्वाबों में तुझको संवारा है, जज्बों में अपने उतारा है, मेरी ये आंख जिधर देखे तेरा ही तेरा नजारा है। ख्वाबों में तुझको संवारा है, जज्बों में अपने उतारा है, मेरी ये आंख जिधर देखे तेरा ही तेरा नजारा है।
Excellent, sir.
Thank you very
Super.
much.
Yeah. Beautiful it was. And usually you sing old songs. आता हे थोडंसं अलीकडचं गाणं घेतलं होतं, त्यामुळे अजून मजा आली.
Yeah, this
Yes,
time I was
yes, the song
advised by
selection.
Darshana ma'am की नाही सर तुम्ही एखादं नवीन गाणं म्हणता का, म्हटलं ठीक आहे, I will sing now also.
खूप मजा आली.
As it was containing some Arabic lyrics, no?
हो.
I spent almost 14 years outside, so I knew Arabic. So I
Okay.
said, "Sir, this
Wow.
time we'll sing this song." So I
Oh,
could
that's
make
great.
that.
Yeah.
But sir, you are super talented. I regularly watch your post on Facebook also, and
Thank
you
you.
have a karaoke club, everything. What not you do?
Yes. I know.
Thanks a lot.
Yeah,
Thank
and
you
he
very much.
encourages his son also to sing. That's really,
That's the
really,
best
really
part.
good. Yeah, best part.
Thanks
Okay,
a
so
lot.
can we move now to our next program? Dr. Sandesh
sir.
Doshi, right? Yeah,
Right.
he is again another multi-talented personality. Whatever you say in music, he's able to do. So many instruments he plays on, sings beautifully, and then he's also a marathon runner, a cyclist, and a VR surgeon, of course. So let's.
He is now a permanent member of any cultural event. I hereby declare.
sir.
Thank you.
You know, every note, it's like a word. We can hear the song actually in words. That is just fantastic.
Really. Now, for our own Gitanjali ma'am, let us have a very beautiful dance. I had seen this dance in the LBO event also, and it is really, really a beautiful Kathak. And she is so passionate about Kathak. She is regularly in touch with Kathak. How much talented one person can be. Let us enjoy this dance by Dr. Gitanjali. Wow. Ma'am, every step was so clear. It is really difficult. I am a Bharatnatyam dancer. I know to keep the body posture like straight throughout the dance. It gets difficult day by day, and I really appreciate, ma'am. I really appreciate.
And though you said I'm in touch with Kathak, this was after 30 years of break.
I know. Lockdown made that come up.
I'm so proud of you. You are such a great dancer after having such big children. You were excellent. Yes.
Hello, Dr. Harshul.
Welcome.
What a time to log in, no? It was a treat to watch, Gitanjali ma'am.
Thank you.
Amazing.
It was because of you I gave this performance for LBO actually. After 30 years, I gave and I won the contest. So the whole credit goes to Dr. Harshul for encouraging me.
Amazing.
No, Dr. Harshul, I tell you, LBO has been instrumental to bring up talent of so many people.
Yes.
Day one, I'm seeing it. I really appreciate that. You take out time and you are so passionate about it.
Yeah, thank you very much.
We are very lucky to have you today.
Yes.
Thank you. It's my pleasure.
Yeah. Next, we have a fashion show, Indian traditional wear by POS, Pune Ophthalmic Society. We'll request Sai to please play it. Welcome, Ragini ma'am.
Hi.
Hello, ma'am.
देखी है सारी दुनिया, जापान से लेके रशिया, ऑस्ट्रेलिया से लेके अमेरिका। देखा है प्यार का सपना, दिल चाहे कोई अपना, मिल जाए घर एक साथिया, एक देसिया। मेरे इंडिया, मेरे इंडिया, एक दिल चाहिए रस मेरे इंडिया। ओ हो मेरे इंडिया, एक प्यारा सोनिया, एक दिल चाहिए रस मेरे इंडिया।
All right.
तन गोरा हो या काला, पर हो सच्चा दिल वाला, चांदी नहीं सोना नहीं कोई हीरा। दिल जिसका हिंदुस्तानी, नहीं कोई इंग्लिस्तानी, रात और दिन मुझे प्यार कोई करने वाला। मेरे इंडिया, मेरे इंडिया, एक दिल चाहिए रस मेरे इंडिया। ओ हो मेरे इंडिया, एक प्यारा सोनिया, एक दिल चाहिए रस मेरे इंडिया।
Orchestra.
कैसी है यार अमीरी, कैसी दिलदार गरीबी, अच्छा है क्या क्या है बुरा मुझको बता। देखी है सारी दुनिया, जापान से लेके रशिया, ऑस्ट्रेलिया से लेके अमेरिका। मेरे इंडिया, मेरे इंडिया।
ड्राइवर आया है
Nice, nice. Rujita, both the videos were very nice. Everyone participated so enthusiastic.
During this fashion show, we had a lot of fun. Doing the whole procedure, everybody enjoyed it a lot.
Right, right. So we are all waiting for Dr. Harshul. Huh? So should we take up the live song by Dr. Harshul now?
Yes, yes.
Yeah, we all are so eagerly waiting.
Harshul, the stage is yours.
Oh, thank you so much for inviting me. Yeah, so thank you so much, Dr. Darshana, Dr. Gitanjali, Ragini ma'am, and all the other respected members of Maharashtra Ophthalmic Society. It's always a pleasure to be a part of your cultural program. And so I'll be doing one song. May I request audiovisual people to please mute everybody's feed so that there's no disturbance in between, no? Otherwise, Zoom catches a lot of disturbance from other sources. Numerotech, please take care.
Done, doctor.
Okay, thank you. So this is a very special song for me. So this is song sung by Arijit Singh. Here it goes. मरमर की ये मीनारे कुछ भी नहीं है आगे तुम्हारे आज से दिल पे मेरे राज तुम्हारा ताज तुम्हारा सुनो ना संगे मरमर की ये मीनारे कुछ भी नहीं है आगे तुम्हारे आज से दिल पे मेरे राज तुम्हारा ताज तुम्हारा सुनो ना संगे मर की ये मीनारे बिन तेरे मध्यम मध्यम भी चल रही थी धड़कन जब से मिले तुम हमें आंचल से तेरे बंधे दिल उड़ रहा है सुनो ना आसमानों के ये सितारे कुछ भी नहीं है आगे तुम्हारे ये देखो सपने मेरे नींदों से होके तेरे रातों से कहते हैं लोग हम तो सवेरे हैं वो सच हो गए जो सुनो ना दो जहानों के ये नजारे कुछ भी नहीं है आगे तुम्हारे आज से दिल पे मेरे राज तुम्हारा ताज तुम्हारा सुनो ना संगे मरमर की ये मीनारे थैंक यू
Superb. Lovely, lovely.
Thank you so much.
Wow, Dr. Harshul, you have a wonderful voice.
Thank you, Ragini ma'am. Thank you so much.
Wow.
Just wow. Yeah. He sings with all those feelings. The notes are perfect and he enjoys. When he sings, you know, it's pleasure watching him singing. That's the best part. So you sing with so much of ease, you know, like though it is a difficult song, you feel, oh, so simple it is.
Exactly.
A lot of, yeah, lot of practice and everything. I don't know how you manage everything. It's just unbelievable.
Thank you so much.
Beautifully sung, really. It was as if we are hearing the original song or what.
Yes, yes.
And Arijit is like the most sought of singer, and the voice quality of Dr. Harshul was like same, and it was not even thought like it's going live.
Thank you so much.
Yes, Gitanjali madam will take the next.
Yeah, next Do we take Masurkar's song? Mr. Masurkar, is he going to sing now? Or Dr. Vanashri, you wish to sing something live?
Oh yeah, we have Melody Queen with us.
Yeah, so Vanashri, go ahead. Unmute yourself and sing. Yeah.
Is the music audible?
No.
उघडून ठेवू ना, उघडून काढू ना.
No, we can't hear.
No, Vanashri, we can't hear you.
Music, nothing is audible?
No, nothing is audible.
You can hear my voice?
Yes.
Yeah, now we can hear your voice.
Okay, then let me sing without the music only. I'm not getting the music here. 1 second. Let me.
So try again. Yeah. Play. We can't hear the music. No, you can go without music, I guess.
Sorry. I'll sing something without music then. I'm so sorry for the background music trouble. अब तो है तुमसे हर खुशी अपनी, अब तो है तुमसे हर खुशी अपनी, अब तो है तुमसे हर खुशी अपनी, जब हो गया तुम ये दर्द, फिर चाहे जो भी कहे हमको ज़माना, जब हो गया तुम ये दर्द, फिर चाहे जो भी कहे हमको ज़माना, कोई बनाएगा जितनी हो, अब तो है तुमसे हर खुशी अपनी, तुम अब तो है तुमसे हर खुशी अपनी, प्यार में बदनाम दूर दूर हो गए, तेरे साथ हम भी सनम मशहूर हो गए, देखो कहाँ ले जाओ अब तो है तुमसे हर खुशी अपनी, तुम पे मरना हो, अब तो है तुमसे हर खुशी अपनी. Thank you.
Wow.
Superb, Vanashri. And for the first time, I heard you without music. Your voice is so melodious.
Yeah.
First time I realized, with music also it is beautiful. But without music, it's pure. There is some purity in the voice. Excellent.
I'm already a fan since the first time I heard her, and I'm adoring her more day by day. She's just superb.
I know.
Very nice. Amazing voice quality and modulation she has. Amazing. Very nice.
Yeah. There is a song by Mr. Masurkar. Sai Dada, can you play that song, please?
या जन्मावर या जगण्यावर शतदा प्रेम करावे या जन्मावर या जगण्यावर शतदा प्रेम करावे शतदा प्रेम करावे शतदा प्रेम करावे या जन्मावर या जगण्यावर शतदा प्रेम करावे या जन्मावर चंचल वारा या जलधारा भिजली काळी माती चंचल वारा या जलधारा भिजली काळी माती हिरवे हिरवे प्राण तशी रुजून आली पाती फुलेला जरी बघून कुणाचे फुलेला जरी बघून कुणाचे हळवे ओठ स्मरावे या जन्मावर या जगण्यावर शतदा प्रेम करावे या जन्मावर रंगांचा उघडून या पंखा सांज कुणीही केली रंगांचा उघडून या पंखा सांज कुणीही केली काळोखांच्या दारावरती काळोखांच्या दारावरती नक्षत्रांच्या वेळी सहा ऋतूंचे सहा सोहळे सहा ऋतूंचे सहा सोहळे येथे भान हरावे या जन्मावर या जगण्यावर शतदा प्रेम करावे या जन्मावर
अप्रतिम सॉन्ग होतं मासुरकर सरांचं
व्हेरी नाईस
एन्टॉडची खास पेशकश होती. We are really grateful to Entod for always encouraging and supporting us for all these cultural activities beyond ophthalmology. So let's have another song from our guest of honor, Dr. Harshul.
Okay. So there's a song from Mohammad Rafi. थोड़े नए तड़के के साथ है song. I hope all of you would like it. If you can mute everybody, please. La 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 la. La 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 la. La 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 la. La 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 la. गुलाबी आंखें जो तेरी देखी, शराबी ये दिल हो गया। संभालो मुझको ओ मेरे यारों, संभलना मुश्किल हो गया। दिल में मेरे ख्वाब तेरे, तस्वीर जैसे हो दीवार पे। तुझ पे फिदा मैं क्यों हुआ, आता है गुस्सा मुझे प्यार पे। मैं लुट गया मान के दिल का कहा, मैं कहीं का ना रहा, क्या कहूँ मैं दिलरुबा। बुरा है जादू तेरी आंखों का, ये मेरा कातिल हो गया। गुलाबी आंखें जो तेरी देखी, शराबी ये दिल हो गया। मैंने सदा चाहा यही, दामन बचा लूं हसीनों से मैं। तेरी कसम ख्वाबों में भी बचता फिरा नाज़नीनों से मैं। तौबा मगर मिल गई तुझसे नजर, मिल गया दर्दे जिगर, हो गया मैं बेखबर। जरा सा हंस के जो देखा तूने, मैं तेरा बिस्मिल हो गया। गुलाबी आंखें जो तेरी देखी, शराबी ये दिल हो गया। Thank you.
Lovely, lovely.
Too good.
Do you practice every day, Dr. Harshal, singing?
Been practicing since childhood, ma'am. Yeah.
Yeah, it's wonderful. Like, what do you say to everyone on this occasion? Just say something like, how do you manage all the things? You know, such multi-talented personality.
Yeah. So I think everybody has some or other talent, no, with them. So only thing is you need to nurture that talent. You need to take out little time every day to, nurture your talent, to learn, keep learning new things, because learning never stops, So there is no age that you can't learn anything or like that. Of course, from childhood only you should try that, kids start learning everything. So I'll just tell everybody that keep living your passion, enjoy your life to fullest. So there's a lot of life beyond ophthalmology also. Of course, ophthalmology is everything. Whatever we are today is because of
Yes, that's
yeah.
very true. We all have to think something beyond ophthalmology along with ophthalmology. Definitely. And it's not work-life balance, but this kind of thing, like, conference, when we do such programs, it is work-life fusion, I would say. So the whole day you do some academics, but in the evening have some fun and talent. And this gives more positivity, I would say, of
Yes.
mind. So that's really wonderful, Dr. Harshul. Thank you for joining.
Thank you. Thank you so
And
much. My
thank you
pleasure.
for accepting our invitation. Darshana is here. Darshana, can you unmute yourself, please?
Yeah, there are no words to say thank you to Dr. Harshul. It
No,
was
my
a
pleasure.
highlight of our program. Actually, I am traveling, so it's all your disturbances are there. But it was really good to have you, Dr. Harshul, and very well said. Even ophthalmology, we can do better if we do something beyond ophthalmology.
Yes, definitely.
Yes, ma'am, please continue.
Yes,
So I
Ragini madam, your words for Harshul, please.
I think Harshul very well said. And he practices what he preaches. He's a fantastic ophthalmologist. He has multiple passions. He invokes the passion of life beyond ophthalmology in all of us. Harshul, you really mean it, and because you live it with passion, you sing with passion, you do ophthalmology with passion, you do your bike riding with passion, and it's an inspiration to see you. Great,
Yes.
and we are
Thank you so much, ma'am.
really for being with us, Harshul.
Thank you. My honor, ma'am. It's my honor.
Thank you so much.
Dr. Vaishali, now I request Dr. Vaishali, Dr. Bhagli madam and Dr. Radhika to continue, please.
Good evening, everyone. Thank you, Dr. Harshul, for such a wonderful performance. Can we have Dr. Shubhangi Kulkarni's performance now?
शायद फिर इस जन्म में करोना भी हो न हो, लग जा तुम्हें पे फिर ये वैक्सीन हो न हो, शायद फिर इस जन्म में करोना भी हो न हो, लग जा तुम्हें पे हमको मिली है वैक्सीन बहुत नसीब से, हमको मिली है वैक्सीन बहुत नसीब से, कोई ऐप देख लीजिए उसको करीब से, फिर आपके नसीब में ये वैक हो न हो, शायद फिर इस जन्म में करोना भी हो न हो, लग जा तुम्हें पे जात में Wow, better than the original, I would say. It's so superb, superb, ma'am. And
I didn't know
Corona
the
say
corona.
ho na ho.
No, I didn't know the corona and the vaccine could become so melodious one day.
Exactly.
For corona, like for humor, adding humor to the song.
No, but it is really, it felt melodious, more better than the original, I would say.
हर्षुल, it was very good, है हर्षुल.
And ये अभी Shubhangi.
शुभांगी बहुत
And
अच्छा गाते हो,
everybody from
बहुत
the
अच्छा,
cultural community.
बहुत अच्छा थे.
Okay, so he was giving
Good evening,
message
sir.
to the whole community.
Good evening, sir and ma'am.
Good evening, Vaishali.
Yeah.
Wonderful.
Driving back?
हाँ, तो नीचे करो कांच, कांच नीचे करो.
Yeah, yeah.
Okay.
कांच नीचे करो.
Now going forward, I request the mouth organ piece by Dr. Bhushan. Can we have that? Hello?
Well, I think there is a dance now Kathak dance by Himashri.
Yeah. I'm now calling.
Which one do you want to play, madam? Do you want to change the order or?
No, please play the dance
No,
by
please play the dance by Dr.
Dr.
Himashri.
Himashri. We have that order, na? The same order, please.
Hello? हो मग तेच केलं ना शुभांगी नंतर माउथ ऑर्गन होता ना मग परत चेक करून
छुटे न छुटे मुझसे रंग तेरा डोलना एक तेरे बाजू तुझे मेरा कोई बोलना माही बोलना माही बोलना तेरे लिए आया मैं तो तेरे संग जाना बोलना मैं तेरे नाल जिंदड़ी बितावा कभी नहीं छोड़ना इश्क दी डोरना सारे छड़ जाए माही तू न छोड़ना बोलना बोलना
Wonderful performance.
Lovely. Himashri is always my inspiration. You know, she every movement of Kathak is so delicate और वो नजाकत से करती है ना, तो देखते रह जाते हो आप. You know, every movement, fantastic dance.
And
Himashri.
dancing on this song was really, really beautiful fusion. I loved it. Yeah. And sorry for the goof up, guys. Now I request the dance number from Pyar Hua Chupke Se. Can we have that number, please? Wow, Nupur, you're always my favorite. Such a beautiful dance. The moves were excellent.
And so what if there is no stage?
Exactly.
घर के घर में beautiful dance.
Yeah. Even I was wondering the same thing, that the COVID has not stopped us from getting entertained and doing entertainment. Like it's so soothing for the soul also. Wonderful.
And Nupur's smiling face, you know, it's like sunshine.
Beautiful dance, Nupur.
Thank you, ma'am. Thank you. Thank you so much.
Lovely. Dr. Harshal, would you like to say something to Nupur?
Yes, yes. Nupur is always an amazing dancer, no? She has a lot of expressions and, her dances are always to look forward. We always enjoy watching Nupur's dance. Nupur, amazing, very nice. And
Thank
you all
you, sir.
know that very soon we are going to have LBO Super Dancer competition, and Nupur, Priya, Manashi, all these people are taking care of that. We are about to start in October, but because of some reasons we are delaying
So
it.
count
So in
me in also.
yes, ma'am, of course. Everybody is a part of it.
We all.
So yes. So who better than Nupur, Priya, and all those people to, and Gitanjali ma'am, of course, to take care of that entire program. Yeah. Very nice, Nupur.
Yeah, we now move to the Radhika, the next performance.
Can I leave, ma'am? I'll just like to. Yeah.
Thank you.
Okay.
Thank you,
Thank you
Dr.
so much.
Harshul, for joining. Yeah, you took out time, especially for us.
Thank you
So
so much,
thanks
ma'am.
a lot. Yeah.
Thank you.
My
Thank
pleasure.
you.
Thank
And
you.
it was wonderful to hear you. Thank you
Thank
so
you.
much.
Thank you. Bye.
Do we have Dr. Vanashri with us? The next performance by Dr. Vanashri Nayak.
पल भर ठहर जाओ, दिल ये संभल जाए, कैसे तुम्हें रोका करूं, मेरी तरफ आता हर गम फिसल जाए, आँखों में तुमको भरूं, बिन बोले बातें तुमसे करूं, अगर तुम साथ हो, अगर तुम साथ हो। बहती रहती नहर नदियाँ सी तेरी दुनिया में, मेरी दुनिया है तेरी चाहतों में, मैं ढल जाती हूँ तेरी आदतों में, अगर तुम साथ हो।
तेरी नजरों में तेरे सपने, तेरे सपनों में नाराजी, मुझे लगता है कि बात दिल की होती लफ्जों की धोखेबाजी, तुम साथ हो या ना हो क्या फर्क है, बेदर्द की जिंदगी बेदर्द है, अगर तुम साथ हो, अगर तुम साथ हो।
Super. Very nice
Beautiful
one.
performance, Dr. Vanashri. Beautiful.
हे प्राइवेट हॉस्पिटल है का नोबल हॉस्पिटल जे
Dr. Vanashri?
Excellent, Vanashri. Yeah.
you, ma'am.
जी करता है सुनते जाओ तुम्हें बस, और कुछ न करो अगर तुम साथ हो.
Thank you, ma'am. Thank you for the live performance opportunity also. Thank you so much. It was fun to sing for every one of you. Thank you so much.
Yeah.
Thank you, Dr. Vanashri.
Next we have Karubi ma'am's dance. Yeah.
When the rock starts spinning, you snooze and when the chicken at the hop. Do the dance sensation, then the sweet sensation at the hop. Let's go take 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 the hop. Come on, let's go take the hop. Swinging the beer start to move it at the hop. Where the jockey hits the strings and the music hits the blues at the hop. All the cats and the chicks gonna get their kicks at the hop. Let's go! Let's go to the hop. 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 Come on. Let's go to the hop. Let's go! When you rock it to the road, stop and then stroll at the hop. When the record starts spinning, your lips are when chicken at the hop. Do the dance sensation, tell us the nation at the hop. You can't swing, but you can really start to move it at the hop. Where the jockey hears the strings and the music is the blues at the hop. All the cats and the chicks gonna get their kicks at the hop. Let's go! Let's go to the hop. 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 Come on. Let's go to the hop.
Superb, superb, ma'am. Karubi ma'am, let's do the hop. We are all so much of into it. Wonderful.
Yeah, there's so much of oomph in a dance.
Right, right.
Now, can we move forward to a performance by Dr. Sachin Atle?
Yes. Yes, Radhika, we can go there.
खामोशियाँ आवाज है, तुम सुनने तो आओ कभी, छूकर तुम्हें खिल जाएंगी, घर इनको बुलाओ कभी। बेकरार है बात करने को, कहने दो इनको जरा, खामोशियाँ
खामोशियाँ खामोशियाँ लिपटी हुई खामोशियाँ। क्या उस गली में कभी तेरा जाना हुआ, जहां से जमाने को गुजरे जमाना हुआ। मेरा समय तो वहीं पे है ठहरा हुआ। बताऊं तुम्हें क्या मेरे साथ क्या क्या हुआ। खामोशियाँ एक साज है, तुम धुन को हिलाओ जरा। खामोशियाँ अल्फाज है, कभी आ गुनगुना ले जरा। बेकरार है बात करने को, कहने दो इनको जरा। खामोशियाँ तेरी मेरी खामोशियाँ खामोशियाँ लिपटी हुई खामोशियाँ। नदिया का पानी भी खामोश बहता यहाँ। खिली चांदनी में छिपी लाख खामोशियाँ। बारिश की बूंदों की होती कहाँ है जुबान। सुलगते दिलों में खामोश उठता धुआं। खामोशियाँ आकाश है, तुम उड़ने तो आओ जरा। खामोशियाँ एहसास है, तुम्हें महसूस होती है क्या। बेकरार है बात करने को, कहने दो इनको जरा। खामोशियाँ तेरी मेरी खामोशियाँ खामोशियाँ लिपटी हुई खामोशियाँ खामोशियाँ तेरी मेरी खामोशियाँ खामोशियाँ लिपटी हुई खामोशियाँ।
Awesome. Brilliant, brilliant. Too good.
Excellent. Sachin, you are so good.
Don't feel bad, but for one moment I thought, are you just lip syncing? It was so beautiful, melodious, just superb. Now, can we move on to the Lavani performance by Dr. Tanmay?
तुमची घाई नकला उगठोड बांधायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला जेवण करते पूर्णाची पोळी बातमी घातलाय रांधायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला तशी मी नांदायला हो यू कशी तशी मी नांदायला बाबा गेले हो परगावा निरोप त्यांचा यायला हवा नाही विचारला थोरल्या भावा नाही विचारला थोरल्या भावा आई गेली पाणी शेंदायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला तुम्हाला सजना सांगते ऐका चालवू नका तुमचा हे का तुम्हीच सांगा हे बर हाय का तुम्हीच सांगा हे बर हाय का श्रावण लागलाय कुंडायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला यू कशी तशी मी नांदायला हो यू कशी तशी मी नांदायला
मस्त मस्त फारच सुंदर सुरेख नृत्य डॉक्टर तन्मय ॲब्सोल्युटली मॅजिकल. Can we move on to the next performance? Radhika? Dr. Bharat, can we have Dr. Bharat's performance?
तालिया तालिया तालिया
it's very difficult to do salsa on garba beat. Huh? Even we tried at Jalgaon, and it's really like it looks very nice. Dr. Bharat did it very nicely. The same way we also did here.
Really, hats off to Dr. Shah sir and madam. It was really superb performance. Next, can we move on to the mouth organ? Yeah, Shubhangi ma'am.
melodious performance by Dr. Shubhangi ma'am. Dr. Shubhangi ma'am, are you here with us? I don't
Absolutely lovely song.
Lovely song, yeah.
Evergreen song like Shubhangi ma'am. Evergreen ma'am.
Hi everyone, how are you?
Hi, Karubi ma'am.
Nice to you. Radhika, happy birthday to you.
Oh, thank you, ma'am. Thank you. Thank you.
Yeah, Radhika, happy birthday. I forgot to wish you on personally.
On Zoom.
Zoom,
Thank
yeah.
you.
Ma'am, we enjoyed your hop dance very
You
much.
did? Okay,
Yeah.
okay. Thank you.
That was a very flamboyant dance, ma'am.
Oh my God.
Absolutely.
I know. It's good fun.
Can
Now
we move on?
Can we
Yeah,
move
who's
on?
next?
Yeah. We need to move on, but there'll be a mouth organ performance by Dr. Bhushan.
Absolutely brilliant, Dr. Vibhuti Bhushan. Excellent performance.
Yes.
I joined in late for who had performed before Shubhangi's performance, but she also sang very well.
Yeah, Dr. Bhushan is like the control mouth organ is so difficult. It seems so easy, but I'm sure it takes lots of efforts. Now for a wonderful song by Dr. Atul Seth, Zindagi Mil Baithenge.
जिंदगी मिलके बिताएंगे, हाले दिल गा के सुनाएंगे। अब तो सात रंग हैं, ये जहां रंगी बनाएंगे। जिंदगी मिलके बिताएंगे, हाले दिल गा के सुनाएंगे। हम तो सात रंग हैं, ये जहां रंगी बनाएंगे। सरगम हमसे बने, नगमे हमसे जवाब, झूमे आसमां, और हम ही तो दुनिया के साथ अजूबे हैं, हमसे है जहां। सरगम हमसे बने, नगमे हमसे जवाब, झूमे आसमां, और हम ही तो दुनिया के साथ अजूबे हैं, हमसे है जहां। धुआं 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 है। जिंदगी मिलके बिताएंगे, हाले दिल गा के सुनाएंगे। हम तो सात रंग हैं, ये जहां रंगी बनाएंगे। खुशियाँ बांटेंगे हम, हर गम मिलके सहे, फिर क्यों आंसू बहे, और बन के सहारा एक दूजे का यूं ही चलते रहे। खुशियाँ बांटेंगे हम, हर गम मिलके सहे, आंसू बहे, और बन के सहारा एक दूजे का यूं ही चलते रहे। धुआं 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 है। जिंदगी मिलके बिताएंगे, हाले दिल गा के सुनाएंगे। हम तो सात रंग हैं, ये जहां रंगी बनाएंगे। जिंदगी मिलके बिताएंगे, हाले दिल गा के सुनाएंगे। हम तो सात रंग हैं, ये जहां रंगी बनाएंगे।
This is a combination talented son of the talented father, and both of them create such melodious and masti bhara music that it's fun to hear. Thank you, Atul, and thank you,
It was
Rishabh, for.
such a catchy number. Atul sir, I also joined in the chorus of Dua Dua, though I doubt
Atul is
if
listening
you've
from
heard it.
here.
Wonderful, wonderful presentation.
Okay.
And now the birthday girl will present us with a performance on the beautiful song
Atul, sun liya na?
Ghumar. So I welcome now Dr. Radhika to give her performance.
धड़क प्रीत की सर पे हो
Wow, Radhika, what a performance. So graceful. And who would say you've
This
just
was directed
recovered?
by Sanjay Leela Bhansali, I think.
Dancing so well.
Yeah.
Superb, Radhika.
Absolutely beautiful.
Absolutely amazing.
Thank you, ma'am.
I regret so much not sending my dance number. Now I'm getting that.
I know, Vaishali, don't make such mistakes in future.
And Radhika, माझ्याकडून हॅपी बर्थडे.
Happy birthday. Happy birthday.
Yeah, yeah.
We all
Especially the
काय ग तू किती सुंदर दिसतेस पिंक साडी मध्ये.
दिवाळीची थाली घेऊन.
I know. No, Gitanjali has worn a lovely pink sari.
Oh, thank you.
But Radhika, who would say that you've just recovered from an illness and then you're dancing so beautifully, you know?
Actually, I chose this dance because my knees were not very good, so I couldn't do anything.
No,
else.
you couldn't make out anything. It was very good. And what energy here. Very good. Welcome, Nikhil.
Yes, ma'am. Welcome.
Yeah, we are both the latecomers here into the show. But the thing is,
This was next level, ma'am. It was like ultimately very Sanjay Leela Bhansali and what graceful. I don't know who shot it. Who shot it for you?
One of my nephews who's still aspiring in the business, actually.
It was really well conceptualized. Beautiful.
And he did not have any, a lot of gadgets or anything, just the cameraman and a light. And both of them were running around me.
Okay.
Absolutely. This
Yeah, you were grooming, so they were also grooming. Okay, I think next in line is the Lavani, right?
Yes, ma'am. We are waiting for you.
No.
We are waiting
I want to say a few things about the Lavani. The
Please
Lavani is a joint effort by all of BOA. And in this, the music has been created because the song was not available on karaoke. So Namrata has sung the song, Prashant and Dilip Gaitonde and Harish have created the music, and all the participants who are there are the BOA members, which we had done for 2017, but just see it and enjoy it. Nikhil, you have anything to say?
I want to say that you are the best Lavani woman I have seen. So graceful and so nutcut and naughty you are. We'll see all your antics now, ma'am. We're waiting to see who all you will make them dance.
Okay.
ला 3 बाबा रे खूप महाग आहे नको रे 15 ला 3 दे ग 15 ला 3 चटणी चांगली आहे 25 या
Once again.
अरे चल हट.
डोळ्यांच्या डॉक्टरला लगीन करणार आहे काय गप्पोऱ्या बरोबर चला आपण विवो घेऊया आणि नवरा बघूया
आज आले उद्या मी येणार बी नाही आज आले उद्या मी येणार बी नाही आम्हाला लगीन करायचं हाय मला भेटला नवरा हवाय बाई आम्हाला लगीन करायचं हाय मला भेटला नवरा हवाय बाई बिबा शिकत नाही गल्ली बोळात ना वाढत जाई गल्ली बोळात ना वाढत
ट्रॉफी देने 1 मिनट को मैडम he wants to take the pic. Please. सर के साथ प्यारी सी पिक तो बनती है.
Interesting performance. Very nice.
यहाँ पे किसी का सिटीबैंक का कार्ड.
And this was reliving all good memories and such.
Yes. We have seen it live, but it was fun watching it again, Karobi. Excellent performance.
So, ma'am, you know,
Very
this was
nice.
entirely
Very
written by
nice.
Karobi, ma'am. And she tied in all the Marathi words with everything very well. I'm brilliant, huh? Only you can think of this. And Launi, mein you included salsa with the Nawari sari. That was also brilliant.
But we had fun doing it. I still remember that the education of Dr. Keki Mehta, Dr. Lahane and Dr. Nayak was in the corridors of the conference because I had not met them before. So I just instructed them in the corridors, you have to come and do this. So they said, okay. They were also very, very cooperative and it was like a fun act, you know.
Yeah. It was wonderful watching it again, Karobi. Excellent.
Thank you.
Very nice. Very nice.
I know. It's like some fun.
Yeah, nostalgic memories. Yes. I hope we meet again, you know, in a physical conference and have a lot of fun. Maybe in the AIOS conference, we'll have a lot of fun.
Yeah, sure. I'm sure that's going to be a physical one.
Yes, correct. Yes.
Absolutely. Ma'am, you have
Nice,
to make everybody
nice.
dance there, no?
Hello?
Ma'am, you have to make everybody dance at the next physical
Yes. Everybody has to dance.
So, ma'am, I think the next performance now is by Dr. Sonal Lakrawala. And she's done a brilliant act. Sabko malum hai, ishq masoom hai. Let's watch.
Yeah, and this is her famous choreographer husband, Dr. Umesh Jadhav, who is a dance choreographer for Marathi films. So you watch him in action with his wife.
तुमको पाया है तो जैसे खोया हूँ, कहना चाहूँ भी तो तुमसे क्या कहूँ। तुमको पाया है तो जैसे खोया हूँ, कहना चाहूँ भी तो तुमसे क्या कहूँ। किसी ज़बान में भी वो लफ्ज़ ही नहीं कि जिनमें तुम हो क्या तुम्हें बता सकूँ। मैं अगर कहूँ तुम साहसी, कायनात में नहीं है कहीं तारीफ, ये भी तो सच है कुछ भी नहीं। तुमको पाया है तो जैसे खोया हूँ।
मोहब्बतों में जीने वाले खुश नसीब हैं, मोहब्बतों में मरने वाले भी अजीब हैं। अजीम है हमारी दास्तां, जाने रास्तों में रहते हैं लेकिन करीब हैं।
हमको मालूम है इश्क मासूम है, दिल से हो जाती है गलतियाँ, सब्र से इश्क महरूम है। मैं समझा न पहचाना जो तुमने मुझसे कहा है सेन्योरिटा, मगर फिर भी न जाने क्यों मुझे सबके अच्छा लगा है सेन्योरिटा.
No desvíes la mirada, quédate sentada en mí.
मुझको बाहों में तुम घेरो, समझी ना सेन्योरिटा. चाह के तो मर गई दिलवाले, दुनिया में भी कौन है क्या, कौन को तो खराए. मेरा होता है क्या सेन्योरिटा, सुनो सुनो सेन्योरिटा कहते हैं क्या. Hello.
Superb,
Sonal,
ma'am. Superb, really.
that was such an exquisite performance with your choreographer husband. I mean, it was just too nice to watch. What do you say, Nikhil?
Thank you, ma'am. Thank you so much.
I know. It's dearie, it's like reliving old times, and it's so beautiful. Both of you done so well.
I think it
Thank
was
you,
out
Karovi
of the
ma'am.
world. And you know what, Sonal? The romance shows.
Yes.
You can see it. It's beautiful. Beautiful. God bless you.
Thank you.
and the
Thank
thing
you
is
so
that
much.
you can tell Umesh that you're taking a second profession of being a parallel choreographer with him. You can also teach your students dance.
Thank you so much. Thank you.
Excellent.
Beautiful, very nice. Now, who's next on the line?
It's Nikhil. It's Nikhil.
I have to announce. That's why I'm laughing.
Okay.
I thought you're
Yeah.
pulling my leg.
Really a beautiful video. I just found it so amazing.
Very beautiful. Nikhil's ramp walk, this is?
Such video.
नमस्कार सीवर्स, आय एम डॉक्टर निखिल नासला. हा स्टेज खूप भारी आहे, पण हा कॅन्डिडेट लई भारी आहे.
Thank you, Sebas. You have helped me discover a new side to my life and a new identity. I have made so many nice friends through this platform who I think will be with me for a long part of my life. And yeah, you got me out of a shell, and I'm kind of enjoying this newfound confidence that I'm having, bringing out the best side of me. So thank you so much, Manali Kamat and Sebas, and it's my pleasure all the way.
My God, Nikhil.
Heartiest congratulations, Nikhil.
Thank you.
Never knew that. Huh?
Yes. So, ma'am, I have to tell you, Dr. Meenakshi Bagli is my Masi's best friend.
Okay.
And so joining
I
of
have
that.
known him since he was a baby in cradle. We have been babysitting him, when he was small. So I'm so happy and proud of you, Nikhil.
Madam, I hope he didn't do susu potty on you.
Yes, he has done. I won't mention that.
All your secrets are out, Nikhil.
No, Nikhil, that was superb. Superb. Just too good.
I just want to add one thing, Meenakshi ma'am. सीबस मधून मला एक चान्स मिळाले आणि एक मराठी चित्रपट मध्ये आता तुम्ही मला बघणार मार्च मध्ये रिलीज होईल. फुलराणी पिक्चरचं नाव आहे. इट्स अ रिमेक ऑफ जॉर्ज बर्नर्ड शॉ
My Fair Lady.
Wow, we have a celebrity in our
I know.
Congratulations, Nikhil.
Congratulations.
Dr. Nikhil, a selfie, please.
Selfie and autographs.
You know what, Nikhil? I'll tell you something. You, with all this act and all, now you have all the girls drooling and all the male artists or the actors packing their bags and going home.
But ma'am, this creative push was given by you. I have to say that.
Good. At least I could give you something.
Good.
Very nice.
I think with that we move to the next presentation, which is back in Karobi ma'am's court. So it's Karobi ma'am and Dr. Natarajan sir. And ma'am, it's all yours.
Nati and me doing a cha-cha-cha with a bachata mix.
You're getting crazy, but you keep my body amazing. Turn up the lights and the sound, get loud, shout it out, 'cause you're getting crazy.
Karobi madam, you are just too much.
Too good.
Too good.
Excellent.
Pretty much.
You're mute.
You are muted, ma'am. Can you unmute, please?
Yes, the thing there was a lag in the this in
No,
the
no,
dance.
that's
No,
okay.
no, no, it
No,
was
एक बार
perfect,
लावणी
perfect.
करते हो, एक बार salsa करते हो, मतलब, you know, you are master of everything, and so
I have
graceful you
I
are
have
doing.
learned Bharatnatyam also.
Wow,
I do
Wow,
Bharatnatyam also.
great,
that's
great.
too good, and you are
Gitanjali, we
enjoying
three
so
will.
much.
Yes, yes.
Gitanjali, me and ma'am will do Bharatnatyam and you do Kathak. We'll have a fusion
Yes, yes. We'll have
next
a
time.
Yes,
trio
yes,
dance.
yes,
Yes.
we'll definitely do.
Or you do Bharatnatyam, you do Kathak. I'll do some cha-cha-cha on the side.
Yeah, actually,
Done, done.
ma'am,
Nikhil, join
during
us.
Yeah, I'll also join, and
LDP,
you have to include Radhika in it, yeah.
Yes, yes, 100%. She'll do Ghumar dance. That's
It'll be
why.
fabulous. I think वो stage टूट जाएगा इतना ये सब लेके. It'll be too good. तानसेन
In
ने
fact,
कांच तोड़ दिए थे, आप लोग stage तोड़ देना.
Not
Robi
heavy
ma'am,
duty
we had
dancer
your
on the
same
stage.
during the LDP in 18.
yeah.
We were also taught bachata by the same your sir.
Jitu.
Yeah, so it
Jitu.
was
He's good.
wonderful to learn that also.
No, he's very good. He's very good. Actually, you know what? Whenever there's a physical conference, no, let's plan it now. We can have a group dance where all of us perform on different aspects of dancing,
Yeah.
different this, and we can have it on a same number.
And ma'am also have a bachata session. You had a yoga session in your time. Let's do a group bachata. कितना मजा आएगा? Zumba,
बहुत
yoga
मजा
सब.
आएगा.
Yeah.
We'll do it.
Ma'am, AOS is coming to Mumbai, so we'll have a nice
We'll
Yes,
have it
gathering.
at
yes,
that time,
We'll
sure.
have an
definitely we'll
entertainment
have
zone, ma'am.
something
Entertainment
great.
zone.
Yeah, very nice. We'll do
So
it.
wait and watch.
Yes.
What are we going to do? Vaishali, it's like that.
We'll line up all the dancers who are
Yeah.
there on our show and we'll have it, and whoever else wants to join also.
And
Yes,
at
yes.
Aurangabad conference, were you there, ma'am? Like me and Raju
Yes, yes,
had
I was
done
there.
me and
Yeah,
Raju had done on swag se kar lo. I was
thanks,
hoping I
Karlo.
could have sent the video
Oh.
here.
You didn't have it with you?
I had, but like I couldn't send it at the right time.
Next time.
Yeah,
There's
maybe
always
next time.
another time.
Next time for sure.
So it was so much fun doing on swag se kar le sabka swagat. That was the first song, and it was
In
wonderful.
fact, in all this, the rehearsals are the best, because there's so much
Absolutely.
fun while doing this, sort of ironing out all the
Practice.
bloody nitty-gritties of everything,
Yes,
it's real
yes.
fun.
Those are memorable.
Yeah, very memorable.
Absolutely. Ma'am, shall we move to the next performance?
Yes,
We
yes,
have
Yes.
our very own Dr. Swapnesh Sawant.
yes.
He's also multi-talented. He's been a child artist in movies and he plays cricket very well. ऐसा कुछ नहीं है जो वो नहीं करता है. And of course, he's a master retinal surgeon. So let's watch his dance.
चांदी नहीं यार तो मिला
अरे प्यार
प्यार
कर
कर
ले.
ले. You know what? He feels very shy. He can sing also well, he can dance also well, but when you ask him for a clipping, he'll never give it to you. So, Nikhil had done this group song, of Yaar Bina Chain Ka Re. So, what happened is that I edited that little part of Swapnesh and I sent it. I said, let it be short.
Okay, okay, okay.
That's why
Just
it's so
to give
short.
some
Yeah.
glimpse of his talent. Yeah,
Glimpse
that
of
was
his,
good.
but he does it well. And the best thing I liked about is that his, of course, performance was very nice, but his shoes and his puff, everything was moving in unison.
So he got the
And I could
entire
sing the
retro vibe.
song because it 2018 I had sung this as well.
Okay.
Even actually, Vaishali, I had sung this song for BJ Medical Orchestra when I was in second
So
MBBS.
sing no, both of you.
I'm
Why
feeling like you all have to sing.
अभी गाओ ऐसे ही गाओ.
Let's have
नहीं,
2-3
नहीं,
lines.
अभी
चलो
नहीं.
चलो 1, 2, 3.
One stanza,
start, ma'am.
one stanza.
Please.
चलो, both of you sing.
यार
वैशाली
बिन चैन कहा रे प्यार बिना चैन कहा रे सोना नहीं चांदी नहीं यार तो मिला अरे प्यार कर ले सोना नहीं चांदी नहीं यार तो मिला अरे प्यार कर ले
Very nice.
Thank you.
Superb,
Thank you.
superb.
Madam, in between this program, I had another invitation to present my poetry.
I know you had written on the group.
Yeah,
because
so
you
I
went and
joined
came
over
back.
there. Just now I finished, so I was enjoying both. So that this is the best part of technology, you
I
can
know, I
join
know.
with two devices and you enjoy both.
And you
So
can
everyone says
present
that there
everywhere.
should be physical, but somewhere I feel that this digital thing and technology has helped us so much.
I know,
We
I
all
know.
have come close to each other. We know the talents of everyone and we can enjoy every program.
I know. See, the thing is that we really didn't know the talent from whole of Maharashtra. And as I told you, Taswala had helped me out at that time with this program because he gave me the names of people who could sing, dance, have skits and all that. But now, after like doing this program, cultural program, I've come to know so many others who are so
I know.
multi-talented. And it's like a cohesive group, which is very nice. It's like
I
that's
know.
the reason why that OCT thing is there. So like everybody can talk their own things, and you can communicate, and
I
it's a
know.
very nice group where no shop is talked on. It's just creative work. So it's
Right.
really nice.
Yes.
So,
I'm
ma'am,
missing
should
my
we
friend
move?
Naina also, ma'am. Naina dances superbly. I wish
Okay.
she had also sent a video.
Yeah.
You should coax her next time to send it.
Yeah. No, it's like my mistake only. I didn't. Now I'm
No,
regretting it.
everyone is welcome. Whoever can sing, dance, act,
I
do
know.
anything well is welcome.
Right.
Can we go to the next program? No, next
Yes,
event?
my
Yes,
dear.
yes, ma'am. So the next one is Ekla Chalo Re by Sabyasachi Sengupta.
Aha.
Fabulous singing and wonderful song. So he had done this during COVID where everybody was akela. So it resonates even now. We are not alone. So no Ekla Chalo Re, but the song is beautiful.
Yeah.
যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, তবে একলা চলো একলা চলো একলা চলো একলা চলো রে, তবে একলা চলো একলা চলো একলা চলো একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি কেউ কথা না কয় ওরে ওরে ও ভাগা, কেউ কথা না কয়, যদি সবাই থাকে মুখ ফিরায়ে সবাই করে ভয়, যদি সবাই থাকে মুখ ফিরায়ে সবাই করে ভয়, তবে পরাণ খুলে তবে পরাণ খুলে তুই মুখ ফুটে তোর মনের কথা একলা বলো রে, তুই মুখ ফুটে তোর মনের কথা একলা বলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। जब काली घटा छाए ओरे ओरे ओ अंधेरा सच को निगल जाए, जब दुनिया सारी डर के आगे सर अपना झुकाए, जब दुनिया सारी डर के आगे सर अपना झुकाए, तू शोला बन जा, वो शोला बन जा जो खुद जल के जहाँ रोशन कर दे। একলা জ্বলো রে, जो जल के जहाँ रोशन कर दे। একলা জ্বলো রে, যদি তোর ডাক শুনে কেউ না আসে, তবে একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে, তবে একলা চলো রে।
Excellent. Excellent. In our last cultural program, Dr.
Yeah,
Rupali
Rupali-
Rasne.
Rupali
yeah,
Abhyankar had sung the same
yeah.
song.
She's
but
same Rasne. She's
she
here, I
sang-
guess.
sang
Rupali,
the- she
Rupali,
sang
if
the
you're
whole
there,
song in
just
Bengali.
unmute yourself and release
Come
your
forward.
video. No, I can't see her.
There?
She had joined, but I don't know now where she is. Because her song is also there, but I just wanted her to sing some live Ekla Chalo Re.
I don't know whether she's there.
I don't see her now.
Yeah, she must have just
Yeah.
coming back probably.
Okay.
But Sabia is a very good
Yes,
singer,
excellent.
excellent singer, and the fusion was very unique of the uh,
It was
Hindi and the Bengali version.
Yeah. I think Rupali has joined. Rupali, are you there? Just unmute yourself, please. She is there, but I think she cannot hear me, or I don't know. Rupali, if you can start your video and you can unmute yourself.
Or just unmute and talk.
Yeah, just unmute and talk, please, Rupali.
Hello.
Yes. Yeah, we can hear you, Rupali. आम्ही लास्ट टाइम तुझं एकला चलो रे घेतलं होतं. दॅट टाइम यू कुड नॉट जॉईन. आता पण डॉक्टर सव्यसाचीचं एकला चलो रे झालं, तर तू एक लाईव्ह 2 ओळी फक्त गा, म्हणजे छान वाटेल.
छान झालं, त्यांचंही छान झालं खरं तर. मी
Eating at a restaurant, let her eat, yeah. একলা একলা খাচ্ছো.
we have
I'm not done.
in short time we have her song also.
Yes.
Okay, let
so
her finish
maybe
it.
you can finish your dinner by then, and then you can
come and sing later.
we can go to the next program till then.
Can you hear me?
Yes.
Yes. Yeah. Should I sing?
Yes, go ahead.
Yeah. যদি তোর ডাক শুনে কেউ না আসে, তবে একলা চলো রে, একলা চলো, একলা চলো, একলা চলো, একলা চলো রে, যদি তোর ডাক শুনে কেউ না আসে, তবে একলা চলো রে।
Beautiful.
Sorry.
wonderful.
No, it's beautiful.
Good, because I'm in Panchgani. I don't have a very good range here.
No, it's okay. No, your voice is really, really beautiful.
Thank you so much for giving me an opportunity. Thank you.
Yes. We'll go to the next song, Dr. Nikhil. Next event.
Yes, ma'am. So for Rupali, first I want to say she's in a cold place, but her voice was so warm and loving. A very, very beautiful rendition. And of course, Sabyasachi was also excellent. उसके तो गले में से जैसे फूल बरस रहे थे. तो अभी नेक्स्ट वाला भी डॉक्टर मिहिर करने वाले हैं, वो है फूलों के रंग से. So let's hear it from Dr. Mihir.
फूलों के रंग से दिल की कलम से तुझको लिखी रोज पाती, कैसे बताऊं किस किस तरह से पल पल मुझे तू सताती। तेरे ही सपने लेकर के सोया, तेरी यादों में जागा, तेरे ख्यालों में उलझा रहा यूं जैसे कि मालाओं में धागा। हाँ, बादल बिजली चंदन पानी जैसा अपना प्यार,